Please start, Indranil.
Shuprabhat, Namaskar, Vanakkam, Sat Sri Akal, good morning, hello. You are watching the 23rd edition of the annual conference of Indian Society of Neuroanaesthesiology and Critical Care with me, Indranil Ghosh, organizing secretary of the meet. Along with me is Dr. Palash Kumar, who is the scientific secretary of this. I welcome all faculties and delegates to the scientific session of the conference. In spite of the pandemic, all faculties have given their best to make the academic schedule a really memorable one. And I hope all of you will enjoy it to the fullest. And at the outset, I thank the ISNACC Central Secretariat for entrusting the neuroanaesthesiologists and neurointensivists of West Bengal with the responsibility of organizing this conference. And I think we will be able to justify the responsibility entrusted on us. So, having said that, I now request our scientific secretary, Dr. Palash, to declare the scientific schedule open. Dr. Palash.
Good morning, everybody. The delegates, the faculty, the chairpersons, the tradespeople, everybody. A lot of effort has been put in by the team here and also by everybody participating, especially the faculty, to prepare a memorable conference for you. So without spending much time, I declare the scientific session of ISNACC 2020, the 23rd edition of ISNACC open. Thank you very much. Hope you have an enjoyable time. Thank you. Now I welcome Dr. Jayati Ghosh to conduct the first scientific session of ISNACC 2020. Thank you.
Good morning. Welcome all the delegates and the guests for the scientific session of the ISNACC 22. This is the session 1 of day 1 of ISNACC 22 Kolkata. So I will like to invite the chairpersons of the session 1, Dr. Kavita Sindhu, Dr. Rahul Yadav, Dr. Arvind Arya. Dr. Kavita Sindhu, introduction. She is Director and Head of Neuroanesthesia and Critical Care, Max Super Specialty Hospital, Saket, New Delhi. She has done her MBBS from FMC Pune, MD from Delhi University, and trained in neuroanesthesia from AIIMS, New Delhi. She has got many awards and medals in her naval background. Before this appointment, she was professor and senior advisor at Army Research and Referral, New Delhi. She is a course director of a SNACC fellowship program at Max Hospital. She has got numerous publications in national and international journals, and her special interest is neurocritical care. Second chairperson of this session, he has got many publications, and interesting is that he is first neuroanesthetist of the Indian Navy and first neuroanesthetist of Indian Armed Force to do DM neuroanesthesia. And he has also done fellowship of International Medical Science Academy at Royal College of Physicians and Surgeons of Glasgow and fellowship of Academic College of Emergency Experts. Third chairperson of today's session is Dr. Arvind Arya. He is senior consultant and HOD, IHBAS Delhi. And he is MD, MBA, LLB, LLM, PGDM, LE. He is also medical legal advisor of Delhi Medical Council. He is EC member of the SNACC National and ISA Delhi EC member. He is a member of different government setups. And he has got many publications, 40 publications, 30 paper presentation in national, international conferences, and more than 100 guest lecture in national and international conferences and CME. So now I would like to invite Dr. Kavita Sandhu at the dais to introduce our first speaker, Dr. Ashish Bindra, who will be speaking on multimodal monitoring in traumatic brain injury, bench to bedside. Dr. Kavita Sandhu, please.
Good morning, everybody. I hope I am audible. Am I audible?
Audible, ma'am.
Okay, so good morning, and I think we're all ready and set to go cracking and start our first scientific session for the day. And who better than our dynamic Dr. Ashish Bindra, who will set the ball rolling today. I think she needs no introduction, but still it is my pleasure to introduce Dr. Ashish Bindra this morning as the first speaker for today's scientific session. Dr. Ashish, as we all know, is an additional professor at the All India Institute of Medical Sciences and the JPNA Trauma Center at New Delhi. She has vast experience in various aspects of neuroanesthesiology. She's always been at the forefront of our neuroanesthesiology meets. More importantly, she has done a lot of work and was member of the UTHM, where she worked in targeted temperature management. Many of us have heard her wonderful lectures on more than one occasion on this subject. She's also been very, very deeply involved with multimodal monitoring, especially cerebral microdialysis in neurotrauma and in epilepsy anesthesia. She also is on the editorial board of Neurology India and is also in the board of the Journal of Neuroanesthesiology and Critical Care. She has more than 80 publications and has more than 10 chapters in various books. So without wasting any more time, I hand over to Dr. Ashish Bindra, who shall be speaking today on multimodal monitoring in traumatic brain injury and will show us how to get it from the bench to the bedside. Dr. Ashish Bindra, please.
Yeah.
Good morning, everyone. Greetings from AIIMS New Delhi. I would like to thank the organizers for giving me this opportunity. At the same time, I miss being in Kolkata, meeting with all ISNACC family members. I hope and pray that next meeting is not a virtual one. The topic given to me today is multimodal monitoring in traumatic brain injury, bench to bedside. So on the bench, we have established that brain maintained its cerebral perfusion and blood flow through a variety of autoregulatory mechanisms. And with the onset of acute traumatic brain injury or acute insult to the brain, these autoregulatory mechanisms are disrupted, which results in cerebral or neuronal injury. On the bedside, we have a variety of monitors which can tell us about the cerebral metabolism, oxygenation, electrical activity. There are some established ones like vital monitoring, monitoring of the clinical status of the patient, of the imaging, which have established their role in management of the patient in every day. However, the other monitors like monitors of cerebral hemodynamics or PBTO2 monitoring, cerebral microdialysis, etc., are still looking at their place in the management of patients with TBI. So on the bedside, when we have a patient with TBI, it comes to our mind that what kind of monitoring should be done to these patients? Will it affect my patient outcome? And is it going to be the cost-effective one? So to answer these questions, I have formulated this talk in these subheadings, like what are the various monitoring modalities and their current status in traumatic brain injury management, multimodal monitoring and its applications on bedside, pitfalls of multimodal monitoring, and a take-home message. To begin with, we come to the most commonly used monitoring modality, that is the monitoring of intracranial pressure. So these invasive methods are the gold standard methods which have been used since years. And there are a few non-invasive methods which have been tried over the years to compare if they are somewhere near to the invasive methods. So non-invasive methods are like optic nerve sheath diameter, correlating with the TCD, transcranial Doppler values, NIRS values, visual evoked potentials, tympanometry, etc. However, let us first focus to the what are the trends in the management in measuring of the invasive methods. These catheters, which are the ICP monitoring catheters, can be placed intraventricularly, intraparenchymally, or subdurally to obtain a number and a waveform. Over the years, we have been taught to treat these values. Like the BTF guidelines also say that intracranial pressure should be treated when it is more than 22 millimeters of mercury. And recently, the trend has come towards the measurement of the waveforms as well as the numbers together. So waveforms, low pressure waveforms, they reflect of the compliant cranium, whereas the high pressure waveforms, they communicate us about the non-compliant cranium. So they said that ICP should be determined depending upon the number and the waveform. This will be helping early warning of deterioration and acute prognostication and also the timely management of the patient. Number 2 point, which has changed, is that individualized interpretation of ICP should be done along with the other neuromonitoring variables and patient characteristics, like measuring the ICP with the PbTO2 or the cerebral microdialysis variables or along with the TCD variables, etc. Now, number 3 take-home message is that overall burden of ICP is a better indicator of prognostication rather than isolated or individual values. So there are softwares which have come up which interpret the overall ICP insult by multiplying the duration of the insult with the intensity of the insult. So more the red color means more the cerebral insult is. So obviously it gives us a visual depiction how bad the patient is going, what will be the prognostication in this patient, and also the therapeutic strategies should also be designed accordingly. Next in line is the non-invasive ICP monitoring methodology, that is the optic nerve sheath diameter. Since optic nerve is in continuation, has a subarachnoid space around it, and the CSF in the subarachnoid space follows the pressure changes in the cranium. So optic nerves, measuring the optic nerve sheath diameter corresponds to the intracranial pressure changes. The optic nerve sheath diameter measurement can be done by an ultrasound or a T2 weighted MRI or a CT scan. Normal average value for adults have been defined, and values above the decided limits indicate a rise in intracranial pressure. Right now, currently, what limitations we are having with the use of optic nerve sheath diameter is still the cutoff for various age measurement, like in infants, in children, and in adult. There is a confusion regarding those. Also, there is a dispute regarding the measurement technique in various age groups, like from the posterior lobe diameter. Usually the studies say that 3 millimeter difference optic nerve sheath diameter should be measured, but there is literature which states measuring it for 5 millimeter or 8 millimeter down the posterior globe margin. Moreover, the models to determine an accurate value of ICP with changes in ONSD is yet to be established. Next, we come to the role of transcranial Doppler, which is a very commonly used and increasingly popular instrument for measurement of low cerebral blood flows, intracranial hypertension, and cerebral autoregulation in patients with traumatic brain injury. So the values and cutoffs for TCD have been decided, and it is said that increase in pulsatility index and decrease in the flow velocity of less than 20 centimeter per second has been associated with determination of poor cerebral compliance. ICP measuring the TCD values have also the diagnostic potentials for diagnosing the hyperemia, oligemia, or intracranial hypertension. Similarly, measuring the TCD values and looking at the intracranial compliance by measuring the pulsatility index and also measuring the flow velocity can also help us determine the therapeutic plan for the osmotic agents, optimization of ventilation, and surgery. Definitely, TCT values, which indicate a high pulsatility index and low flow velocities, have a prognostic value for management of for outcome of these patients of TBI. This is a study which has been conducted at our institute, which looks at the correlation between invasive and non-invasive techniques of intracranial pressure measurement in pediatric TBI. Herein it was seen that ONSD and PI and combination of both strongly correlate with the invasive ICP values. The optimal cutoff values defined by our study in these pediatric patients was 5.95 for ONSD and 1.065 for PI with a reasonable sensitivity and specificity. Next, we come to the monitors of cerebral oxygenation. Brain tissue oxygen tension. This monitor has been widely studied in many clinical trials, which consists of placing a small cloud-type electrode in brain at rest, usually with an ICP and temperature sensor. It reflects the availability of oxygen for oxidative metabolism. Clear-cut cutoffs and average values have been defined. So it is said that if PbTO2 is less than 15 to 20 millimeters of mercury, therapeutic interventions targeted at increasing the PbTO2 should be started. So this study was modality was studied in a big study, which is the BOOST-2 trial for the management of severe traumatic brain injury, where treatment protocol directed at managing the ICP and PbTO2 was tested for its sensitivity, for its safety and efficacy. So PbTO2 values greater than 20 were treated normal, less than 20 were indication for intervention. Similarly, ICP greater than 20 was indication for intervention. It was seen that treatment guided by PbTO2 and combined ICP monitoring reduced the proportion of time with brain tissue hypoxia. ICP control was similar in both the groups, and it is feasible and safe to do PbTO2 monitoring along with ICP monitoring in TBI patients. Though it was not the primary objective of the study, was not powered to see the secondary outcome, but there is a hint towards better GOSE at 6 months and DRS with the use of PbTO2 and ICP monitoring. However, BOOST-3 trial is on its way to look at the secondary variables or the long-term outcome with the use of this monitoring modalities, which may give a very useful data. Next is the NIRS monitor. NIRS monitor is a non-invasive bedside portable monitor of cerebral oxygenation, apparently very lucrative because of its non-invasive nature. But there are issues with the use of NIRS monitoring. And right now, there is limited study looking at cerebral desaturation, CPP determination, or cerebral blood flow management with the use of NIRS. However, it has becoming a good tool for screening of intracranial hematomas in emergency settings, especially in pediatric patients, where it can be used to diagnose and see the progress of intracranial hematomas. Newer devices like ultrasound tagged NIRS are on their way, which may probably do a better justification with other things like cerebral blood flow measurement, etc. Next is the jugular venous oxygen saturation. We know this is an invasive monitor wherein a catheter is situated in a jugular bulb, wherein intermittent or continuous sampling at predefined rates can be done to look at the global hemispheric oxygenation. Normal values have been well defined up to 50 to 70%. Brain Trauma Foundation guidelines have advocated using the JVO2 monitoring for institution of hyperventilation in the first 24 hours. It has also been used as prognostication. There are also studies wherein JVO2 has been used to correlate with the clinical outcome, like full force score in severe TBI patients, and also has been used to compare the various anesthetic regimes used in patients with traumatic brain injury. But the role of JVO2 monitoring and its effect on outcome is not very well established, and routine monitoring of JVO2 in all TBI, severe TBI patients still is not clear. Next, we come to the monitors of cerebral metabolism. So I would like to talk about the cerebral microdialysis, wherein a small microdialysis probe is kept into the interstitial brain parenchyma, and a perfusate fluid is circulated through it. And there is an exchange of various metabolites from brain capillaries, interstitials placed to the microdialysis probe, and a dialysis fluid which was circulated through the probe is removed from the patient in the form of around few microliters of the sample. This sample is in turn placed in the analyzer to find the various values of the cerebral metabolism. The most commonly measured values are the lactate pyruvate ratio, lactate, pyruvate, cerebral glucose. Now, the biochemical changes which occur well ahead of the clinical and global symptoms is the main advantage of studying the microdialysis. So if we start treatment at the time of biochemical changes, so probably the clinical symptoms would improve. Thereby, cerebral microdialysis gives us a window of opportunities at the time where we can change the patient outcome. Apart from the cerebral energy metabolism parameters, markers of cell membrane degradation, amino acids, proteins, or other markers can also be studied with the cerebral microdialysis. The main things which are proposed after cerebral microdialysis are, apart from early warning for the secondary results, it has also been used for monitoring of serum glucose, cerebral glucose, CPP augmentation or reduction, transfusion threshold, determining the effect of body temperature on cerebral biochemistry, outcome and prognostication. So on the bedside, we have few studies from our institute. The first one was published in 2016, which was the correlation between the intracerebral glucose and blood glucose. In our study, we found that there was a poor correlation between plasma and cerebral glucose. Neither mean glucose values nor the mean cerebral glucose values predicted the outcome at 3 months. However, the good outcome patients had fewer episodes of hypo as well as hyperglycemia. The next study was to establish the metabolic patterns after decompressive craniotomy in severe TBI patients, wherein we saw both mitochondrial dysfunction and ischemia. They were common in first 72 hours after TBI, and those episodes were associated with poor outcome. And now we had this intervention or the therapeutic study wherein microdialysis was used to see the incidence of cerebral ischemia and also the correlation between CPP, ICP and lactate pyruvate ratio and effect of cerebral pressure augmentation on ischemia biomarkers. This was a small study of just 7 patients wherein we saw that 1 patient had cerebral ischemia and 1 was having cerebral mitochondrial dysfunction. However, we could not see any correlation between cerebral perfusion pressure, ICP and CMD variables. There were 2 patients who had lactate pyruvate ratio more than 40. In those patients, we augmented the mean arterial pressure with noradrenaline. However, the post-augmentation values of lactate pyruvate were not significantly higher, or they did not change the lactate pyruvate ratio and other cerebral biochemistry in these patients. So overall, we could not establish the role of cerebral microdialysis, or we could not establish the role of cerebral perfusion augmentation with the correction of microdialysis parameters in our study. The next monitor, which is commonly used, is continuous EEG monitor. The continuous EEG monitor is most commonly introduced for non-convulsive status epilepticus diagnosis, which is a common cause of unconsciousness in patients with traumatic brain injury with a pathology which is not corresponding to the neurological status in those patients. So since the EEG continues for 24 hours or more, will generate lots and lots of data which is difficult to interpret. So there are softwares which do a power spectrum analysis, and they gave us a color density spectral array wherein the color coded changes in electrical activity of the brain can be seen. Now we have lots of monitors which are telling us about oxygenation, about the pulsatility index, about the ICP changes, about so many variables. Now what to do with it? It is practically impossible to go and look at each monitor, see its value, correlate with the other monitors and form a therapeutic plan. So what was required is like integration of all those monitors. Otherwise it will become like blind men trying to define an elephant. So that integration is supposed to integrate all the displayed information together and help us to make a therapeutic plan. So on the bedside, on the bedside, we have some software. This one is ICM Plus from the Cambridge University, wherein it is able to integrate all the bedside monitors. Like you can put in or plug in all your hardwares and software inside the monitor, putting an ICP monitor output into this monitor, putting a CPP monitor, auto regulation indices, PBTO2, whatever you have into this monitor to obtain a one single screen of values along with some secondary indices also. So this is one of the examples I have taken from their website only, whereas they have done the integration of PBTO2, CPP, arterial blood pressure, ICP, pressure regulatory index, ETCO2, and respiratory rate on a single screen. Here we can see that at 11:30, there is a rise in ICP. This rise in ICP was treated by increasing the respiratory rate, which led to decrease in ETCO2, and at the same time, it also led to decrease in PBTO2. So certain kind of intervention, we can see that what is the effect of that intervention on all other variable parameters. At the same time, it also tells us what is the relation between the ETCO2 and ICP. So for decrease in ICP, how much decrease in ETCO2, how much ICP is decreasing, or for decrease in ETCO2, how much PBTO2 is decreasing. Similarly, it can also tell us about the derived parameters. So in this, it is the pressure reactivity, which it has calculated as a secondary variable. Then this red pressure reactivity indicates a poor pressure reactivity index, which indicates that if increase in MAP is there will be a corresponding increase in ICP also. Whereas this PRX is green, which indicates that this patient is pressure active. So this is good pressure reactivity after traumatic brain injury, and increase in mean arterial pressure may not increase the ICP values. Similarly, this software can also calculate the optimal CPP from the various given values. Now, these are many pros of the multimodal monitoring, that there we have ample of data, we have time synchronized formats, we have trends, we can annotate our data, we can put in the therapeutic intervention in our results. But at the same time, there's immense of data. Just imagine in every minute, every second, you are having lots and lots of information coming to us. So it kind of results in data explosion. And there are issues for this data integration and interpretations. And currently we are having less of algorithms or the working algorithms, which can actually tell us what has to be done with that many of data, because we have lack of thresholds for treatment and interventions. So though it is developing right now, it is little difficult to interpret the data and treat the patient. So if we come to our initial question, that what should be the choice of monitoring and modality, what is the effect on patient outcome, and is it cost effective, then we are currently unclear if all TBI patients can benefit from neuromonitoring, but it seems plausible if certain types of injuries or phenotypes which may do better with the multimodal monitoring guiding interventions. However, various established monitors like ICP monitor or the monitoring non-invasive monitors like TCDs are being increasingly used for the patients for this diagnostic as well as the therapeutic interventions. Available monitors should be used to generate more data according to our own setup, so that we can understand it better and make our own therapeutic plans. ICP and PBTO2 monitoring, probably in vulnerable patients where there is a zone of penumbra around the lesion, are good for management or guiding the treatment, and they are likely to result into better outcomes. Use of ultrasound in neurocritical care should be increased because it has a future potential because of its non-invasiveness. The take-home message is monitoring is fundamental to the care of critically ill TBI patients. High-quality evidence is still elusive. However, there are substantial challenges for conduct of robust prospective outcome studies. Advanced informatics is promising and may provide us a supportive tool to interpret physiological events and guide physiological-based therapeutic decisions. Thank you very much.
Thanks. It was really nice presentation, very elaborate and up to the mark. Now I will call Dr. Rahul Yadav on dais to introduce our next speaker, Dr. Nitin Manohar, who will be talking about IONM in pediatric neurosurgeries. Dr. Rahul Yadav, please.
Thank you, ma'am. Good morning to my fellow esteemed panelists and I would say the very well-known speakers. So now coming to the second speaker for the conference, for the inaugural session of the conference, Dr. Nitin Manohar is well known to all of us, an alumnus of NIMHANS from where he completed his DM neuroanesthesia. He went on to head the Department of Neuroanesthesia and Neurocritical Care at Yashoda Hospital, Hyderabad, where he was the program director for ISNACC fellowships. Presently, he is associate staff anesthesiologist at Anesthesia Institute of Cleveland Clinic, Abu Dhabi, United Arab Emirates. He's got numerous publications in the index national and international journals, as well as 5 textbook chapters. Apart from that, he is reviewer for many anesthesia, critical care, and neuroanesthesia journals. And coming to the main aspect of his multifaceted personality, for which he is very well known in the neuroanesthesia circles, he has been the pioneer in conducting training workshops for the intraoperative neuromonitoring in the various national conferences for neurosurgeons, neuroanesthesiologists, and neuroscientists. He has been a speaker at various national and international conferences. His area of interest are neuromonitoring. You all know that, Dr. Nitin, awake craniotomy and neurocritical care. So over to Dr. Nitin. I hand over the dais to Dr. Nitin.
Hi everyone, hope you're all doing well. Thank you so much, organizers of ISNACC 2022, Dr. Nil and the team for giving me this opportunity. I'll be speaking on IONM for pediatric neurosurgeries. Okay, so I bring you greetings from Cleveland Clinic, Abu Dhabi, where I'm currently working. To introduce, neurophysiology in children is different from adults. Children have immature nervous system, their synaptogenesis is not complete. So the IONM signals and the IONM waveforms are different in children. And there are various factors like age of the child, location of the lesion, type of the lesion, preoperative neurological functional status. All this determine the kind of IONM modalities we are going to use and how to interpret these IONM signals. There are also various challenges with anesthesia maintenance in young children and neonates and infants who come for procedures with IONM. So for the outline of the talk, I'll first start with anatomy and physiological differences, and then I'll move on to types of surgeries, the common surgeries where IONM is used, and what modalities are used for each surgery, and then anesthetic considerations for each of these surgeries and techniques in these pediatric population. So children are not small adults. So they are not the same as small adults. So you cannot just generalize that because they have a different neurophysiology. Like I said, the nervous system is immature, the myelination is not complete, synaptogenesis is not complete. So they're completely different from adults. And the response also differs from child to child. So as the age of the child increases, the IONM signals also change. That is because of the maturity of the nervous system. So young children have thin calvarium, and infants have open fontanelle. So this anterior fontanelle closes by 13 to 24 months of age. So before this, we are many times encountered with meningomyelocele and spinal dysraphism, these kind of cases where we have to do IONM. And here we cannot place the normal corkscrew electrodes because this is invasive, and we are very often afraid that this can pierce the dura also. So we go for a less invasive stimulation technique on the scalp. We use EEG cup electrodes and sometimes simple needle electrodes also. So something to remember is the anterior fontanelle closes by 13 to 24 months of age. So before this, you have to be really careful. The posterior fontanelle closes by about 6 to 8 weeks after birth. So these are various types of stimulation parameters on the scalp that we use. Corkscrew, if the fontanelles are closed, you can use it. Needle electrodes, you can also use cup electrodes with plasters to keep them for stimulation. So the myelination is not complete, and this completion of myelination happens about 36 to 40 months of age. So until then, the neural pathways are not very well myelinated. So this is something which we need to remember. Because of this, even though there is the calvarium is thin, we expect, you can expect that at lower currents you might get good responses, but it is the opposite actually. You need to have higher currents, and the threshold for stimulating and getting responses is very high in this pediatric population. Something to note is also that the myelination of sensory fibers is before that of the motor fibers. So the sensory system is well myelinated before the motor fibers. Also, one more thing to remember in spinal cord surgeries or spinal dysraphisms is that the dural sac ends at a much lower level at S3, and the spinal cord ends at L3 level at birth. And it takes about 2 years of age until the spinal cord comes to the normal adult level, that is up to the lower border of L1 that we call as the adult level. So any lesion around this area also we need to keep in mind that the spinal cord may be lying at a lower level. The various common surgeries where IONM is used in pediatric population are for the brain. You can use it for supratentorial tumors involving eloquent areas. You can also do them awake. So some children with motor lesions or speech lesions, we can do them awake, but not the very young ones, the ones who can cooperate and who can stay awake during the procedure. Deep-seated tumors like near the internal capsule or thalamus, infratentorial lesions like lesions around the brainstem, fourth ventricle, skull-based tumors. In the spine, deformity surgeries, spinal dysraphisms, CV junction abnormalities. We see pediatric AADs and these kind of CV junction abnormalities, renal carry malformation, these kind of C1, C2 or CV junction abnormalities, and also spinal cord tumors. So coming to various modalities, about each modality, motor evoked potentials, we need higher thresholds. Like I said, there is a higher threshold for stimulation, so you need higher currents in pediatric population. You need to sometimes use multiple trains, higher pulses, and this is because of the incomplete myelination and synaptogenesis of the motor tracts. Less than 2 years of age, even the MEPs that are recorded are not very reliable. So it's a difficult process to get MEPs in young pediatric population. SSEPs in children, like the latency and amplitude are highly sensitive to anesthetic agents, and this is again because of the immature nervous system. So SSEPs may also be very difficult to achieve in young children. So coming to EMG, that is the free running or the triggered EMG. This the EMGs can detect damage or irritation to the nerves, like the free running EMG or the triggered EMG with by a stimulator like a bipolar or a monopolar stimulator. This fortunately is not very affected by the myelination and the non-myelination in very young adults, very young children. So we can use this very effectively in pediatrics. So this is the most popular technique in pediatric neuro IONM. So for the spinal nerves, we can use in surgeries like tethered cord, meningomyelocele. For cranial nerve surgeries, you can use triggered EMG and raw EMG of the cranial nerves for brainstem lesions, fourth ventricular tumors, and various other procedures. So EMGs are easier to perform in pediatric population. The various other higher modalities or the advanced modalities like D-wave for intramedullary spine tumors, though they have been tried, the literature is sparse. Brainstem auditory evoked responses can be used in medulloblastoma, fourth ventricular lesions, ependymomas, and brainstem gliomas. VEPs, unfortunately in India, we have the goggles which are very bulky and which do not stay in pediatric population. So it's very difficult. I tried them for a couple of cases, but the goggles are too bulky and we still don't have the scleral caps in India to place on the, on the eye directly for stimulation. So the bulk is the thing, and also VEP is difficult in pediatric population. And like I said, adult awake procedures can be done in little older children, and we can use awake mapping and monitoring techniques. But for motor lesions, even though if we cannot do them awake, we can still do. There is enough monitoring techniques available now to monitor the motor pathways, even if we don't keep them awake. So speech is probably the real indication now to go for awake in these patients who may not be cooperative. So today's era is of multimodality IONM, and we combine a lot of modalities together to do IONM in these pediatric population, in adults as well and in the pediatric population. So it's not only one modality, it's multiple modalities many times. So to give an example, this is a spinal dysraphism case. You can see that there is a split cord here. It's called diastomatomyelia. Here the surgeon's aim is to identify the fibrous tissue between the cord and to dissect it. So he has to identify whether this is a nervous tissue or non-nervous tissue. So with a simple stimulator, a bipolar or a monopolar stimulator, bipolar which is preferred in this kind of specific stimulation, you can differentiate the nervous and the non-nervous tissue. So you can place also anal sphincter monitoring. You can place needle electrodes around the anal sphincter, and the stimulator here you can see is when the stimulation is on the phylum, that is a non-nervous tissue, you don't have any responses on the triggered EMG. But when the nervous tissue is stimulated, you can see the responses here in the anal sphincter. And also, not only through the stimulator, you can do, this is a mapping which the surgeon uses a stimulator to map out the nervous tissue. You can also use a continuous monitoring modality by using transcranial stimulation and recording the anal sphincter MEPs and also SSEPs, ascending pathways you can monitor continuously in pediatric population. So there is one video where for tethered cord IONM was used. Again, this is the stimulator where the phylum is stimulated. You can see there is no response, and now as the stimulation is on the nervous tissue, you can see the responses. So very simple technique and very easy to use, not affected by age or myelination. Lipomeningomyelocele are also very common procedures where IONM is used. Here the aim of the surgeon is to dissect the whole fatty tissue around the nervous plaque cord and keep the nervous tissue safe. So he will use a stimulator to map out the nervous tissue in between the mass of fibrous fatty tissue. So mapping and then continuous monitoring also can be performed. One modality which has caught recent attention is bulbocavernous reflex. This is a continuous reflex where you can continuously stimulate in males the dorsal nerve of penis with cup electrodes. In females, you can stimulate around the clitoris and get responses from the anal sphincter. So this is a reflex, and this gives an information about continuous reflex arc mechanism to look for bladder and anal sphincter function. So it has to be, it is reported in literature that this has very high specificity and this can be continuously performed. So this is a very new modality and most commonly being performed nowadays in these kind of surgeries. Coming to spinal deformities, kyphoscoliosis, no doubt that IONM is very, very valuable, even for screw to detect the screw position. So if there is a medial cortical breach, at even with low currents, you get triggered EMG responses in the nerve root. So we can use screw testing, which is nerve root testing. Also, when the screws are placed and the rods are finally placed, and then there is traction given on the spinal cord to correct the angle. With every 5 to 10 degrees of correction, it is said that you have to perform MEPs and check for MEP responses. So triggered EMG for screw testing, and SSCP and MEP for the cord monitoring when the rods are placed and traction is performed. So these kind of cases are common. Brainstem lesions also, pediatric IONM is very commonly used. This is a case where 7-year-old child came with fourth cranial nerve palsy. You can see that the tumor is on the brainstem, and we are worried about cranial nerves. We are worried about ascending and descending tracts of brainstem. So in this case, we performed third, fourth, sixth, fifth, seventh, and also lower cranial nerves monitoring with triggered EMG. And also we performed SSCP and MEP for the ascending corticospinal, ascending posterior column, that is a sensory tract, and the descending corticospinal tracts with SSCP and MEP. And also we used a continuous suction stimulator, which while the surgeon was dissecting out the tumor, he was continuously using this, and this stimulates at the tip. So you can record triggered EMG responses and detect any cranial nerves or any neural functional tissue around the resection. And also BERA for integrity of the brainstem monitoring. So this was also used. So in total, cranial nerve monitoring, tract monitoring, and also brainstem auditory work responses were used in this kind of case. So coming to anesthesia for IONM, anesthetics cause dose-dependent decrease in amplitude and increase in latency, like in adults, and it's very difficult to and it's challenging to perform anesthesia for IONM in pediatric population. The ideal way to do it is with TIVA and with opioids, and I prefer to use 0 MAC without inhalational agents, though there is literature that low dose inhalational less than 0.3 or 0.5 MAC inhalational agents can be used while IONM is performed, but TIVA is the gold standard. So if at all inhalational has to be used, desflurane is better than sevoflurane, and sevo is better than isoflurane to preserve MEP and other IONM responses. Propofol is the most common drug used for TIVA, and FDA recommendations say that propofol can be used for induction above 3 years of age and maintenance of anesthesia over 2 months of age. One thing is we should be careful in children with mitochondrial diseases, because these patients can be prone to propofol infusion syndrome. But a common question that is asked is when propofol is used for TIVA, does it lead to any side effects? No, with normal maintenance of propofol TIVA, propofol infusion syndrome has not been reported, because this propofol infusion syndrome is seen only when dose of more than 4 mg per kg per hour or more than 4 days is used, the propofol is used. So it is relatively safer for using propofol for TIVA. PRIS can be manifested as metabolic acidosis, hypertriglyceridemia, rhabdomyolysis, cardiac and renal failure. So to do propofol TIVA, TCI or target control infusion is the best way to do propofol TIVA. It gives us a steady state anesthesia, and it helps us to maintain propofol infusion beautifully without disruption. The two pharmacokinetic TCI models available are PITFuser and Acharya. Acharya can be used from 3 years on and weight from 15 kgs on. The PITFuser can be used from 1 years also, so 1 to 16 years, and from 5 to 61 kgs. So PITFuser is a very popular pharmacokinetic model for propofol TIVA, which is used. But the problem is below 1 year and below 5 kgs, so there is no TCI model available. So we have to use manual calculation of infusion of propofol, and these two are useful dosing methods. The Stewart propofol infusion scheme and the McFarland infusion scheme can be used in this pediatric population when you don't have TIVA, that is TCI TIVA, or when you have a child which is less than 1 year of age or less than 5 kg, you can use this manual calculation, and then also titrate it to depth of anesthesia monitoring. So the other drugs like ketamine and etomidate can be used only to potentiate baseline recordings, not when the signal is lost in between surgery. Remifentanil, unfortunately, the Minto model for remifentanil is also for the TCI is about 12 years and more than 30 kgs. So for pediatric population, there is no TCI available yet. but remifentanil is very useful whenever it is available. Dexmedetomidine works beautifully with pediatric population, especially when you need to maintain good hemodynamics. I generally use a bolus of 1 microgram per kg slowly over 15 to 20 minutes, and then go at an infusion dose of 0.5 mics per kg per hour infusion, and works beautifully, preserves the IONM signals, and also gives a good hemodynamic control. Neuromuscular blockers, we should know when to use and when not to use. So depending on the IONM modality used, we should avoid the neuromuscular blockers. Some institutes also have TOF monitoring and use neuromuscular blockers up to a TOF of 2, count of 2. But it creates a lot of confusion. So I would rather avoid this and directly go for without relaxation, only TIVA with propofol, opioid, and dexmedetomidine. So to summarize all the anesthetic agents and their effects on the INM signals, this is the table. I'll be sharing this later with you. Regarding depth of anesthesia monitoring, it is recommended to use process EEG monitoring more than 1 year in more than 1 year kids. Less than 1 year, the problem is the process EEG is unreliable. This is because of the immature brain, and the EEG changes because of the lack of cerebral maturation. So there is a lot of need for developing pediatric processed EEG algorithms. Also to have smaller sensors. The adult sensors are generally too big for small pediatric patients. So probably this is one area where we need to improve and get new research going. The other challenges are temperature. Hypothermia is a major concern. To maintain temperature in these kind of pediatric population is a major concern, and hypothermia is one of the most common factor where IONM signals are dampened. And the other thing is bite blocks for tongue injuries should also be placed meticulously, and there are various ways by which we use bite blocks. The silicone bite blocks work very well when they are placed between the jaw, and we also can rose gauze pieces, but in prone position and lateral position, it's very important to keep these bite blocks in place. Also, always the cold saline or irrigation fluid should be ready to give to the surgeon whenever there is an episode of seizure, and this effectively controls the seizure whenever we encounter them, especially in direct cortical stimulation. So whenever there is a drop in signal, always checklist has to be followed. We have to check the hemodynamics, check the metabolic parameters, temperature, blood loss, anemia, all the metabolic parameters, and then anesthetic factors that any boluses were given, and then look for technical factors if there was any technical glitch which led to loss of signal, and then finally the surgeon can be warned. So this is a checklist that every time an IONM signal has been lost or the amplitudes are reduced or the latency is increased, we go with this checklist. So this is one such case where interestingly we used anal sphincter MEP monitoring in a conus medullaris lesion. So you can see in between the surgery, we lost one side, we lost all the lower limb MEPs, but the anal sphincter was still intact, and the opposite side, everything was intact. So what we did was we chose to stimulate unilateral anal sphincter or unilateral MEP stimulation. So when we stimulated the opposite side, you can see that the lower limb leads are still lost. The IONM, the MEPs are still lost, but the anal sphincter is intact. The opposite side is the same side, the MEPs are not getting recorded as expected. But when we stimulated the opposite side, the MEPs from the lower limbs and the anal sphincter were intact. So in this way, we could differentiate that the anal sphincter was not because of direct, spread because of proximity. So it was actually a true drop in lower limb MEPs. And then we warned the surgeon, and he irrigated with warm saline, removed the retractor, and then you can see that the MEPs are slowly coming back, and this patient woke up without any neurodeficit. So in this case, we tried to do unilateral anal sphincter MEP monitoring, and we could map that if we even stimulate unilaterally, we can get anal sphincter MEP responses. So this was an interesting case which we published. So to conclude, IONM in pediatric neurosurgery is safe and it betters the outcome by preventing neurodeficits. Understanding of anatomy, physiology, and age-related changes is very important in this pediatric population who come for IONM. So this is the summary of all the procedures which are commonly performed in pediatric pediatric neurosurgery with IONM, and each modality, what are the anesthetic agents that we can use and avoid. It's all summarized in this table. So all these tables are present in this review of literature which we published last year. I can share it with you if you write to me. This is my email ID. Please feel free to write to me. I can share the reference and the article as well. So all the concerns about pediatric IONM have been addressed in this review article. Thank you so much. Thank you for the opportunity, and hope you all are safe.
Thank you, Dr. Nitin, for a very lucid presentation. You made a complex topic look so easy. I hope after hearing your talk, more and more neuroanesthesiologists are able to incorporate the IONM monitoring in their pediatric neurosurgeries. Thank you.
Thank you, Dr. Rahul. Thank you.
Yeah, I will like to invite our third speaker, Dr. Sriganesh Kamat. Dr. Arvind, please introduce him. Thank you.
It's my privilege to welcome Dr. Sriganesh Kamat. He's a very dynamic person and good, excellent academician. He's right now working as a professor in the Department of Neuroanesthesia and Neurocritical Care at IMS, Bangalore. And he will be speaking on a very good topic. That is the airway management in the neurosurgical patients. It's always a challenging to manage the airways, particularly in the pediatric age groups and in the trauma patients. So over to you, Dr. Sriganesh, for your topic.
A very good morning to all. I bring greetings from NIMHANS, Bangalore. At the outset, let me thank the organizers of ISNACC 2022 for inviting me to speak on airway management in neurosurgical patients. This is the learning objective of this presentation, to know about the airway concerns in neurosurgical patients, how to assess the airway, challenges that are likely to be seen in the airway management and maintenance, and approach to airway management in specific neurosurgical conditions, and lastly, end with extubation concerns and measures to overcome them. So the airway management in neurosurgical patients impacts the intratracheal homeostasis and neurological outcome. And over a period of time, the expansion of neurosurgeries has enhanced the airway challenges for the anesthesiologist. The airway concerns are more in emergency neurosurgery as compared to elective neurosurgery. But in elective neurosurgery, the management has to be individualized based on the pathology such as acromegaly or cervical spine disease, and surgery such as spine surgery, etc., where the posterior fossa surgery, where the concerns are likely to be different. Overall, airway management in neurosurgical patients require careful planning, optimal preparation, and deft performance for successful outcome. So the airway in neurosurgical patients is slightly different for management as compared to non-neurosurgical patients. And we all know that any airway misadventure in these patients can lead to hypertension, hypotension, hypoxia, and hypercarbia, which can affect the intratracheal dynamics, such as aggravation of the raised intratracheal pressure and compromise in the cerebral oxygenation and perfusion. And therefore, it is important to ablate cardiovascular and intratracheal response during airway management using titration of the anesthetic drugs and dosage. And lastly, smooth and swift airway management, both at intubation and extubation, is vital to minimize the impact on intratracheal dynamics. Now, what are the airway concerns in elective neurosurgery? This is broadly, I have mentioned what are commonly encountered problems. One is the cervical spine pathology, such as atlantoaxial dislocation, ankylosing spondylosis, rheumatoid arthritis. All these patients require good assessment and preparation to prevent any airway problems. Remember that patients who have undergone temporal or frontotemporal craniotomies earlier can manifest with pseudoankylosis of the temporomandibular joint. Similarly, patients who have undergone transnasal transmural surgery or have CSF rhinorrhea can be a challenge for mask ventilation, which can lead to pneumocephalus or infection, and therefore modified rapid sequence induction in these patients is desirable. In children, the complex airway challenges can be complex because of the large head, presence of encephalocele, and syndromes associated with the pediatric neurosurgical conditions. Any abnormal position during surgery can result in challenge in maintaining the airway in secure position, and also there may be a need to rescue the airway when there is a airway complication. And lastly, a good extubation plan is necessary, and the management after extubation has to be understood by all the stakeholders for good outcomes. Now, this slide summarizes the airway concerns in emergency neurosurgical patients, especially those with traumatic brain injury. You have a patient with the raised intracranial pressure, and it can get aggravated during airway management. A patient who is comatose, not responding, airway assessment is not possible. The airway is not certain. We don't know whether there is blood, secretions, food particles in the airway, and that is only seen when we do a laryngoscopy. There can be extracranial injuries associated, such as cervical spine injury and maxillofacial injuries, which can create problems during mask ventilation and intubation. And the physiological difficult airway is when there is desaturation, hypotension, and this can lead to intracranial dynamic changes, which are detrimental to a good outcome. Coming to the airway assessment in neurosurgical patient, a good thorough evaluation is necessary irrespective of the anesthetic technique that you're going to adopt. We need to identify patients with difficult mask ventilation and intubation. Remember that complete airway assessment may not be possible in patients because they are subnormal, they have subnormal consciousness. It could be pediatric neurosurgical patient, supine position because of traction, airway assessment in supine position may have to be performed, and the complete range of cervical spine movement cannot be assessed. And in these situations, radiological assessment may add on to the information regarding difficult airway. The clinical assessment generally involves this lemon criteria for identifying difficult airway. You look for facial trauma, incisors, mustache, large tongue. Then the 3-3-2 rule, 3 fingers for interincisor gap, 3 finger between the hyoid and the mentum, and 2 finger between the thyroid and the base of the mouth. And the Mallampati assessment from class 1 to class 2. And O is self-explanatory, obstruction because of epiglottitis, abscess, edema, trauma, etc., and neck mobility. In patients with pituitary lesions, acromegaly, also there can be some additional challenges. A large tongue may be present, a large teeth may be present, the oral intensor distance may be narrow. There could be a decrease in the temporomandibular, the thyromental distance. Neck circumference may be large. The limited mobility of the cervical spine, especially with regards to extension. The upper lip bite test also provides some idea about a difficult airway in neurosurgical patients. And in supine patients, we need to perform the Mallampati grade assessment in supine position. Cervical movement assessment is difficult, and but Mallampati grade has been tested in supine positions as well and shown to predict a difficult airway in if not better than upright position. Because of the COVID times, virtual assessment of the airway has been attempted, and this particular study from Srichitra has shown that it is feasible to perform virtual airway assessment. And when these clinical assessments are not possible, or to add more information to the clinical assessment, radiological assessment are performed. This is the flexion extension X-ray of the cervical spine, and this is the chest X-ray, which gives us more information regarding the likely challenges in airway management. Here you can see that there is, because of the pulmonary fibrosis, there is a deviation of the trachea, and here you can see a large bullae which can positive pressure ventilation can result in rupture and then result in airway complications, respiratory complications. So we need to be mindful of this and utilize the lung X-ray, chest X-ray also to plan your airway management. CT MRI are generally performed for primary pathology, be it brain lesion or a spine lesion, and they also provide us information on the airway problems, the tracheal dimension, the epiglottis size, the size of the tongue, the space, the uvula. and that will help us in planning our airway management better. And lastly, bedside ultrasonography is now commonly used for assessment of airway in neurosurgical patients as well. The specific neurosurgical population present with unique challenges, and these need to be understood, especially in pediatric neurosurgery, traumatic brain injury, spine surgery, aneurysm surgery, pituitary surgery, stereotactic surgery, awake craniotomies, and posterior fossa surgeries. We look at them one by one. Hydrocephalus can result in challenge both physiological difficult airway and anatomical difficult airway because of the malalignment of the laryngopharyngeal axis, and physiological because of the further increase in ICP during airway management. Patients with occipital and frontal encephalocele can present difficulty in mask ventilation and in intubation. This patient may require intubating in the lateral position. Patients with craniosynostosis can have some facial dysmorphism because of the syndromes associated with that, which can make airway management difficult. Now, especially with patients having encephalopathy in children, both mask ventilation and intubation can be difficult because of the associated problems such as hydrocephalus, clipperfill, and subglottic stenosis and micrognathia. And as I mentioned, intubation, lateral position, platform, rolled blanket, urinary laryngoscope use may be required. And also the care during the procedure per se, and also at the end of the surgery during extubation needs to be taken. There is no best or safe technique for airway management in traumatic brain injury. It depends on the urgency of the situation, the expertise, the skill that the operator has, and the resources that are available at that particular point of time. The usual practice is to perform oral intubation using manual inline stabilization with rapid sequence induction and precord pressure. Both succinylcholine and roculine have been used in these scenarios. When the patient is already intubated, it's always advisable to reconfirm the airway and oxygenation and ventilation, because especially when it's performed as a casualty by a non-anesthesiologist. Secondary insults should be avoided during airway management, especially hypotension, hypercarbia, hypoxia. Newer gadgets such as video laryngoscope, ventilating bougie can facilitate faster intubation without any secondary insults. The spine pathologies, especially chronic spine pathology, can be associated with poor pulmonary reserve, myelopathy, and elderly. These patients are elderly. So video laryngoscope may be a better choice in this particular patient. Whereas in acute cervical spine injury, there is further risk of neurological worsening, autonomic instability, and airway management may be emergent or urgent. In these situations, awake fiber optic intubation or awake intubation with laryngoscope, video laryngoscope may be preferred, and this will help us in assessing post-intubation neurological status as well. But there are certain challenges. Airway assessment becomes limited in cervical spine patients. The airway can be difficult because of the spine immobilization from hard collar traction or manual stabilization. And lastly, we need to prevent cervical spine movement during airway management, which results in
There's an interruption in the feed. The connection is lost with Dr. Sriganesh.
Organizers has to continue. Actually, Sriganesh is available here, but this slide sharing has been stopped.
In these situations, alternative intubation gadgets should be explored. And in this particular study, we compared video laryngoscope with fiber optic scope and found that the degree of cervical spine injury is not significantly different, and no patient developed new neurological deficits after intubation. And this was again also seen in where we compared fiber optic intubation with intubating laryngeal mask airway assisted awake orotracheal intubation. Again, this was found to be equivalent. So video laryngoscope or intubation through a intubating laryngoscope is feasible without any additional risk of neurological injury in patients with unstable cervical spine where fiber optic intubation is not possible for any reason. In this study, we evaluated the opinions of anesthesiologists for performing intubation for neurosurgical procedures, and the reasons for choosing a particular intubation technique was the familiarity and availability, and less likely to produce neurological changes. These were the three most common reasons for choosing one particular intubation technique. And when the respondents were asked which airway maneuver is likely to result in maximum cervical spine movement, majority of them mentioned that it was chin lift, jaw thrust, and head tilt. and the least maneuver that is likely to cause cervical spinal loss, awake fiber optic intubation. The next, moving on to aneurysm surgery, there is one report which mentioned about rebleeding during airway management, and therefore care has to be taken while securing the airway in aneurysm patient. There could be large glottis, hypertrophy of soft tissues, and limitation of mobility. None of the conventional airway assessment tools predict difficult intubation, and these patients are likely to develop post-extubation laryngeal bronchospasm because of the clogging of the airway after surgery, airway obstruction, desaturation, resulting in re-intubation. Remember that the nose is packed in this patient, and after extubation, if there is a need for re-intubation, remember that patients can have schizophrenia, which can lead to pneumocapillus after during because of the mask combination. The next surgery is stereotactic neurosurgery. The mask ventilation can be difficult, as you see on the left side of the screen, but intubation is generally not difficult because of the newer stereotactic frames. However, a balance between sedation comfort and likely respiratory problem because of sedation and need for emergent airway has to be kept in mind. Awake craniotomy can lead to problems requiring airway intervention. The asleep awake asleep technique can be challenging, especially airway removal and reinsertion. Most often airway intervention is performed to protect secretions or manage seizure, uncooperative patient, and procedural complications. To rescue airway compromise from oversedation or ictal apnea, to reduce brain swelling from hypoventilation and desaturation. But there are certain obstacles for emergent airway management during awake craniotomy. The presence of the Mayfield head clamp restricts the head and neck movement. Need for maintaining sterile operative field, non-availability of space at the head end, fixed or extended fixed head position, and acute changes in neurological cardiorespiratory status is likely, which warrants a quick airway management in patients requiring emergency airway management during awake craniotomy. The most commonly used gadgets are supraglottic airway devices and video laryngoscopes. This is an example of apnea during awake craniotomy and how high flow nasal oxygen can prevent desaturation and airway obstruction, need for reintubation and management during seizures. Post-exposure surgeries per se may not present difficulty in securing the airway, but there are certain issues that we need to take into account during airway management. Remember that airway reflexes are poor, so judicious extubation decision has to be made. Most of the time, post-exposure surgeries are performed in non-supine position. The choice of tube becomes important. Mostly we use the flexometallic tube. And when certain conditions warrant awake intubation and awake positioning, this has to be considered using comfortable drugs such as dexmedetomidine. And there can be multiple neurofibromas in the airway in patients with CP angle lesions. This also needs to be one needs to be aware and plan for management, especially when you look at the images. The last part is next part is regarding airway complications during neurosurgery. This table lists the potential complications in the perioperative period: postoperative airway obstruction, accidental disconnection, accidental extubation, kinking of the tube both internally and externally, bite injuries, dental injuries. The likely cause, the manifestation, and possible solutions are informed here. The choice of airway and complications, LMA has been used in neurosurgery, but it may not be suitable for all types of surgery, especially V patient surgery, where we observed the loss of ventilation because of the extreme neck rotation and tunneling in these patients. So judicious selection of airway is important. Similarly, if the patient is likely to be sent to ICU on tube, then it's better that we select a subglottic suctioning tube so that the incidence of ventilator pneumonia can be reduced. Now, during intubation, so there can be a dental injury, and however, it has to be identified and rectified immediately. Similarly, temporomandibular joint dislocation can occur during intubation, and again, this needs to be identified promptly to prevent long-term side effects. The other common complication during prong neurosurgery is tube kinking, especially with fish hook retractors, abnormal neck positioning, and especially when intraoperative neuromonitoring is used, motor potential especially, and no muscle relaxants are used. Also, the use of transdiaphragmatic echocardiography can result in airway obstruction, especially at the tip where it is very soft in flexometallic tubes. Then there can be position-related complications, especially in sitting position, prone position, and
मैंने
lateral
देखा नहीं है पेशेंट
rotation,
कोई कोमोबिलिटी से
and kinking of the
इको हुआ है उसका
tubes, rail tube,
अच्छा
which can
अच्छा
induce
नहीं मतलब डिलीरियम कितना है उसका
and then lead to post-operative complications. Hemodynamic complications are commonly seen despite adequate depth of anesthesia and good doses of analgesia, and these can have adverse impact on patients with raised intracranial pressure or intracranial aneurysm. Last part is regarding the extubation concerns. Again, it has to be swift and smooth like intubation, and hemodynamic activation can result in brain edema, hemorrhage, delayed awakening, additional investigations, redo surgeries, and poor neurological outcomes. Therefore, ablation of this response has to be taken care of by using lignocard, additional opioids, continuing dexmedetomidine sedation, and deep extubation. But remember that neurosurgical patients, especially those undergoing posterior fossa surgeries, have a higher incidence of pneumonia and reintubation. And if reintubation is required, airway can be difficult because of macroglacia, orofacial swelling, airway edema, obstruction, pseudoankylosis, lower cranial or recurrent pharyngeal palsy, cervical fusion, and brainstem dysfunction. Now, certain intubation characteristics can inform the likelihood of difficult extubation, such as number of attempts, number of persons involved in intubation, number of alternative technique used, Cormack grade, lifting or force or laryngeal pressure, and vocal cord mobility. This is known as the intubation difficulty score. This will help us in identifying patients who are likely to have a difficult or problems with extubation. Now, the awake versus deep extubation has been debated. There are certain advantages, disadvantages of either technique. At awake extubation can provide immediate neurological assessment, whereas it can result in hemodynamic activation and consequently intracranial dynamics changes can occur. Deep extubation provides smooth, pain-free awakening without any significant systemic or intracranial dynamic fluctuations. However, the disadvantage is inability to assess neurological status and potential for aspiration and airway obstruction. Reintubation after neurosurgery is a challenge. The common causes are neurological deterioration, respiratory distress, unmanageable secretion, and seizures. This can be prevented to some extent by careful patient selection for on-table extubation, adequate and complete neuromuscular blockade reversal, ensuring return of consciousness and recovery of swallowing and airway reflexes. Despite that, there can be possibility of reintubation, and this has been documented in patients with cerebral hemisphere pathology. Lastly, I'll take you through quickly through the flow charts for airway management in elective craniotomies. Remember that we need to avoid hypo or hypercarbia, hypoxemia, hemodynamic appeals in patients to prevent further aggravation in raised ICP, and also to prevent rebleeding aneurysm surgeries. If the craniotomy in patients with difficult airway, awake fiber optic should be considered. And if mask ventilation is easy, video laryngoscope or asleep fiber optic intubation should be performed. If the awake craniotomy is planned, then keep supraglottic airway devices ready and be prepared for emergent airway. Intubation strategies for cervical spine depends on the awake intubation or asleep intubation. For awake intubation, good preparation is important. Remember that airway assessment is possible in this, whereas in asleep, it is neurological assessment is not possible. Common immunization techniques have their own disadvantages, and the intubation technique which produces the least cervical spine movement should be selected. Lastly, extubation strategies for elective craniotomies: avoid common problems that occur: hyperoxia, hypercarbia, hypoxia, hemodynamic appeals. Extubate when extubation criteria is fulfilled, that is, patient is conscious, gag and cough reflexes are present, breathing is regular, good tidal volume and rate, and neuromuscular blockade is completely reversed. In difficult airway, be prepared for complications, keep tube exchanger ready, and if all these attempts fail, then tracheostomy can be performed. To summarize, difficulty in securing the airway remains a major cause of anesthesia-related morbidity in neurosurgery. Airway management, including extubation, can be challenging, and one has to be prepared. And the key for successful intubation and extubation and overall airway management in neurosurgical patients is adequate knowledge about airway anatomy, anticipating problems, a good assessment of the airway, prepare for a difficult airway, obtain essential skills for securing the airway, and have adequate resources that are essential for safe airway management in neurosurgical patients. Thank you very much for your patient hearing.
Dr. Arvind, you are not audible. Please unmute yourself. Yeah.
Thank you, Dr. Sriganesh, for very nice presentation, and it was a very elaborate discussions about the airway management of neurosurgical patients. The house is open for the discussion. We are not seeing any question in the chat box.
Since all the three speakers are there online, so any questions can be asked from any of the three speakers.
I think there was a comment by Dr. Nidhi about the trends of optic nerve monitoring, but I also don't see any questions in the chat box.
Yes, ma'am. Dr. Nidhi had rightly said that in the ONSG measurement, it is a trend which is more important than a single reading in the prognostication and management. We all agree to that, ma'am.
Yes, yes.
My question is to Dr. Ashish. If we ask for one single monitoring for bedside monitoring for such patients, what will be your choice?
Dr. Arvind, thank you for the question. This is the most popular but a most difficult question to answer. So what is the single best? So probably single best is ICP in the settings where we have an ICP, and number two would be a TCD monitor.
Okay, thank you.
Yeah, but I have just described it in 2 words because probably that was the answer you asked from me. But I think it's a difficult and a long question.
Hello.
Yeah, there's no gold standard as far as monitoring, because there, as you had rightly brought out, invasive, non-invasive, and what specific parameter you want to monitor, and most important is availability and the familiarity.
Pathophysiology, I think, stands at the first. Then is the feasibility and availability of the monitor, and third is your choice.
Hello.
Dr. Ashish, between brain tissue oxygenation and cerebral microdialysis, which have you found more useful out of the two? Because we are always strapped for funds everywhere other than elite institutes like AIIMS, and we would like to know your views on this.
Okay, ma'am, thank you for the question. Ma'am, we don't have a PBTO2 monitor. So personally, I've used cerebral microdialysis monitor. So my experience is cerebral microdialysis is not it's not an easy monitor. Despite its cost, there is lots of labor which is associated with the cerebral microdialysis, doing it hourly. This is my experience from the literature. I think PBTO2 currently is has more literature which supports its use in neurocritical care settings vis-a-vis cerebral microdialysis catheter.
Thank you. And do you think that jugular venous oximetry is falling by the wayside? I see less and less papers coming out of late on that subject.
Right, ma'am. You are very right in saying so, because JVO2 monitoring as per was just introduced, and it is a part of BTF guideline for hyperventilation, but less of literature is available on it, and probably less of studies are indicating its usefulness in day-to-day management of TBI patients.
I think you are very right.
Thank you all. Now we are going to start the next session as we have shortage of time.
Thank you. Thank you, ma'am.
Thank you, speakers, and thank you, organizers, for having us here today.
Thank you all. Now, welcome you all to the inauguration ceremony of the 23rd Annual Conference of Indian Society of Neuroanaesthesiology and Critical Care. A very good morning from Kolkata, the city of joy. To begin with, I would like to welcome Professor Dr. Nidhi Panda, President ISNACC and Head Neuroanesthesia Division, Postgraduate Institute of Medical Education and Research, to preside over the ceremony. I also call upon respected Swami Atma Priyanandaji, Pro-Chancellor Ramakrishna Mission, Vivekananda Educational and Research Institute, to grace the occasion as chief guest to the ceremony. I also invite upon Professor R.P. Sengupta, OBE, Chairman and Managing Director of Institute of Neurosciences, Kolkata and National Neurosciences, Kolkata, to grace the function as guest of honor. I now invite Dr. B. Punaya, Secretary ISNACC. Good morning, sir. I also invite Treasurer ISNACC, Dr. Prasanna Bitkar. I extend a warm welcome to Professor Pramod Vittal, Editor-in-Chief JANEC, and Professor H.H. Desh, Founder Member of ISNACC. A pleasure to welcome our very own Professor Bibu Kalyani Das, Organizing Chairperson, ISNACC 2022 on screen. Finally, I welcome Dr. Indranil Ghosh, Organizing Secretary, ISNACC 2022. To begin with, I would like to invite Professor Bibu Madam to welcome the dignitaries, faculties, and delegates.
Thank you, Aisha, for those kind words. Revered Swamiji Sri Atma Priyanandaji Maharaj, Chief Guest of this occasion, Honorable Professor R.P. Sengupta, OBE, Guest of Honor of the occasion, Professor Nidhi Vidyut Panda, President ISNACC, Professor Pramod Vittal, Chief Editor of Journal of Neuroanesthesia and Critical Care, Dr. V. Punaya, Secretary of ISNACC, and Dr. P. Bitkar, Treasurer of ISNACC, and Dr. Indranil Ghosh, the Organizing Secretary of ISNACC 2022. Invited faculties and dear delegates, good morning to all of you. On behalf of the organizing committee, I welcome you all to the cultural capital of India, the city of joy, Kolkata. At the outset, I must extend sincere gratitude to the executive committee and the general body of ISNACC for giving us the opportunity for the third time after long 12 years. We are very enthusiastic to have it in the physical platform, but unfortunately, due to the COVID-19 pandemic, we have to shift to virtual one. I'm sorry that you will have to miss the hospitality for which Bengal is famous, mostly the gastronomy and the sightseeing. But the scientific program has been excellently designed by our scientific committee, considering the theme of the conference, envisage, innovate, and implement the art of neuroanesthesia and neurocritical care. Eminent faculty from abroad and from various parts of India have been involved. There will be workshops which will be conducted by experts in the specific fields. Hope you will cherish the academic feast. I am confident that the virtual conference will be as good as the physical ones. Our event management team, led by Madam Sanghamitra, are trying hard to leave no stone unturned to have this conference a great success of this. Once again, I thank all of you for your active participation to make this event memorable. Long live ISNACC, Jai Hind.
Thank you very much, Madam. I now invite all dignitaries to participate in the virtual lamplighting ceremony and welcome song.
तुषार हार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना.
I now welcome Professor Nidhi Panda Madam, National President ISNACC, to say a few words. Madam, you're muted. Please unmute yourself.
Sorry. Good morning, everyone. It is a proud moment for me as the President of Indian Society of Neuroanaesthesiology and Critical Care to welcome Swami Atma Priyananda ji, Chief Guest of the inaugural function, Professor R.P. Sen Gupta, Guest of Honor, Professor H.S. Das, Founder Member of ISNACC, Dr. V. Ponaya, Secretary ISNACC, Professor Prasanna, Treasurer ISNACC, Professor Pramod Vittal, Editor-in-Chief of ISNACC, Professor Bibhu Kalyani Das, Organizing Chairperson, Indranil Ghosh, Organizing Secretary, all national and international faculties and participants of 23rd Annual Conference of ISNACC 2022. In history, a small group of anesthesiologists in India practicing mainly in neurosurgery OT and taking care of neurological patients planned to develop neuroanesthesia subspecialty. With their dedication and unlimited effort, Society of ISNACC was established in the year 1999. Professor H.S. Das, Professor Uma Maheshwar Rao, Professor Mary Abraham, Dr. K.J. Chaudhary are few of the founder members of the society. Since that time, ISNACC is growing steadily and helping the anesthesiologists working in the field of neuroscience to improve the quality of care of the neurological and neurosurgical patient. The membership of the society is growing steadily and has crossed 800 in number. Neurocritical Care Society of India has been established in 2020 under the aegis of ISNACC to improve the knowledge in the field of neurocritical care. Second Conference of Neurocritical Care Society of India was organized by NIMHANS Bangalore in 2021. It provided excellent academic inputs which benefited all the young and senior neuroanesthesiologists and neurointensivists. In addition, ISNACC is very active in various training programs. Under the aegis of ISNACC, postdoctoral fellowship program, both in neuroanesthesia and neurocritical care has been started and is going on successfully to train the anesthesiologist in the field of neuroscience. Various classroom programs are also going on under the aegis of ISNACC to improve knowledge of the student doing DM, DNB, PDF courses in neuroanesthesia and neurocritical care. ISNACC encourages research in the field of neuroanesthesia and neurocritical care by providing research grant to the neuroanesthesiologists who are interested in good quality clinical research in the field of neuroscience. Our society also encourages students to present their research work in the international forum by providing travel grant. Acute neuro care program was planned, established and carried out by ISNACC in various cities of India to create awareness about proper care of the patient with acute neurological emergencies. Even during the challenging time of COVID era, journal under ISNACC Society is published regularly under the able leadership of Professor Pramod Vittal. With these words about the society, I welcome you all to 23rd Annual Conference of ISNACC 2022. Though we all will miss hospitality for which Kolkata is well known, we will be enlightened by the academic content of the conference. During this conference, advances in the field of neuroanesthesia and neurocritical care are presented by national as well as international faculties. These topics are discussed in length, which helps the delegate to incorporate these in their routine practice to improve patient care. I wish good luck to the organizer of the conference, ISNACC 2022, to conduct a very successful conference with excellent academic contents. Thanking you.
Madam. I now invite Dr. Puneya sir, Secretary SNACC, to say a few words.
Thank you, madam. Good morning, all the dignitaries on the dais, esteemed Chief Guest Swamiji, our own dear Bibu Madam, Indranil, Madam President Nidhi Panda, and all the dignitaries on the dais. It's indeed an honor to be associated with ISNACC and serving as a secretary. The last 2 years, unfortunately, due to this COVID scenario, we are not able to do a physical meeting, but that's not stopping us from exchanging our knowledges on the ever advancing field of neuroanaesthesiology and neurocritical care. As you all are aware, how the medical specialties branches and sub branches, ultimately the final beneficiaries are the patients whose quality of life and whose standard of care is going to get improved. And with this highly subspecialized branch of neuroanaesthesiology and neurocritical care, we form an integral part of the entire neurosciences, along with neurology, neurosurgery, and neurocritical care, and other allied specialties of neurorehabilitation. Our job starts from the pre-operative area till the patient gets discharged from the hospital, including as a neurohospitalist. The branch has evolved into various territories of the hospital, and thereby in areas where we were not able to give a very good outcome, now we are able to give that with the help of understanding the knowledge of anesthesia and the critical care and implementing in the neurosciences. So with this regard, a lot of juniors from the anesthesiology are taking this subspecialty, and more importantly, this subspecialty is intruding into the peripheries of India also, and that is an extremely happy situation, because most part of our population live in the peripheries and they should be given the proper care or the standard care for which they are eligible for. And this conference will serve as a model to reach each and every practicing anesthesiologists who are interested in neuroanesthesia and neurocritical care. Thereby, they enhance their knowledge, implement and apply in practice, and finally aim for a better patient outcome. I wish the organizing committee, chairperson, secretary, a very grand conference, and it's already the topics are very interesting, and there's a great discussion which is happening, and I'm sure that it is going to be a great event. Madam, really we miss meeting you physically in the Kolkata and enjoying the Kolkata hospitality. I think soon it will be a reality. Anyway, this virtual meeting has given us an opportunity to interact, and this is going to be a great success. Thank you, madam.
For your kind wishes. I will now welcome Professor R.P. Sengupta, OB, guest of honor, to grace the occasion through his video message. Please play the video message.
Dear friends, my heart fills with joy to say a few words to this wonderful gathering of the neuroanesthetist and neurointensivist. I would have preferred to be with you, albeit virtually, but at the age of 86, And at the time of 4 a.m. in England, I am with you at least through a video message. As a fossilized neurosurgeon now, I do not have much useful knowledge to share with you. So I resort to some of my own experience to appreciate the importance of neuroanesthesia and neurointensive care. As a neurosurgeon, I was working in England for nearly 50 years, being an Indian senior registrar, indulging in difficult neurosurgical operations such as intracranial aneurysms was frowned upon by many consultants. However, there was a kind-hearted neuroanesthetist by the name of Dr. Douglas Whitby who observed that if I had any chance of promotion to a consultant level, I had to prove my surgical skill. Dr. Whitby told me that I should take as much time as required for surgery, but do it carefully. Apart from his patients, he would check the patient very frequently to ensure there was no problem. Dr. Whitby was in fact the first neuroanesthetist in England who dedicated to neuroanesthesia only. Although infrequently, I had the opposite experience too. Once I was operating on a small acoustic neuroma in a young lady who was in fact a secretary to the ENT consultant. There was some visiting neurosurgeons who came to see how I save not only the facial nerve, but also the acoustic nerve. But the patient never woke up from surgery and died few days later. It transpired that there was a sudden drop in blood pressure during the operation. The inexperienced anesthetist did not appreciate the air embolism and did not alert the surgeon. In another case, I operated on a difficult tumor. The patient was fine after the operation. However, because of the long anesthesia, it was decided to keep the patient in the ICU overnight. I saw the patient at 11 p.m. and she was fine. The next morning, the patient was found dead because nobody realized that the endotracheal tube was in fact blocked. As a neurosurgeon, we really act as a skillful plumbers to repair the damaged part in the brain or spine. We cannot concentrate on the physical survival of the patient. With an experienced anesthetist on the other side of the table, the surgeon knows that the patient would remain safe and he can give all his attention to the damaged part of the organ. Similarly, when the patient is in the ICU under a dedicated intensivist, the surgeon can have a peaceful night. This type of experience tells any neurosurgeon the role of neuroanesthetist and neurointensivist in the success of surgery. Neuroanesthesia or neurointensive care is quite different from anesthesia or general ICU. The crucial reason for the difference is that neurosurgery or neurology, a patient's conscious level is often altered. He may not be able to protect his own vital organs and may become totally dependent on the intensivist or anesthetist. Moreover, each region of the brain controls each vital organ, such as heart, lung, kidney, endocrine, and others. A neuroanesthetist and intensivist has all the knowledge and thus distinguishes himself from others. Despite such an important role in the success of recovery, the credit unfortunately goes to the primary clinician or surgeon. Understandably, the patient and their relative only knows their consultant to whom they go with their problem. In my view, this is totally unfair. There is, however, an opportunity to rectify this. If the anesthetist, during the time of pre-medication, explains his role to the patient and his relatives and sees the patient in the post-operative days, his role will be much appreciated. For the intensivist, the methodology is exactly the same. It is no good to have a first-class brain and a second-class ambition. Please wake up. The power is in your hands. I know many brilliant scholars in neuroanesthesia, neuroscience, in intensive care from all parts of India assembled here today, albeit virtually. I know many young specialists and trainees who are here to listen to these scholars. Over the 2 days of scientific program, you will hear all the pearls of wisdom from these jewels in the specialty, learn from the masters. In addition, I hope my own experience will stimulate you to think and learn from your elders. Nowadays, there is a tendency for the anesthetist to rely on the most sophisticated gadgets to monitor the vital functions of the patient undergoing surgery. The anesthetist may be out of the room carrying out other work and instruct the nurse or technician to call them if there is any change. But as a neurosurgeon, I can tell you that the surgeon's anxiety is only relieved when he sees the anesthetist on the other side of the table. And if he or she is handsome or a pretty one, as the case may be, it is even better. Finally, I congratulate Professor Vibhu Das, Dr. Indranil Ghosh, and their associates of ISNACC to organize such a wonderful gathering despite the ravage of the pandemic. And I'm grateful to them to give me the opportunity to tell you some of my own stories. Unfortunately, you cannot enjoy the beauties of the City of Joy and our Institute of Neurosciences, but invite you to do so when it is safe. Thank you for your time.
Thank you, respected sir, for sharing your valuable experiences with us. I would like to announce that this year, Dr. Anil Parekh has been bestowed upon with the Distinguished Professional Service Award. I would like now please the slide of the students here. I would like to announce that the students on your screen are the ones who have qualified for the PDF in neuroanaesthesiology and neurocritical care following their online examination 8th and 9th of January 2022. Please show the list. As you can see on your screen, I would also like to announce that Dr. Mridula Kuttarkar from Jaslok Hospital has been awarded the Outstanding Student Award. Congratulations to her, to Rashi Madam, for all the great efforts. I now welcome you all for a special felicitation ceremony of Professor R.P. Sengupta, OBE, and Professor Amna Goswami, eminent neuroanesthesiologist and former HOD, Bangur Institute of Neurosciences, Kolkata. Please display the CV of Dr. R.P. Sir. As you can see, graduation from Kolkata University, FRCS, Edinburgh, FRCs from different places, National Neurosciences Center. He is the chairman and the managing director, founder. Yeah, next slide, please. Yeah, next. Yeah. Next slide. Yeah, see, BBC documentary is made on his life. Next. Surgical theatre has been awarded, dedicated to Robinson Gupta at NHS at Newcastle General Hospital. He has been awarded by the Neurosurgical Society of India for his contribution in neurosurgery. Change. He founded Institute of Neurosciences, Kolkata. He's founder, chairman, and managing director. Next. Next. He's been awarded by Vivekanand Samman Award by President APJ Abdul Kalam Azad. Next. Been awarded as a Lok Kalyan Award by the International Gita Foundation Trust. Next. Medal of Honor by WFNS. Next. Next. Okay. That is the World Federation of Surgical Societies. He is conferred upon Doctor of Medicine by University of Newcastle upon Tyne. Next. Last but not the least, is awarded by Officer of British Empire Award by the Queen of England for his services to the people with neurological disorders. These are the, these mementos. Now, Professor Amna Goswami needs no introduction. She finished her MBBS from Kolkata, then his diploma in anesthesia and MD from Kolkata. He was RMO cum clinical tutor in Kolkata. After that, he's promoted to professor and head of the department in 1988. He started pain clinic in 1983. Along with Bibu Madam, she made the department into a state-of-the-art one. And she is the past president of the ISNACC, ISA, and ANEI. At present, after her retirement, she is attached to the Park Clinic, where she is attached till date. She is also coordinator of the PDCC in neuroanesthesia in the Park Clinic. Yeah, show the next, please. These are the memento and the gifts for Madam.
Thank you.
I would like now to invite respected Professor H. Dash to facilitate Professor Sen Gupta and Professor Amna Goswami.
Good morning, everybody. Thank you very much for inviting me to facilitate the two doyens, one in the neurosurgery and the other in neuroanaesthesiology. It is a great pleasure on my part to hand over the memento, of course, virtually, to both the eminent people in their respective field. First, I'll just say a few words pertaining to these two tall individuals. Robin Sengupta, I think when I saw his name, RP stands for Ram Prasad. This is, I think, an unusual name in Bengal. I was thinking probably the people with unusual name will rise to the greatest heights, like what Dr. Robin Sengupta has done both in England as well as in India. I think I consider him, first I was considering Professor A.K. Banerjee, one of his best friend, as the Bhisma Pitamaha, but here I think he's a person who is the Bhisma Pitamaha of England as well as India. I pray the Almighty to shower all his blessings on Professor Robin Sengupta so that he goes on with his technical skill, which I think everybody knows, and particularly I think I know very well because I was the anesthetist when he was demonstrating one ruptured intracranial aneurysm. All our All India Institute surgeons, they were dead scared, but he came, sat calmly and quietly, drained the CSF, and then slowly he operated and did a wonderful job. I'll never forget that. Thank you very much, sir. And coming to Madam Amna Goswami, she is the live air of our society. She is always full of with enthusiasm and energy. And her gifts in every conference is like it is the blessings from Mother Mary, or maybe she comes like Santa Claus. Be in the academic or be in the entertainment arena, she is always very vibrant. And I pray the Almighty, please keep the smiles in her face for years to come. Madam and Dr. Robinson Gupta, wish you all the very best in your future. Thank you very much.
Thank you very much,
Hand over.
sir. Thank you very much. I now request respected Swami Atma Priyanandaji to bless us with his kind words of wisdom. Pranam Guruji.
Om yaschandasa mrishabho vishwarupah छन्दोभ्योऽध्यमृतात् सम्बभूव समेन्द्रो मेधया स्पृणोतु अमृतस्य देवधारणो भूयासं शरीरं मे विचर्षणं जिह्वा मे मधुमत्तमा कर्णाभ्यां भूरिविश्रुवं ब्रह्मणः कोशोऽसि मेधया पिहितः श्रुतं मे गोपाय ओम शांति 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 हरि ओम तत्सत. This is a mantra from Taittiriya Upanishad, and Bhagavan Bhashyakara Shankaracharya, he says this mantra is chanted for Medha Vriddhi. Medha is a very interesting concept in Indian spiritual wisdom, in Vedanta, and Medha is associated with subtle nervous purity and nervous attunement and appreciation of higher spiritual truths. The physical nerves which with all of you are dealing has a subtle spiritual counterpart. Swami Vivekananda discussed it elaborately in his Raja Yoga, which created a great sensation in his time, so much so many neurophysiologists, anatomists, psychologists like Sir William James, all of them became excited. William James wrote a book, Varieties of Religious Experience. So nerves form a very, very important component in spiritual experience. It is not the physical, muscular, and other parts of the body becoming strong. When you say the physique should be very strong, it is the nervous system which has to be strong. Very often, we always, common parlance, we have nervous breakdown. So that means your mind becomes weak and your nerves fail. And nerves are the most important. We always say, he is the nerve current of the whole organization. So all of you are doing extraordinarily great service in the nerves, which is the subtlest and perhaps therefore the most difficult. And anesthesia has always given me great wonder, although I have been trained as a particle physicist dealing with dull, dead matter. Anesthesia is something which has always fascinated me. You suspend the consciousness temporarily for some time, and it comes back. Twice I had to be operated for several reasons. And I was trying to watch when the consciousness gets suspended. Carefully watched, but I could not trace. Suddenly you are nowhere. After a couple of hours, you wake back as if nothing has happened. So what is happening in anesthesia, I found on reflection, is that it is not that the pain is reduced. When we talk about pain management, particularly in neuroscience, etc., it is not the pain is removed, but the feeler of the pain is temporarily suspended. This is where Vedanta and religion come in. Who is that feels the pain? The person who feels the pain, the ego, is feeling the pain through a system of nerves, nervous network. So when you suspend the consciousness of the person who is feeling the pain, then the feeler of the pain goes away and the pain may remain. Now Vedanta is asking, Indian religious tradition is asking, is it possible for you to suspend the feeler of the pain even while being awake? So can you induce a kind of anesthetic feeling in you, suspending the consciousness temporarily while being perfectly awake? This has been attempted and perfected as a science of the Indian yoga, Indian yogis. One such example I will just briefly mention to you. Swami Turiyananda was one of the direct sannyasin disciples of Ramakrishna Paramahamsa. He was a very great yogi. Once he was operated upon in those days for a carbuncle in the back. The doctor came and said, I'm going to now operate. Shall I give you anesthesia? He said, no, don't give me anesthesia. He simply said, you tell me when you are going to operate. I will withdraw my consciousness from that portion of the body. He did it. Then the doctor said, Swami, there is a problem here. When we operate, when we cut too deep, there is a slight sensation in the patient, and therefore we are careful. In this case, we are completely withdrawing the consciousness. We are not aware whether we are cutting too deep. Then Swami smiled and said, then do you want to keep some portion? All right, how much percent? 20% of the consciousness I will leave, and the portion which is being operated, 80% I will withdraw. These are the things which are possible, doable, demonstrable, and successfully documented by hundreds of thousands of Indian yogis over millennia. So this is a very strange science which they have found out. Swami Vivekananda wanted to integrate this ancient spiritual wisdom with the modern neuroscientific and neurophysiological systems. This is the success of Swami Vivekananda's Raja Yoga, and I'm extremely happy that very, very special neuroanaesthesiological and critical care is being discussed by so many people who are specialists in that field. I am the odd man out in this, except that I have the only right which I have to enter this conference is the Girva robe which I'm wearing. And Dr. Shangupta has been a great friend of ours. I was present during the inauguration of this Institute of Neurosciences in Calcutta. We are running a university named after Swami Vivekananda, Ramakrishna Mission, Vivekananda Educational and Research Institute, envisioned by Swami Vivekananda himself on the last day of his passing away in 4th of July 1902, in which he said, Prachin Bharatiya Dhara Bojai Rekhe Tar Shonge Adhunik Gyan Vigyaner Anushilan Jate Hoy এমন একটি বিশ্ববিদ্যালয় গড়ে তুলতে হবে, which means keeping the ancient spiritual roots intact and blending them harmoniously with modern science. We should have an institute. In fact, Swami Vivekananda inspired Sir Jamshedji Tata on that historic occasion when they were traveling in the same ship to Chicago in 1893, that we should start an institute in India for sciences to teach Indian youth about the development of science and technology. The result is the Indian Institute of Science, where Jamshedji Tata writes to Vivekananda. The original letter is available in the archives at Belur Math. You have inspired me to start an institute where men will live with ordinary decency and cultivate sciences, both natural and humanistic. It's a very profound statement. Along with the natural sciences, the various science and technology, we should also develop the humanistic sciences, because all sciences and technology and all knowledge is for the human being. So how to cultivate a noble human being with feeling, Along with that, how to cultivate the knowledge in him is a very important idea which Swami Vivekananda gave. This Institute of Neurosciences, founded by Dr. R.P. Sengupta, we have a memorandum of understanding MOU for the university for carrying out research and for sharing a facility and so on. We are so thankful to Dr. Sengupta and his team for offering this opportunity. And I heartily thank Dr. Vibhu Kalyani Das for inviting me to say a few words in this important conference. The two people who have been facilitated, I particularly congratulate them on the lifetime achievement, devoting their whole lives for the development of a particular topic and a subject in neurosciences for the good of the world. Bahujana Hitaya, Bahujana Sukhaya, as the Buddha said, for the good of the many, for the happiness of the many. May Dr. Sengupta live for several more decades now. May all of you thrive, develop knowledge, and use the knowledge for the good of humanity is my prayer. Om Shanti 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 Harihi Om Tat Sat Sri Ramakrishna Arpanamastu.
Thank you, respected Swamiji.
Yeah, I extend my thanks to respected Nidhi Madam, National President, Dr. Ponaya, Secretary, Dr. Bidkar, our Treasurer, Pramod Sir, the Editor-in-Chief of JIPMER, my teacher, Professor Das Sir, Professor Amna Madam, and all other dignitaries for gathering this morning and showing that we will definitely achieve success in our days ahead. With this, I convey my thanks to all and end the inauguration session. So please stand by for the next session. I will invite Dr. Jayati Ghosh to moderate the next session, which is a session of PG Symposium. Thank you. Thank you. Pranam.
So now coming to our next academic section. So this is session 2. It's actually a PG symposium for DM students. So I will like to invite mentors of the session. They are Dr. GP Singh, Dr. Ashish Bindra, and Dr. Muktiyan Balasubramaniam. So Dr. GP Singh, he is additional professor, MD and DM and in AIIMS, New Delhi. He is having many key achievements, Outstanding Scientist Award, Research Award, and he has got more than 140 publications and 15 chapters in books. And he is EC member of ISNACC. He has got a special interest in awake craniotomies, neurotrauma, airway, neurocritical care, and neuromonitoring. So our next mentor is Dr. Ashish Bindra. She is additional professor, AIIMS, and the Associated Trauma Center. She has got many clinical interest and experience, and she is also in the editorial board of Neurology India, Journal of Neuroanesthesia and Critical Care, has got almost 80 publications and 10 chapters in different books. Our third mentor is Dr. Bala Subramaniam. He is Assistant Professor, JIPMER, Pondicherry. His area of interest is anesthesia-induced neurotoxicity and biomarkers, neurocritical care, and neurotrauma. So now I will ask our first mentor, Dr. GP Singh, to come on the dais and introduce our speaker, Dr. JS Rahul. And I will request all the moderators or mentors to be very, time should be maintained. Thank you. Please, Dr. GP Singh.
Good morning, everyone, and thank you. I would like to congratulate the organizers for conducting such a wonderful conference. A very nice beginning in the morning. Without wasting time, I call upon the first speaker, Dr. J.S. Rahul, who is has done his MD in anesthesia from prestigious JIPMER Institute from Chandigarh, PGI Chandigarh, and have been working in other reputed hospitals like Jaslog in Mumbai, Yashoda, Secunderabad, where he developed his keen interest in neuroanesthesia and critical care. Following this, he decided to join, take neuroanesthesia as his branch and join DM in neuroanesthesia and critical care, and is presently pursuing his course at AIIMS New Delhi. He's a very, he happens to be my student also. So I liked him to present his talk today on this platform. Over to you, Dr. Rahul.
Good morning, my name is Dr. J.S. Rahul, and my topic for PG Symposium today is awake craniotomy, challenges for neuroanaesthesiologists. And I would like to thank the organizers for giving me the opportunity and Dr. GP Singh for mentoring me with this session. Thank you. So as we begin, why we keep awake? We keep awake when the surgery is being done around the eloquent areas, or when one needs to identify or resect an epileptic foci, and definitely to eventually to minimize the overall morbidity and ICU stay and hospital stay. And these are the eloquent areas around which, when the surgery is being planned, we try to facilitate an awake craniotomy. And there are certain indications, there are multiple of them, but for the purpose of this discussion, epilepsy surgeries and lesions around the eloquent areas form the bulk of the surgeries where awake craniotomies are performed. How one can avoid challenges or hassles is with a proper patient selection and trying to ensure that whoever is being selected, it is in indication and not trying to stretch too far. Sometimes, as I said, the reason why knowing the surgeon is important is sometimes a young, an upcoming neurosurgeon, for example, they might have a point to prove, and sometimes one can become slightly, overfetch or try to go a little slightly overboard and select a wrong patient or a lesion which is much big and which is not congenial for an awake craniotomy. Definitely identifying and addressing the psychological aspects, not missing things preoperatively, ensuring that the scans are thoroughly reviewed, and ensuring that the surgical duration is definitely, we need to know about the surgical duration to ensure our anesthesia planning. And coming to challenges, the challenges can be broadly divided into an anesthesia related and the complication related. Over the next couple of slides, I'm going to discuss individually each of them. So anesthesia-related factors, as spoken, the patient selection becomes paramount importance. Why? Because as we know that we need a patient's contribution in this awake craniotomy maybe is as good as a surgeon's contribution in this. A good, properly compliant patient can go a far way in as far as improving the outcomes as well. So one needs to identify the proper patient selection, ensuring the psychological aspects are addressed, the phobias are addressed. The surgery itself is something patients are worried and apprehensive about. On top of that, when they know that the brain is going to be open and they're going to be awake, that adds to it that much more. So an effective pre-op communication and always saying no by knowing the contraindications as to avoid. I'm not going into detail, but one thing we need to keep in mind is, especially in obese patients, patients with OSA, patients who cannot lie supine, especially patients with the NYHA type 4 or shortness of breath or orthopnea, that is something which we need to know preoperatively to ensure that the patient is at least able to lie down supine without having to hyperventilate or get dyspneic. And definitely in uncooperative patients, slight mentally, not exactly mentally retarded, but I would say patients who are anxiety, type A personalities, we might be able to identify them pre-op and kind of preempt that if they are the rightful candidates or not. That with a big lesion, that with a lesion in a tricky area is something which one needs to keep in consideration. Then a pre-op evaluation, again, not going into too much of detail because our topic is entirely different, but the few things like ensuring that the language barriers are addressed, anxieties are addressed. Language barriers becomes very important in an institute like ours, where people come from all over the country with who some of them speak only their local language. That can be a huge challenge as far as communicating with the patient is concerned. We always not find translators for them. That is to be taken. Like for example, once we had a patient from Manipur who only spoke Manipuri. So we ensured that we identified a nursing staff who was from Manipur, and we ensured that she stayed inside the OT. These things may have to be done. And other things like ensuring that the patients are on, if they're already on AEDs, ensuring that they're taking their anti-epileptic medication till the day of surgery. Extremes of age, seizures and type, number, frequency, and the medications are receiving, if available, plasma levels. And of course, as I said, a thorough preoperative airway evaluation, because this is going to be a tricky airway with the head pins fixed. And psychological concerns, as I said, are often underestimated. It definitely improves the patient's overall experience and satisfaction with the surgery. And yes, preoperative meetings, sometimes even multiple, and sometimes as a team, where the surgeon, anesthetist, and then the neurophysiologist may all need to go together and meet as a team, and multiple meets are set to build a better rapport, and definitely a well-informed and a cooperative patient is what we need, because that is almost half the battle won. So addressing psychological concerns, we believe is almost half the battle won. Then coming to the consultation do's and don'ts, there are certain things which, especially in the preoperative counseling session, it's very important that we give honest information and avoiding too much or too little. Sometimes we tend to give too much of information and unnecessarily scare them. At the same time, we shouldn't even brush things aside and they get shocked in the OT all of a sudden. And tailoring the information is very important, and avoiding opportunity to ask questions, and making it rather elaborate one, and trying to avoid too little or too hurried explanation. And definitely misinformation should be kept aside. And anesthesia planning again anesthesia planning. There are multiple ways, multiple techniques that have been prescribed. We need to have a clear-cut institutionalized protocol beforehand to avoid unwarranted outcomes, unwarranted challenges. So after the advent of Dexmed, almost as far as the awake craniotomy is concerned, where we keep the patient sedated throughout. So why it is important to ensure a targeted conscious sedation to say a BIS monitoring or an entropy is to avoid unwarranted over or under sedation, because both of them can add to our problems. So as said, knowing the targets, even clinically, one can keep it as a MOAS score 3, which is a modified observer's assessment of alertness and sedation, where we need to keep the patient to a sedation level where he is easily arousable with loud noises. You call out the patient's name and you should be able to respond, and he should be arousable is the thing. Of course, it's definitely great if you can have BIS and entropy in the institute. It's always good to target a good BIS value in the upper range of 50, in the upper range especially. So to know how to keep the patient and how deep is very, very important. As said, multiple drugs have been prescribed, not going into too much of details, but Dexmed, Ketofol, Propofol are some of the widely used ones in awake craniotomy. Then knowing the scalp block is very, very important, because there's some sort of maybe a cornerstone in awake craniotomy. Because as we know that a good awake craniotomy is purely sometimes based on a good scalp block. If the scalp block is good, the patient is pain-free, the patient is comfortable, the patient is compliant, and the surgery goes in a rather smooth direction. So there's no harm in calling it a cornerstone. And definitely knowing the anatomy is of great help. And we might also have to know the upper thresholds of the drug doses. Why? Because both the sides, multiple nerves, and us and surgeons, everybody is giving. So we need to ensure that the doses are kept in check and planned accordingly, that the surgery or the duration of the block should at least come to 6 to 8 hours, because the surgery can go for that long. And yes, the pins are also on the opposite side. It's not only about giving a good block in the side of surgery, but also on the opposite side, because there is a pin, there's a little pin lying on the outside as well. And ultrasound techniques have been proposed, which are known to lower the drug requirements and vascular invasion. So as said, knowing the anatomy and a good scalp block and a good efficient scalp block is of great aid. And almost half the challenges are prevented if the patient is pain-free. So as said, there are a few adjuvants which are prescribed, which can reduce the, which are said to reduce the overall dosages of the local anesthetic, like the dexamethasone and Maxelf have been tried, which can be used as well. And then patient comfort and compliance, as said, a nice and warm, noise-free OT with a nicely comfortably lying patient, avoiding extreme neck positions, ensuring that the extremities are well padded, he's not painful. We need to ensure that the alarms are set as well. Many a times we forget to set the alarms. Alarms have to be set to ensure there's unwarranted honking, and because already the patient is anxious, apprehensive, and the unwanted blaring horns might make it all the more difficult. And ensuring and coordinating with the surgeon the various painful procedures to ensure that the anesthetist is, the technique is given, and sometimes even they might have to be told the patient is awake. And ensuring that the face is visible, approachable all the time is very important. And the drapes have to be tilted away from the face as well. But this is the most paramount important. The face has to be visible and approachable. But as we know, this is a difficult airway scenario if it gets to that. So we need to have an access to the patient. And most importantly, the face has to be visible. If he's drooling, if he's having secretions, if he's snoring, everything has to be visible right in front of our eyes. Then this is how we try to keep the tents away from the patient. And sometimes we might have to just cover the eyes just to facilitate him to sleep. Again, this is based on the patient's request sometimes. And we ensure that the patient's face is always visible and accessible from all places. In the position as said, this is how the anesthetist and the machine is. So there has to be some place to reach the patient's face. So some non-verbal techniques, some non-pharmacological techniques to ensure that the patient is calm and comfortable is to continuously have a verbal and eye contact, holding hands. Holding hands can go really far away in assuring them that they are fine, that they're in good hands. Refraining from unwanted noises in the OR, unwanted people in the OT. Sometimes a light music can be of great help, and telling them that they're doing great, and ensuring them, and sometimes even giving them a heads up before, say, a bone is being drilled, or before there is some anticipated pain. We might have to tell them beforehand, you might experience some amount of pain or some amount of discomfort, or you might hear some pressure or some noise. That also can definitely be of great help. And yes, ice chips and cold cloths have to be kept all the time to ensure that their tongue and lips are not dried. Then, of course, these are, as mentioned already, we need to know at when to taper sedation, when to keep a sedation at a higher level. As said, the initial phase of the surgery, where the sedation requirement and the analgesia requirement is slightly higher than when after the dura is open, when the testing and surgical intervention is being done. As said, there we might need little to no sedation required at that point. And closure of, and just before closure, we might again need some more pain as well. Coming to the anticipation and management of intra-op complications. As said, there are airway-related challenges can be quite dreaded and sometimes extremely challenging to manage, especially considering the fact that the patient's head is fixed to a pin and head is not accessible many times. And sometimes, to make things even worse, the brain is already exposed and you do not want to lose an airway at that point where it is difficult to bring him off pins. So as said, the head, inaccessible head, exposed cranial contents, and hypoxia, desaturation, all these sort of things can have immense amount of effect. And sometimes the over-sedation has to be definitely suspected and titrated accordingly. So always, as I said, the troubleshooting of an airway situation starts with preoperative beforehand. Preemptive preparation is the key. That the airway card has to be fully functional with all video laryngoscope, fiber optic, whatever is available has to be kept. But most importantly, the most of the times, we need to try to awaken the patient, give a good jaw thrust, and if possible, most of the times a well-fitted nasopharyngeal airway, which has to be calculated beforehand and not to run around and look for the right sizes at that time of a calamity. It's always good to identify one nasopharyngeal airway and mark it and keep. And if needed, a nasopharyngeal airway many a times we'll try to avoid most of the times even intubating or even putting an LMA for that matter. So are identified and however LMA, and if needed, try to intubate him after removing the drapes of the face and even the frame for that matter. So as said, there are two different ways an airway can go wrong. The patient can have a respiratory depression because of over-sedation, or they can have obstruction. The patient has just vomited, or patient through a seizure, or patient is patient of OSA. So all these are possible. So intra-op seizures, as said, more often are focal self-limiting. We find them more often than not. But the problem happens when they become uncontrollable. So much so with an exposed brain, it becomes extremely catastrophic. So an ice cold saline, ease of mandation, not just on surgery side, from our side as well. We need to time and again give them heads up and even inform the nurse and the nurse anesthetist beforehand that ice cold saline be kept ready, be available, and also tell them that this is what we are anticipating and this is what you need to do in that particular time. And definitely preoperatively, we have to optimize and ensure that the anti-epileptic medications are being taken. In our institute per se, we tend to give repeat dose even on the day of surgery. And we might have to even repeat as well. But ice cold saline, as I said, can be of paramount importance, especially when there's there is some amount of focal movement after a particular point of the brain is stimulated. We inform the surgeon and they flood the field immediately with ice cold saline, and they will try to avoid it. Usually, most of the time, they try to avoid re-stimulating it. But the challenge happens if it happens multiple times. We might sometimes even have to go for conversion into GA as well. If it becomes extremely difficult to manage by just ice cold flooding, we might even have to go for a complete GA as well. So as I said, notify surgeon immediately, immediate visual stimulation, ice cold saline, or RL, cold RL, if it's available. Small profile boluses, preventing re-stimulation and GA conversion if needed. So tight brain is again a very big issue one can face because we are not able to monitor ETCO2 that well. And PaCO2 is not readily available in a dynamic way. So definitely an underlying Marsley effect. On top of it, there is hypercapnia because the patient is sedated and patient is not clearing out CO2 that well. There can be some amount of hypercapnia which is adding to it. So as a reason, there can be some tight brain affected where one needs to verify the patient's position, administer challenge osmotic agents, and sometimes even might have to reduce sedation. Sometimes an over sedation itself can be a big cause for tight brain as well. So informing the surgeon and being in constant communication is of great importance to identify tight brain, because we don't want a fully tight brain and only then we start doing things. We can actually start it as a preemptively. We can probably reduce sedation, ensure that the patient is in good position as well. And role of mannitol, in our institute, we are giving mannitol as a routine, but widely it is believed, the moderators can throw some light, that mannitol, they say, is better as a rescue drug than preemptively give. There could be some conflict on that, but there is no clear-cut evidence as to routinely prescribe mannitol. Of course, we are giving, and many institutes I know are giving, but there's no clear-cut mandation in who gets mannitol or not. We can have a discussion on that, I believe. Then coming to nausea and vomiting, yes, it's always better prevented than treated. It might look relatively normal thing to happen, nausea, vomiting, but in a patient who's already sedated, it can be quite dreading. Especially there are risks of the patient can lose his compliance. They might stop cooperating, and there is definitely a huge risk of aspirating, airway obstruction, and definitely all this can cause brain bulge, hypercapnia. All sorts of unwarranted things can happen with a simple nausea and vomiting, which can be prevented. So as a rule in our institute, when the patient walks in, we attach monitors, we place line, we take the basal vitals, and the first thing we give most of the times is an MSIT. The simple MSIT, sometimes a prophylactic antiemetics, can go far away. And we try to avoid excessive narcotic because we are always giving, most of the time we're using dexmedetomidine that itself reduces unwarranted opioid excess in general. And definitely reassurance and sometimes rescue antiemetics and low dose propofol also helps in nausea and vomiting. Then coming to hemodynamic instability, all combinations are possible as expected in any of the surgeries. But what we need to cater to is the pain, anxiety, hypovolemia, sedation overdose. All these factors might have severe hemodynamic perturbations, like a lot of pain, a lot of anxiety, hypovolemia. They can be tachycardia, hypertension, sedation overdose, dexmed. They can be bradycardia, trigeminal cardiac reflex, bradycardia. These things have to be also to be kept in mind. I'm not going into detail because of the short of time, but we have to ensure that that there is good amount of analgesia during the rate limiting steps or the initial steps, not in the rate limiting, the initial steps where there is pain expected. There we ensure adequate analogous sedation. And we have to look for blood loss anticipation as well, because the patients, because the surgeon is in a hurry to finish off the surgery. So there could be a risk that the hemostasis is not effective. So we have to anticipate the blood loss as well. And always one needs to keep in mind in an awake craniotomy, sudden drop in blood pressure, almost VA has to be kept in mind as well. So talking of VAE, which can be of quite dreaded, not because of the air, but because of the fact that we might miss the diagnosis on time in an awake patient, because we do not have the usual ETCO2 monitoring, and also the TE is not possible. So we may be able to miss a diagnosis more often than not, because the patient is head up, patient is awake, and they're spontaneously breathing. So there's a lot of negative intrathoracic pressure which is building up, which can kind of cause the air to entail. So we have to prevent hypovolemia. We have to ensure that they are pain-free, they're comfortable, because pain, agitation, everything can cause hyperventilation, and that itself can be a risk factor for venous entrainment. There are a few case series which has been done by in a couple of isolated case series. What they have found is in patients who are awake, who are subjected to venous air embolism, they tend to have a tachypnea, sudden bouts of coughing, chest pain, and suddenly a comfortable cooperative patient becomes restless and agitated. So whenever in our patients in awake craniotomy, suddenly these things are found, always it is better to inform the surgeon, because this could be a venous air embolism presenting as tachypnea, cough, chest pain, and restless, agitating, and uncooperative patient. Because as we see in intubated patients, it's kind of clear cut. When we see there's a drop in ETCO2, sometimes there's hypoxia, EC changes, but these may not always be translated in awake. So it's always good that watch out for an unexplained hypotension with cough, tachypnea, and chest pain. Look for venous embolism, and may even have to intimate the surgeon as well. So just finishing off in last couple of slides. So these are the complications which we discussed about, and these are the biggest challenges that one anesthetist face. But the take-home points I would like to say are that every institute needs a sound, evidence-based institutional protocol is of paramount importance in awake craniotomy, and emphasis has to be kept on pre-op counseling, psychological support, and the face needs to be visible all the times inside the OT. And thorough airway preparedness, no matter how cooperative the patient and how seemingly uneventful the surgery might seem. Perhaps now targeted monitored sedation to ensure that there is no over or under sedation, and ensuring that the patient is comfortable is almost a good compliant patient is almost half the battle won, and never ignore a coughing patient. Thank you.
Thank you, Dr. Rahul, for such a wonderful presentation, bringing out all the aspects what a patient can face while he's awake during awake craniotomy and how to manage them. I am really stunned by your presentation, and more so because you finished right in time. So congratulations once again, and maybe we'll take the questions at the end when all the presentations are over. I just now call the next mentor, Dr. Ashish Bindra, to take the rise.
Thank you, Dr. Gyanendra. So for the next topic, I would like to invite Dr. Mangesh, who is a senior resident in Department of Neuroanaesthesiology and Critical Care, AIIMS, New Delhi. So he will be talking on status epilepticus. Mangesh otherwise is working on pupillometer and pediatric TBI. Along with that, he also has some knowledge and working on a project in non-convulsive status epilepticus and pupillometry. So for topic, it is refractory and super refractory status epilepticus implications for neuroanesthesiologists. Mangesh, can we please start?
Good morning. Yeah. Good morning, everyone. I'd like to thank organizers for giving me this opportunity, and I would like to thank Ashish Bindra madam for guiding me for this topic. So I'll be discussing on refractory and super refractory status epilepticus and its implications for neuroanesthesiologists. The outline of my discussion will be defining refractory and super refractory status epilepticus. We'll discuss the pathophysiology, rationale for the aggressive treatment, the prognosis and the treatment options, and the role of neuroanesthesiologists as well as intensivists, and then summarize. Status epilepticus, as had been defined by International League Against Epilepsy in 2015 as a condition which results either from the failure of the mechanism responsible for the seizure termination or from the initiation of the mechanism which leads to abnormally prolonged seizures after the point T1. So if a seizure, that is a tonic-clonic seizure, if it is continuous after a time frame of T1, that is point T1 for 5 minutes, there is a high propensity that this seizure will continue for a longer time. And if it continues after the time T2, there may be chances of long-term consequences, which includes neuronal death, neuronal injury, as well as the alteration in neuronal networks. The conventional stages of convulsive status epilepticus has been divided because with the time frame from the onset of the status epilepticus. The first 5 to 10 minutes from the onset is called as impending status epilepticus. 10 to 30 minutes after the onset is called as established status epilepticus. 30 to 60 minutes after the onset is called as refractory, and if the seizures continue for more than 24 hours, it is called as super refractory status epilepticus. What is refractory status epilepticus? If a convulsive seizure lasts longer than 60 minutes, which may be continuous or intermittent without the return to the baseline mental status, or if an acute convulsive seizure that fails to respond to 2 anti-seizure medications, one of them being non-benzodiazepine anti-seizure medication, is called as refractory. The relative prevalence is almost 20 to 30%. When a seizure continues or recurs 24 hours or more after the onset of anesthetic therapy, or if it recurs on the reduction or withdrawal of anesthesia, is called as super refractory status epilepticus, and almost 1/5 of the patients with refractory status epilepticus go on to have super refractory status epilepticus. Coming to the pathophysiology, the local hypersynchronization of excitatory and recurrent inhibitory neuronal networks, they diffuse to the rest of the brain and they generate a spontaneous seizure. So these paroxysmal hypersynchronous electrical discharges, they result from an imbalance between the too much of activation and too little inhibition. So we should understand the concept of receptor trafficking, where they have found that there is an internalization of the GABA A receptors, which causes a reduction in the potency of benzodiazepines as a treatment. There is activation of NMDA receptors, which leads to glutamate induced excitotoxicity, and there is upregulation of P-glycoproteins, which results in rapid export of phenobarbital and phenytoin molecules. So thus, in turn, it is an imbalance between the proconvulsant and inhibitory peptides, which leads to status epilepticus, and if it is not treated, definitely it becomes refractory. So what is the rationale for aggressive therapy in such patients? Basically, it is because of the complications and the dreaded complications. The most important complication is cerebral damage, the hypoxic insults which result from the status epilepticus because of the excitotoxicity. There are cardiorespiratory and autonomic complications which are secondary to the catecholamine surge during the status epilepticus. Dyselectrolemias, rhabdomyolysis, acute kidney injury, disseminated intravascular coagulation are the other metabolic and systemic complications of status epilepticus. One of the studies conducted by Tristan et al. In 2009, they have found that there is a better outcome when in the younger patients who have absence of any medical comorbidities, absence of structural brain regions, and who have a seizure duration of less than 10 hours, that is short duration, as opposed to there has been a poor outcome which has been found in older patients who have an underlying etiology and a longer seizure duration. So when you come to the prognosis, the overall mortality with status epilepticus is almost 25%, with almost 48% of mortality with refractory status epilepticus, even with aggressive therapy. In case of super refractory, the mortality is almost 30 to 50%, specifically in the cases of new onset refractory status epilepticus, as we call NORS. So 1/4 of these patients with all super refractory status epilepticus, they have good outcome, but most of them have significant residual impairment. So the aim of our treatment is primary aim is to control the seizure and prevent the excitotoxicity. Secondary aim is neuroprotection, and third aim is to avoid and treat the systemic complications which are related to prolonged unconsciousness and anesthesia drugs used for the treatment. So what is the evidence for the use of drugs and other modalities for the treatment of refractory and super refractory status epilepticus? There is a lot of research papers available, but the maximum evidence is available with midazolam, phenobarbital, propofol. So when we encounter a case of refractory status epilepticus in our neurocritical care, ICU or in emergency, the first basic thing is stabilizing the patients. We start with ABC, airway, breathing and circulation. Intubation should be done as early as possible to secure oxygenation and ventilation. Finger blood glucose should be examination should be done to diagnose hypoglycemia and treat accordingly. A good peripheral IV line should be secured to start emergent initial anti-seizure medication therapy within 5 minutes. start for the fluid resuscitation. Nutrient resuscitation like thiamine should be transfused along with dextrose in cases of alcohol withdrawal, and vasopressor support should be initiated to support cerebral perfusion pressure. So when by the time we stabilize the patient, we should also look for the cause. What is the cause of this status epilepticus? So the most common causes being head trauma, stroke, CNS infections, metabolic disturbances, and non-compliance with anti-seizure medications. The other few less common causes are withdrawal of the drugs, drug toxicity, hypoxia, cardiac arrest, hypertensive encephalopathy, and some autoimmune causes. Some chronic causes we should be in our mind is CNS tumors, chronic ethanol abuse, and any pre-existing epilepsy patients who may have breakthrough seizures or discontinuation of anti-seizure medications. Specifically in children, we should know that prolonged febrile seizures are the most common cause of status epilepticus, and CNS infections and inborn errors of metabolism should be in our mind. So what are the treatment options? With the status epilepticus, all the treatment protocols start with benzodiazepines as the first drug of choice, plus the second line anti-seizure medications is started like phenytoin, valproate, levetiracetam, bivaracetam, and osamide. For refractory status epilepticus, we have IV anesthetist, midazolam, propofol, thiopentone, ketamine. For super refractory status epilepticus, there are only few options like inhalation agents, some miscellaneous drugs, and surgery, which we'll be discussing in few slides. So once we have found, or if we know which is the etiology for status epilepticus, a etiology specific treatment needs to be initiated as early as possible. For example, if there are metabolic disturbances that needs to be treated. If we are suspecting inborn errors of metabolism in children, we should start pyridoxine as early and avoid valproic acid. If infections are suspected, it should be treated accordingly with antibacterials and antivirals. If autoimmune encephalitis is suspected, immunotherapy should be started early. So when we implement aggressive therapy for refractory status epilepticus, there is a universal agreement that general anesthesia is the backbone of the therapy. And however, there is no agreement on the optimal choice of which anesthetic drug needs to be used, but there are the three conventional choices: thiopentone, propofol, and midazolam. What is the role of neuroanaesthesiologists in intensive studies? Definitely in neurocritical care, airway protection, maintaining the hemodynamics, treat the refractory status with IV anesthetic agents, preventing the complications related to IV agents, and most importantly, weaning from the anesthesia drugs. In periphery, we will be involved from sedation or giving anesthesia for such patients whose seizures have been treated, and definitely in operation theater for the disconnection or resective surgeries, which are the last resort surgeries for the treatment. Coming to the drugs, midazolam, one of the only drugs which is only benzodiazepine, which is suitable for the prolonged infusion, acts by enhancing the GABA receptor. Advantages being faster onset, strong anti-epileptic action, relatively short heart life, and allowing for the faster titration. The adverse drugs effects have been used. The active metabolite is excreted renally. That's why the prolonged effect may be seen in renal dysfunction. Cardiorespiratory depression is common. Most importantly, tachyphylaxis, seizure recurrence after the loading dose, and seizure relapse and withdrawal has been seen with midazolam in many of the research papers. Propofol acts by modulation of GABA receptor and inhibition of NMDA receptor, the advantage being very rapid onset and recovery after prolonged infusion, more control on the level and depth of the anesthesia, no serious drug-to-drug interaction, and definitely decreases cerebral oxygen utilization and decreases the ICP. The few disadvantages: pain and hypotension, though it is less than barbiturate and midazolam. Propofol infusion syndrome is an important complication which we should know, and also there is a risk of misinterpreting the drug-induced involuntary movements with GABA, with propofol, which should be in our mind when we are treating this. A short word on propofol infusion syndrome: rare but potentially lethal toxic effect on the mitochondria and cellular metabolic function. It's a dose and duration related. There is a high mortality and morbidity associated with rise in creatinine kinase levels, rhabdomyolysis, metabolic acidosis, ECG changes, refractory shock, or all the clinical manifestations. It was first reported in younger children. That's why better avoided. Barbiturates, thiopentone and phenobarbiturate act by enhancing the action of GABA receptor. The advantages being the strong anti-epileptic action, lowering the body temperature, theoretically neuroprotective drugs, and relatively safety in longer experience of its use. However, the disadvantages being the longer T-half, hypotension, and cardiorespiratory depression is profound and usually needs vasopressor therapy. Dynamic ileus, bowel perforation, pancreatic hepatic dysfunction, propylene glycol toxicity, and high infection rates are associated with the use of barbiturates. That's why we always keep a high threshold for using this drug. Ketamine in its last 10 years has been widely used and started being used as a treatment for refractory and super refractory status epilepticus. Being an NMDA antagonist, it has also advantages over the conventional anesthetics because of the no cardiac depression and potentially being neuroprotective. However, there is a theoretical risk of neurotoxic effects when it is used used for prolonged periods and the safety has not been tested. There is possibility of late development of cerebral atrophy, probably the excitotoxic effects of ketamine. And there has been definitely one of the disadvantages of raised IC with ketamine. However, the recent literature does not support this adverse effect. Inhalation agents. Now, it is one of the potential last resort for the treatment. The advantages being they're easily transported to CNS, that's why immediate seizure control. They're easily titrated to burst suppression and have a cerebral protective effect. Isoflurane and desflurane, there are many case reports and very, very few case studies for the use of inhalation agents. Desflurane requires higher MAC to achieve burst suppression, and sevoflurane being pro-epileptogenic, that's why it is definitely avoided. What are the disadvantages? When used for the longer time, inorganic fluoride levels may be higher in patients, probably the effects we don't know. Cardiovascular suppression, definitely yes, calcium-mediated myocardial depression is there with higher MACs. Isoflurane has been implicated in neurotoxicity and apoptosis-induced neuronal cell death. There definitely are the logistical issues or delivery of these inhalation agents in neurocritical care units. Long-term effect of these drugs, most of the studies are not available, and few of the case reports there have been other complications which has been reported like atelectasis, infections, paralytic ileus, and DVT. So how we select the drug? So several questions arise about which drugs should be selected, for how long it should be used, how deeply we need to suppress the clinical seizures, and most importantly, how to taper and discontinue to drugs, assuming that they have controlled the status and now without the patient relapsing back into status epilepticus. This is one of the treatment protocols which has been found to be in used by the Oxford hospitals in NHS Foundation. So once the refractory status epilepticus is diagnosed, they either use one of the two drugs, propofol or midazolam. So midazolam bolus doses followed by the continuous infusion. It is started to achieve ictal discharge suppressions on EEG. Once it is achieved, the midazolam infusion is continued for 24 hours seizure-free duration. If the propofol is used, the burst suppression, if it is achieved after the bolus dose followed by the infusion regime, and if there are no breakthrough seizures, they continue the propofol for at least 24 hours seizure-free duration. When both the drugs have been used and maximum doses have been reached, the third drug is added, that is thiopentone sodium. Thiopentone sodium is also titrated after bolus doses to achieve burst suppression. And when the maximum dose of thiopentone has been reached, a fourth drug is added in this protocol, ketamine, to achieve the target. If all the four drugs don't work, then finally inhalation agents, surgery, or other miscellaneous therapies have started. So what I mean to say is, what is the endpoint of our treatment? The European guidelines suggest EEG burst suppression as the endpoint for propofol, thiopentone, and seizure suppression for midazolam. For how much duration? For at least 24 hours after the seizures have been stopped, and it should be maintained for the minimum period irrespective of which anesthesia drug is used. What are the other modalities? Neurosurgery. When there is a definite radiological evidence or electrophysiological evidence of focal onset of seizure, definitely the last resort treatment is neurosurgery in super-refractory status epilepticus. There have been studies on as early as use of 8 days following onset of status epilepticus, but most of them usually wait for 2 weeks for a failed medical therapy. Resection surgeries and disconnection surgeries are available to treat it. Magnesium, definitely the drug of choice in eclampsia, but it has been off-label use in refractory and super-refractory status epilepticus because there are no randomized controlled trials to support that. Mechanism of action is because in the NMDA receptor antagonist, it acts as a cerebrovasodilator. The therapeutic range of 30 to 60 microgram per ml is required to achieve anti-seizure effects. The advantages being only few drug interactions. Disadvantages are because of the magnesium toxicity. Pyridoxine. Now, this is one of the important drugs in inherited metabolic epilepsy, that is the pyridoxine responsive and pyridoxine dependent epilepsies, which is considered in neonate children less than 3 years of age, which present with refractory status epilepticus without any identifiable lesion on imaging. And it is recommended that to use this drug routinely in all the cases of super refractory status epilepticus in young children, because definitely there are no side effects. Steroids and immunotherapy with IV steroids, intramuscular ACTH, and IV immunoglobulin have been recently used in few of the epilepsy syndromes without any clear guidance, because there has been research that they have found that there are antibodies which are directed against the neural elements like NMDA receptors or GABA-B receptor, and the role of inflammation in the epilepsy. Immunotherapy and steroids are helpful in few conditions like autoimmune encephalitis, NORS, and febrile infection-related epileptic seizures. Ketogenic diet. Now, this treatment has been preferred in childhood epilepsy after multiple drugs have failed, and in many of the refractory epilepsy syndromes. Usually it is easy to administer through a gastrostomy tube or a parenteral feeding, and it is initiated after 24 hours of fasting. What is the postulated how it helps? Probably by potential of inhibitory neurotransmission, augmented of neuronal function through cellular level, hyperpolarization of the neurons through potassium channels, and chronic ketosis is postulated to stabilize and reduce the synaptic hyperexcitability. Thereby, it increases the C cell threshold. What are the contraindications? Congenital enzyme deficiencies, which are related to lipid metabolism. If they are present, definitely it's absolute contraindication with porphyria. If concomitant use of propofol, definitely there is a chances of high triglyceridemia. That's why it is related to contraindication. The complications are mostly gastrointestinal, like abdominal pain, emesis, constipation, and pancreatitis. Some cardiac and few metabolic, like hypertriglyceridemia and hypercholesterolemia, are other complications. Hypothermia. Now, hypothermia exerts its anti-epileptic action, and it has a neuroprotective role by reducing the brain oxygen utilization, ATP consumption, decreasing the glutamatergic drive, free radical production, and other oxidative stress. What are the risks? Acid-based disturbances, disseminated intravascular coagulation, coagulation disorders, thrombosis. So how it is done? It is induced by endovascular cooling, and usually a mild hypothermia of 30 to 35 degrees Celsius is started for 24 to 48 hours. If the seizures are treated, it is continued for 20 to 48 hours. Barbiturate anesthetics are avoided with hypothermia. Patient needs to be monitored for coagulation parameters, acid-based, basically the arterial blood gases needs to be monitored. And we being the anesthetist, we should know that the clearance of the anesthetics and anti-epileptic drugs are usually reduced with hypothermia. What are the other palliative therapies? Vagal nerve stimulation, deep brain stimulation, and transcranial magnetic stimulation. There is a dismal results in epilepsy and not much data in support of transcranial magnetic stimulation. Vagal nerve stimulation, there are a few case reports on the use of vagal nerve stimulation in treatment of status epilepticus. However, the other additional therapies usually complicates the assessment whether it is the effect of vagus nerve stimulation or other therapies. And in one of the reviews conducted by Ziller et al. In 2015, they couldn't recommend the use of vagal nerve stimulation for refractory status epilepticus. Deep brain stimulation, there has been animal studies for stimulation of anterior thalamic nuclei for the treatment of status. However, there is no much published data to support the same. Electroconvulsive therapy, now it has been first used in 1930. However, the anti-epileptic effects are because of the increase in presynaptic GABA and prolongation of the refractory period of seizure post-ECT. However, the anesthetic should be withdrawn and anticonvulsant drug should be completely withdrawn before the start of electroconvulsive therapy. There has been case reports of successful use of electroconvulsive therapy in cases of febrile infection-related epilepsy syndromes. CSF drainage. Now it is unclear how it helps, but probably because of the removal of inflammatory and other noxious substances in the CSF may help in refractory status epilepticus, and probably it may also help in intrathecal administration of anti-epileptic drugs, but there are only few reports or probably just a theoretical way to support this. To summarize, we can start with midazolam infusion followed by propofol and ketamine. EEG endpoints are burst suppression and suppress ictal discharges for the different drugs. Propofol and ketamine is usually added to reduce the tachyphylaxis seen most commonly with midazolam. We avoid propofol in young children. We check for metabolic acidosis, creatinine kinase level, triglyceride levels, and ECG changes when the patient is on propofol infusion. We keep a higher threshold for the use of phenobarbital, as I have explained about the disadvantages, and specifically look for hypotension, immunosuppression, and bowel ischemia in these patients. To summarize, this is the protocol which we use in our neurocritical care unit in the Department of Neurology in our hospital and our institute. Thank you.
Thank you very much, Dr. Mangesh. You finished well in time at 2 minutes ahead. I was really worried to look at 52 slides and seeing if you will be able to finish in time. Good job. So my take home is that always you should have a protocol to treat the refractory status epilepticus in your own ICU, or depending upon the availability of resources, type of setup you're working in, and also the type of drugs you have. Patient profile should always be kept in mind before discussing or choosing the drugs for treating the status epilepticus. The protocol which is displayed in our ICU should have a mention of drug dosage. Always try to use the maximum drug dosage to break the seizure cycle and then later on titrate gradually. However, you should have all the equipment and necessary resources to deal with the side effects of the drugs when using the maximal doses. Thank you very much. I would like to hand it over to the next speaker.
Hello. Yeah. Am I audible, ma'am?
Yes, you are audible.
Yeah, hello. Good morning, everyone from JIPMER Pondicherry. I'd like to congratulate the organizers and organizing committee for this virtual conference and wishing them a grand success. And I will also thank the organizing committee for giving this opportunity. Without wasting much time, Dr. Jerry James Joy. He did his MBBS from Kotai Medical College and MD anesthesia from WIMS Bellary. Currently, he's doing DM neuroanesthesia from JIPMER Pondicherry. And his topic is recent trends in depth of anesthesia monitoring, thinking beyond numbers. And Dr. Jerry, you can take over.
Good morning to all. In this occasion, I would like to thank the organizers of ISNACC 2022 for providing me with this opportunity, and my teachers, Dr. Prasanna sir and Mugilan sir, for guiding me with this presentation. So as already told, my topic for today is recent trends in depth of anesthesia monitoring, thinking beyond numbers. So when we discuss about depth of anesthesia monitors, we have an n number of depth of anesthesia monitors, and most of them we are using in our daily practice. So basically, these are processed EEG monitors, which provide us with an arbitrary number or an index, which help us in guiding the depth of anesthesia. So this table shows the target range of surgical anesthesia for various depth of anesthesia monitor, and we are familiar with all these numbers. So initially in early 1930s itself, they have started using raw EEG to analyze the depth of anesthesia. So later they found out that it was too complicated because they were not able to find out a relationship between the EEG pattern and the anesthetic brain state and the exact pathophysiological mechanisms. And many of the clinicians found it extremely complicated to analyze the EEG under anesthesia. And this raw EEG had so much external artifacts and external interferences. So it was so the use of raw EEG for analyzing the depth of anesthesia gradually declined over the period of years. So then came in early 1990s the concept of processed EEG, where the raw EEG has been processed to form a processed EEG, and subsequently they apply an algorithm to arrive at a number or an arbitrary index. So this will help us in guiding the depth of anesthesia. So this is basically how a depth of monitor works. So basically, signals are converted to digital signal by the analog to digital converter. And then once it is done, next step is pre-processing. Here, when during pre-processing, the machine analyzes which part of the EEG has to be analyzed. So after pre-processing, next step is algorithm. Application of the algorithm. So in the first step, the artifacts are removed from the EEG signal. So the main artifacts which comes are the cardiac activity, from the EMG, from the frontal muscle activity. So the reliability of a depth of anesthesia monitor depends upon the quality of artifact rejection. So after artifact rejection, the next step we'll obtain a new signal, and this signal is compared with the signals in the database. Usually the database is obtained from young individuals. So after it is the obtained signal is compared with the database signal, and subsequently they will arrive at an index number. And after the index number is obtained, the next step is post-processing. In post-processing, they will average the index values over a period of time so as to minimize the fluctuation in index values. So what are the disadvantages with these index values? Basically, as already mentioned, we have an inherent delay because multiple steps are there, and those index number, what we see, it's not an instantaneous value. It is usually an average value over a seconds or a minutes. So then the next step is these monitors have some problem with some drugs. For example, with dexmedetomidine, there will be an increase in frequency towards the slower waves. So this might give false low values, even though the patient might be easily arousable. And similar is the situation with ketamine also. It can cause increase in false high values, even though the patient may be sedated. Now, as already mentioned, the database is usually obtained from young individuals. It is not sure whether this depth of anesthesia monitor will provide reliable values in pediatric individuals because the cortical development is not fully achieved. Similar is the situation in elder patients also, because with increasing in age, there is chances of cortical degeneration. So it may not be appropriate in elder individuals also. Then the most important thing is the clinical context. These monitors does not take in the physiological parameters of the patient. So we have to interpret the numbers based on the clinical scenario or the clinical condition of the patient. So should we see the number alone? So in our anesthesia monitor, we always have a waveform along with the number. So we always see the waveform and the number. Even if you see for blood pressure, we'll see the arterial waveform, and then only we'll see whether the value is correct or not. Similar is the situation with pulse oximeter also. Always we'll trust the waveform, then we will see the number. Then only we will come at a conclusion that the number is trustable. Even for ventilator parameters also, ETCO2, though it gives a number, we always see the waveform also. So we should always see the EEG waveform as well as the index number or the number. So we should not lose valuable information by just using only an index number, because this EEG provides us with rich information about the state of the brain. So we should consider both the EEG as well as the index number. So why raw EEG analysis has become a challenge? Because when you see an ECG, we have a regular repetitive waveforms are there, which is not seen in an EEG. We don't have a regular waveform, a repetitive waveform, or a definitive waveforms are not seen. What we usually see is the frequencies and the amplitudes. Then like that, we'll classify the EEG frequencies into different classes. 5 classes are there: alpha, theta, delta, beta, and gamma. So if you see we know that delta frequencies are slower frequencies, and gamma and beta are higher frequency waveforms. So if you see the waveforms, we can easily interpret that these waveforms looks like a higher frequency waveform, and these waveforms are slower frequencies with higher amplitude. So under anesthesia, or when the patient is awake, usually we will have a higher frequency waveforms, higher frequency, slow amplitude waveforms. With increase in depth of anesthesia, there will be change in EEG waveforms from higher frequency to lower frequency, higher amplitude waveforms are seen. So with increase in depth of anesthesia, the waveforms changes to lower frequency, higher amplitude waveforms. So these are the patterns what you see under general anesthesia with propofol. So when the patient is awake with eyes open, here we can see higher frequency oscillations are seen. When there is paradoxical excitation, we can see beta oscillations. When the patient is under sedation with propofol, here we can see predominantly alpha and beta oscillations are seen. See, if you see compare between A and C, we can see that A frequencies appear higher frequency. Here the amplitude are also more. So there is a shift towards lower frequency waveforms. So this is when you are using propofol for maintenance of anesthesia, you will get predominantly slow waves and alpha oscillations. And during induction, you will get predominantly delta oscillations are seen. You can see higher amplitude, slower frequency waveforms. And this is burst suppression. And with further increase in concentration, we will get an isoelectric EEG. So when you see an EEG waveform, it looks complicated, because actually an EEG waveform is formed by multiple waveforms superimposed on it. So if you analyze this EEG, we can see multiple waveforms in the EEG. So here we can see one sine waveform going like this. Along with that, you can see another waveform, which is of higher frequency waveform. So this is how an EEG waveform is formed. So analyzing the raw EEG is very difficult, looks difficult. So now comes the concept of spectral analysis. Now spectral analysis is used to decompose the EEG waveform into its component EEG waveforms. So if you see this EEG waveform, the component waveforms are extracted from the parent EEG waveform. Usually we'll see alpha oscillations and delta slow waves are seen. So this is spectral analysis. By spectral analysis, we'll see all the frequencies that make up the signal, and along with that, it gives the power at each frequency. And power is the 10 times logarithmic square of amplitude. So they'll provide a spectrum. Now, spectrum means all the frequencies that forms the raw EEG. So when you take this EEG waveform, this is the spectrum that it provides. So if we see, this is known as frequency domain analysis. Here on the x-axis, we have frequency, and on the y-axis, we have power. Power is square of amplitude. So if you see here, we can see that most of the waveforms are in the maximum power is in the lower frequency range. So 0 to 3 hertz in the delta frequencies. And it is followed by the next higher power is at around 10 to 13 hertz. So this is how a spectrum is formed. So from the spectrum, we'll get two other values. The solid vertical line is the spectral edge frequency 90. That is 90% of the frequencies are below this particular frequency. And the other one is median frequency. Median frequency divides the spectrum into two halves. So basically, if the SCF is low and median frequency is low, this implies that the depth of anesthesia is more. So next is what I told previously is for a particular instant or for 1 second analysis of spectral analysis. So if we want a continuous analysis of EEG, we have to analyze we have to do spectral analysis at each second, and we need a 3D spectrogram. So the x-axis will be frequency, y-axis will be power, and each frequency is at each second it is analyzed, and on the y-axis time is plotted. So a 3D spectrogram is formed, that is known as compressed spectral array. Then to plot 3D spectrogram is difficult, so we have a 2D spectrogram. Here the difference is that in the y-axis we have frequency, and in the x-axis we have time, and the power is represented by color codes. Actually, here we can see warmer the color means higher the power, and cooler the color means lower the power. So if you see this spectrogram, here we can see warmer colors, red colors are seen here in the lower frequency range. Similarly, here in the alpha range also warmer frequencies are seen, yellow and red frequencies are seen. So this is a density spectral array. Now, newer monitors provide us with a density spectral array like BIS-VISTA bilateral monitor. Then the SedLine monitor also provides a density spectral array. Here we can see the density spectral array provided, and this white line represents the spectral edge frequency 90. So when using the depth of anesthesia monitor, we should see both the EEG waveform as well as the number. So if you see here, we can see the waveform looks like a high amplitude, low frequency EEG waveform, and the number it's shown is 43. It's almost, it's in the depth, adequate depth. Then this waveform, if you see, we can see the almost isoelectric waveforms are seen, in between bursts are seen. So burst suppression pattern is seen. Here we can see suppression ratio of 15 is seen. So this is the value shown by Connox monitor. Here also we can see higher amplitude, lower frequency waveforms are seen. And this is the EEG mode, GEEG module. Here it will not provide a number, but we can see the EEG waveforms. Along with that, the spectrum is also shown, and the spectral edge frequency is also shown. So this is with SedLine monitor. Here we can see higher amplitude, lower frequency waveform. Patient state index is around 50, adequate depth 25 to 50. And here spectral edge frequencies are shown, and the density spectral array is also being shown. So this is the waveform what you get in an entropy monitor. Then coming to EEG signatures, each drug has a particular EEG signature. So this is very important in managing anesthesia. So first I will discuss with propofol. So propofol, when used for sedation at a concentration of 2 mics per ml, predominantly we will get delta oscillations and alpha beta oscillations. So here we can see, if you see the density spectral array, warmer colors are seen in the lower frequencies. So the delta oscillations, and ranging from 12 to 25 to 30 hertz. So alpha beta oscillations are seen with propofol sedation at a concentration of 2 micrograms per ml. Now, with induction, what will happen, we can see. So this is when the patient is awake, and with a 200 milligram of propofol bolus, the higher frequencies have come down. We can see only delta oscillations. And when propofol is used for maintenance, we can see predominantly alpha oscillations and delta oscillations are seen. So when propofol is used for maintenance, the signature is alpha oscillations and delta oscillations are seen. And when you come out of propofol, when you stop propofol infusion, the characteristic signature pattern seen is zipper opening pattern. So here we can see this is the alpha frequencies. Here we can see once the propofol infusion is stopped, we can see there is a gradual shift towards higher frequencies. So this pattern is known as zipper opening pattern. So these are the various signatures with propofol. With sedation, you can see predominantly beta gamma oscillations. With induction, slow delta oscillations are seen. Maintenance, alpha and delta oscillations. And emergence, we see a zipper opening pattern with predominant beta gamma oscillations. Now coming to ketamine, signature of ketamine. So with ketamine, you will see higher frequencies are seen in the range of gamma frequencies and beta frequencies. So this can give false high values with depth of anesthesia monitor when we are seeing the index only, even though the patient might be well anesthetized. Now coming to dexmedetomidine, dexmedetomidine signature is dose dependent. So if you see dexmedetomidine, this pattern shows at a lower concentration at around 0.6 microgram per kilogram per hour. Here we can see delta oscillations, and another waveforms are seen in 10 to 15 hertz. And this pattern looks like that of propofol alpha oscillation, but it is not propofol's alpha oscillations. These are sleep spindles. Here we can see in propofol signature, you can see those frequencies are continuous. Here it's not continuous. These sleep spindles last for 1 to 2 seconds only. So this is a signature of dexmedetomidine at slow at around 0.6 microgram per kilogram per hour. Then at higher concentrations, those sleep spindles will disappear and predominantly delta oscillations are also seen. And so we have to take care when we are using dexmedetomidine with depth of anesthesia monitor. It can provide you with a lower index values, even though the patient may be easily arousable. Now coming to inhaled anesthetics. So inhaled anesthetics, they will provide an EEG signature which is similar to that of propofol with alpha oscillations and delta oscillations. But this is dose dependent. That is, at less than 1 mic, you will see alpha oscillations and delta oscillations. When you increase the concentrations at around 1 mic, there will be shift from alpha oscillations to theta oscillations are seen with higher mic concentrations. So this is the pattern when you use inhalational agents. So here we can see alpha and delta oscillations, and at 1 mic we can see shift towards theta frequencies and delta oscillations. And once inhalational agents are stopped, we can see opening up, and we can see higher frequencies are appearing here. So what are these limitations when we use with EEG monitor is that most of us, we will use combination of drugs. We will using a combination of drugs, propofol, phenylephrine, propofol, dexmedetomidine, and each has its own signature, particular EEG signature pattern. So we are not sure what is the particular EEG signature with a combination of drugs. So to conclude, most of the depth of anesthesia monitor we have the EEG, raw EEG density spectral array is also seen. So we have to analyze both, assess both EEG waveform or density spectral array and the numbers. And spectrogram provides us with rich information, and it is usually easy to interpret, and we should be able to recognize changes in EEG, and always interpret EEG with numbers and with the clinical condition of the patient. Thank you.
Thank you, Jerry. It was a very nice presentation, very nice, clear and informative. He clearly mentioned about the advantages and disadvantages of various depth of anesthesia monitoring. In our institute, we do use all the depth of anesthesia monitoring, whichever he has shown in the pictures, which has been taken from our institute actually, which makes our residents to practice the depth of anesthesia monitoring and think beyond the numbers. So it was very clear and very good presentation, Jerry.
Thank you, sir.
Any questions?
Well, if the time
In
permits.
chat, there is one question raised by Ashutosh that is directed towards awake craniotomy. Would you like to take it, Dr. Gyanendra?
Yeah.
Ashutosh Kaushal has asked, what is the minimum pediatric age for safe craniotomy and which anesthetic technique to be preferred?
Dr. Rahul,
Yes, sir.
are you able? Will you like to answer this?
Yes, sir. As such, there is no safe limit to a pediatric age where a safe awake craniotomy is feasible. There are reports where as young as 8 years, there was an 8-year-old girl, I believe it was in one of the Scandinavian countries, where awake craniotomy was done in an 8-year-old girl as well. So it all depends on how mature the kid of a certain age group is. It's very difficult to kind of give a safe threshold. But largely speaking, we usually do it in adults, assuming their mature intellectual levels. But it is not a rarity that it has been done in the kids. There is another case report where it was done in an 11-year-old boy somewhere in Lebanon or Turkey, I believe. So yes, it is very difficult to set a threshold. But if the baby is able to, the child is able to cooperate and in preoperative assessment, if the surgeon and if the anesthetist also feels that he will cooperate, he or she will cooperate, and they will be able to.
Right, your point is well taken, and there is no age limit as such defined for any surgery, this awake craniotomy. But yes, you have to see whether the patient is fit into the category to go into the awake craniotomy. If he's considerable, he understands, so that So yes, Doctor.
Dr. Anil has raised a hand, I think.
Sir,
so would you like to ask some question or give some comments?
Dr. Anil, sir, please.
Just a comment, because I had an 8.5-year boy and I had not done like awake, sleep and awake. I just sedated him and explained him very well with the plot. That's and they cooperate well. That's, as you rightly said, there is no age. Thank you.
Absolutely, sir. And this is one I had a
next question is.
Yeah, Dr. Ashish, keep.
Okay, the next question is for Mangesh. That is by Dr. Arvind Arya. That is, how much is efficacy of keto diet in management of status epilepticus? Experience in your ICU.
Hello. Sir, I don't think I have a good experience of use of keto diet. It has been used in pediatric neuro-intensive cares, which I have learned from few of the senior residents there, but we haven't used it in our critical care unit. That's why probably. Sorry,
so we use ketogenic diet as for the chronic epilepsies, and it's an adjuvant therapy. So exact efficacy of ketogenic diet in treatment of the refractory status epilepticus per se, the single thing we cannot say out, because the studies have used combination of drugs, and ketogenic diet has been used in adjuvant. So its efficacy in chronic epilepsy in pediatric patient is defined to be high. I don't remember the percentage, but it is said to be some children are quite responsive for that. But in critical care units, it's basically used in adjuvant therapy. Thank you. The next question is
one more
for
Dr. Ashish has come is for awake craniotomy. If patients, I think this should be the last question because we are running
yes,
short of
there
time.
is one for Jerry also. So maybe he would also like to answer. Yeah.
Rahul, for you, if patient agrees and comfortable with small brain
You can
tumor,
go ahead. There are plenty of times. Okay.
Okay. Should one do all cases as awake craniotomy? What are the pros and cons about it?
Could you repeat that, sir? I'm sorry.
Yeah, if patient agrees and is comfortable with small brain and is having a small brain tumor, should one do all cases as awake craniotomies?
There is, I don't think there is an if and all for all the cases, sir. Again, as said, as you are saying, that if it's a small lesion, if the surgeon deems it can be done with minimal amount of hassles, and if we deem the patient is strong enough in the sense, if he seems compliant enough, mature enough to understand, there's nothing harm in doing so. But of course, we cannot say that all cases. We will have to factor a lot of factors as far as the anatomy is concerned, as far as vital structures, the mass effect, and how the preoperatively patient's symptomatology has been, like if the symptoms have been controlled or not. And definitely the overall, as we the old dictum say, the old dictum of the benefit outweighing the risk. So if there is more risk involved in keeping the patient awake unnecessarily, then we might have to take that option away.
Right, Rahul, but there is a pool of thought which states that probably awake craniotomy can be an alternative to an craniotomy under general anesthesia.
Absolutely.
However, it's the patient choice and the surgeon's comfort and the anesthesiologist who will determine. Right now, it's more towards the general anesthesia, and with the intraoperative neuromonitoring available, awake craniotomy may find its place in limited cases only, because we have the option of intraoperative motor evoked potential monitoring of the cortical stimulation and techniques to map the eloquent areas under general anesthesia.
Absolutely.
So there is
major advantage being the reduction of hospital stay, ICU stay, which is quite far superior in awake as compared to a general. So that definitely has one can consider, even if the indication doesn't permit.
So there is no straight away answer to this, that you are this or this. It is basically on the basis of whether what is the risk benefit ratio of doing each procedure. If there is more risk in one, then there is no point. You have to select your patient, select your thing, and you have to see which is more beneficial. Yes, of course, if a small tumor is small and patient is comfortable, he is ready to go. And if there is a definitive benefit of taking it, obviously, but we can't forget that even awake craniotomy has its own
challenge.
risk. So we have to choose the patient.
Right. Jerry, a question for you. Yeah, the question is, how would you rate various DOA monitors? Which one is your favorite? Number one, can you please, they have asked for each monitor plus pros and cons, but I would like you to just answer for the first one and why. A very crisp answer we would like to have from
commonly
you.
We use BIS and SedLine monitor in our OTs. So BIS, as we all know, we have been using since many from during PG times itself. BIS we are used and we are comfortable with that. And recently we have started using SedLine monitor also, which provides patient state index. So what we noticed with SedLine monitor, which provides 4-channel EEG and 6 electrodes are placed. So it has multiple external interferences are coming. Then it's not much suitable with craniotomy because it is applied bilaterally. And in between readings will come, but in between the readings may not be reliable. So those things are happening with craniotomy cases with SedLine monitor.
Okay. Dr. Balasubramanian, any add-on to your student? Any other comments?
Yes, ma'am. As he said, I think the SedLine monitor, we are doing a project on it actually. We're comparing the SedLine monitor with the raw EEG also. I think the results are yet to out. And we do use BIS and SedLine monitoring. And the advantages and disadvantages are already said by Jerry, ma'am. Yes.
Okay, thank you. And last one is from Dr. Tumul to Dr. Mangesh. That what is the role of trigeminal nerve stimulation for refractory epilepsy?
Yeah, I have come across one of the case reports of use of trigeminal nerve stimulation, but there is not much data how it works or whether, because there is multiple drug treatments which are used for the same patient. So whether it is because of the trigeminal nerve stimulation or because of the other drugs, it's a bit complicating.
Okay, if Dr. Tumul is available for comments, he may add to. Okay, I think we are done with the questions.
We should end the session now because
I think Dr. Manohar want to ask some question.
Okay.
So he can unmute himself and.
Yeah. Dr. Manohar, please.
Yeah.
Good morning, everyone. Just to add on what Dr. Rahul was saying, I think awake craniotomy, the indications are only two. That is when motor tracts are involved and when there is a speech area involved. So I think for the motor, we are done with the discussion. I think IONM has given us enough techniques to get a patient safe without doing an awake. So if you want to do a motor tumor around the motor area, awake, think about it, because there are enough IONM modalities to give you good outcomes without even putting the patient awake. So if it's around the speech area, then you really need to put the patient awake. So motor tumors for awake, the trend is slowly shifting away from awake towards general anesthesia, because the outcomes are not very much different. And in awake, to choose a kid, it's not one size fits all. So, you might easily lose a patient's compliance in between the procedures. So you need to be very careful as to what you're trying to achieve, and when, it's not very easy to do young, though there are reports of, some patients who are done very young, but most of the times it can end up in a mishap also. So you need to be very careful as to choose, the right patients.
Absolutely agree with you. And as such,
Dr. Yanandar, can I add something?
Yes.
Hi, Dr. Saurabh here. Just to add that when you wanted to do an awake craniotomy in every patient, the problem is greater total excision. The greater total excision have been reported to be quite less when you do an awake craniotomy and when you are going to do it in general anesthesia. So that's the main problem when you are going to say that we are going to do a awake craniotomy in every patient. So there is, I think, the largest series which I have come across is from the Japan. So they are doing it as an outpatient procedures, but I think our patients right now are not good enough, I will say educated enough to handle those things at home as well.
Right.
Yes, agree. Even one of the series published from the institute, it showed a lesser good outcome with use of awake craniotomies. Though the literature changed over the years, but the previous study clearly, distinctly showed this. So, but there is a resurgence wherein we recently encountered a case wherein patient wanted to get operated awake, and the one who got operated was the one to motivate the other patient because of the satisfaction scores, etc. So it's an endless controversy, I think.
So with that, I think we come to the end of this session, and I again thank the organizers and all the speakers for the wonderful talk. Thank you, everyone.
Thank you, everyone.
Thank you.
Thank you, both our DM students for excellent presentations and great discussion. Thank you.
Thank you. Thank you.
Thank you. It was really nice session, and we finished exactly on time. And nice and elaborate session. Thanks to all the participants. So now we are moving into our session 3, that is SAARC session. And the chairpersons of these sessions are Dr. Keshav Goyal. He is additional professor in AIIMS, New Delhi. His area of interest is neurocritical care, neuromonitoring, autoregulation, and prognostication. And he is instructor for ATLS, ACLS, and many things. He has got 80 publications in peer-reviewed journals and 7 book chapters. He is also awarded Young Talent Hunt Award by ISCCM. And our next speaker is Dr. Sujata Ghosh. She is from Kolkata only. Associate Professor, RG Kaur Medical College, Kolkata. She has got experience and clinical interest in many fields. And she was a speaker, moderator, and chairperson in many conferences. And she has got interest in various types of anesthesia. And she has got many awards and honors. One is Vasudev Guha Memorial Paper Competition. And she is also winner of Jaipur Award for acute pain. She is also honorary secretary of ISA West Bengal and past treasurer of All India Difficult Airway Association, West Bengal. And our third chairperson of the session is Dr. Manish Marda. He is HOD of Max Hospital, Vaisali, and also DM from AIIMS. His special interest is neurocritical care and many publications and presentation. So I will ask Dr. Keshav Goyal to come on the dais and introduce the first speaker.
A very good morning all. It is indeed a pleasure to be part of this ISNACC 2022 and especially of this SAARC session, which is covering the most important topic, the COVID-19, which is on the tongue of almost even a child nowadays. And really it has affected all of us globally. And as far as our specialty is concerned, we had to reorganize, we had to reshuffle our manpower as well as the machinery. So how we have managed these patients, we have given space to the COVID patients as well as timely managed our patients also in a timely manner, like time is brain, and we have managed them timely. So how we have balanced these things. So for that, this I am very happy to invite Dr. Subhas Acharya from Nepal. He is a professor in anesthesiology and critical care, and he is a consultant intensivist and head of the critical care at Teaching Hospital and Grand International Hospital. He is a president of Nepal Critical Care Development Forum also, and he is a general secretary of Asia Pacific Association of Critical Care Medicine. He is a very dynamic personality, and so we'd like to hear from him his topic. Please, Dr. Subhas Acharya.
Namaste. I would like to thank ISNACC
for giving me this opportunity to present at this conference. I'll be talking about COVID, managing human resources in the ICU. These are the organizations I work for and my conflict of interest. Before moving on to the challenges of managing human resources in ICU, I would like to shortly review the history of critical care in medicine in Nepal. It's very recent, and the ICU started only in 1973 when the then king had a heart problem. He was taken to Delhi, and then after he came back, he started a 5-bed ICU. And after that, there was another ICU developed at Tuen University Teaching Hospital, which was another 6-bedded ICU. So this were the total 11-bed ICU for another almost 20 years. The society, Critical Care Medicine Society, is also very new, which was established only in 2010. And most of the members are from anesthesiology, internal medicine, or some intensivist. Till 2010, there were no trained intensivists. According to a publication in 2012, there were only 450 ICU beds, and most of the ICUs were open, around with 7.2 per 100,000 ICU beds, and only 2 trained intensivists. The academic program DM in critical care medicine was started in 2013 with collaboration with Royal College of Canada, and taking 1 to 2 DM per year. The scenario now, prior to COVID, was almost similar. The government of Nepal has established, endorsed the guidelines in 2014 that the hospitals would have at least 5% ICU bed, at least 1 ventilator for 2 ICU beds. Like there's separate isolation bed, 1 nurse patient ratio should be 1:1 to 1:2, but they are all far beyond the reality. Most of the government hospitals do not meet these criteria, and even the largest hospital has less than 5% of critical care beds. No way that we are able to handle and manage like a nurse patient ratio of 1:2 to 1:3. And just at the beginning of the COVID, Nepalese Society of Critical Care Medicine did a survey which found that Nepal had 480 ICU beds with 260 ventilators, and 150 beds were in the government hospitals. There were around 800 critical care nurses and only few intensivists. And with the onset of the pandemic, this paper was published with trying to identify the capacity of the ICU. There were 194 hospitals with ICU, total 1,595 ICU beds, and total ICU beds with ventilators were 840. There were 21 trained physicians and 2.8 ICU beds per 100,000 population. This was in April 2020. And with the onset of COVID, government started to increase the additional ICU beds, temporarily 200 plus ICU beds and around 800 SDU beds, which were developed over 2020 to 2021. And there are short courses of training given to doctors and nurses. Considering critical care physicians, there are only 7 DM critical care physicians, and some are pulmonary critical care, only 1 neuroanaesthesia critical care, a few fellowship in critical care from Toronto, few of them from India, total only 32 critical care physicians in the country. So with this background of Nepal, I'll be talking about managing human resources in ICUs overall. So as the COVID crisis hit, there were manpower shortages in almost all hospitals, not only in Nepal, India, all over the world. And there were many critical care source response strategies that were implemented throughout 2020. And this was mostly derived from United States, where they have a strong baseline statistics of human resources. And this research, during the surge, they focused on space, stuffs, and staff. We'll be dealing with mostly with the staffs in this talk. If we see the baseline ratio in the United States, they had around 97,000 ICU beds in 2020. 94% were located in metropolitan areas. Physician to patient ratio was 1:10. Nurse to patient ratio in the ICU were 1:1 to 1:2. And respiratory therapist to patient ratio was 1:4 to 1:14. And total 62,000 ventilators, which were like 20.5 per 100,000 people. But as I showed an example or background of Nepal, the situation in low and middle income countries was like not this good, very bad. And to mitigate this surge, what they planned was for the nurses in the ICU, they started drawing on shift or from outside the ICU, like the PSU nurse pool for the ICU care, or they started recruiting out of shift ICU nurses from other facilities. What they did was like they did a training, just in time training, which was like 2 hours session for all these non-ICU nurses. And they implemented crisis standard for ICU and also used upper level nursing student to assist with the care for the less sick patients to free up the floor nurses for the critical care. For the respiratory therapy, they increases the ventilator to RT ratios, and they also draw the off-shift operating theater nurses and operating theater nurse anesthetists either to work independently or under the supervision of RT. Whereas for physicians, what they did was they also draw the off-shift emergency doctors, anesthesiologists, physicians, surgeons with critical care, or experience with ICU care. They also recruited off-shift ICU physicians from other federal facilities. And regarding nurses' capacities for management of critically ill patients, the top one shows the standard ICU staffing model where the ICU is led by a doctor, critical care doctor with the nurses, and each of the nurse, ICU trained nurse, looks after 1 or 1 to 2 patients. So, but in the ICU tried staffing strategies, which is also called as the care team protocol. So during the surge, what they started this in United States is one critical care, under the critical care doctor, there are ICU trained nurses, and one ICU trained nurses supervise 2 other non-ICU nurses who in fact run the patients in 1:2. So one ICU trained nurses is supervising almost 4. And during this time, this off-duty anesthesiologist was managed with, like they were called for duty either 12 hours or 24-hour shift, and they used to come on duty for every 24 hours. The nurse-patient ratio was around 1:4. One non-critical care nurse used to manage 2 patients under supervision of critical care nurse and the respiratory therapist, or registered nurse anesthetists were asked to manage the ventilators. This is the tiered staffing strategy for pandemic given by the Society of Critical Care Medicine. If you see here, one trained or experienced critical care physician used to see different care teams. This is a care team model where there's one non-ICU physician, there is a respiratory therapist, other doctors, pharmacists, and one nurse. One ICU nurse is supervising another 2 or 3 non-ICU nurse or advanced practice nurse. So this is one care team model, whereas one critical care physician is managing multiple, around 3 to 4 care team models during the surge. And this was the most commonly utilized modality of human resource management in the ICUs. And various guidelines has been published about how to manage, how to overcome the shortage of ICU staffs. And this is one of the publications which mentions that among various strategies, one is suspending all elective medical surgical procedures once there is increase in number of cases. Another is to temporarily redeploying healthcare workers and trainees to ICU to work in a care team model. And another is providing just-in-time training and simulation session for non-ICU clinicians and even doctors and nurses reassigned to work in the ICU to better prepare them for the roles. So this was the best approach that has been identified so far. And so what are the strategies that various countries used to expand health workforce during the pandemic? If you see this, this was a publication done from a study of 44 countries. Most of the countries, they called upon medical and nursing students to work in clinical practice, almost 36 countries. And these are the examples: Bosnia, Malta, Serbia. There were campaigns launched to bring retired or inactive healthcare professionals back to the workforce. This was done in many countries, including Belgium, Denmark, Germany, and Iceland. Countries have also implemented emergency recruitment procedures to hire new healthcare workers. For example, Portugal hired around 1,100 nurses and 137 doctors. Serbia, they hired 4,500 healthcare workers, whereas Romania hired 2,000 temporary healthcare workers for 6 months. Volunteers have also been enlisted to support the COVID-19 response in selected countries like France, Belgium, Greece. They announced volunteer vacancies for volunteers and called upon volunteers to help with the crisis. There were other recruitment strategies which have targeted migrant health workers, health professionals from private sector, armed forces, or even foreign countries. And this was employed in countries like Belgium, Ireland, Italy, Greece, Spain, and UK. This was the strategies done to mitigate the healthcare worker crisis during the pandemic. Now, how did we, low middle income countries like Nepal, India, and developing countries handle this COVID-19 in the ICU? After COVID-19, there was a huge surge in hospital patients, cases were overloaded, and we were lacking emergency directives. Like we didn't have specific protocols in the beginning. The number of ICU beds was less, so we started increasing, converting general wards or any wards into ICUs. We started increasing number of COVID-19 beds, and new ICUs were formed. The government started buying ventilators, like building up oxygen planted resources, PPE. That was the priority, and the PCR labs. In Nepal, prior to the COVID, there were only one PCR lab was established, but within 2020, there were around 50 plus PCR labs. And now there are 80 plus PCR labs. So the PCR labs were increased. So there COVID, where there were a lot of wards were converted into COVID wards. Old ICUs were converted into COVID ICUs. Even step down units, all the wards were started to convert into COVID units. But what about human resources? There was a complete lack in planning and managing human resources in ICU, and there was a very big challenge in our setup. As we had a lack of specialist doctor, this was a major problem faced by many hospitals and ICUs in Nepal, India, and developing countries. There were lack of intensivists. So ICU was being managed by anesthesiologists, other department consultants, even internal medicine, general practitioners, whoever was available. Having an anesthesiologist was a blessing to the unit. And lack of ICU trained nurse. There were no ICU trained nurse, very few. So the ward nurses were assigned and paired or tagged with the trained ICU nurses, or was being supervised with the ICU nurses. But there was no definite pattern as we could see that happened in developing countries. In the first wave, everyone was scared, and the problem was PPE. We didn't have adequate PPE, and our shifting pattern was not managed. So we were doing a 12-hour shift. There was not enough time to go to eat, drink, bathroom, and even we were using hazmat suit for PPE, and taking off the PPE and then getting it again was very time consuming. And then also the PPE were like so not available. And then we tried to change the shifting pattern to 6 hour, which was more comfortable, but we required more staffings. And then we again went back to 8 hour shift, where 4 hours, one team used to dawn in and another team used to stay back. So 8 hour shift with half of the people going into the ICU in and out. But the challenges was like, one team used to be active for a week and one day was covered by one team. So we need like 3 sets in 1 week, and one whole set, like all those teams used to be on quarantine for a week. Previously, the problem was that there was like quarantine for 14 days. And so we needed like 3 sets of manpower for week 1, week 2, week 3. One set was active, other 2 were on quarantine. And then we later on, after the publication from the Singapore came out, the quarantine period was reduced to 7 days. And then even then for one unit, we required like almost 4 sets of nurses and around 2 sets of doctors. The number of human resources required was quite challenging in the first wave. Whereas in second wave, there were adequate number of more PPE were available, were more trained, and they were more comfortable wearing the water-resistant gowns and the PPE, not the hazmat suit. So even like in the second wave, people were saying like, I don't want to wear hazmat suit, give me a gown. And most of the time, we are not scared because most of the healthcare workers were vaccinated. So, but the challenge in the second wave was too many patients. There were too high number of patients, and moreover, the crisis of oxygen was more challenging rather than clinical management and human resources management. And the challenges faced by healthcare workers in these 2 waves were the high workload, lack of PPE in the beginning, and low social acceptance. When the healthcare workers went back to home, they were not allowed. Even people protested keeping them in the hotels. There were so many mental health problems and also lack of incentives. You know, like mostly commonly in private hospitals, the nurses were in quarantine period, they were not paid, like they were on loss of pay. And also there were lack of coordination and direction from our stakeholders, basically government, ministries, and various bodies that was felt by the healthcare workers. And mental health impact was very much, according to this study, the incidence of anxiety was like 23.9 to 62%, and depression was almost 27 to 50%. This was because of the change in role and workload, impact and symptom on general and mental well-being, reasons and triggers impacting mental health, and the susceptibility to infections. And there are also physical impact and impact on life of medical health workers. And in Nepal also, there are quite few publications discussing about mental health impacts among healthcare workers. So considering this, what are the way forward managing human resources in ICUs and hospitals? First and foremost is the safety of the healthcare workers. So number 1 is the physical safety of the healthcare worker. We should be ensuring, like in any disaster or pandemic situation, the strongest point we should be considering is the physical safety of the healthcare worker, providing adequate PPE, and then adequate workplace resources and supplies. In the first wave, we had very few resources, and that was causing much stress to our healthcare workers. Number 2 is ensuring financial security of healthcare workers. We are making our healthcare workers work for 24 hours, 12 hours, 24 hours, and then keeping them on quarantine, but we are not able to pay the salary on time. Most of the private hospitals were not paying salary on time. On the quarantine period, they were off salary. There were loss of pay. So we have to ensure that there is no loss of pay, and we should also ensure personal loans for the healthcare workers, if possible, interest-free or low-interest loans. Also, we should ensure psychosocial safety and well-being of healthcare workers, workplace counseling and psychotherapy, and adequate leaves and rest period in between the crisis period. That will give time for the healthcare worker to regenerate and also to be with the families and reduce the stress. Also, we need to ensure overall safety and well-being by timely education and training. If we see that the just-in-time training that was introduced in the United States to train the non-ICU clinicians was very handy, very useful, and perceived by many non-ICU clinicians as one of the main support during their pandemic surge. So education and training, and also motivation and incentive. Some study also showed that incentivizing healthcare workers in many ways, even some studies showed that monetary incentivizing had given some mental stress relief to healthcare workers in various countries. So motivation and incentives to the healthcare worker should be planned. I would like to thank the organizers, and these are the challenges and management strategies that we followed during the pandemic management, managing our staff in the ICU. I'll be happy to take any questions for discussions. Thank you very much.
Thank you, Dr. Subhas, for the nice presentation. Of course, it was a very difficult time, especially the second wave, and it affected us psychologically as well as economically in all the things. We'll take the questions at the last. I think we can go ahead with the next speaker. Dr. Sujata, yeah, please.
Yeah, our next speaker is Dr. Sujata. Welcome, Dr. Sujata Ghosh, and introduce our second speaker.
I feel humbled to be a part of this August gathering. And with the shift of COVID-19 infection to the multi-system arena, neurocritical care has taken a front seat. And I'm honored to introduce our next speaker, Dr. Navadeva Harendra Kure from Sri Lanka. He obtained his MBBS from the All India Institute of Medical Sciences, New Delhi in 1994. And he has done his postgraduate in critical care medicine and emergency medicine from the Postgraduate Institute of Medicine in Colombo. He is the secretary of the Sri Lankan Society of Critical Care and Emergency Medicine, and was also the founder president of Sri Lanka College of Emergency and Retrieval Medicine. He is the member of the Advisory Committee on COVID-19 Sri Lanka Medical Association. I welcome Dr. Navadeva Harendra Kure. Doctor, please.
It is indeed a pleasure and a privilege to be invited to give this guest lecture at the 23rd annual conference of the Indian Society of Anesthesiology and Neurocritical Care. And may I extend my deepest gratitude to Dr. Indranil Ghosh for communicating with me and facilitating this. So I would like to share my slides. So over the next 20 minutes or so, I'm going to briefly discuss my personal experience and what we went through at the height of the COVID pandemic that hit us recently in the recent past, where absolutely nobody is being spared at the moment. So it's titled Neurocritical Care Amidst COVID-19. So I'm an emergency physician by profession, but have much involvement in critical care medicine. in my country. Emergency medicine is a very new specialty in our country, but we are just forging ahead with every opportunity that we are given. So very briefly, background about myself. So I had the fortune to attend this very prestigious institution, which is your own institution. This is the All India Institute of Medical Sciences in New Delhi, where I did my undergraduate studies way back in 1990. I graduated in 94 and returned to Sri Lanka in 1995 after my internship. And ever since then, I've been practicing clinician in my home country. So Kolkata and Colombo, there's a straight air link. This is an open invitation to any of you who are happy to visit our beautiful island nation. Please get in touch with me if I can be of any use. So it's a fair distance, but with the current global pandemic, I know it's a bit difficult to make air travel. So we had to resort to modern technology. I'm very much involved in the Sri Lankan Society of Critical Care and Emergency Medicine, and I'm now currently involved with our own college, which is very new. So that's a bit of who I am and where I'm from and where I'm practicing. This is where I worked. This is the Neurotrauma Center of the National Hospital of Sri Lanka, which is based in Colombo, which is our capital city. This is actually a dedicated neurotrauma center because, as you are fully aware, our Southeast Asian countries with very high population density, with not the best of public transport, we get a large load of motor vehicle accidents. And this is a tertiary care center that looks after neurotrauma patients. It is a fully fledged institution with is self-sufficient in providing neurocritical care, neurosurgery, rehabilitation, and even ward-based management. We are well equipped. We have approximately 60 critical care beds, including 30 intensive care units for the neurotrauma patients. We are well staffed with 6 full-time neurosurgeons, 5 neuroanaesthetists, and 2 neurointensivists. And I was the first and the only emergency physician who mans the emergency treatment unit of this very impressive building. We see about 2,500 trauma cases per year. And with the COVID, the numbers obviously have changed. It is less in number because of various reasons, as even during my talk, I would elucidate too. So SARS-CoV-2 took us by storm, so to say. It became a global pandemic in 2020. Sri Lanka was kind of spared initially. And our very first case of confirmed COVID-19 was this Chinese tourist from Wuhan. This was in March of 2020. And we were extremely happy, as you can see, once she made a full recovery and was discharged. But of course, things that followed is pretty grim. The worst, obviously, was the Delta variant that took us by storm. No one was spared. All the neighboring countries of India were affected, and Sri Lanka was no exception. And unfortunately, Colombo and the suburbs of Colombo in the Western province was the worst hit. And we had to take a brunt of the critically ill and the severe COVID patients presented to our hospitals. So in this context, it was it was not unexpected that even the trauma patients following neurotrauma would present to us with incidental infection because the community spread was quite profound. So what we were faced with was that even though stringency measures were taken, a little delayed, we went into lockdown. That kind of drove down obviously because people were kept indoors, were not traveling too much, drove down the number of motor vehicle accident related neurotrauma. But on the other hand, it led the way to more increased domestic violence, falls at home, people trying to do it yourself, repairs on their roofs, taking taking advantage of the time at home, but it led to kind of a surge in that element of trauma patients. So all in all, what we found was that we were still getting neurotrauma patients, but we were getting neurotrauma patients who had a screening antigen test positive, which meant we were faced with this problem where we had healthcare worker anxiety and phobia because of the nature of the transmissibility and the infectivity and the virulence of this viral infection, which kind of led to a bit of patient neglect. And obviously, us being a tertiary care center, we were not in a position to ensure patient care, neurocritical care, because ourselves, we were not too sure how well we can do it. So there are many challenges with SARS-CoV infection and neurocritical care, obviously, because if you do get the severe or the COVID pneumonia patient suffering brain insult, management would be a nightmare because we have to deal with patients with altered level of consciousness. We need to therefore secure their airway, and everyone knows that these are high-risk procedures because they are so-called aerosol-generating procedures. So anyone involved in providing neurocritical care under these circumstances was at risk. Then the mainstay of managing COVID-19 in the severe and the critically ill form, the two kind of evidence-based measures, that is the steroids and anticoagulation, obviously are contraindicated in our group of patients, especially trauma patients, traumatic brain injured patients. So this obviously was a real challenge as to if we were to be faced with this category of patients with the comorbid of COVID-19, which is the severe or the critically ill COVID-19s with neurotrauma, it was going to be a horrendous challenge. But what we did see was mostly incidental COVID infection, mildly symptomatic patients presenting with neurotrauma. And what was the obstacle there for us was, providing the usual neurocritical care that we would provide these patients in our institution because of these issues that we had to address. One thing foremost was our own staff members, our colleagues, even myself initially, the anxiety and the phobia surrounding the COVID infection, because Delta variant was not sparing anyone. And mortalities were high. The severe and the critically ill numbers were high. So we felt we were at risk in managing our patients. So we had to do something about it. We needed to train ourselves about safe clinical practice skills. So that was from top down. It entailed all the specialists to our senior medical officers, junior medical officers, our nursing staff, our intensive care staff, our allied health, sort of the radiographers, the chest physiotherapists, everyone who plays a huge role in managing neurocritically ill patients had to be spoken to, had to have simulation sessions, and we had to start from scratch basically to ensure that we have our own safety concerns looked after while providing the optimum care for the neurocritically ill patient. Similarly, we had to create a critical care unit that was capable of maintaining that safety, where we could optimally manage our neurocritically ill patients in providing, intensive care, such as invasive mechanical ventilation, close monitoring, and ongoing, suctioning, chest physio, all the things that entail high risk for aerosol generation had to be provided for our patients to ensure that they get the best care while not compromising at all and still being safe for the healthcare worker. So this was a challenge, and this had to be overcome. This had to be overcome very fast because it appeared that the Delta variant was raging on, and more patients were presenting to us with infection, but with neurotrauma as well. So paramount for us was to prevent patient neglect. There were instances where we had to transfer out neurocritically ill patients who needed neurosurgical intervention to COVID care, critical care units, which had no capability of managing them. And that was absolutely unacceptable. And from a perspective of a tertiary care center, it was absolutely unacceptable. So that led us to make the transformation in a short period of time. So personal protection obviously was important, and myself, my staff, and my entire crew had to kind of be taught about personal protection. We had to provide them with the necessary equipment. We had to ensure that they understood the very essence of it being a personal protective equipment. That means it is up to you to protect yourself. But having said that, we had to also provide them with the standard of equipment that would ensure that carrying out high-risk procedures in our patient category would be a certainty. So we had to resort to a bit of improvisation. As you can see, the scuba gear, which came in so handy, and that's myself really donning it. Because to carry out intubation, to insert central venous catheters, sometimes the standard recommendation of goggles and face shield gets in your way, and it can compromise your ability. But this particular device was absolutely fantastic. It ensured safety for me and did not obscure my vision in any way. So certain things, certain accepted innovations were practiced in our unusual situation where we had to adopt ourselves to manage our patients. Similarly, we had to do certain rethink and stick to protocol, especially in intubating our patients, because as you know, the majority of neurocritically ill patients do need to have a secure airway, and invasive ventilation is always one of the methods. So that neuroprotective ventilation is more or less a must in most of our patients. So there was no escape for us. So we had to rethink our strategies, be more systematic in our approach, formulate protocols, guidelines, and ensure that every member of the team would abide by them for their own protection and to ensure that our patients are not neglected and do get the optimum care that we always provide. And there was our duty was to overcome this horrendous pandemic situation and ensure that we continue the care. So we had to, formulate our own protocols and guidelines based on accepted recommendations from all these accepted kind of standard protocols from many of the international organizations. So we adapted whatever was more suitable for us. We did have to upgrade our equipment in the form of video laryngoscopes had to be purchased. The government, as you know, Sri Lanka has a free healthcare service. We do not levy any charge from our patients. So the government has to kind of support the healthcare services with a lot of financial aid. And at this kind of unprecedented event, it's a huge burden on the economy. So we did have to resort to, raising our own funds, formulate a fund drive, and, kind of supplement whatever that we needed for ourselves to be safe and to provide the optimum care. We had to fund from sources, and there was an overwhelming response of people willing to do that, and that in itself made things quite easy to deal with a difficult situation. So my unit has 10 beds and with 8 ventilator beds. So I'm able to, so it is more or less a combination of a ED ICU-like setup where I can initiate emergency management and sometimes, even continue care depending on the availability of my disposition. If it intensive care units are full, I'm able to, supplement that care as well. So I had to completely revamp and redesign this unit. We need that physical barriers between the infective area and the non-infective area. We had to create an area for a longer dwell time, which should be non-infective. So, and also we need to come up close to the patient so that we have good visibility. We can maintain the monitoring from the non-infective side. And we generally resorted to about a 2-hour dwell time in the infective area. So our critical care nurses had to regularly change over. Myself and my doctors used to dwell mostly in the non-infective area from a physical barrier so that we were up front and close to our patients. And if the need arises, we could always don our personal protective gear and go in. So that took a bit of training. It took a lot of labor to restructure and redesign. And one of the other main concerns was the ventilation, because we had common air conditioning ducts for the entire area. It had to be separated out. We had to introduce a negative pressure system, which was quite a costly exercise, where the negative pressure would take out the circulating air and then vent it out through a HEPA filter, which is a large HEPA filter, and to ensure safety all around. And we had to kind of spend a lot of time refurbishing, but eventually we got things going and the unit was functional within a short period of time. So as I said, paramount for us was that in spite of the COVID pandemic, in spite of the horrendous Delta variant surging through in numbers, we had to ensure that optimum care was given to our neurocritically ill patients. The map of Sri Lanka that you can see and all the dots are all the COVID care centers that are spread out throughout Sri Lanka, but the neurotrauma center at the National Hospital is the only apex center to manage neurocritically ill patients. Of course, we do have neurosurgical capabilities in most places around our country, but we get a gamut of referrals coming to us as well. So it is absolutely important that we adopt ourselves to the situation and ensure optimum care. And I cannot overemphasize the commitment of my staff, my team members, my junior doctors, my senior doctors, my senior nurses, my junior nurses, and all allied healthcare providers who chipped in, who got on the bandwagon with the intention to provide the optimum neurocritical care to our patient population. So in summary, SARS-CoV-2 infection really posed a lot of challenges to managing neurocritically ill patients in our center. So neurocritical care had to be provided without a break in spite of the raging Delta variant. We had to ensure that patient neglect could not be tolerated. So it was essential that we embark on this transformation of care model where we could allay fears of our healthcare workers and create safe areas to manage these patients. And that entailed a lot of hard work. We had to train our staff. We had to redesign our work area. But ultimately, it was teamwork that was successful in providing the optimum care to our patients. So thank you very much for giving me this opportunity once again. And may I wish the Neurocritical and Critical Care Society, Neuroanesthesia and Critical Care Society of India all the very best and hope you have a very fruitful annual session. Thank you very much.
Thank you, Dr. Kure. That was a lovely speech. And I would just like to ask one of your experiences, if you really care. Like in our country, we found that the cognitive recovery has been very delayed in the neurocritical units. Has it been the same in Sri Lanka? It is mostly in all parts of the world, they are saying that. What is your experience in Sri Lanka about the cognitive recovery of these patients post-COVID-19? Or is it no different? You found the same?
Thank you very much for the question, madam. I'm not really able to answer it in specifics because I think what you're posing is we know that depending on the severity of the traumatic brain injury, the post recovery, especially in cognitive sense, can be very variable. And many factors come into play, especially the age of the patient and so on and so forth. So I'm sure the degree of COVID disease, that is whether the patient was having a severe or critically ill, but I should be very honest with you, the very few patients that we did get with severe and critically ill COVID did not survive. In fact, the mortalities were very, very high. So it is only the mildly symptomatic who really did survive. But I'm not in a position to tell you exactly whether they are.
Thank you so much. Thank you. Actually, it's a question very close to my heart because my grandmother, she died in the very similar fashion. And I started looking up the things. So I really wanted to know the experience. Thank you so much. Thank you.
You're most welcome.
We'll take rest of the question after the session. So we should invite our third speaker. I will ask Dr. Manish Marda to introduce our third speaker. Thank you.
Good morning, all. The next topic is I'm in private practice since I left AIIMS, so that this is very pertinent to all the private practitioners. There were many clinical as well as ethical issues regarding the private practice during COVID pandemic. And the gentleman is Dr. Paediatric Goswami, who is an intensivist in Park Clinic in the Department of Neuroanaesthesia and Critical Care, Park Neuroscience Center, Kolkata. So I request Dr. Paediatric Goswami to share his screen. Dr. Paediatric, we cannot hear you. Please unmute yourself.
Good afternoon, ladies and gentlemen. I bring greetings from the beautiful city of Kolkata. Those who have been here will savor the memories of a winter in this wonderful city with a fantastic history. And those who have not been here, I extend my arms to have a small visit and enjoy the sights and sounds of Kolkata. The topic for today's discussion is the coronavirus and the anesthesiologist in practice. Now, this is a little bit about me. I've been working at the Park Neurosciences Center at the Park Clinic for almost 2 decades now. Haven't moved too much. And we've done a substantial number of cases of neurosurgery, spinal surgery, and plenty of neurointensive care. Now, according to me, the history of human existence can be conveniently divided into 2 parts. And this is a recent development. I call it BC, not before Christ, the conventional thing which you know, but before Corona, and AC, which is after Corona. And I've even conveniently divided the Corona epoch into 2 parts, BV and AB, which is before vaccination epoch and the after vaccination. And as all things in life, the coronavirus has left a very deep mark in every aspect of human existence, whether it's medicine or anything remotely not concerned with medicine. And as you can see here, very, very clearly, how the Nikkei and the Dow Jones and the London Stock Exchange have crashed substantially because of the coronavirus and the trading inequalities. However, as we look at the flip side of the story, as we began to battle the epidemic, learn a few lessons, adjust ourselves, readjust our lives, the stock markets have also begun to pick up over time. And like all things, the bounce back is more important than the fall. So who is at risk for the coronavirus? It's a very popular saying that COVID-19 is not an equal opportunity killer. It kills certain selected individuals. And this is a fantastic graph which tells us who is more vulnerable to the COVID-19. You see 76.7% of all deaths that have happened in the COVID epidemic have happened in those who are above the age of 50. And this is an alarming statistic which tells us very, very clearly that the US deaths from COVID-19 match the toll of the three major wars which the US fought, which is the Vietnam War, the Korean War, and of course the World War II. Believe me, some alarming statistics are still beginning to emerge from the pandemic across the globe. And this year, as of December 2021, the COVID deaths exceed the annual death toll of HIV, tuberculosis, and malaria. Now that sends alarm bells ringing all over the world, in every nook and cranny, in every household across the nation and this big country of ours. So when the COVID came, how did we adjust to it? This is a funny slide. The first phase was, oh, it's just another passing viral scare. Then they said, oh hell, this is getting a bit heavy and serious. Then it was, oh my gosh phase. Life is being turned upside down. Finally, once we know where your apples and oranges are, you begin to say, let us tighten up our seat belts and gear up against the enemy. Finally, when the shots were given, the vaccination came into existence, we began to say, all right, let us readjust our gears and keep this battle alive. It's a battle for existence. It's a battle more fought than the battle at Waterloo. Therefore, we actually did not know what was the true path, what was the correct path. And the only thing which we knew was there was uncertainty ahead. Uncertainty in professional lives, uncertainty in personal lives, uncertainty in the socio-economic existence of human beings. And as we know, in this wonderful article from anesthesiology, that anesthesia care providers are uniquely positioned to be at very high risk for development of COVID infection. Now that does not make you feel very comfortable at any cost. But we knew we had to follow one Charles Darwin. Charles Darwin had a correct observation when he said that it is not the strongest of the species that survives, nor the more intelligent that survives. It is the one which is the most adaptable to change. And over time, we have changed the way we practice neuroanesthesia. And we have adapted to the uncertainty of the coronavirus. So what did we do? We designated a COVID OT and access to it. We had an elevator for suspected and confirmed cases and desegregated the central air conditioning from the operating room. PPEs became a way of life. Masks, gloves, eye shield, and we had minimal operating room traffic. It was like fighting a war against the unknown enemy, the unseen enemy, the unforgiving enemy. The team was led by the senior most anesthesia provider, We tended to avoid somebody above the age of 65. And because we had minimal operating room traffic, we had only one technician for help during induction of anesthesia. It's very difficult to form a designated team. We had teams in rotation of 4 days on and 3 days off. And there was an absolutely clear allocation of roles and responsibilities to every single member of the team. We made it a point to practice correct donning and doffing of the PPE apparatus. The correct donning and doffing sequences are here for you to see and for the juniors to follow, because this is going to be there for some time still before it marriages into a peaceful existence with the human beings. So once the patient came for an operation, we had a rapid assessment of the patient from the cardiovascular point of view. We had minimal personnel in theater. And we realized over time danger of COVID transmission. Therefore, it was at this point of time when we were in business, as we called it, folks. We have protective N95 masks. We have industrial gas masks which we use for medical purposes, face shield, and gloves. Once the masked patient arrived in the operating room, a wet gauze was placed over the nose and the mouth, and therefore some degree of protection was there. We had a mask and viral filter. Over the last 1.5 years, we've been using rapid sequence intubation and the video laryngoscope exclusively for intubating patients. Bag mask ventilation is avoided to the strictest degree, and we had low flow maintenance anesthesia, preferably with total intravenous anesthetics. As far as the monitoring is concerned, we had a continuous monitoring of patient vitals, including the end tidal carbon dioxide, which gave us a very clear idea of the ventilation as well as the other parameters of the patient. Now, this was another innovation which we had to incorporate into practice. And this is a clear acrylic intubation box, which has been used in the operating room. But as the literature will tell you, the ergonomics of this box remain completely undefined. It needs practice to be done. It cannot be done on an emergency basis. And therefore, we had dummy runs and simulation exercises before this can be effectively put into practice. We also defined an indigenous method to avoid aerosol contamination at intubation and extubation. So one of the most important things which happens for inadequate anesthetic planes is cough. And that was prevented by a deep plane of neuromuscular blockade, intravenous lignocaine, propofol. Minimal tube disconnections and suctioning only on an SOS basis. All equipment and surfaces were cleaned with antiviral disinfectants like ethanol, hydrogen peroxide, or povidone iodine. Now, as far as the anesthesia equipment for COVID-19 is concerned, we had a COVID-19 designated trolley, which we gathered from the literature, as well as a backup trolley for emergency situations. One of the most important questions, one of the most thorny questions, is whether to extubate the patient at the end of surgery or not. All non-anesthesia personnel were advised to leave the room during the process of extubation of the patient. PPE for staff was provided. Coughing at the end of anesthesia was strictly avoided. Wet gauze placed over the mouth and the nose at extubation. An N95 applied with the low flow binasal cannula. And if the patient was not extubated, as often happens in neurosurgical operations, the patient was sent to the intensive care unit with a pain circuit to the handover team with viral filters. But there are some special conditions for pediatric neurosurgical patients. We avoid nasal pre-medications. Intravenous induction of anesthesia is preferred. Inline closed suction catheters were used. We extubated deep, and TIVA was used for a significant number of cases. But there are so many combinations in pediatric neuroanesthesia and neuroanesthesia per se, which immediately call for innovation of the operation in the operation theatre. You had an infected patient and a non-infected mother. You had a non-infected patient and an infected mother. You had an infected father, a non-infected mother, and an infected child. So the combinations were endless. And therefore, it called for immediate innovation in the operating room. As far as the post-operative management is concerned, the hospital has a designated COVID recovery areas, surgical mask N95 in all cases. And for people who require post-operative respiratory support, a non-rebreathing mask, helmet NIV, early re-intubation for actively desaturated cases. And despite knowing everything, there are many unknowns in these combinations. As far as interventional neuroradiology is concerned, only emergency cases need to be done. Minimal anesthesia care or monitored anesthesia care for airway management, cleaning up of surfaces with virucidal agents, and rapid and safe transfer of the patients to COVID areas. Now, there are so many dimensions which are still gray in patients with COVID-19. How to manage an awake craniotomy? What about the concept of a regional anesthesia with neurosurgery? What about the pregnant patient undergoing neuroanesthesia for a brain tumor? What about post-operative care and rehabilitation? We don't have black and white answers. We have only gray dimensions to these unsolved problems. And when we don't know the road ahead, the road always diverges. It breaks into two different paths. And believe me, it has a fantastic psychosocial dimension, which all of us have faced over the last 2 years. The psychological status among anesthesiologists and operating room nurses in the outbreak of COVID-19 in Wuhan, where it all began. Incidents of anxiety, incidents of depression, incidents of helplessness, incidents of uselessness have increased tremendously in all operating room personnel over the last 2 years. It's been a slow pandemic of the COVID causing the mind to break down. It's been a mind-breaking story. It's been a heart-breaking story. Occupational stress and mental health among anesthetists during the COVID-19 pandemic. Too much workload, lack of family time, lack of sleep time, claustrophobia, physical illness. The list is endless. The consequences are devastating. And if you don't have a healthy caregiver, what sort of a healthy patient would you exist? Professional fulfillment, burnout, and wellness of anesthetists during the COVID-19 pandemic. This was published in the CanJam. Again, the same results. There have been a tremendous burnout, a tremendous fade out of people who have been forced to leave the operating room and work in COVID units. There have been stories of anesthetic machines being converted into ventilators for sick patients. Stories which have grabbed the headlines time and again. And we've had poor sleep, patients with tremendous anxiety, alcohol abuse to the point of suicidal ideation. And if this does not hurt the mind, what will? We're looking at a story of glorious uncertainty. And yet, despite all of that, we've had to look at the financial stability of the practicing anesthesiologist like me, who's managed to keep his head above the water despite all what life has thrown at me. And this is a closing slide from Professor Martin Smith from the world, one of the figures we all revere. Just as the world will be irreversibly changed by the pandemic, many aspects of healthcare will also be different in the post-pandemic era. We have to change the way we look at neuroanesthesia. We have to change the way we practice neuroanesthesia for critically ill patients. We have to change our personal lives. It's a change which will come from deep within. And as this business marketing slide would tell you, there are no knowns. We know how the COVID virus behaves itself. We know how it attacks the cells. But there are known unknowns. So the medicines which we use for COVID, what are the anesthetic considerations? We don't know. We know, but we don't understand. There are unknown knowns, things which we understand, but we are not aware of. How does COVID affect the brain? How does COVID affect the long-term survival of pneumocytes and neurons? And there are unknown unknowns. The most brilliant question which emerges on this unknown unknown is, when will this pandemic end? So we have to deal with all the 4 quarters of this unknown unknowns grid. But of course, in this brilliant uncertainty that we have, as Carlos Castaneda said, we have to balance the linearity of the known universe with the non-linearity of the unknown universe. And this is the WHO data, which has emerged on the 31st of December 2021. An alarming 11% increase in the number of COVID cases, particularly of the Omicron variety. And as of 26th December, ladies and gentlemen, 2021, as we step onto a new year, 278 million people across the world have been affected with the COVID epidemic. A chilling reminder. And just under 5.4 million people no longer exist because of this tiny, invisible enemy. We have to readjust our lives, our professional existence, and our personal well-being to fight it. I bring you greetings from Kolkata, and have a healthy and safe 365 sunrises ahead. Excellent gathering. Thank you for your time.
Thank you so much for such an excellent talk.
So
if anyone
now,
has any questions, I
yeah,
will be glad to address that.
we'll go for question answer session now, if anyone is having. Professor Amna Goswami has asked some question. I think Partho can answer that.
I did not get to hear what she asked.
Yeah, she has asked whether high flow oxygen is more harmful than ventilators so far as aerosol generation is concerned.
This is a very thorny question. If you look at the literature concerned, high flow nasal oxygen does actually generate more aerosol than conventional mechanical ventilation. But the flip side of the story remains that high flow nasal oxygen actually has prevented a lot of COVID patients from actually going onto mechanical ventilation and dying. So this question is really unsettled. For mild and moderate cases, if a sizable amount of personal protection can be done, then a high flow nasal oxygen offers us a way to avoid invasive mechanical ventilation in these patients. And we know for a fact, we know definitively that patients with COVID-19 who go on to mechanical ventilation have universally poor outcomes as compared to somebody who has not faced the ventilator. So you have to take personal protection, have to take the face mask, complete distancing from patients, minimal patient contact, and then the high flow nasal oxygen is a very good bet. We've used high flow nasal oxygen over the last 2 years, and it served us wonderful, absolutely wonderful.
I feel mechanical, that is very well, point is very well taken, Dr. Parthasarthi. Basically, the mechanical ventilation should always be avoided as much as possible.
As much as possible, sir.
Yes.
Because once the tube is in, the outcomes will universally be bad.
Absolutely. It has been repeatedly seen also. It has been repeatedly shown that outcome is never good with ventilators.
And not only that, once you go on the ventilator, then steps in the ECMO and so many other things, the costs spiral through the roof. And I think the outcomes have universally been bad.
The patient also spirals out.
The patient also spirals out at the same time to the next level of the COVID pandemic. Anyway, if there are any more questions.
I would like to, please, Parsadi, please go ahead. You were saying something. Yeah.
For a practitioner like me in private practice in an institution which is dedicated to neurosurgery, existence has been hard, but we have learned to adapt. And believe me, adaptation has been a very slow process. With limited resources, limited ideas, we have gathered all that we can within our means. We've been able to barrage all that has been thrown to us. And I think it leads us to that idea of the Pandora's box. Once Pandora opened the box, all the ills of the world seeped out, but there was only one thing which was left in the Pandora's box, and that was hope. And it is that hope and expectation of a better outcome that has left us in this position where we still continue to battle the pandemic like you and I are doing. Very bravely, very, with very strong arms. And I think we can do well for a lot of other people.
Dr. Partho, there is another question that has come up along with it. That is, what do you think will be the ideal time for ventilation in the COVID patient? And the question has come from Dr. Shoikat Niyogi. I think you can jolly well end up this question.
Yeah, Shoikat, thank you for the question. We managed to run a COVID care unit for a period of approximately 2.5 months. We had 150 patients in that brief 2.5 months, and we had to only ventilate 5 of them. Out of those 5, 3 died, 2 made it home. And the only thing which I observed that we were getting younger patients during the second wave, and once they began to rapidly desaturate beyond 93% on a high flow nasal oxygen therapy for more than 2 hours, it was time to implement the laryngoscope and the endotracheal tube.
I think that is why it was called happy hypoxia.
It was happy hypoxia because the brain was completely unresponsive to the peripheral chemoreceptors as to the dropping oxygen. The people were laughing, they were talking at you, they were sitting there with oxygen saturations of 85%. And believe me, in the next 30 minutes, they would be down to 65. And within the next 30 minutes, you had a dead patient. So I think the threshold for intubation and ventilation in these patients would be low. But then again, once you had the comfort of the high flow nasal oxygen therapy, you had a cushion around which to play, but the threshold for intubation would be very, very low. So I would intubate somebody with a high flow nasal oxygen therapy, approximately 30 liters per minute, half an hour into them, patient slightly becoming, neurologically impaired, put in the laryngoscope, put in the tube, and there you are in business.
I think that nicely answers the question. And yes,
Dr. Sujata, I have a question for Dr. Harendra as well.
Absolutely, absolutely.
He was managing the neurocritical care at and acutely managing, was in the emergency department. So then, like in the patients of neurotrauma, traumatic brain injury, they have associated COVID. So any experience with the prone ventilation, because in the COVID, the prone was very much useful when there was hypoxia. So any experience or any...
Thank you very much for the question, Dr. Goel. In terms of proning traumatic brain injured patients, you can just imagine what kind of a challenge that would be. But thankfully, I did not need to prone any of my neurotrauma patients, the ones that I managed. So I did not have any personal experience regarding that. But considering the huge number of critically ill COVID patients that surged during the Delta variant, I had to actually double up my unit to offer critical care beds for those patients. And yes, proning them was definitely on the cards, and it did make management easier because improving the very poor oxygenation, it did help. What we could do is, we could, by proning them, we could come down on ventilatory parameter settings during the period of pronation. So you always had that time to save the better lung, which would otherwise get affected by the ventilatory strategy that you had you had to implement. So proning did play a large role in managing these patients, but unfortunately, to answer your question specifically about neurotrauma patients, I did not have to prone any of my neurotrauma patients who had severe COVID pneumonia. In fact, unfortunately, as I mentioned earlier, all the severe COVIDs or critically ill COVIDs who had comorbid neurotrauma did not survive.
Right.
Okay.
So, Dr. Jayati, could we round up this session? It has been a wonderful SAARC session, and I think it would be nice if we go on to the next session, with which we are eagerly waiting for.
Yeah, no, this was really nice session and very informative session. So now it's lunchtime, and we'll take our next session after post lunch. Thank you. Thank you very much.
Thank you. Lunch on our own.
Yeah, that's there. Lunch on your own.
Okay.
Thank you. Thank you, everybody. It was a wonderful session.
Thank you. Thank you. We'll meet after lunch for the next session. Thank you.
Good afternoon, ma'am.
Good afternoon. Good afternoon. Good afternoon, Georgie.
Good afternoon, ma'am. How are you keeping?
Good. I'm fine. Thank you.
How are you, Dr. Singh?
I'm good. How are you?
Yeah, fine.
Great, ma'am.
Good afternoon, everyone.
Good afternoon.
Good afternoon, everyone. I am Dr. Jagriti Shukla. I'm consultant at NNC Hospital, Kolkata. So this is a post-lunch session on how I do it. We have 3 talks in this session, and to take it forward, we have 3 eminent chairpersons. It is my privilege to introduce Dr. Pinakin Gujjar sir and Dr. Rashi Dev Pujari ma'am and Dr. Georgian Singh. Can I see Dr. Pinakin Gujjar sir? Okay. I welcome Dr. Rashi Dev Pujari ma'am. She is a senior consultant in Jaslok Hospital, currently our vice president of ISNACC. Ma'am has many papers and presentations. Our next chairperson is Dr. Georgian Singh ma'am, Professor and Head Department of Neuroanaesthesia, CMC Vellore. Ma'am is a prestigious member of ISNACC and has many publications in national and internationals. And ma'am is also a reviewer of Journal of Anesthesiology and Clinical Pharmacology. So I request all the chairpersons to please carry forward this session. Please introduce okay, I welcome Dr. Pinakin sir. Sorry, sir. Actually, there was some problem in the video. I welcome Dr. Pinakin sir. Sir, please introduce the speakers.
Yeah. Okay.
Dr. Pinakin sir, please introduce our first speaker. Sorry for the delay.
Yeah. Hello. Hello. Good afternoon, everyone. Hello.
Good afternoon, sir. We are able to hear you.
Yeah. Hello. Now how I do it in that, Dr. Gyanendra Singh. Dr. Gyanendra Singh is a MD/DM neuroanaesthesiology from AIIMS, Delhi. He has got lots of achievements, like recipients of Outstanding Scientist Award of 2019, Best Researcher Award of 2020, over 140 publications, 15 chapters in books. Is a board member of scientific journals of editorial board, executive committee member of ISNACC. His main interest is awake craniotomy, neurotrauma, airway. I'll hand over to Dr. Gyanendra to talk on how I do it, scalp block. Thank you. Over to Gyanendra.
Thank you, sir. I hope I'm just able to get my...
Gyanendra, please mute all the mics.
Sir, am I audible now, sir?
Yeah.
Yeah. So very good afternoon to the chairpersons and all the eminent members of the society and all the lovely audience of ISNACC 2022. I thank the organizers for inviting me for this wonderful conference, which has been going very timely since morning. And I'm here to present on the scalp nerve block, how I do it. So I bring greetings from All India Institute of Medical Science, New Delhi, and I just begin with my topic. See, scalp has got an abundant nerve supply, which has got many nerves right from, there are almost 6 to 7 nerves on each side, which are the branches from trigeminal nerve and cervical spinal nerves, which supply the scalp. If you see from the anterior part of the scalp is supplied by supraorbital, supratrochlear, zygomatic-temporal, auriculotemporal, which all are the branches of trigeminal nerve, and the posterior aspect by the greater occipital, less occipital, and small area behind the pinna by the great auricular nerve branch, which are the branches of the dorsal rami of the cervical spinal. So all these nerves supply the scalp either side. So they are almost 6 on each side. So, and blocking this nerve is actually the scalp block. So there are various techniques like scalp infiltration, where you infiltrate the local anesthesia and give local anesthesia infiltration to the scalp, or you can block the individual nerve. So individualized target nerve blocks of the scalp, which is actually called the scalp nerve block. Now, the scalp block involves regional anesthesia to the nerves that innervate the scalp, thus providing analgesia for a considerable period of time after you give the block. So, as I said, there are 6 nerves which are blocked individually on each side, and these are supratrochlear nerve, supraorbital nerve, zygomatic-temporal nerve, and auriculotemporal nerve on the anterior aspect of the scalp, which are all branches from the ophthalmic, maxillary, and mandibular division of the trigeminal nerve. On the posterior aspect, we will block lesser occipital nerve, greater occipital nerve, and also sometimes the great or posterior auricular nerve. So these are the nerves we block when we give a scalp block on each side of the scalp. What are the anesthetic agents used? We all know local anesthetic agents like lignocaine, which is a short-acting one, and bupivacaine or ropivacaine, which is a long-acting one, are being used. They can be used either without adrenaline or with adrenaline or a vasoconstrictor, which not only increase the duration of the block, but also you can give a higher dose and the toxicity by reduce systemic absorption and thus local anesthesia toxicity. So most of the time, we all find this, what are the pharmacokinetics and pharmacodynamics of these drugs in any book. So just to say that lignocaine or mepivacaine are the have got fast onset and shorter duration, while other 3, that bupivacaine, levobupivacaine, or ropivacaine, has got a longer duration. I usually mix short and long-acting drug to have achieved the benefit of both the types of local anesthetic drugs, like to achieve speed of onset as well as duration of block is prolonged. Moreover, you can have adjuncts like fentanyl, clonidine, dexamethasone, dexmedetomidine, magnesium sulfate, or NSAIDs like paracoxib, which can be added to these drugs so that you can increase the duration and performance of these blocks. Now, coming on to a technique per se, you have to prepare the site and properly for giving the block. So you should have all the like betadine, chlorhexidine, sterile gauze, and syringes and drugs ready. And you have to aspirate the drug with all aseptic precautions to avoid any kind of infection at the site. How to prepare? You have to clean the area with chlorhexidine or betadine on bilaterally on each side, anteriorly and posteriorly. Mind it, you should place a sterile sheet around all over. So sterile area around should be there. Then you should paint the area with the betadine. I completely on both sides, right up to the posterior aspect where we are going to give the block. It should be properly painted all the side. And after adequate timing, when time to be given for the drug, betadine to act, and after that, for say 3 to 5 minutes, when it's dying, then you clean it with the spirit, so that the area is now ready for giving the block. So what are the nerves we block? Supraorbital nerve and supratrochlear nerve. These are blocked on the anterior aspect, and these are the nerves. Let us see how we go. First of all, we find the landmark. Landmark for this is the supraorbital notch or supraorbital foramen, which can be palpated on the superior margin of the orbit, somewhere between the medial 1/3 and lateral 2/3. Through this foramen, we have comes out the supraorbital nerve along with the supraorbital vessel, and medial to it, around 1 centimeter medial to it, we have the supratrochlear nerve and vessel. So let's see how we block. We first palpate the superior border of the superior margin of the orbit. Then, after locating the supraorbital notch, we will infiltrate the area with the drug, 1 to 2 ml of the drug, right at the supraorbital notch or foramen. You have to make sure that you aspirate before you give the drug, because it is accompanied by the vessels, supraorbital vessels, and make sure that you have a finger below it to guide that you do not go into the globe, the eye. There have been reports where eye has been punctured because of the I'm sorry, there's some just a minute. Is there any I've lost my hello. Hello.
You're audible, Dr. Singh.
Somehow my slides are.
The slide is not moving.
Just a minute, ma'am. I'll just check it. Maybe I have to share it again. I'll share the slides again, ma'am. What has happened? I'm so sorry for this glitch. Ma'am, do I need to join it again? Let me just stop my things and come back. I think there is some issues with the, I'm not able to view my slides here. Yeah. Is it visible, ma'am?
I think you rejoin and share the slide.
Yeah. Is it visible now, sir?
Slides are not visible.
Not visible. Okay, ma'am. Yes. Has it now become visible now?
Yeah. Now it is visible, but not in full screen mode.
Yeah, just coming up. So this, I'm very sorry for that glitch, some issues. So we have to palpate for the supraorbital notch, and then
understand.
We are giving this block here. Make sure that you are not injecting into the orbit. So you have to keep a finger below it. Now, after aspiration, you have to give 1 to 2 ml of the drug. And from the same side, you can also go medially with the, and block the supratrochlear nerve from the same side. So this is one way of blocking the supratrochlear and supraorbital nerve. Or sometimes if you can also give a separate block about 1 centimeter medial to the supraorbital nerve, you can give the block here for the supratrochlear nerve. So this is how you give the block of the supraorbital and supratrochlear nerve. Similarly, you are going to repeat the block on the opposite end. Right? So I'll move to the next slide now. The next nerve which we block is the zygomaticotemporal nerve. Zygomaticotemporal nerve is a branch from the maxillary division of the trigeminal nerve. This is the nerve which we are going to block. So we will first locate the zygomatic arch, and about 1 centimeter above the zygomatic arch, pointing towards the lateral border of the orbit, we are going to inject about 1 to 2 ml of the drug. Remember, we are going to inject in a fan-shaped manner, and also we are going to go deep and inject 1 cc of drug below a deeper aspect, because this has got a superficial and deep branch, and if we do not block both the branch, there can be some amount of pain to the patient. Next, the nerve which we block is the auriculotemporal nerve. Auriculotemporal nerve is a nerve which is a branch of the mandibular nerve, and which can be located in front of the tragus of the ear. So if you see, this is the area where you can see that nerve along with the superficial temporal artery. So you palpate for the superficial temporal artery in front of the tragus of the ear. And after the palpation, you have to make sure that you can palpate the artery very well, and you have to keep that artery below your finger so that you do not inject into the vessel. If you happen to inject into the vessel, what will happen is that you can have a toxicity of the local anesthetic. So after you have located the vessel very well under your finger, then you will inject around 1 to 2 cc of the drug right by the side of the vessel after aspiration. Yes, after negative aspiration. And while you inject also, you should keep on aspirating so that there is no chance of injecting into the vessel. So similarly, you are going to repeat on the upper side. Next nerve which we block is the great or posterior auricular nerve, which is a small nerve supplying the area behind the pinna of the ear. So now this nerve can be blocked by palpating the mastoid process. So if we palpate the mastoid process, and just about 1 centimeter above the tip of the mastoid process, we will inject around 1 to 2 cc of the drug and block the vessel, the nerve. So here we will inject around 1 to 2 cc of the drug, and you can see the wheel being raised because of the infiltration, and this can be done in a fan-shaped manner to avoid any twig which can remain unblocked. So this is how we block the nerve. Similarly, we are going to repeat the block on the other side, on one side and then to the other side. Okay. So anyway, you can see we are palpating for the tip of the mastoid process. Then above it, around 1 centimeter above it, we will infiltrate with around 1 to 2 centimeter of the drug here. Next nerve which we block is the lesser occipital nerve and the greater occipital nerve. Both are the branches of the spinal, cervical spinal nerve. So these lesser and greater occipital nerve can be palpated or can be blocked by the landmarks are, you have to file for the external occipital protuberance and the mastoid process. Line joining these 2 points, if you divide it into 3, the lateral 1/3 and middle 1/3, the junction of lateral and middle 1/3, medial 2/3, you can say, the junction of the lateral 1/3 and medial 2/3, that at this point, this is the site where you block the lesser occipital nerve. And the greater occipital nerve can be blocked at the junction at the point which is the junction of the medial and middle 1/3. So if you divide into 3 areas, so lateral 1/3 and middle 1/3 junction is the lesser occipital nerve, and middle 1/3 and medial 1/3, the junction of that is a greater occipital nerve. Remember, the greater occipital artery nerve is accompanied by greater occipital artery, and you can give the drug inadvertently into it, and that can cause toxicity. So always feel for the vessel with your finger before injecting, and make sure you aspirate before you inject. And you can give in a fan-shaped manner so that you can block the. Okay, so this is we are giving on the opposite end. Let's similarly we are going for the greater occipital nerve. Now, what to be careful about? See, inadvertent intravascular injection or systemic absorption. This is a common complication which can happen because of adrenaline. They can, if you are using a local anesthesia with adrenaline, you can have hypertension, tachycardia, and other hemodynamic changes. Or if if it goes into the vessel, there can be local anesthesia toxicity. So you have to be very careful about that. Overdose of the drug should be avoided at any cost. And there are some newer drugs which are more safer. So if they are available, like ropivacaine or levobupivacaine, they can be used, which are less cardiac neurotoxic. Infection can be a concern, and so strict sterility should be maintained. In hematoma can be another concern, especially in patients who have bleeding disorders. So you should be careful about it, especially when injecting into and should not inject into the vessels. And other complications can be swelling of the upper eyelid, ecchymosis. Globe injury has been reported. Allergic reaction can occur, and inadequate anesthesia where you do not have the adequate effect. So next is where do we need a scalp block? Yes, for any awake craniotomy, this is the cornerstone. A scalp block is a cornerstone, and you have to have a very good scalp block to do this procedure. Another area where can be used is chronic pain syndromes of head and neck, like cluster headaches, occipital neuralgia, migraines, etc., etc. There can be scalp procedures which can be done, like wound laceration repair, upper end of shunt repair, Omaya placement, IC placement, etc. Then you can use it in patients who have undergone craniotomy under general anesthesia, because for an analgesic effect. It will blunt the hemodynamic response, reduce the intraoperative and analgesic and anesthetic requirement, thereby facilitate early post-operative awakening and neurological assessment. Moreover, it will reduce the post-operative pain, both acute and persistent, and will decrease the post-operative requirement of analgesia. So take-home messages: classic scalp infiltration technique has now been replaced, and the newer technique have involved, which are called scalp nerve block, where you target the individual nerve blocks. These are useful in intraoperative and post-operative pain management, useful in perioperative management of patient, where they provide better hemodynamic stability, decrease anesthetic and analgesic requirement, and improve pain score in patients. Scalp blocks technique are quite safe, can be used in children, and have a very steep learning curve, can be learned very easily. They are having growing interest, people having growing interest into this nerve blocks, and are likely to see wider use in future also. So with that, I thank you. And before I end, I just want to inform everyone that our department is organizing the 3rd annual conference of Neurocritical Care Society of India, along with AIIMS Neuroanesthesia Update in 2022, which will be from 6th of October to 9th of October at AIIMS New Delhi. And I cordially invite all the members of ISNACC to please come and be a part of this event. Thank you. Thank you so much.
Thank you, Gnanendra. We'll take the questions later on.
Sure, sir. Thank you.
I request.
It's my proud privilege to introduce Professor Neerja Bharti. She's a professor from the Department of Anesthesia and Intensive Care at PGI, Chandigarh. Experience more than 25 years. There are publications, 63 international, 21 national. She's on the editorial board of Indian Journal of Clinical Anesthesia and Journal of Pain, and for pediatric case reports as well. Special interest is neuroanesthesia critical care, USG guided nerve blocks. Awards and orations are many. So best paper presentation at AOSRA at Bangkok, high quality research work, publication award, and I am unable to see the last award. If you are, it will be very interesting. I have great regards for Bharti and her acumen, and it's always a pleasure to interact with her. So Professor Neerja Bharti, please can you start your talk and take it forward. So as we know, regional anesthesia is becoming much and more refined with better technological tools. So as a neuroanesthetist, we can have some advantages of these newer nerve blocks, which Professor Neerja will tell us. So please carry on, Professor Neerja.
Hello, good afternoon, everybody. Thank you, ma'am. I'm going to discuss recently introduced regional anesthesia techniques which are found to be beneficial for the management of perioperative pain during back surgery. A multimodal analgesia technique with the use of regional anesthesia is found to be effective in managing perioperative pain after various surgeries. The expanded use of regional anesthesia techniques is also advocated by IRAS protocols aimed at minimizing opioid analgesics whenever possible. After the introduction of ultrasonographic technology, many regional blocks have been developed to improve the management of perioperative pain. Recently, a variety of interfacial plane blocks have been introduced for providing perioperative analgesia during spine surgery. The most commonly used are erector spinae block, thoracolumbar interfacial plane blocks, and the quadratus lumborum block. All these blocks require a large volume of local anesthetic to be injected in the facial plane of the back muscles. Therefore, it is important to discuss the anatomy of back muscles before going to these blocks. The back muscles are broadly divided into two groups, the extrinsic group of muscles and the intrinsic group of muscles. These both groups are separated by the thoracolumbar fascia. The extrinsic block muscles consist of trapezius muscle, levator scapulae muscle, rhomboid minor and major muscles, serratus posterior muscles, and the latissimus dorsi muscle. The erector spinae muscle lies just deep to the thoracolumbar fascia. The erector spinae muscle composed of three muscular columns which lies both sides of the vertebral column. The spinalis muscle attached between the spinous process of the vertebra, while the longissimus muscle attached between the transverse process of the vertebra. The iliocostalis muscle span between the angles of the ribs and the transverse processes. Just beneath the erector spinae muscle, there lies another important group of muscles, which is known as transversal spinalis muscles. This also consists of three major subgroups of muscles, the semispinalis, multifidus, and the rotators. All these muscles originate from the transverse process of the vertebra and attach in the spinous process. The quadratus lumborum muscle is another important muscle of the back. It originates from the posterior one-third of the iliac crest and inserts at the T12 rib and the transverse processes of L1 to L4 vertebra. It is surrounded by the thoracolumbar fascia. The psoas muscle lies medially and the erectus spinae muscle lies posterolaterally to the quadratus lumborum muscles. The lumbar spinal nerve roots run between the quadratus lumborum and the psoas muscle. The thoracolumbar fascia is a sheet of fused aponeurosis and fascial layers that encases the back muscles. It also affects the spread of local anesthetic. The thoracolumbar fascia can be divided into three layers. The anterior layer lies anterior to the quadratus lumborum muscle and bends medially with the psoas major muscle, while laterally it continues as a transversalis fascia. The medial layer located between the erectus spinae and quadratus lumborum spinae block can be performed by depositing local anesthetic between the deep fascia of the posterior layer encloses the erectus spinae muscle. The erectus spinae block can be performed by depositing with the psoas major muscle, while laterally it continues processes of L1 to L4 vertebra. It is surrounded by the thoracolumbar fascia. The psoas muscle lies medially and the erectus spinae muscle lies posterolaterally to the quadratus lumborum muscles. The lumbar spinal nerve roots run between the quadratus lumborum and the psoas muscle. The thoracolumbar fascia is a sheet of fused aponeurosis and fascial layers that encases the back muscles. It also affects the spread of local anesthetic. The thoracolumbar fascia can be divided into three layers. The anterior layer lies anterior to the quadratus lumborum muscle and bends medially with the psoas major muscle, while laterally it continues as a transversalis fascia. The medial layer located between the erectus spinae and quadratus lumborum muscle, while the posterior layer encloses the erectus spinae muscle. The erectus spinae block can be performed by depositing local anesthetic between the deep fascia of erectus spinae muscle and the transverse process. The local anesthetic deposited here spreads into the ventral and dorsal rami of the spinal nerves. Erectus spinae block provides somatic analgesia in a wide area of 3 to 4 segments above and below the level of the block. It also prevents visceral autonomic pain and provides good postoperative analgesia. Erectus spinae block can be performed in prone, sitting, or lateral positions. The level of the block depends upon the surgical indication. It can be performed by using the high-frequency linear probe, especially for the thoracic region, and low-frequency curvilinear probe for the lumbar region. The probe is placed longitudinally in the parasagittal plane, approximately 3 cm lateral to the midline. And here we can recognize the ribs and the glistening pleura. After that, the probe is moved medially to identify the transverse processes. Transverse processes can be identified by the blunt tip. In the thoracic region, the erectus spinae muscle lies deep to the trapezius and rhomboid muscles, and the needle should be inserted, and the local anesthetic should be injected between the transverse process and the erectus spinae muscles. In lumbar region, the erectus spinae muscle lies below the latissimus dorsi muscles. Here, the erectus spinae muscle is quite thicker, and therefore it is better to insert the needle till it touches the edge of the transverse process, and then withdraw the needle for 1 to 2 millimeters to inject the local anesthetic. The thoracolumbar interfacial plane block targets the dorsal rami of thoracolumbar nerves as they pass through the paraspinal musculature. The Tele block is first defined by the Hand et al. In 2015. However, after that, there are increasing reports about the efficacy of the block in perioperative pain management. It can be administered by classic technique or the modified technique. In classic technique, local anesthetic is injected between the multifidus and the longissimus muscle by positioning the block needle at 30-degree angle from the skin and then advancing from lateral to medial side. In modified technique, the local anesthetic is injected between the longissimus muscle and the intercostalis muscle, and the needle is advanced from medial to lateral side. For performing the Tele block, the probe is placed in transverse orientation in the midline position to identify the spinous process and the interspinal muscles, and then move laterally to identify the multifidus and longissimus muscles. The local anesthetic is deposited between these two muscles and which spread proximally to the main stem of the dorsal spine, dorsal ramus. The quadratus lumborum block was first described by Blanco in 2007 as an extended approach to the TAB block. It is an important block for the lumbar spine surgery. However, it has been widely used for the abdominal and hip surgeries. The spread of local anesthetic depends upon the site of the injection. 4 approaches have been defined by various authors. In lateral block, the drug is injected lateral to the quadratus lumborum muscle, just deep to the transversus abdominis aponeurosis, while in posterior block, the injection is given posterior to the quadratus lumborum muscle. In anterior block, the local anesthetic is injected anteriorly between the psoas major and the quadratus lumborum muscle. In intramuscular block, the local anesthetic is directly injected into the quadratus lumborum muscle. The quadratus lumborum block can be placed in lateral or the prone position of the patient by using a low-frequency convex probe. In lateral position, the probe is usually placed vertically between the iliac crest and the lower costal margin at the mid-axillary line to identify the external oblique, internal oblique, and transverse abdominis muscles of the abdomen. And then it moves posteriorly until the abdominal muscles start tapering off and converts into the thick aponeurosis. The quadratus lumborum muscle lies just deep to this aponeurosis between the psoas major and the erector spinae muscles. Local anesthetic can be injected anterior, lateral, or posterior to the quadratus lumborum muscle. Here we can see that psoas major muscle lies just anterior to the quadratus lumborum muscle, while the erector spinae muscle lies just posterior to the quadratus lumborum muscle. But this can easily be recognized by the Shamrock sign or the thumbs up sign, where the quadratus lumborum muscle lies at the tip of the thumb, while the fingers points towards the psoas major muscle. The erector spinae muscle lies just behind the thumb. The quadratus lumborum block can also be performed in prone position by keeping the probe in transverse or paramedian orientation. The probe is placed approximately 3 cm lateral to the spinous process, and the blunt tip of transverse process is identified. The quadratus lumborum muscle lies just below the erector spinae muscle, and the drug can be injected just beneath the quadratus lumborum muscle. blocks are quite safer, even though they can lead to local anesthetic toxicity, puncture of the intra-abdominal structures, hypotension, retroperitoneal hematoma, lower extremity weakness, pneumothorax, and intrapleural injection. Though interfacial plane blocks have gained popularity in the last decade due to the ease of application, low risk of complications, the analgesic efficacy, and the reduction of opioid consumption, these blocks cannot generate surgical anesthesia. However, they can reduce the requirement of general anesthetic intraoperatively and can be used as the main component of multimodal analgesia postoperatively. The blocks are usually safer, but the injection site must be watched for the infection, blood hematoma, and the organ injuries. It is better to use saline hydrolocation to keep the track of the needle tip. The block should always be performed under sterile conditions and standard monitoring. These are my few references. Thank you.
Thank you, Dr. Nirja Bharti. That was a wonderful, meticulous, and very fine description of the erector spinae block, the thoracolumbar interfacial block, and the quadratus lumbar block. And these can help us. You have very well described the ultrasonography and the anatomy of all these particular blocks, which we should be all aware of. And I'm sure there may be many questions. We'll take it at the end. Thank you very much.
Thank you. Thank you, ma'am. Thank you.
Good afternoon, everyone. Am I audible? Yes. Good afternoon, everyone. The last topic for the How I Do It session is on video laryngoscopes. And we would all agree that video laryngoscopes have become a very important part of the neuroanesthetist armamentarium. And it's my privilege to welcome Dr. Amit Shah to speak on this topic. Dr. Amit is the Director and Consultant Anesthesiologist at WINS and the Chief Consultant Anesthesiologist at Isha Multi-Specialty Hospital, Vadodara. His areas of interest include advanced and difficult airway management, low-flow anesthesia and anesthesia workstations, advanced neuro and laparoscopic anesthesia. He is the proud inventor of Padpasha laryngoscope and HuFlow 2, which is a high-flow nasal oxygen device. He chairs the training committee of the International Airway Management Society and is the representative from the West Zone for the All India Difficult Airway Association. He has received multiple awards and received the ISA Presidential Appreciation Award for significant contribution to Anesthesia Society. He is the co-author of the first Indian Difficult Airway Guidelines for 5 scenarios published in IJA. He has multiple publications to his credit and was the organizing chairman for the National Airway Conference, ISNACC 2016 at Vadodara. We welcome you, sir, to present the session on video laryngoscopes. Over to you, sir.
Greetings from Vadodara, Gujarat, and I am Dr. Amit Shah. At the outset, I would like to thank organizers, Dr. Bhiku Kalyani Das Madam, Dr. Indrani, and entire team for giving me this opportunity to speak in this meeting. And I'll be speaking about how I do it, video laryngoscopy. So I would like to disclose that we have developed a video laryngoscope device and we have a commercial interest in this particular device. But what I have expressed, what I am trying to explain here is the evidences and the views, and it is not to compare any device with our own device. So video laryngoscopy is essentially, instead of direct view from outside, it is your view beyond the curvature of tongue, so that the primary curve you overcome primary cup, look towards straight away towards larynx, so you don't need to align axis. You don't need to maintain proper position. Force is not necessary, and there is a large field of view. The device which looks around corner of tongue is called indirect laryngoscope, and if you use video camera, it is called the video laryngoscope. So video laryngoscope by definition is a device which is used in place of line of sight visualization to accomplish endotracheal intubation. Now earlier with direct laryngoscopy, there are very few devices and we had to do very few things before we start the anesthesia, but now there are multiple devices and we have to understand. So we'll try to understand how to differentiate and classify them and how to optimize intubation with each type of device. If you really carefully look at the blade part which goes inside oral cavity of every device, it has a different shape and angle, and we need to understand that. So first to develop was a device which can be which was essentially anatomically shaped as per the oral cavity, but the device tip was almost pointing towards vallecula, and we can call it hyperangulated device. Second to develop was later on to facilitate easy intubation, a device which was still again anatomically curved but not as much angulated, and it was sort of pointing towards vocal cord rather than vallecula. And we can they were channeled video laryngoscopy blades and they are anatomically curved. And of course, camera could always be incorporated in Macintosh type of a laryngoscopic blade and can be used as a video laryngoscope. So video laryngoscope can be classified as anatomically shaped and non-anatomically shaped. Anatomically shaped can be hyperangulated or angulated channel video laryngoscope, and non-anatomically curved could be Macintosh type of video laryngoscope. So to understand device and optimize intubation with the video laryngoscope, you have to understand angle of blade, which you have already understood. You also have to understand direction of camera and in which direction the vision is, and what is the area of the vision which is available. Also, to successfully intubate, you need to, as in the video laryngoscope, you are looking somewhere else and intubating somewhere else, you need to develop hand-eye coordination. So we'll try to understand how to optimize intubation with the various types of device. So first we'll look at the hyperangulated non-channel type of a device. Hyperangulated non-channel type of device looks up towards larynx. Epiglottis do not block your view and force requirement is actually minimum. But since the angle is hyperangulated, the endotracheal tubes are not shaped like that. You need to change to reach larynx. You need to change the shape of the endotracheal tube with the help of a stellate. Majority of the device are supplied with their dedicated stellate according to angle of their blade. But if you don't have one, then you can use regular stellate, which you can change the shape of endotracheal tube according to your blade. Once this hyperangulated stellate with the stellated endotracheal tube, once you reach the larynx, if you push it further, it will go and hit anterior tracheal wall and you might feel impingement or you may create trauma. So to avoid that, what you need to do is to withdraw stellate outside the larynx and only push endotracheal tube without stellate into the larynx, and this is very, very essential. So here, if you look at carefully, I have introduced, this is CMAC D blade. You get a fantastic view, and once you introduce this hyperangulated stellated endotracheal tube from the corner of mouth, once you reach the larynx, you carefully observe my fingers. I am only pushing endotracheal tube without stellate. It is essential that you push only endotracheal tube. So these are the 4 important points which you must understand to intubate with a anatomically shaped hyperangulated non-channel blade. Now, anatomically shaped channel video laryngoscopes are, as already discussed, it looks straight and the tip is not pointing towards vallecula, it is pointing towards laryngeal opening. So epiglottis may come in your view and you need some lifting force to elevate the epiglottis. After achieving proper view, once you push the endotracheal tube through dedicated channel, it will go straight towards larynx, and passage beyond larynx does not require any further manipulation. But because of this dedicated slot, because this tube track and view axis are connected, if your tube is not going towards laryngeal opening, for altering direction of tube delivery, you require manipulation of device or endotracheal tube. Here, if you look at carefully, as the tube comes out from the channel, it goes slightly down, and then the natural curvature of tube, endotracheal tube shape, it takes up towards the laryngeal opening. So you need to withdraw the device to allow PVC tube curvature to take its own course, or you may need to pull up to help to direct tube anteriorly. Also, you can do side-to-side movement of the device so that tube trajectory can be altered towards laryngeal opening. Or you can manipulate the endotracheal tube as you are pushing it in the channel, so that tube can be sway sideways on either side by doing clockwise or anti-clockwise movement, so that the tube can be directed towards laryngeal opening. Macintosh type of a video laryngoscope blade, basically you may or may not require stellate introduction. You can be introduced from the center of oral cavity or from the angle of mouth. Procedure, pressure and displacements are almost similar to conventional. So it is good for the teaching, but its role in difficult airway has been questioned by few authors. So this is Macintosh type of a video laryngoscope blade. If you carefully look at this patient, you get a good view, but you can intubate without use of stylet. So I'm introducing it without use of stylet. You can directly intubate. There are many Macintosh type of devices are available in the market, and in fact even you can use bougie with the such video laryngoscope devices. So golden rule for successful video laryngoscopy: you need to check the device, battery, charging, anti-fogging, etc. Angle and channel blade video laryngoscopes devices are introduced from the center of oral cavity. Sniffing position may not be helpful according to one study where they have compared, they have seen sniffing position as a counterproductive position in angulated and hyperangulated, so the anatomically shaped device. Always look inside oral cavity whenever you are introducing any either device or endotracheal tube, and you should not see only on the screen, which creates blind spot. Experience with standard Macintosh blade laryngoscope does not equate to the skill with the video laryngoscope. Experience with one video laryngoscope does not mean that you have skill for every video laryngoscope. A good video laryngoscope may not guarantee you easy intubation. A bougie may not be of solution, especially in anatomically shaped device. And the video laryngoscope chosen must be selected according to the indications and according to these three clinical situations: rescue or anticipated difficult airway, hyperangulated or anatomically shaped channel video laryngoscopes will work better. For routine users, that Macintosh type of device really works well and easily. But after little experience, you can easily use anatomically shaped device. But if there is a blood in the airway, only device which works is a Macintosh type of device. Now we'll try to look at the update on various situations and procedures where video laryngoscopy can be done. So first we look at the Cochrane review, which was published in 2016. 64 studies identified during this 2015 survey that enrolled 7,000 patients. And authors very clearly identified that video laryngoscopy may reduce number of failed intubation, particularly among patients presented with a difficult airway. They may improve glottic view and may reduce the laryngeal or airway trauma, but it may not reduce number of intubation attempt or incidence of hypoxia or respiratory depression. So adult patients, VL versus DL, adult patients, if there is a difficulty, it is going to have a definite role. Again, video laryngoscopy versus direct laryngoscopy, known difficulty for the experienced anesthesiologist. 9th study, including 1,329 patients, use of video laryngoscopy was associated with significant better view, less mucosal trauma, and it has definitely added value for experienced anesthetists, improving first pass success and the view of glottis and reducing mucosal trauma. In children, results are not so encouraging. Evidence suggests that indirect laryngoscopy or video laryngoscopy leads to prolonged intubation time with the increased rate of intubation failure when it compares with the direct laryngoscopy, though this is very low quality evidence. So it might lead to improved view, but we are not sure about its other part of the intubation success. Similarly, other meta-analysis also concluded that there is no benefit in pediatric patients on time to intubate and failure of the first attempt. They are nearly same with the direct laryngoscopy. In obstetric patients, there are 4 RCTs with 428 participants, 9 observer studies, and 35 case reports were included, where 100 participants were there. So first pass success rate and time for tracheal intubation demonstrated no difference in video laryngoscopy and direct laryngoscopy in patients without difficult airway. But patients' observation studies and case report underline the role of video laryngoscopy as a primary choice when difficulty with tracheal intubation is expected as a rescue modality or in difficult or a failed intubation. Similarly, orotracheal intubation comparison of video laryngoscopy versus direct laryngoscopy outside operation theater, where they identified 15,000 plus emergency intubation. VL compared with direct laryngoscopy associated with greater first pass emergency intubation in ICU and among less experienced clinician reduces the esophageal intubation. But it was associated with higher hemodynamic instability. Video laryngoscopy versus direct laryngoscopy neonates author concluded that though there is a moderate to very low quality evidence suggests that video laryngoscopy increases the success of intubation in the first attempt but does not decrease time to intubation or number of attempts for the intubation. For awake tracheal intubations, 8 studies including 429 patients were included. Video laryngoscopy for awake tracheal intubation is associated with shorter intubation time. It seems to have success rate and safety profile comparable to fiber optic bronchoscopy. In obese patients, 1023 reports initially identified 8 RCTs involving 747 patients were eligible. A video laryngoscopy overall superior for tracheal intubation as it improves clotic view and makes intubation easier in short intubation time and reduce intubation failure in obese patient. Again, it has identified another meta-analysis in obese adult identified that performance of both type of video laryngoscope with or without tracheal tube guide was superior to that of Macintosh laryngoscope, except for the intubation time where channel video laryngoscope works better. So at end of my lecture, video laryngoscopy definitely improves clotic view in all the situations. It improves success rate in predicted difficult or difficult airway situations. It has been found helpful in emergency room, obese individual, obstetric patients, and neonatal patients. In pediatric patients, though it provides better glottic view, it may take prolonged time and authors' conclusions are not encouraging. And in awake tracheal intubation, it is as good as fiber optic intubation. Thank you for your kind attention.
Thank you, sir, for the excellent presentation and for outlining the choice of video laryngoscopes for different clinical scenarios. We may now take questions from the chat box.
Hello, Dr. Gyanendra. Most of the person wants to know what adjuvants you are using and what is the total dose you use in these blocks.
Sir, the commonly used adjuvants are either fentanyl we add around 50 to 100 mics we add to it, or dexmed we can 1 to 2 mics per kg. That is what we use. Other doses, again, depending on the local anesthetic, the same dose, 2 to and up to 5 milligrams if you are using lignocaine, and without adrenaline, with adrenaline up to 7 mics. So that is the maximum dose, but we have to keep much below the dose, because many a times surgeon also infiltrate the site or may use for it for infiltration during dural thing. So better to have some lower doses. So the doses are what is mentioned in any textbook. The similar doses. Only we have to avoid toxicity, so to avoid overdoses, and of course adjuvant can prolong the durations and thereby decrease the amount of doses. And we are usually mixing long and short acting together, so that we have a benefits of both.
Okay. Dr. Dev Pujari.
Yes, so let's come to the next topic, Dr. Nirja Bharti. There are questions over here. Sapna has asked, which out of quadratic lumbarum 1, 2, 3 blocks is most effective for lumbar spine surgery? You are not, you haven't unmuted.
Yes. Hello, ma'am. Hello, everyone. Yeah, it is as I told, the quadratus lumborum block 2, that is posterior, one is better for the spine surgery. And the quadratus lumborum block 3 here, anterior quadratus lumborum block, is better for the abdominal surgeries. So we use generally quadratus lumborum type 2 block for the spine surgery. The main problem with the quadratus lumborum block is that it is a little bit difficult in posterior position, and it is better in lateral position. So if we use before the surgery, pre-operative, then it is better to give leave the patient in lateral position, and we can transfer bilaterally the patient easily. And it is very well localized, the quadratus lumborum block. In posterior position, it is a little bit difficult, but if we want to give the block after the surgery, so it is better.
Okay. The other question is, thank you for the answer. I hope it answers Sapna's queries. And the other question is, ma'am, what is the volume of local anesthesia which you are using for the erector spiny block for post-operative analgesia? And do you practice unilateral or bilateral erector spiny?
Generally, we use bilateral block, and 15 to 20 ml of 0.2% lignocaine is better, or 0.25% bupivacaine we can also use.
Okay. Yeah. So now, is it my question is, Dr. Nirja, do you now routinely use these adjuvant, the regional blocks for your spine surgery, or you are still, you know, getting, it's a steep learning curve for these blocks. It's not an easy learning curve, but with USG guided and the way you have showed it, it looks very simple. So
it's not very difficult, especially the erector spiny block is very easy.
Okay.
Anybody can just, it is not a very long curve for the learning, and it is very easy and very good, especially post-operative period. Patient can move easily.
Okay.
For the post-operative movement, it is very good, and surgeons are very happy with that also. So we are mainly using quadratus lumborum and erector spiny block. We are not much have used the tail block, because sometimes it may be difficult to recognize the intermuscular plane in that block.
Thank you. Thank you. Georgine, you can go ahead, please.
Dr. Amit, could you just tell us which of the video laryngoscopes will be useful for when the cervical spine is stabilized?
Okay. So, when the cervical, can you hear me?
Yes, sir. Yes, sir. We can hear you.
When there is a cervical spine stabilization done, then there is a restriction of neck movements, which will make our direct laryngoscopy difficult. So these are sort of anticipated difficult laryngoscopy. And in such a situation, angulated blades, either fiber angulated blade or a channel video laryngoscopes, which are still angulated anatomically shaped device, will be more useful compared to a Macintosh type of a video laryngoscope device. So if I have to opt, if I have choice of all devices, I'll opt for angulated devices or anatomically shaped device with either angulated or hyperangulated.
There is another question for Nidra from Psychic. He asked that can we use ropivacaine for electrospinal block, and can you add adjunct to it?
Yeah, we can also use dexmedetomidine with this.
So ropivacaine can be used.
Already I told 0.2% ropivacaine we are using. Because the volume is high, so we have to keep the concentration low. It is better to give with the adjuvants also.
Oh, thank you. Thank you.
Dr. Nija, are you using it as single shot or as catheter? Single shot or catheters?
We are using basically single shot, but it is good to use catheter also. We can use easily. With the electrospinal chordatus lumborum, easily we can use that.
Another just comment. Gyanendra.
Yes, ma'am.
I loved your idea of having an angulated hypodermic needle for giving those blocks. And what gauge is it? 20, 24?
25.
25, yes.
25.
Okay. Good, thank you.
And it was a good learning experience for all of us. Ma'am, any further questions?
No, no more questions now.
Okay. Thank you, sir. Thank you, ma'am.
Thank you.
Thank you. Thank you.
Thank you.
Their presence and everyone for this patient hearing. Thank you so much.
Yeah.
And thank you to the organizing committee, and they're doing a great job. It's not easy to do an online thing, coordinating with so many people. Congratulations, Bibu, and congratulations to all the organizing.
One more thing I want to tell you, there is some repetitions of talk. So you have to tell the administration.
Okay. Okay, sir. Thank you, sir. And sorry for any interruption. Thank you, ma'am. Thank you, ma'am.
Thank you. Thank you.
Yeah, we can go ahead with the next.
So moving on to our next session, that is our first session of oration on the name of Dr. Harveer Singh. So for this session, I want to welcome, it's my honor to welcome Dr. Nidhi Panda ma'am and Dr. Hemant Bhagat sir. Dr. Nidhi Panda ma'am, she is the president of our ISNACC team. Ma'am is presently Professor Neuroanesthesia and Head Division of Neuroanesthesia and Intensive Care at PGI Chandigarh. Ma'am has many papers and publications. Ma'am has guided many theses. And yes, as I told you before, that she is the president of Indian Society of ISNACC. And our next chairperson is Dr. Hemant Bhagat sir. Sir is also presently at PGI Chandigarh, Professor Division of Neuroanesthesia and Intensive Care. Sir, special areas of interest are aneurysmal subarachnoid hemorrhage and anesthetic neurotoxicity emergence from anesthesia. So I request our chairpersons to carry forward the session. Can you hear me, ma'am? Nidhi ma'am?
Yes, yes, I can hear you.
Ma'am, please carry forward the session with the oration part. Introduce.
Yeah. Can you show the slides of Dr. Harveer Singh?
Yeah, yes, sure, ma'am.
Yeah. Good afternoon, everyone. It is my pleasure to introduce my teacher, Professor Harivir Singh, to you all. Professor Harivir Singh was my mentor, an ideal teacher, and a legend in anesthesiology and intensive care. Next slide, please. He was born in 1938 in Punjab. He did his MBBS from Government Medical College, Amritsar, Punjab. He did his specialization in anesthesia in the form of DA and later MS from Rohtak Medical College, Haryana in 1963 and joined as consultant in the same college. Next slide. He joined as assistant professor in PGI in 1966. He assumed the position of head of department in PGI in the year 1981 and continued till 1993. He started and developed the department of anesthesia and is fondly remembered as father of anesthesia in PGI Chandigarh. He started the intensive care unit under the department of anesthesia in the year 1979. This used to be the first ICU in PGI Chandigarh, which was under the anesthesiologist. Next slide, please. He was bestowed with honorary fellowship by National Academy of Medical Science in India for his contribution to the specialty. He worked as chairman, Department of Anesthesia in Bahrain from 1993 to 95. He had more than 120 publications to his credit. He was a visionary who thought of super specialization in anesthesiology in very early years. He planned starting the super specialization in neuroanesthesia and cardiac anesthesia. And today our Department of Anesthesia can boast of full-fledged super specialty unit in neuroanesthesia, cardiac anesthesia, pediatric anesthesia, trauma anesthesia, intensive care anesthesia, and fellowship in transplant anesthesia and obstetric anesthesia. Because of the effort of Professor Harivir Singh, Dr. Y.S. Verma was appointed as the first professor of neuroanesthesia in India. Next slide, please. He was a great and very sought after teacher by the student. He was a tough administrator and a person with a golden heart. He was very passionate when it comes to patient care and taught us how to deal passionately with the patient during perioperative period. He was a fatherly figure for anesthesia department. He was always approachable to the student as well as subordinates of the department whenever there is any personal or professional problem. I have the proud privilege to work under him and have him as guide of my thesis. He left for heavenly abode on 12th August 2001. We pay our tribute to a great visionary, teacher, mentor, and a legend in anesthesiology and intensive care. Next slide, please. May his soul rest in peace. Now I invite Dr. Hemant to introduce the orator, Dr. Gentle Srestha.
Good afternoon, everybody. At the outset, I would like to thank the organizers for giving this opportunity to chair this session on the Harivir Singh oration. So it's my great pleasure to introduce an eminent speaker and an academician, Dr. Gentle S. Srestha. He is currently working as Associate Professor, Department of Anesthesiology at Tribhuvan University Teaching Hospital at Kathmandu, Nepal. And he did his primary qualification is MD Anesthesiology, followed by Fellowship in Adult Critical Care from University of Toronto. He also has done his European Diploma in Intensive Care and is currently the Fellow of Neurocritical Care Society. He is an avid researcher and has authored a number of papers, and his special interests are that of neurocritical care, neuroanesthesia, and point of care ultrasound. Dr. Gentle Srestha has been associated and has been attending the meetings of ISNACC from almost more than a decade, and we are very privileged to have him here to speak on a topic that is bridging the gap between evidence and the practice in neurocritical care, especially in a resource-constrained environment. I welcome Dr. Gentle Srestha.
First of all, I'd like to thank the organizers of this
23rd Conference of Indian Society of Neuroanaesthesiology and Critical Care for this opportunity to talk in this oration session. I bring the greetings from the Nepali Society of Critical Care Medicine, from the Society of Anesthesiologists of Nepal, and from Neurocritical Care Society. I'll be discussing and talking about bridging the evidence practice gap in neurocritical care in resource limited settings. I have nothing to disclose and I don't have any conflict of interest for this talk. So I'd like to start with the burden of neurocritical illness, how it is globally and how it is in our part of the world. So if we see this paper published in Lancet Neurology in 2019, they have reviewed the burden of neurological disorders globally and as well as regionally, and they have also looked after the trend of the burden of disease neurological disorders. And it is seen that in 2016, neurological disorders have become the leading cause of disability-adjusted life years, and it is a second leading cause of death globally. And also, it is interesting to note that over these 30 years duration of time between 1990 and 2016, the absolute number of deaths attributable to neurological disorders increased by 39%, and disability-adjusted life years also increased by 15%. That means globally the burden of neurocritical illness is increasing. And among the top 4 neurological disorders that have contributed significantly to the disability-adjusted life years, we can see that the first contributor is stroke, and the fourth is the meningitis. These 2 disorders are of clinical significance from the neurocritical care perspective. So if we see the scenario of India, we can see this paper that was published in Lancet Global Health in 2021, where they have reviewed the neurological burden of disease attributable to neurological disorders in the various regions of India. And they have also compared how the burden of disease of the neurological disorders have evolved over these 20 years duration of time, 30 years duration of time. And you can see that the burden of neurological disorders is mainly due to the non-communicable disorders like stroke, and the disability-adjusted life years have almost doubled over this 30 years duration of time between 1990 and 2019. It was 4% initially in 1990, and it has increased to 8.2% in 2019. And the contribution from the injury-related neurological disorders like the traumatic brain injury to disability-adjusted life years has also increased almost 3-fold in this 30 years duration of time, from 0.2% to 0.6%. And among the top 3 contributors for disability-adjusted life years, stroke contributes for almost 40%, and then second is epilepsy, and the third is encephalitis, contributing for 5.3%. All of these 3 contributors are of significance from the neurocritical care point of view. And also it is important to note that the neurocritical illness is disproportionately higher in low-income countries and in places with resource limitation as compared to high-income nations. If we see over the past decades, we can see that neurocritical care has emerged as a distinct specialty. If we see the history, and if we go back to 1980s, this specialty initially it started as dedicated post-operative monitoring units for neurosurgical patients, where they found that if the post-operative neurosurgical patients were cohorted in a dedicated unit where there were the trained staffs capable of monitoring these patients effectively, then the outcome of these patients were possibly improved. And the neurocritical care, this specialty has emerged, especially in the last decades. And if we see how it has emerged in the United States in the last decade, we can find that there was a formation of the multidisciplinary neurosurgical society in 2003, where they involved the healthcare workers related to neurosciences from various specialties like neurology, neurosurgery, intensive care, anesthesiology, and also other healthcare workers like nurse practitioners, pharmacists, and so on. And they created this society in 2003. And also you can see that in 2005, the neurocritical care has gained a full acceptance by the United Councils of neurological subspecialties as a distinct subspecialty. So it has evolved in a very good way in the United States in the last decade. And after the formation of this neurocritical society, they have also created various regional chapters. So far, they have 4 chapters: the Asia Oceanic chapters, which is the largest of all these 4 chapters. The next is the Middle East, North and Central American, and the South American chapters. And the objective of these various chapters is for the international collaborations with respect to the research, enhancing the neurocritical services, and so on. And also we can see in our part of the world as well, this specialty has gradually evolved, but yet it has lagged behind as compared to other specialties. In a country like India, now there are multiple centers who have which have dedicated training programs for various specialties related to neurocritical care. However, in many parts of the resource-limited settings, there are very limited healthcare workers that are trained in this specialty. So let's go back and look after the evidences in favor of dedicated neurocritical care unit. Does it actually help or not? And how, if so, how it helps? So this seen that the introduction of a neurocritical care team with a neurointensivist is associated with reduction in hospital mortality and ICU length of stay without increasing the readmission. This was an interesting paper published by the Suarez and colleagues in 2006. And also it is seen that the high intensity ICU staffing with mandatory intensivist consultations or with the closed ICU intensive care units, they are associated with improved outcomes in the patients with neurological and neurocritical disorders. So we can see that when the patients are treated in dedicated neuro ICU, the mortality of the patients are improved in the various ranges of the Apache quartiles. Also, we can see the better survival of these patients when the patients were being treated in dedicated neuro ICUs as compared to when the patients were treated in the general intensive care units. So this is a list of various studies. Most of them are cohort studies with historical controls. You can see that the introduction of dedicated neuro intensive care units, generally they are associated with improved outcome in the patients in the form of decreased mortality and ICU stay, as I just discussed. And also we can see that if we can see that in this summary of various studies in which the effect of dedicated neurocritical services on mortality were compared, we can see that the introduction of dedicated neuro ICU was associated with decreased mortality in various neurocritical disorders like traumatic brain injury, intracerebral hemorrhage, subarachnoid hemorrhage, general neurointensive care unit, and so on. So it is obvious that the burden of neurocritical illness is significant globally and more so in the places with limited resources. And also we know that the dedicated neuro ICU helps in improving the outcome of these patients. And also we can find various evidence-based practice guidelines in the field of neurology, neuroscience, and neurocritical care overall, like this good guidelines on acute stroke. So we have good quality evidence that is emerging for the care of the patients with neurocritical illness. And recently in 2018, there was a statement for healthcare workers from Neurocritical Care Society, where they have published the standards for neuro ICU, how the neuro ICU should look like, how should the organization and design of neuro ICU should be, and they've categorized the neuro ICU into various levels like level 1, 2, and 3. And level 1 is, as mentioned by them, the level 1 will be the ICUs, neuro ICUs with the highest level of care that will be capable of dealing with the most sickest of the neurocritically ill patients. And those ICUs would also have the academic programs dedicated for training and competency development for the specialty, for the experts in the field of neurocritical care. Level 2 neuro ICUs would be able to stabilize the patients with neurocritical disorders and would be able to manage the stable neuro ICU patients. And level 3 ICUs are categorized as those units, neuro ICUs, that are capable of stabilizing the patients with neurocritical disorders, and there should be good communication between these three levels of ICU, so that then they can have a good system of referral. So they have various sections describing how the organization of these ICUs should be, how should the policies and guidelines should be in these ICUs, the healthcare workers, the various specialties of the healthcare workers to be involved in the new ICUs, the ratio of those staffing staffs over there, supporting specialties, facilities, diagnostic facilities, the need of equipments, monitorings, and the need of research and trainings. So we have a good amount of evidences as well as guidelines as how the neurocritical ill patients should be managed in the ideal scenario. But if we see the scenario in the resource-limited settings, we can find a significant gap between these evidences and what actually we find in our real-world scenario. If we see about the management of stroke in the resource-limited settings in LMICs, low and middle-income countries, this part of the world has a higher burden of stroke. Almost 60% of the global burden of stroke lies in these low and middle-income countries, and the mortality is also higher in this part of the world attributed to stroke. Almost 70% of stroke mortality occurs in this part of the world, and we can also see that the patients with stroke, they present with higher severity in this part of the world, and as compared to the high-income countries, the proportion of the patients presenting with intracerebral hemorrhage is higher as compared to acute ischemic stroke. So the barriers in the stroke management, there are the various levels, starting from the pre-hospital level, because of lack of the stroke helplines, because of lack of awareness among the general public about stroke, insufficient infrastructures, and inadequate pre-hospital transportation facilities, like the lack of ambulance services, lack of emergency medical services for the proper and rapid transportation of patients in the pre-hospital setting. Also in the hospital setting, the resources are limited in emergency departments. There are limited resources related to the imaging and radiology. And also regarding the stroke units, there's a significant lack of trained neurologists, stroke experts, and personnel trained in managing the stroke and other neurological disorders. And also the cost of the drugs that are required for managing these patients are usually high, and often out of the reach of general public to afford for these. So we can see that globally the public awareness of stroke remains low, and the awareness is even lower in our part of the world, like in India also. The stroke awareness among the public is significantly lower. And it is seen that the community stroke awareness education programs can help to raise awareness significantly, and it can thus delay the lag between the symptom onset and presentation of patients to the hospitals. And for this purpose, television programs, newspapers, books, magazines, and various online resources can be of help as well. As you know, the stroke management in this part of the world is costlier. It's associated with significant morbidity and mortality. one of the important steps for decreasing the burden of disease and associated morbidity should be to focus on the primary prevention. And as you know, in this part of the world, many patients presenting with stroke, they have the significant risk factors like hypertension, smoking, diabetes, obesity, atrial fibrillations. They're often not diagnosed or they're poorly managed, thus also contributing to a higher burden of this specific neurological disorder. Also, we can see that the risk factor like diabetes is increasing significantly in the general population. And in the last decades, it has increased by almost 3 or 4 folds among the general publics. Also, we can see that the cost of management like a stroke and secondary prevention is high. This also applies to the road traffic accidents. As I mentioned earlier on, in the last 3 decades, the incidence of the traumatic cause of neurological disorders, that is traumatic brain injury, has almost increased by 3 folds, and that is mostly attributable to road traffic accidents. So the preventive measures to minimize road traffic accidents can also help to decrease the burden of disease, and also the vaccination program, especially for the meningococcal disease, can help decrease the infectious cause of neurocritical illness, and thus the burden of disease from that cause as well. If we see the pre-hospital transportation and MS medical services from this paper published in 2016 by Panjan and colleagues, the most of the pre-hospital transportation is by the means of the personal vehicles, taxis, auto rickshaws, and only around 12% of the pre-hospital transportation was by the dedicated ambulance. And this was one of the significant causes responsible for the delayed presentation of the patients with stroke to the emergency unit. So this is what we actually expect and what we dream of, and this is what is the standard of care. Like there should be dedicated rapid transportation of patients in the form of heli rescue, ranging from heli rescue to the dedicated, very sophisticated ambulance and EMS services. But if you see in our part of the world, often we can see this type of scenario, especially in the rural regions, where the transportation of these patients is really challenging. They are often transported, the sick patients are often transported by being carried by the friends and relatives, in part because of the geographical challenges, because of the very primitive development of the roads and primitive EMS and hospital transportation systems. So this is one of the big challenges, and because of this also the many patients with stroke and other neurocritical illnesses, they arrive to hospitals, they arrive to the attention of medical services pretty late, and usually they present with more severe illness and in the later course of the critical illness. So it is important to train the paramedics, and it's important to train the EMS nurses, and also it is important to overcome these unique challenges if we are to receive these patients on time, and thus to improve the outcome of these patients. So if we look at the access to the CT scanners, we can see that the number of CT scanners per 1 million population is remarkably lower. That is just 1.3 CT scanners are dedicated to each million population in low-income countries, as compared to 21.2 scanners per 1 million population in high-income countries. Also, at the same time, in the low-income countries, we can find that these CT scanners, they are not uniformly distributed, and most of these scanners are located in the major cities and academic centers, and then also the cost of CT scanners is usually high, and also some of those scanners they are non-functional. In the low-income countries, many equipments are being donated by the other nations or by the donating bodies, and after installation of these devices, usually the maintenance of these devices are not performed regularly. There is because in part because of the lack of the servicing that can provide repairing of these devices if they become damaged. And thus, we often find that there are equipments, but there are this might be non-functional, and that can also be responsible for the limited access to the CT scan in these patients. Also, we can see that most neurological emergencies and neurocritical illnesses are managed by the healthcare workers with no specialized trainings, and also there are limited trained healthcare workers in the low and middle income countries. Like there are very limited number of people with training in the neurosciences. We have a limited number of neurologists, neurosurgeons, neurointensivists, and so on. And also, despite the growing evidence in favor of dedicated neurocritical units, the dedicated neuro ICUs in this part of the world are largely limited to the major centers. Both those centers are usually the private centers that are quite expensive for the general publics. And this was one study from Nepal, published in 2019, where we looked retrospectively looked after the patients presenting with acute ischemic stroke in a tertiary level teaching hospital over duration of 1 year, and we found that of all the patients presenting with ischemic stroke, only 20% of patients they arrived within the time frame of thrombolysis. Again, those patients who presented within the time frame, only 13% of those patients actually received the thrombolysis. One of the main reasons, one of the main barriers why they couldn't receive thrombolysis was because of the cost of the treatment, because of the cost of the drug alteplase. So if we see the effectiveness of various interventions increase the rate of thrombolysis, we can see that if we can raise the public education, public awareness, if we can enhance the services of the emergency medical services, and if we can introduce the telemedicine, these interventions can potentially increase the rate of thrombolysis and thus potentially may improve the outcome of the patients with acute ischemic stroke. So how can we effectively narrow the wide these interventions gap between the evidence and practice? The gap is even wider in this part of the world with limited resources. So first, it is important to identify the specific barriers for adoption of the guidelines, and then to design the interventions to purposefully overcome them. Also, it is very important to meticulously consider local context and appropriateness while designing the interventions. Often the standard guidelines that are derived from that are designed and formulated based on the studies and research in the high-income countries may not be directly applicable to the places with the resource limitations. So it is important while formulating the local policies and while adopting the guidelines in the places with limited resources. And it is important to implement the quality improvement interventions, and these interventions should be tested with the well-designed trials, and then only these interventions can be actually translated into the clinical practice, and the well-designed knowledge translation research can significantly help in implementing these guidelines and thus narrowing the evidence practice gaps. This is one example of a very well-designed study regarding the effectiveness of multifaceted quality improvement interventions on the hospital personal adherence to the performance measures in patients with acute ischemic stroke in China. Also, it is also called as Golden Bridge acute ischemic stroke trial that was published in Jame, where they randomized a total of 40 hospitals. The 20 hospitals were categorized into the intervention arm, enrolling almost 2,400 patients, and in this intervention group, the involved centers. In the involved centers, they applied the quality improvement interventions in the form of the clinical pathways, dedicated care protocols, quality coordinator oversight, performance measure monitoring and oversights. And in the 20 hospitals that were considered as a control group, they provided usual care. And they found that the quality improvement interventions significantly yielded the better adherence with the evidence-based performance measures, and also they improved the patient outcomes and decreased the mortality in the 3, 6, and 12 months follow-up. So this was a paper published where they did the literature review regarding the trends in publications regarding the evidence practice gaps. So they reviewed the data over the 10 years duration, and they reviewed the publications related to the evidence practice gap data related to the nine guidelines related to various medical conditions. And basically they categorize the interventional studies into 2 categories. The first category was well-designed studies that met the effective practice and organization care criteria. And the next category was other studies that didn't meet this EPOC criteria. So the studies that met this well-designed EPOC study criteria were either the randomized control trials, patient randomized or cluster randomized, or the non-randomized control trials that are quasi-randomized, or the studies that were controlled before and after studies, or the studies that were of the interrupted times series design. So it was interesting to see that more than half of these evidence practice gap studies were of the descriptive design. And of note, these study designs, they help to elicit the problems, elicit the existing gaps and reasons of gaps, but they don't help to know how those gaps can be minimized and what type of interventions can help. And only about 15% of the studies were of the interventional type. And of those interventional studies, only 30% of those met the POC criteria. So you can see that only a limited amount of the studies that are being performed in this field of evidence practice gap were of interventional design, study design, and among that also a very small fraction of those intervention studies are actually well designed studies. And also we can see that the patient participation in these well designed studies are low. The expected patient participation is more than 75%, but we can see that only 60% of those studies were actually participated by the physicians. I was going through this interesting editorial that was published in the American Journal of Critical Care, and it is interesting to notice that it takes in an average of around 17 years for a good quality research to be translated into practice. So this is a long duration of time, and that usually the clinicians take to adapt the available evidence into the practice. So what is needed is we need to promote a translational science. Basically, there are 2 types of translation. One is to convert the basic science understandings to the testable clinical research, and the next step of translation would be to implement the clinical research, to implement the available guidelines, available understandings, available research findings into the practice. And actually, this type of translation helps in changing the clinical practice. And so, in the United States, they have formulated this National Center for Advancing Translational Sciences, NCATS, and that is dedicated to improve the translation of these evidence bases into the clinical practice. And at the same time, to improve this translation of available evidence into the clinical real-world scenario, we need the larger multi-site studies that generates a well-designed, that generates the good quality evidence in the context where the evidence need to be applied. And also the newer trial designs, like adaptive trial designs, step-based design, and comparative effective analysis can also help to generate good quality evidences that are appropriate to the local context and local resource availability. So regarding the perspective of resource-limited settings, we have the unique challenges. We have very much limited research availability, and the guidelines, as I mentioned earlier, and the standard practice guidelines that are designed and published based on the research from the Western world may not be directly applicable, and the evidence practice gap that exists in this field of neurocritical care globally seems to be even wider in the places with resource limitations. So in the efforts to narrow the gap and in the efforts to increase and train people's in the field of neurosciences, neurocritical illness, we try to, with this small study, to explore if this emergency neurological life support course is applicable in the low-income countries or not. So this is published in 2018, and what we did was that we did a prospective course study on this first ENLS course that was conducted in Asia in 2015 in Nepal, and we tried to explore whether this ENLS course that was designed and formulated by the Neurocritical Society is applicable in this part of the world, and whether it is helpful or not. And we try to explore the knowledge and decision-making skills that was assessed at baseline immediately after the course and after 6 months following the course completion, and we could find that this course was helpful in improving the knowledge and decision-making skills among the participants, and this improvement, this change was retained even at 6 months. Also, we shared our experience regarding the endovascular management of acute ischemic stroke in Nepal. It was published in Lancet Global Health. Actually, we shared our experience of the initial 20 patients. It was a single center experience. But our major focus in this paper was about how we can, what are the barriers, what are the potential barriers regarding the expansion of these services, and how we can overcome those barriers to expand this mechanical thrombectomy services to the larger patient populations, not being limited to a single center. And we mentioned various possible steps that can help, like the need to raise public awareness, need to develop the pre-hospital transport system, the need of multidisciplinary approach, need for the local policy and protocols, need for support from the local governments. Definitely we need the funding supports, and we need more trained healthcare workers. And also it is important to link the comprehensive stroke center to various satellite centers, and the tele-stroke services can also be of help to expand this specialized, highly specialized stroke management services. So how we are moving ahead, I'm going to mention about how our center is moving ahead in the managing of stroke patients. Our center is a dedicated tertiary level teaching hospital, one of the largest hospital in the capital. So what we did to move ahead was we created a multidisciplinary stroke committee that comprised of neurologists, neurointensivists, neuroanaesthesiologists, radiology team, as well as a neurosurgical team. And then the committee worked together to develop a institutional stroke protocol that was approved by the hospital. And we also initiated the dedicated stroke unit in our center. And we are planning to implement this, formally implement the protocols for the patients arriving in our hospitals very soon. And the next step would be to expand this service to other centers as well. And for that, we we are collaborating with the local hospitals for the support, and also we are planning to function. Our center is planning to function as the hub hospitals, and our hospital will be providing the stroke services, both the referral services and also the telestroke services for the 13 centers of the province. And we are planning to begin this service from one province initially, and then if this project would be successful, then possibly the similar projects will be launched in other provinces of the country as well. And also we are collaborating for the government funding, because one of the major barriers in the management of stroke patients has been the lack of fundings and the cost of the drugs. And the dialogue has been very fruitful so far. We are also planning to train and educate the healthcare workers of those 13 centers. We are planning to train the frontline healthcare workers who will be dealing with the stroke patients over there. And at the same time, we'll also be doing the translational research, and we'll be doing various audits to explore whether the program is functioning well or not, to explore the various barriers. And then we will be trying to narrow those gaps and move ahead with that. Also, we are planning to start the stroke registry in our center, and also we'll be collaborating with the various other centers, major centers in the capital for starting the stroke registry. And the future will be in the future we'll be starting the TBI and acute brain injury registry as well. And also we're planning for the international collaboration and the various global partners so that we can move ahead. And also we will be planning for the specialized training services in our centers in the future. Just to summarize, the evidence practice gap exists in neurocritical care globally. The gaps are wider in resource-limited settings, attributed to a multitude of unique challenges. The orchestrated multidisciplinary approach to narrow the gaps and to translate the available evidences into clinical practice is crucial to improve the patient outcome. Thank you.
Thank you, Dr. Shrestha, for a very informative and lucid talk on the condition of neurocritical care in resource-limited setting and methods to narrow the gap. So, as it is an oration, there will not be any question-answer session. I request organizers and ISNACC Secretariat to felicitate Dr. Shrestha for delivering Professor Hariveer Singh oration.
Thank you, ma'am. Thank you, sir. Certificate of appreciation. So it was a very wonderful session on Dr. Hariveer Singh's oration. Though Dr. Gentle Shrestha sir was not present in live, but it was a very, very informative session. So from our team, this certificate of appreciation is presented to Dr. Gentle Shrestha sir in recognition of his contribution as the speaker in this Dr. Hariveer Singh sir oration. Thank you. And also the medal for his presentation and his oration. Thank you, Dr. Gentle Shrestha sir. Thank you, Nidhi ma'am. Thank you, sir.
Thank you. Thank you all.
Thank you.
Thank you, the organizers. Thank you.
Good afternoon, everyone. So moving ahead to our next session, that is session 5. So for this session, I would like to welcome our chairpersons, Dr. Joseph Montero sir, Dr. Rashi Gandhi ma'am, and Dr. Kalol Deb sir. So few words for Dr. Joseph sir. Dr. Joseph Sir is presently a neuroanaesthesiologist, program director, DNB at Hinduja and Medical Research Center, Mumbai. Sir has done MD and fellowship in neuroanesthesia at Edinburgh Hospital, Cambridge University. Sir has been awarded and had many scholarships. Sir's areas of interest are neuroanesthesia and neurocritical care, airway management, and other researches and publications. Next, I would like to welcome Dr. Rashi Gandhi ma'am. Ma'am is the Chief of Neuroanesthesia Department, Program Director of PDF and DNB Neuroanesthesia and Neurocritical Care, and faculty at National and International Neuroanesthesia and Neurocritical Society. Ma'am has also many publications in national and international journals. And ma'am is presently working in Kokila Bain Hospital as a Chief of Neuroanesthesia Department. Next, I would like to welcome Dr. Kalol Deb sir. Sir is presently working at IIMS Institute of Neurosciences, Kolkata as a senior neuroanesthetist for the last 4 years. Sir has been the neuroanesthetist for the 20 years in the various different hospitals, known hospitals of Kolkata. Sir has done MD and neuroanesthesia specialization from AIIMS, Delhi. Sir has also many contributions and papers and presentations in various international and national publications. Thank you all chairpersons. And I request all our chairpersons to carry forward this session.
Thank you.
Thank you very much for that introduction. And I welcome you to this session, the 5th session of ISNACC 2022. And as the first speaker, I'll invite Dr. Francisco Lobo. His topic of deliberation is cognitive complications after anesthesia and surgery. It is my pleasure to introduce Dr. Francisco Lobo. He's a consultant of anesthesiology, and his current affiliation is he's the Director of Research, Institute of Anesthesiology, Cleveland Clinic, Abu Dhabi, UAE. He's done his residency and training in Porto, Portugal, and he's a visiting professor in the Division of Neuroanesthesia at Washington University School of Medicine. He also was a research fellow in the Department of Anesthesiology at SUNY Downstate Medical Center, New York. And his areas of interest are intravenous anesthesia pharmacology, perioperative brain monitoring, and anesthesia for awake neurosurgery. I welcome Dr. Francisco Lobo. Over to you.
An invitation to participate in this ISNACC meeting. My name is Francisco Lobo from Portugal, at this moment working at the Cleveland Clinic in Abu Dhabi. And I'm going to talk about postoperative neurocognitive complications, reviewing what are these complications and how we eventually may prevent the occurrence of postoperative cognitive complications. So that's a challenge for 20 minutes. Anyway, I'll do my best to review all these concepts. So I'll try to review the PMDs, recognize the interaction between predisposing and precipitating risk factors. I'll try to shed some light into the perioperative neuroinflammatory process. And then in the end, what can we do to prevent PMDs? So classically, we may divide the cognitive complications after surgery and anesthesia in these 3 types: the emergence delirium that can happen in the PACU or in the after awakening, the postoperative delirium, which may happen during the first 24 to 72 hours after surgery, and then the postoperative cognitive dysfunction, which may be recognized and happen during weeks and months, even permanent after anesthesia and surgery. There's a very recent reformulation of this nomenclature published in 2019 in different journals. And I think it's more detailed, but from a practical point of view, let's keep our attention in this emergence delirium, postoperative delirium, and postoperative cognitive dysfunction. So this is an issue that is in the media among a lot of patients ask now about problems in memory and in cognition after anesthesia. And it's interesting if we look to this paper published some years ago in Lancet, that there's a new trend in what the patients are worried about. So if you look to this survey in 1972, 30% of the patients had no fear, some have about pain. And then what's in more recent surveys, what we have is fears about brain injury and memory loss. And we have a lot of reports in the news, right? So for example, this American writer, he had a heart surgery and he reports his own experience after the surgery. The issue is, this is not new, right? So in 1887, Savage was describing cases of insanity after anesthesia. Okay, after ITER, what's the problem with that? Some years after, in the 50s, Bedford was an internist in London, and they reviewed the records of almost 1,200 patients over 60 years, and who had surgeries under general anesthesia, and they found 10% of patients who had mental deterioration. And they related this cognitive decline with anesthetic agents and with intraoperative hypotension. And Bedford suggests that operations on elderly people should be confined to those who were unequivocally necessary cases. It's interesting to see that elderly people in 1954 was 50 years old, 55, 50 years old. So it's interesting the life expectancy changed during these decades, right? So the problem is that we cannot escape from aging, and aging is associated to a natural decline in cognitive performance. This is very well related with changes in anatomy and in physiology of the central nervous system. The cerebral blood flow decreases, the anatomy in dendrites and neurons are very marked with the age. So there's the aged brain is a pro-inflammatory brain. So there's changes in white matter, there's a dysfunction in the network connectivity. So the brain in aging is a much more vulnerable, and there's no mechanisms of compensation. So these old patients who have surgery, they are more sensitive to complications after surgery and anesthesia. So that's the background for these issues. Despite the detail that we may have cognitive problems, and we are going to see mainly in patients who are not old, but they are frail, they are sick, and emergence delirium, for example, is common in children, and as you know. So let's review these three general types of postoperative cognitive disorders. Delirium is a very common postoperative complication that manifests as an acute fluctuating failure of the brain to support normal arousal, normal attention, and organized thinking. There are several criteria for the diagnosis of delirium, but can be hyper and hyperactive, despite the emergence delirium is very, is most of the times it's a hyperactive delirium, right?
They're bringing you some right now. Oh, wow. Wow. You sit up at all? In a minute, I'll see if they'll lift you up, okay? The doctor send you? Don't do it. I can't. Whoa. I'm the prettiest I've seen. Are you a model? Nope, I'm gonna be right here with you. You eat the cracker. My name's Candace. I'm your wife. You're my wife? Yeah. Holy shit.
Well, this is a very nice emergence delirium, right? So, but most of the time, what we have is a patient screaming with a terrible agitation. But this is typical, this failure to have an organized thinking and to recognize familiar situations and people. We have some data about risk factors and patients' characteristics. And for example, it's common to have an association between anesthesia with volatile and emergence delirium, for example, and the previous emergence delirium is also a risk factor. And this delirium, as I said, the postoperative delirium can be hyperactive or hypoactive. And we may identify premorbid factors predisposing for postoperative delirium, advanced age, previous cognitive problems, interestingly, a low educational level, frailty, some visual and hearing impairment, depression, drug and alcohol addiction, poor nutrition, and a previous history of delirium in previous surgeries. So, and then we have factors that can precipitate delirium. And this interaction between them can be an explosion of problems, or we can act on them and trying to decrease the incidence of the delirium. That's how we may contribute to prevent the occurrence of postoperative delirium. And so this is a paper published 2 years ago by the American Society for Enhanced Recovery. And so I think that today it's easy to detect those patients who are at high risk to have delirium, right? It's interesting that during the idea that regional anesthesia, for example, was protective. Well, this is a very recent published paper, and it's a study comparing the effect of regional or with general anesthesia on occurrence of postoperative delirium in patients undergoing hip fracture surgery. And what we can see is there's no difference. So the patients with general anesthesia, volatile or TIVA, compared with patients having spinal or epidural, combined with peripheral nerve blocks, also in the general anesthesia group, there's no difference in the incidence of postoperative delirium and other problems. So it looks at it's not the technique, the anesthesia technique that matters only. There's something more behind the occurrence of the delirium. But that's an open road for further investigation. What we know today is that patients who had delirium after surgery are at high risk to have permanent cognitive problems in the future. So we have to prevent occurrence of the delirium. And even more, we have some data showing that mortality, long-term mortality is higher in those patients who had delirium, even adjusted to other possible covariates justifying eventually a higher mortality. And so postoperative delirium should be a real concern for us. And it's now considered a surgical quality parameter. So I think that we have to be really aware of this problem, and we should avoid occurrence of postoperative delirium. Postoperative cognitive dysfunction is the decrease in or impairment of the intellectual function, presenting as impaired memory or concentration, is not detected until days or weeks after surgery, may last during several weeks, months, even to be permanent. And there are also risk factors, precipitating factors. They are quite common, the same as a postoperative delirium. But something that we cannot also escape is to the contribution of the surgical insult. Marvin Mays and Susana Vacas, a very good friend also from Portugal, who is also a speaker in this ISNACC meeting. So they have been doing a lot of research among this. They have this very interesting and I think valid model showing that the peripheral surgical insult triggers a systemic inflammatory cascade of events with changes in the blood-brain barrier, expression of strong neuroinflammation in some regions of the brain. The hippocampus, it's a very important target of this neuroinflammation. And then in the hands, this long-term potentiation, disruption, changes in the glial cells and in other neuronal networks are possibly the mechanisms behind the cognitive problems, which may be potentiated by other factors and the anesthetic insult also. So how to prevent postoperative neurocognitive disorders? So I think that we have to have in our mind that we have those patients, the normal population who have with age an impairment of cognitive performance. Then we have a population that is at high risk to have a faster decline in cognition. For example, patients with sickness, with genetic background, frail patients. And then we have high-risk patients who are going to have surgery, who are going to have intraoperative surgical events, anesthetic events that can increase even more the risk to have a faster decline in their cognition. So what can we do to change this? To make different the surgical and anesthetic perioperative events. Even we can stop or even improve this. For example, pain, chronic pain, if we increase the quality of life, possibly decreasing the chronic pain, for example, after a hip arthroplasty or knee arthroplasty, we can even improve the cognitive course of these patients after surgery. So that's where we should pay attention. So education and training, pain control, avoid antipsychotics and anxiolytics drugs, and have a cognitive screening before surgery in our pre-anesthesia testing clinics with a screening delirium. There are very fast mini-cog tests, very easy to perform tests to detect high-risk patients, and some other non-pharmacological interventions are very important to prevent this. For example, cognitive pre-habilitation before major cardiac surgery changes in a very significant way the course of these complications. The same for delirium. And I would say that preservation of cerebral physiology is important. Is it difficult? Yes, many parameters that should be avoided, but we are neuroanesthesiologists and we have to share our care, our knowledge to our colleagues who are not so involved with the patients having a frail brain, right? So preservation of blood pressure, it's important. Avoid hypotension during anesthesia and surgery, it's essential. And then we may have healthier drugs. And we have some data that showing that intravenous anesthesia may be protective with a lower neuroinflammation, and I think that dexmedetomidine has a very important role here, decreasing the incidence of delirium. Eventually, NSAID drugs like parecoxib, decreasing the neuroinflammation, has also a role. And it's very important to measure the clinical effects of the drugs in the brain of our patients. For example, decreasing and recognizing and avoiding the burst suppression and with intraoperative EEG monitoring. Burst suppression is not normal. Electroencephalographic burst suppression is not normal and should be avoided and should be seen like a brain arrest. So we have to resuscitate this brain. And even if we see the power of alpha activity during anesthesia, we can detect patients who are at high risk to have postoperative delirium also. The way the patients awake, we can see the course of emergence. We can see and change this course, for example, with a small bolus of dexmedetomidine. If we see these 4 and 6 trajectory from very deep anesthesia to a fast awakening. Pain control is important. So we have to start a very postoperative, very good postoperative management during anesthesia, possibly using EEG and some sort of anti-nociception balance monitoring. We have a very interesting study published a few months ago showing that guided anesthesia by SedLine and EEG and ANI, analgesia nociception index, decreases the incidence of delirium, and then oxygenation. So if we detect patients with a poor brain oxygenation before anesthesia, we can detect these patients and we can pay more attention during anesthesia. And NIRS, for example, may help us to construct the individual autoregulation curve, and we can see the limits of the autoregulations to see what blood pressure the patients may tolerate or not. And decreasing this blood pressure, we saw before that we are decreasing the risk of postoperative cognitive problems. Gathering information from EEG, brain oxygenation monitors, we improved the outcomes regarding cognition after surgery. So take-home messages: yes, cognitive disorders after surgery and anesthesia are common and are a serious burden. Preoperative optimization is essential to decrease the incidence of these neurocognitive disorders. Intraoperative anesthetic management should include TIVA and dexmedetomidine, parecoxib, brain monitoring with EEG, and non-invasive cerebral oximetry with NIRS, and normal physiology and nociception and T-nociception balance monitoring. I think it's also very important. Data so far exists for ANI index and postoperative pain management, promoting a familiar environment, early mobilization, early discharge are important goals to achieve in the postoperative period. And the general principles: keep homeostasis, normal volemia, normal tension, normal capnia, normoxia, normal glycemia, and normothermia. Thank you very much for your attention.
Thank you very much for that, Dr. Lobo. It's a very interesting topic and you have covered it. It's also a topic of a lot of current research. And I hand over now to my co-chair, Dr. Rajeshri Gande, to introduce the next speaker.
Thank you, Dr. Joseph. I am really pleased to introduce Dr. Lakshmi Kumar Venkatraghavan, MBBS, MD, DNB, FRCA, FRCP. He is Associate Professor at University of Toronto, Director of Neuroanesthesia at Toronto General Hospital, and is a Program Director of Neuroanesthesia Fellowship Program. So he's done his medical schooling from India, UK, and training at Western Ontario Hospital, Toronto. And his research interest is in anesthesia for functional neurosurgery, functional neuroimaging, improving patient outcomes after neurological and spine daycare surgeries. He has 120 peer-reviewed publication in his PT. Over to you, Dr. Lakshmi Kumar, and very welcome to you, ISNACC 2022.
Good afternoon. Thank you for this wonderful
international collaboration.
And it's been my great pleasure and privilege to be here to presenting to you today. My topic here today is the cortical mapping for anesthesiologists. So first of all, I don't have any disclosures except for I do get a royalty from my chapters in UpToDate. And all the images are from the reference article or from the Google images. So as we all know, the advances in neurosurgical techniques has improved the overall quality of life of the patients and with the brain tumors and epilepsy. And total resection of the tumor or complete removal of epileptogenic focus is the key to the success. And lesions close to the eloquent areas pose a unique challenge to the neurosurgeons. There is a conflict between the main maximal resection with preserving neurological functions. There are well-established pre-surgical mapping techniques, for example, functional MRI, diffusion tensor imaging, magnetoencephalography, and PET scans. But still, there are some patients, intraoperative stimulating mapping is indicated. So with this background, the learning objectives of my talk are to discuss the rationale and the outcome evidence for intraoperative cortical mapping, to describe different techniques of intraoperative cortical mapping, and then finally to touch upon on the anesthesia considerations for patients undergoing intraoperative cortical mapping, comparing awake craniotomy versus sleep mapping, and also on the choices of the anesthetic agents. As we all know that the cortical mapping is also called as the direct electrical stimulation, intraoperative stimulation mapping, or just stimulation mapping. Just touch upon a brief history. In 1874, Robert Bartholomew is the first person who showed that the motor cortex with a contralateral motor response in a patient who has got an exposed cortex as a result of basal cell carcinoma. But major work on the cortical mapping is done by Dr. Penfield from Montreal, and he did a lot of works, and especially in the epilepsy surgery. And the George Ogerman in 1970s is still considered as a pioneer of current mapping technique. Most of the language mapping and the also development of a handheld bipolar stimulator, so which are currently still in use, is all on the basis of the work of the George Ogerman. He enabled the precise mapping with accuracy of approximately 5 millimeters. And in early late 1990s, Taniguchi is the one who pioneered the motor mapping under general anesthesia using a high frequency multipulse brain stimulation. So what are the rationale for cortical mapping is that the identification of electron cortex is very difficult because of the quite a bit of inter-individual variations, as well as the visual inspection. Normal or abnormal tissues may be quite difficult because the resolution is not very good. And there is an intraoperative brain shifts which may affect the intraoperative neuronavigation methods. And the identified abnormal brain tissue may still have a normal function. And the most importantly, because of the pathological conditions, there is a brain plasticity which lead to neurophysiological and neuroanatomical dissociations, which is one of the main reason why we need an intraoperative cortical mapping. So regards to the outcome evidence, there are a lot of studies looking at the utility of intraoperative stimulation mapping or cortical mapping. And two main outcomes. One is they maximize the extent of resection. There's a couple of systematic review and meta-analysis have shown that the maximal extension of resection was comparatively higher with the intraoperative stimulating mapping versus without the stimulating mapping. So maximizing the resection does improve overall survival and progression-free survival, as well as the improved post-operative seizure control in patients with epilepsy. The other spectrum is to minimize the post-operative deficit. And one of the study from 2012 with the meta-analysis of 90 reports over 8,000 patients have shown that the intraoperative stimulating mapping does have a low post-operative neurological deficit compared to no intraoperative stimulation mapping. So before we proceed to the rest of the talk, so I just wanted to clarify a few terminologies which comes up related to the stimulation mapping. And these are related to either to a stimulation part of it as well as the response part of it. I think as an anesthesiologist, we need to really understand this concept much more clearly because we are not very familiar with some of these terminologies. We probably heard very well. So one is when you're considering the stimulation, there is a biphasic versus monophasic stimulation. So biphasic is, as the name suggests, there is two phases. There is a positive anodal phase and the cathodal phase. And the pulse duration is the whole time from the anodal phase and the cathodal phase as well. In contrast, monophasic pulse stimulation is basically a single phase, only on the positive side on the anode phase, and that whole duration is considered as the pulse duration. When you're coming to the stimulators, there are two types of stimulators. The bipolar, the A and B are the typical ball electrodes or tip electrodes, bipolar stimulators, which is similar to electrocautery machines we are all familiar with. And then monopolar, the C and D are the monopolar stimulation. The main difference between them is that how the current is dispersed with the stimulation. As a bipolar, the most of the dispersion is between those 2 points. So only the area between those 2 points are usually stimulated. Whereas with monopolar, there is a much more wide diffuse spread of the electrical current in. So this is important when you're considering the positive mapping or a false positive, false negative mapping. So that's where what type of stimulator is used is important. When you're coming to the another important terminology, and especially for us, is the after discharge. The after discharges are the electrocardiographic recording during the cortical mapping. So for example, either they can use the grid electrodes on the surface while they're doing a stimulation with the blue tip here, or they use the classical Montreal or Medusa frame where you do electrocardiography along with stimulation. So these are like epileptiform-like discharges related to the stimulation. And when this discharge is lasting longer than the stimulation, they're called as the after discharges. And the important of the after discharge is that the recording electrocardiography does indicate that we can make sure that the electrical stimulation is delivered. You get a stimulation artifact. For example, in this figure on the right-hand side, at 3 milliamps, there is a stimulation artifact is seen that we know that the electrical current is just conducted through the brain. If there is no stimulation artifact, then we may have to check the equipments, or we may have to go up on the electrical current. And we need to stimulate it till there is a positive changes which is felt or seen on the patient. And also we need to look for the presence of after discharges. So the stimulation increases stimulation until the after discharge is seen. That is considered as the highest stimuli. So for example, here it's a 7 milliampere and 3 milliamps, there is no after discharges, whereas 7 milliamps, there is an after discharge in. So the stimulation mapping should be done within these two ranges, current ranges in. Usually the after discharges doesn't have any clinical implications, but it may indicate a continuation of after discharges, may indicate a subclinical seizure, and also there is a progression to a clinical seizure, so that you can identify the onset of seizure earlier and then we can treat it sooner. Okay, so this is one of the classical onset of the after discharges and the onset of the electrocardiographic pattern of the seizure. When you're coming to the physiological responses, there is few terminologies we need to clarify. One is a positive response. When you're stimulating the cortex, so you may get a positive response as a sudden movement or paresthesia or visual changes with the pause genes, pause phenes. And with the negative responses, it can be a tingling, it can be a numbness, or especially with the language mapping, there is an interruption of the language function. And which should not be confused with the positive mapping or negative mapping. Positive mapping actually indicates that the functional important site is identified, and the negative mapping indicates that no functional site identified in the mapped area, or otherwise the area is considered as a non-eloquent. And this is important so that we can minimize the false positive and false negative. The false positive is a mischaracterization of a non-eloquent region as an eloquent region, leading to premature cessation of resection. And one of the common causes for false positive are patient fatigue, stimulation induced partial seizures, and also stimulation to remote structures by axonal propagation. In contrast, the false negative is the failure to identify critical eloquent brain region. And then if you go ahead and do a resection, there is a results in postoperative deficit. The cause for a false negativity is the inadequate stimulation setting and the inappropriate neurophysiological testing as well. So when you're coming to the neurophysiological testing, we can talk about it later. And stimulation paradigms, conventionally, there is only these two stimulation paradigms are used. One is the low frequency stimulation. Predominantly, most of the awake mapping is done with the low frequency stimulation mapping. And then high frequency stimulation mapping is predominantly done in asleep patients or under GA. Okay, as you also notice that there is a different type of electrodes and different type of pulse waveforms are used. So in generally, the low frequency bipolar is predominantly used for an awake craniotomy, and then mapping under general anesthesia is typically high frequency with a train of 4 or 5 with the monopolar with the either monophasic or biphasic, especially if you're going to do a subcortical mapping. So that's what these are the two commonly used stimulation paradigm. When you're coming into the mapping function or responses, both cerebral cortical mapping, also subcortical mapping, depending upon the different regions, there is a different testing paradigm, things we need to do it. And I think that's beyond the scope of this lecture, how to do a language mapping, speech mapping, and the different parts of it. So if people are really interested in, I strongly recommend this article, which is just published in 2021 March in Frontiers in Human Neuroscience. The figures are from that article. It's one of the really a good review on this topic. So more important for us, the anesthesia and the cortical mapping. So intraoperative mapping of the most neurological functions occur in awake patients. And hence intraoperative stimulative mapping is the most common indication for an awake craniotomy, which we are all very familiar with. However, general anesthesia or asleep mapping is still possible for a motor mapping. And there is a small case series where they said even a speech mapping is possible using a motor function of the speech testing, using electrodes in the vocal cord functions. There is a small case series demonstrated that motor speech mapping is possible under general anesthesia. So when you're coming to the awake craniotomy and the intraoperative stimulation mapping, it's very well established. And as you all know, there is two specific techniques, either asleep, awake, asleep, or monitored anesthesia care with no airway manipulation with the conscious sedation. And studies have shown that there is no difference between these two techniques with regards to the success or failure of intraoperative stimulation mapping. Similarly, the individual choices of agents, there is no specific technique which has been recommended. And the studies have shown that there is no difference between any combination of, so whatever the institutional specific, whatever one is comfortable with, that seems to be the best option of choice of anesthesia for intraoperative stimulation mapping. Just a word of caution, benzodiazepines and the opioids can cause a reappearance or worsening of a neurological deficit. So we did do a systematic review and we published it early last year. And I think this article just came out this month in Journal of Neurosurgical Anesthesia. Also, we looked at almost 600 patients having an awake craniotomy, and we used look at people who had a midazolam as a sedation for awake craniotomy and looked at the post-operative neurological deficit. And we found that there is the people who had a midazolam sedation compared to no midazolam tend to have a more post-operative neurological deficit. So we just submitted the abstract to Frontiers Oncology, which is in press, and we are working on the actual paper. And there is one small study we did compare the dexmedetomidine versus the asleep-awake sleep craniotomy, and which did show that the dexmedetomidine is maybe a better agent because patients were more awake and more able to perform the mapping much better. So the success rate of mapping was much better with the dexmedetomidine. And always there is a failure of awake craniotomy or intraoperative stimulation mapping. So the failure is usually defined as the unplanned conversion to general anesthesia and or premature cessation of mapping. And it is still incidence around 2%. And there are various causes of failure, including improper patient selection, patient preparation, patient cooperation. But two commonly comes topic on the causes of failure is one is the seizures, and intraoperative seizure associated with the stimulation mapping can be anywhere between 3 to 40% of people. And most of the seizures are related to stimulation. And that's why the monitoring the after discharges may be able to pick up the seizure early, and then most of the seizures that spontaneously recover, and using an ice cold saline or Ringer's lactate solution seems to work very well, and most of the time you don't need any pharmacological agents at all. And again, the point I was trying to stress here again is that is the monitoring the after discharges or using electrocardiography along with mapping. So seems to you can reduce the incidence of seizure by early detection of a subclinical seizures. And the second important cause of failure is the inability to communicate with the patients. The incidence is around 4.6%. And there are many factors, including the patient selection, language barrier, preoperative dysphasia, especially, and also using anti-epileptic, especially phenytoin. And they are all being considered as risk factors in this small sample size study. When you're coming to the cortical mapping under general anesthesia, not all patients can able to tolerate an awake craniotomy. There are some patients we may need to do under general anesthesia. So asleep motor mapping is gaining popularity, and we can do both cortical and subcortical mapping under general anesthesia. And there are various techniques that have been employed for mapping under general anesthesia. The first is the SSCP phase reversal. And then second is the trainer 4 or 5 high frequency stimulation. And the third is a combination of classical motor work potential monitoring in addition to direct cortical stimulation. And fourth is the continuous mapping by integrating the monopolar stimulator to a suction step as they suctioning out and resecting the tumor. So we give a continuous feedback to the surgeons in. And SSCP phase reversal, I think most of us are very familiar with this SSCP phase reversal. And this is used to identify the central sulcus so that you can identify the premotor, precentral gyrus or motor cortex. And so it's basically using a strip electrodes across the central sulcus and using an SSCP monitoring. So you can see that in the sensory cortex, the SSCP waveform is usually positive. And then there is a equal positive or negative at the central sulcus, and then you have a negative waveform in the precentral or a motor area, so that we can identify the motor area, so that the direct cortical mapping can be possible following the SSCP phase reversal. And this is the classical sleep motor mapping with under anesthesia with the high frequency stimulation. Usually trainer 4 or trainer 5 stimulations are used. Since the patients are asleep, the response is usually done using an electromyogram. So in this figure, as you can see, this is the face and this is the arms and legs. So with the stimulation, I can see the activation of the EMGs in those muscles indicating a positive response. And for a cortical mapping, anodal stimulation is used. And then for the subcortical tissue, the cathodal stimulation is used. Studies have shown that is the high frequency stimulation is better than low frequency stimulation, and as well as the lower seizure incidence even in a patient with epilepsy. And another important concept is that especially using high frequency stimulation for a subcortical tissue. Studies have shown that there is a linear relationship between the stimulation intensity, for example, milliamperes, and the distance from the corticospinal tract in the subcortical mapping. So for example, 1 milliamps current is usually equivalent to 1 millimeter distance from the corticospinal tract. So that as the current comes down, so you can have this crude calculation to identify how close they are to a corticospinal tract. Even though some other studies question this linear relationship, but most of the neurosurgeons still believe this relationship of 1 milliamperes equal to 1 millimeter of distance from corticospinal tract. And the combined MEP with the cortical and subcortical mapping usually done with the addition of a strip electrode. So it gives you, in addition to a cortical mapping, you can do a continuous motor work potential monitoring and provides a predict information of the motor outcome, and they improve the safety of resection because they do the mapping then followed by the resection. So during the resection process, they may cause more harm. So the continuous monitoring with an MEP may have an additional tool, give you information during the resection part of it. When you're coming to the anesthesia for asleep motor mapping, there is very minimal literature on this topic, and very small retrospective study on 49 patients. They compared awake and asleep mapping, and they showed that general anesthesia allowed reliable motor mapping, and there is no difference in the extent of resection between awake and asleep mapping patients. And the TY is most commonly used technique with no muscle relaxant after intubation. And inhalational agents, maybe MAC less than 0.5 is acceptable when you're using a multi-phase high frequency stimulation. However, generally most surgeons and the neurophysiologists are very reluctant for us to use the inhalational agents because most of the studies looking at the correlation between the stimulation threshold at the distance from corticospinal tract was validated only under TIVA anesthesia. As you all know, the intravenous and inhalational anesthetic may have quite a different effect on the cortical surfaces. So we don't know under inhalational agents, this relationship is, or this correlation still exists. So they still consider to use TIVA. And currently there are no studies which has compared TIVA versus inhalational agents. So in summary, the intraoperative stimulation mapping is increasingly recognized a critical tool to guide the resection of pathology within or adjacent to the LEC1 brain cortex. It can be performed under awake craniotomy or general anesthesia. Awake craniotomy has been the frequent choice for its feasibility of intraoperative neurological and neurocognitive testing. Variety of anesthetic regimens are compatible with the awake functional mapping, although dexmedetomidine seems to be beneficial. TIVA has been a standard recommendation when you're doing a sleep mapping, and the role of volatile anesthetic can be used, especially with the high frequency stimulation, and but more work needed to study the effect of anesthesia on intraoperative stimulating mapping, as well as the effect on the overall postoperative neurological deficits and the other outcomes in. So with this, I strongly recommend anybody interested in. These are the two excellent, there is a more excellent reviews on this topic, but these two are quite important review. One is 2010 and the other one is 2021. So both of them are really a good review on this topic. And once again, I thank you, organizer, for inviting me for this talk. And this is the aerial view of early winter in Toronto. And that's my email address and my Twitter. And so if anybody is interested, if you have any questions, feel free to email me or send me a tweet.
Thank you, Dr. Lakshmi Kumar, for such a beautiful talk. It really made it look so simple, cortical mapping for anesthesiologist. Thank you.
Thank you, Dr. Rajeshri. I take this privilege to introduce Dr. Andrew Kofke to you. He is a renowned neuroscientist and he has been a faculty and director of neuroanesthesia at the University of Pittsburgh, West Virginia University and University of Pennsylvania. He has been associated with establishing neurocritical care program at these three universities. He had a keen interest in studying the neurocritical care program and outcome of the patients in brain-oriented acute care medicine since very young. He is a pioneer in the field of neurocritical care, and today we'll speak on complexity in neuroprotection, anesthesia, and beyond. I welcome Dr. Andrew.
Hello, everybody. I'm Andrew Kofke. I'm professor of anesthesiology and critical care, focusing on neuroanesthesia and neurocritical care at the University of Pennsylvania. For this session, I'm going to discuss problems in complexity of neuroprotection in anesthesiology and beyond. Along the line, I'm going to suggest a proposed new approach to neuroprotection research. And it's based largely on this editorial below, which I published in Neurocritical Care in 2010. Establishing the efficacy of new neuroprotective therapies in neurocritical care and stroke has really proven to be an exercise in futility. There's been almost 7,000 stroke clinical trials listed in the clinicaltrials.gov database, with few apparent reproducible results of any demonstrable efficacy in the acute context. Many neuroprotection trials have been done and discarded. There's tons and tons of promising preclinical data. And yet whenever it goes to be translated to the clinic, nothing's happening. This is not a new observation. In 2007, Donen in the Feinberg lecture stated that a point has been reached in neuroprotection research where we cannot continue to do business as usual. Either translational research in neuroprotection should stop altogether, or we approach the problem in quite a different way. I don't think much changed since 2007. Some examples of stroke therapy trials are listed here. Drugs have been tested to improve blood flow. Drugs have been tested to protect brain tissue. And there hasn't been that much that much which has translated, except perhaps the antithrombotics and thrombolytics. Why is this? Well, we have a single bullet that we keep, a different sort of bullet, but there's an army of causes. So we need a shotgun with smart pellets, directed towards each facet. And of course, there's issues with randomized clinical trials and animal models poorly model clinical situations. Thus, we see publications like this by respected researchers indicating that most published research findings are false. Why is this? Well, RCTs may not be the only path to new knowledge, believe it or not. Other pathways can be considered. Prospective controlled studies, which aren't randomized, or we can observe for overwhelming effects of a given therapy. Think of penicillin when it was first brought to the clinic, or think about parachutes. Trial and error, Bayesian methodology, QI methodology. All of these may lead to knowledge by different routes. Here's the tongue-in-cheek paper that was published in the British Medical Journal some years ago. Parachute used to prevent death and major trauma related to gravitational challenge, a systematic review of randomized controlled trials. And their conclusions were that, as with many interventions intended to prevent ill health, the effectiveness of parachutes has not been subjected to rigorous evaluation using randomized controlled trials. Advocates of evidence-based medicine have criticized the adoption of interventions evaluated by using only observational data. We think everyone might benefit if the most radical protagonists of evidence-based medicine were organized and participated in a double-blind, randomized, placebo-controlled crossover trial of the parachute. Obviously ridiculous, but I think it makes a point. Multimodal therapy seems to be the logical thing to go to next. So the many negative studies belie the support of basic laboratory studies. Many suggest that multimodal therapy is the goal, as I am suggesting, but the issue is how to implement it. So I'm going to provide a rationale to suggest that such negative results in retrospect are altogether predictable, suggest an explanatory model for such reproducible futility in a complex biological system, and propose a method to develop a multifaceted approach which, taken all together, will produce breakthrough level data, which will then be generalizable for multi-institutional application or study. The impact of perturbations in complex systems. And here we see the example of a complex system, which is basically a widget factory, which has multiple factors, thus it's complex, and they result in the quality of the product or the widget. So we have the conveyor speed, F1 with a standard deviation, raw materials, bolt quality, computer speed, the people, and each has a weighting factor. So some things are very important, like raw materials. Other things are less important, like perhaps computer speed or the people. And it may vary from factory to factory. So what about a biological system? There, in a biological system, you have multiple factors, which lead to S, which is the severity. And so rather than quality, we're using severity. And in this example, we have lipoproteins, vascular regulation, apoptosis, and other genomics, neurotransmitters, cerebral blood flow, many others, which may contribute as a part of the complexity, leading to an equation which is an analogous equation. But here we have severity equals a weighting factor times a physiologic factor, plus a weighting factor for another physiologic factor, plus a weighting factor for yet another, and so on. And who knows how long this equation may be. So in the widget factory, each variable is known, each variable is controlled, small standard deviations, and if you change one factor, you have a predictable result. In a rat, it's fairly homogeneous with reasonable standard deviations, minimal disease variation because they're inbred, limited control over variables, and you can treat one factor with a fairly reproducible result. Thus, we have all this preclinical data which supports neuroprotection of individual therapies. But in a human stroke, intracerebral hemorrhage, subarachnoid hemorrhage, TBI, or cardiac arrest, there's wide variation in disease presentation. There's wide variation in concomitant diseases and genes. There's variable concomitant pharmacology going on. The standard deviations are large. And the time after the insult varies also. So this is important because the weighting factor may change as a function of time after the insult, leading to the equation now looking like this, where the severity is a summation of the weighting factors for the weights and the various factors, but with a time factor introduced also. So the between factor interactions may not be simply additive, however, so but may possibly more complex. So some may have a nonlinear exponential impact on severity. So it begins to look like this. Severity equals summation of the weighting factors affected by time and the factors themselves, with an exponential entered in for that. So as I say, brain ischemia is complicated, and we have all these different things which contribute to the ultimate outcome. But it also changes with time. And this is represented in this figure from Peter Saffer's laboratory years ago, indicating the impact of cerebral ischemia on various physiologic processes, and then the impact of reperfusion and reoxygenation, introducing a whole variety of other pathophysiologic processes. And then with time, genomics starts to kick in, and you can have pro-death activities and pro-survival genes, which may kick in over hours to days. So you can see time is important, and it's all very, very complicated. And then of course, people are complicated. Those of you who may be baby boomers or nearly baby boomers may perhaps have seen this cartoon from the old I Love Lucy series. And here we have Lucy and Ethel assigned to wrap candy in a factory. And as they're going along, the conveyor goes faster and faster. And then the supervisor comes in and says, "Go faster, they're doing great." And as you can see, they've been eating the candy, not wrapping it. And then they just go crazy over the situation. So you can wonder whether this is a metaphor for your OR or your intensive care unit, or how you provide protection, neuroprotection for your patients. And the point of this is that every place has their idiosyncrasies in their people. They have their idiosyncrasies in their supervisors and in their helpers, and every place is different, and the people are complicated. So this creates the notion of system factors, which I expect are likely also nonlinear, which create variation in the severity of injury. Here's some examples: experience and education of healthcare workers, technical and pharmacological resources, nursing and other healthcare worker ratios to patients, rapid response team availability and quality, and quality of the emergency medical systems, and so on. And also there's syndemic theory, which gets into the social effects going from place to place, where there's cultural things. And if you compare the Indian medical system with the American medical system, you'll find numerous cultural issues which may affect patient decisions that are made in patient care. The weighting factors change with time after insult, and the treatment of one factor can alter another. So let's say that you're giving calcium channel blockers as a neuroprotection, but they drop blood pressure. So one is protecting and one is damaging. So the treatment factors may interact and are also likely nonlinear. So now we have an equation where you have the severity equals the summation of the various physiologic factors affected by time, plus the summation of all the various healthcare system and people factors. So here's a real life example of some things that I suspect illustrate these issues. So here we have TBI hypothermia trials. Study after study after study after study were positive in single center trials. Then there were a couple of multi-institutional trials which didn't indicate neuroprotection from hypothermia. Then there were more single center trials. Which makes one suspect that maybe there are inter-hospital differences, health system factors, which are important. And indeed, the PI of one of the studies in post hoc evaluation found intercenter variance in clinical trials of head trauma to be important factors. The trial sensitivity was likely diminished by significant differences in how mean arterial pressure was addressed and how CPP, cerebral perfusion pressure, was addressed and calculated. The hours of vasopressor usage, morphine dose, percentage of dehydrated patients, and the participation of some centers which were quite small, resulting in other unmeasured factors. Just looking at cerebral perfusion pressure, there's issues with what is the lower limit of autoregulation. Drummond suggests that it's higher than the standard 60, and of course it changes with TBI. Then calculating the CPP is an intercenter variant because where mean arterial pressure matters. So if you have someone in a sitting position, mean arterial pressure is measured at the heart level, then that may artifactually increase the CPP by up to 15 millimeters of mercury. So you think it's 60, but it's really 45. You think it's 60 with the blood pressure measured at the heart, but it's 45 if you bring the blood pressure manometer up to the level of the head, like Lassen did when he first described CPP. And everybody does this differently, as a study which I published some years ago where we did a survey, and it's all over the place. And the basic studies that the Brain Trauma Foundation used to make their recommendations, they all did it differently also. And then there's even more complexity that we can add alternative nomenclature suggested by a colleague of mine, a neurosurgeon, when I presented this to them, and that is that you can have damage mechanisms, which I've been discussing, but there's accommodation going on also. There's homeostatic responses and there's genomic responses, and they're all multiples, so that the severity really equals a summation of damaging mechanisms and accommodating mechanisms. Each is a sum of individual components. So you have a damaging team and an accommodating team, and they're working to either make things worse or make things better, just through endogenous processes. So what this means then is each factor has its own weight and is another factor. So you end up with each factor now, physiologic factor now, being a summation of damaging processes and accommodating processes, each with their own weights and time elements. So the combined nomenclature then results in severity equals, which I had presented before, becomes severity of injury equals a weighting factor for a given factor here, but each given factor is also the summation of damaging processes and accommodating processes. So this is the same equation presented here. And now you start to say, well, it's no wonder magic bullets miss routinely when you have all these things going on to result in your ultimate severity outcome. So the failed single bullet RCTs now have created a type of innovation paralysis. Notably, innovation is one of the themes of this meeting. Complexity and big standard deviations have produced reproducibly negative studies with single factor treatments for neuroprotection. And my opinion is this has created widespread skepticism and cynicism within pharma, and they're giving up because they have a poor return on investment. Then you have thus a multifactorial approach is needed. This has been suggested by Rogobuski et al. And others, but no one has suggested how to introduce this. We're paralyzed by traditional notions of knowledge creation and competitive issues between companies, in my opinion. So here's an example of a multifactorial study, which was done by Peter Saffer in '76. They took cardiac arrest, dogs that have sustained cardiac arrest. One group, all they do is provide routine care, and the other group gets hypertensive therapy, anticoagulation, intra-aortic dextran, and hemodilution, with a dramatic difference. This is a better score down here with the therapy versus the controls. However, in real life, we can't just dream up some arbitrary cocktail, which is in essence what they did here. I suggest a theoretical, fictional multimodal study after cardiac arrest. This is the clinical CPC, the clinical performance category over time with each added therapy, and until you get to, in this case, 14 therapies, having a CPC which is way lower than the control or the starting group. Each of these individually is not statistically different than the one before, but taken as a group, you find that combined, you end up with a statistical significant effect. So this leads to the notion of PDSA, or Plan, Do, Study, Act cycles, which is derived from quality improvement literature. It's a QI technique, not meant to create generalizable knowledge, but I think it can be used to help design a study that's advocated by Berwick for QI. So the PDSA method is non-randomized, it's sequential with historical controls. Anything which is used should have an a priori notion or premise of the weights of the factors. Functional genomics one day may help derive this. I've published a paper recently trying to derive some weighting factors using genomics, but it's not a traditional research technique. But nonetheless, it starts with planning to identify a process to improve and a way to do it. Then do a systematic implementation of a new process, study it, collect and analyze results of the new process, and then implement permanent change in processes of care if warranted. So the PDSA for multifaceted neuro research trials would be to incrementally introduce therapeutic measures, each directed against a single facet and focusing on secondary injury and ensuring no harm. One will measure induction of the desired impact on targeted pathophysiologic axis. So let's say you wanted to give a drug to increase CBF, you measure the CBF and see if it actually does it. Serially measure surrogate and actual outcome measures like CBF or biomarkers for injury, and then serially add new therapies. So the PDSA for neuro research trials, the chosen pathophysiologic goals would have to be widely accepted to have neuroprotective potential. And examples would be to prevent extremes of blood flow, anaerobic metabolism, hyperthermia, hypermetabolism, peroxidation, excessive glutamate release, each with an individual therapy designed to produce this. So the new paradigm then would become to start a new single facet therapy. Are there unacceptable adverse effects? If there are, then you discard it. If not, if it's doing what it's supposed to be doing, then you accept it, add it to the standard protocol, and then you go back and you add another therapy until you've added the paradigm that you want to. Then you measure the surrogate neurologic outcomes with them all combined, both ongoing and at the end of the study. Measure functional neurologic outcomes, analyzing at the end of the study. So this would be an example. You could sequentially add antioxidant drugs and then measure isoprostanes to see if they're doing it. Administer a magnesium infusion to see if it has a clinical impact. And of course, if the serum mag does go up, administer reserpine and if you have microdialysis, measure the catecholamines and glutamate in the brain. Adjust CBF with PCO2 and blood pressure manipulation to see if you can optimize it. Give IV oxaloacetate, which may decrease glutamate. And if it's decreased, then you adopt it. And then after you're done, you add all these together, looking at biomarkers, imaging, and so on. And then after everything is done that you wanted to do, then you introduce a multimodal paradigm, and then you do the prospective randomized multi-institutional trial. That's my primary suggestion for this. And then I again reiterate that over time the multiple therapies can add up. However, this is, I think, a neat idea, but I can just imagine the problems with it being translated. First of all, if you have to get drugs from different companies, are they going to cooperate? Are they going to have competitive and secrecy issues? Which modes do you, and of course, getting regulatory approval, at least in the US, would be enormous. Which modes do you decide to treat and how? And this is where the weighting factors come in. Determining them beforehand, I think, is essential. If the drugs are off patent, can you add them? And of course, approved. Can you integrate physiology with pharmacology? Can you integrate devices and drugs? Is the NIH ready for this? Is the scientific community ready for something like this? Is this really new knowledge? So that's the gist of what I have in mind is kind of a, I think, innovative suggestion on a better way to do neuroprotection. I think if someone were to take this on, this is a career's worth of effort to get this worked out. So I'm free, now willing to take any questions. Thank you.
There are two questions for Dr. Lobo.
Yeah. So, Dr. Francisco Lobo, will you take these two questions? One is from Dr. Andrew Kofke. Any thoughts on the interaction with post-COVID cognitive decline and anesthesia, and how long should we wait after COVID to allow elective surgery?
Hi, good afternoon to everyone. Thanks for this invitation for ISNACC 2022, and good morning to Andy in US. So it's a great question, and we know very well that cognitive decline is a very important consequence of COVID-19 disease, and there are some recommendations about to wait at least 2 weeks after COVID to have elective surgery. And during this time, I was chatting with Chiara Roba in Genova. It's probably one of the group in the world with more experience with critically ill patients with COVID-19, and it's their practice. Wait at least 2 weeks for elective surgery after recovery of COVID-19. And it's interesting because Chiara and Paolo Pelosi and the other members of this Italian group of COVID-19, they published 2 or 3 weeks ago a paper in Frontiers in the Neurology. It's very interesting, done in using brain monitoring with NIRS, with near infrared spectroscopy in patients with COVID-19, and their findings showed that there are a lot of problems in the autoregulation. So they were evaluating with the new parameters of the O3 from Massimo brain oximeter monitor. So they have the global saturation of oxygen and subparameters with the venous and arterial components. So we can see what's going on wrongly on the venous or arterial sides of the cerebral blood flow. And what they show is that there are major changes in the brain oxygenation in COVID-19 patients in intensive care. And possibly this is one of the mechanisms leading to cognitive problems after recovery. So at least 2 weeks, I guess, it's the most agreed time frame for elective surgery.
And the other question is from Dr. Lakshmi Venkat to Dr. Lobo once again. What's the role of cognitive rehabilitation?
Yeah, so I think I show one slide in my lecture showing the value of rehabilitation for major non-cardiac surgery in aging patients. So this is it's a paper published in JAMA Surgery, I think last year, and they were training patients at least 7 days or 8 days before major non-cardiac surgery. With so they have a program, an electronic program based on tablets, and targeting memory speed, attention. So the usual cognitive parameters to be evaluated. So the patients were training, preconditioning the brain. And what they found was that those patients who were compliant regarding rehabilitation in this cognitive training before surgery, they had a low incidence of delirium during the first 3 days after surgery. So this is the recent study. There are more papers showing exactly the same findings. So in a practical point of view, if you allow me to suggest, if one hospital with an age population, surgical population having major non-cardiac elective surgery, I think it should be reasonable to start programs to have this kind of rehabilitation approach before surgery.
It will be very interesting if we can have an objective risk assessment index so that we can identify these patients preoperatively itself.
Yeah, there is, I think I mentioned that. It's very well described in Brain Health Initiative from ASA, that we can, in anesthesia clinics, we can use some very short and easy to do tests, mini-cog, for example, the frail risk evaluation, for example. It's easy. For example, here at the Cleveland Clinic, we are having this program now at the pre-anesthesia testing clinic, where we evaluate the frailty of the patient. So we detect patients with higher risk to have cognitive disorders after surgery.
Any more questions, comments from the audience?
Dr. Lakshmi, for cortical mapping, what is your protocol regarding the anti-epileptic drugs? Like, how is there any standard formula?
So our institutional practice is that if they are already on anti-epileptic medication preoperatively, they will take their regular dose on the morning of the surgery. And apart from that, we don't routinely give prophylactic anti-epileptic in these patients.
Okay, only the routine dose to be.
Yeah.
Okay.
And especially for awake craniotomy, sometimes we may give it for under general anesthesia, front temporal tumors. For awake craniotomies, we don't give prophylactic anti-epileptic medications.
That's what we are following. Usually we have a consultation with our neurologist and then we decide. So once the mapping is done, then we might be giving the intravenous doses. Thank you.
Thank you, everyone. I'm highly thankful to all the chairpersons for giving your valuable time in this session. Thank you, ma'am. Thank you, sir. If you allow, we can move on to next session. If we can end this session. Can we end this session?
Yes, yes. Thank you very much.
Thank you. Thank you, sir. Thank you, ma'am. Thank you, all the speakers.
Thank you. Nice to see you again, Andy.
Thank you.
Bye.
Thank you.
Seeing you guys.
So moving on to our next session, session 6 of today. So I would like to welcome our chairpersons for this session, Dr. Saurabh Anand sir, Dr. Jayati Ghosh ma'am, and Dr. Sakat Niyogi sir. First of all, I would like to introduce Dr. Saurabh Anand sir. He is the Chief of the Department of Neuroanesthesia and Neurocritical Care at AIIMS Hospital, Gurugram. He is a recognized faculty in ISNACC, and presently he is the Program Director and PDF Course Director in the AIIMS Hospital. Sir is known for managing and organizing various conferences in our country, and he has many publications, and he has conducted various live workshops, national and international, like USG workshop and TCD workshops in Korea. I welcome you, sir, for this conference. And I also welcome Dr. Jayati ma'am. Ma'am is a senior consultant neuroanesthesia in Kolkata. She is a faculty in national and various international conferences, and ma'am has many publications in various journals. And next, I will like to welcome Dr. Sakat sir. And sir is a professor HOD neuroanesthesiology and critical care at Raiganj. Sir is known for various publications and papers. He is an invited speaker in various conferences and guide and co-guide in various postgraduate and postdoctoral candidates. Thank you all the chairpersons for being live, please. I would like to request our chairpersons to further proceed for the session and please introduce our speakers for the further topic.
So the first session is the first talk of the session will be taken by Dr. Professor Nidhi Panda, ma'am, and the topic is assessment and management of fluid balance following subarachnoid hemorrhage in neurocritical care. It's basically how to manage a fluid balance in a subarachnoid hemorrhage. Ma'am is a known faculty and a known name across India and internationally. She has got 6 chapters in the book, Best Paper Awards in various conferences. She has guided 60 theses, 128 international and national publications. Presently, she's the president of our society as well. I welcome Dr. Nidhi ma'am. I'm looking forward to the presentation.
ISNACC 2022 to give me an opportunity to speak on a very interesting and informative topic in front of you. Today, I will be speaking on assessment and management of fluid balance following aneurysmal SAH in neurocritical care. Fluid therapy is considered as a medication. It has an indication, it has dosage, and it has its side effect. Unfortunately, there is a very narrow therapeutic index of fluid therapy, and for that reason, overdosing and underdosing are common and are associated with various complications. It is especially true in cases of aneurysmal SAH patient admitted in neurocritical care. As we all know, aneurysmal SAH is a devastating neurological condition with very high incidence of mortality and morbidity. 10 to 15% die before reaching hospital, while 25% die within 24 hours with or without medical attention, and almost 40% die in the first 6 months after hemorrhage. And of the survivor, 1/3 of the survivor has major neurological deficits. The major causes of mortality and morbidity in aneurysmal SAH include location and volume of initial bleed, rebleed, and the most dreaded complication of delayed cerebral ischemia, which give rise to cerebral infarction and poor neurological outcome. Patients with aneurysmal SAH are taken care best in the neurocritical care units of high volume centers. There are multimodal approach to the management of aneurysmal SAH, out of which fluid therapy is one of the important therapy in cases of aneurysmal SAH, which is included in modified triple H therapy. Triple H therapy includes hypervolemia, hypertension, and hemodilution. In mid-1970, it was started and then well established that triple H therapy was given to all the patients of aneurysmal SAH in neurocritical care and with good neurological outcome. But later on, the studies have found that hypervolemia and hemodilution, they produce different type of complications and they are responsible for poor neurological outcome. Then there comes the modified triple H therapy. In modified triple H therapy, there are only 2 components. One is euvolemia and mild hypertension. Today, I will be discussing more about euvolemia and fluid balance in aneurysmal SAH patients. The causes of fluid imbalance in aneurysmal SAH includes various causes, and the patient, around 70 to 80% of the patients are reaching emergency area are having hypovolemia. Hypovolemia is because of decreased fluid intake, because of altered sensorium, because cerebral salt wasting syndrome is very common in patients with aneurysmal SAH. They receive osmotherapy frequently, and because of the pre-procedure fasting. Because of all these causes, patients are hypovolemic. There are few patients who are hypervolemic also because of overzealous fluid resuscitation before reaching neurocritical care and multiple fluid challenges within a short period of time. Coming to effects of fluid imbalance in aneurysmal SAH, patient with who all are hypovolemic, they are dehydrated, that causes decreased cardiac output, decrease in blood pressure, decrease in tissue perfusion, increase tissue acidosis, and hypotension also causes decreased cerebral perfusion, giving rise to delayed cerebral ischemia. Hypervolemia, on the other hand, causes increase in extravascular lung water, leading to pulmonary edema, ARDS, tissue edema, which causes prolonged recovery. Hypervolemia also causes worsening of existing cardiac dysfunction, also responsible for cerebral edema, which ultimately can give rise to delayed cerebral ischemia. Therefore, fluid balance in aneurysmal SAH is very complicated. Usually, literature says that patient of aneurysmal SAH should be euvolemic, normovolemic, adequate volume should be transfused, optimum volume should be transfused. But these all words do not give any quantitative meaningful information. It is very easy to say euvolemia, but how to ensure that patient is euvolemic? To know the fluid status, it is very important to understand fluid responsiveness. To understand fluid responsiveness, fluid challenge should be given. Around 5 to 10 ml per kg of crystalloid is given over 10 to 15 minutes, then stroke volume is assessed. If after giving fluid challenge, there is increase of stroke volume by 10 to 15%, that is called positive response, these patients are usually hypovolemic. That means in hypovolemic patient, if there is fluid challenge is given, their stroke volume increases, and these patients are called fluid responders. If after giving fluid challenge, there is no increase in stroke volume, those are the patients who are euvolemic or hypervolemic. They are also considered as non-responders. All the time we cannot measure stroke volume directly, but we know that stroke volume is directly proportional to cardiac output and blood pressure. So by giving fluid challenge, if there is increase in stroke volume, there will be increase in cardiac output, there will be increase in blood pressure and hemodynamic stability, and thus decrease in heart rate. So in fluid responders are hypovolemic patients, and fluid non-responders are either euvolemic or hypervolemic patients. We can understand fluid responsiveness by other method like Frank-Starling curve. This is a curvilinear curve in relation between preload and stroke volume. If the patient is in the ascending portion of the Frank-Starling curve, then with increase in preload, there is significant increase in stroke volume. So these patients are usually hypovolemic patients. But when with preload, there is no significant increase in stroke volume, those patients are considered as non-responders. They are either euvolemic or hypervolemic. Effect of mechanical ventilation on Frank-Starling curve. If patient is hypovolemic, when the patient is put on mechanical ventilation, there is decrease in stroke volume. There is a decrease in venous return and decrease in stroke volume. There will be a significant decrease in stroke volume. So these patients are usually euvolemic. They are fluid responders. And the patient who are in the plateau phase of the curve, if preload is increased, there is no significant increase in stroke volume. These are either euvolemic patient or hypervolemic patient. So what is the target zone in Frank-Starling curve? The target zone is, if the patient is on the ascending portion, patient is hypovolemic. If patient is in the distal portion of the plateau phase, then patient is hypervolemic. So the target zone is at the beginning of the plateau phase. Our aim should be that patient should be in the beginning phase, beginning point of the plateau phase. There are crude ways of fluid management in neurocritical care. For example, physical features of dehydration in the form of tongue dryness and skin turgor, etc., which are not reliable in patient admitted in neurocritical care. There are few intensive care units where fixed volume of fluid is administered, thinking that one size fits all. But it is not true. One size does not fit all. With fixed volume of fluid administration, few patients remain hypovolemic, few patients become hypervolemic. Next is measurement of urine output. Usually we consider measurement of urine output as a good indicator of fluid status, but in patient with aneurysmal SAS, many of the patients have cerebral salt wasting syndrome or syndrome of inappropriate secretion of antidiuretic hormone. So in this patient, measurement of urine output and calculation of positive balance is not a reliable parameter for assessment of volume status. Therefore, to assess fluid status in patient with aneurysmal SAS, special methods of assessment should be done. This can be divided into different groups. Static measures like central venous pressure, pulmonary artery catheter derived parameter, dynamic measures like pulse pressure variation, stroke volume variation, systolic pressure variation, pleth variability index. Other reliable methods include ultrasonographically measured VC collapsibility or distensibility index, echo, measurement of LVOT VTI, and advanced method where continuous cardiac monitoring can be done with minimal invasive methods, which include Vigilio flow track, PICO, or LITCO monitoring. Coming to central venous pressure, it is a static measure of fluid assessment. It is an invasive, need CVC placement. It is not reliable in patient on mechanical ventilation. It is also not sensitive in patient with cardiac abnormality. We all know that there is increased incidence of cardiac involvement in aneurysmal SAS, though it is reversible. 25 to 90% have ECG changes and 15 to 35 has echo changes. So it is central venous pressure measurement is not reliable in patient with aneurysmal SAS. Next comes pulmonary artery catheter. It is highly invasive, requires PA cannulation. High chances of complications are there while putting pulmonary artery catheter, and complicated measurements are required. So that need expertise. So though it is a gold standard for fluid assessment, it is not recommended in patient with aneurysmal SAS admitted to neurocritical care. Then comes pulse pressure variation. It is a dynamic measure of fluid status assessment. Pulse pressure is the difference between systolic and diastolic blood pressure, and pulse pressure variation is the changes in pulse pressure during one mechanical breath. This measurement needs an invasive arterial BP monitoring, and the PPV value of more than 12% accurately predicts fluid responsiveness. But it is not valid in presence of arrhythmia and low tidal volume. If patient is on ventilator with a low tidal volume less than 8 ml per kg, then this method is not a reliable method of measurement of fluid status. Next comes stroke volume variation, which reflects changes in the left ventricular stroke volume during one mechanical breath. It is an automatic measurement by software using pulse contour analysis. In accuracy, pulse pressure variation is a better indicator than stroke volume variation. Next is systolic pressure variation. This is the difference between the maximal and minimal values of systemic arterial pressure during one mechanical breath. If systolic pressure variation is more than 10, that shows patient is fluid responsive. In accuracy, systolic pressure variation is similar to stroke volume variation, but it is inferior to pulse pressure variation. Out of all this, pulse pressure variation is more reliable. Detection of increase but the most important thing is that detection of increased systolic pressure variation during respiration is the first sign of hypovolemia and easiest way to know that patient is hypovolemic or not. Next comes pleth variability index. It is the only non-invasive method to assess fluid responsiveness. It measures variability in the pulse oximeter plethysmographic waveform during one mechanical breath. It is a good predictor of fluid response. It is affected by changing vasomotor tone due to hypothermia and vasoactive agents. Next comes IVC measured IVC diameter measured by ultrasonography. It is a non-invasive, repeatable, radiation-free bedside test, and it can be done by non-radiologist clinicians. We all know that IVC is highly sensitive to fluid changes. Therefore, IVC collapsibility index can be measured in spontaneously breathing patient, and IVC distensibility index is measured in mechanically ventilated patient by various formulas. And the accuracy of this measurement has 90% sensitivity and 90% specificity. Next comes transthoracic echocardiography. It is highly predictive of fluid responsiveness. It is safe, minimally invasive, bedside, repeatable methods of assessment of fluid status. For this, 5-chamber apical view or deep transgastric long axis view is required to be made. It is highly accurate as pulmonary artery catheter derived thermodilutional technique cardiac output. With transthoracic echo, left ventricular outflow tract velocity time integral is measured. Normally it is 18 to 22 centimeter, but when it is less than 15 centimeter with variation of more than 12%, then that shows patient is fluid responsive, patient is hypovolumic. It is reliable both in spontaneous and mechanically ventilated patient, and it can also be used in patient with arrhythmias, which other dynamic measures cannot be used. Now, the advanced methods where there is continuous cardiac output monitoring is done. These are minimally invasive methods. Flow track Vigilio is one of that. It uses arterial pressure waveform to calculate stroke volume and cardiac output. It measures stroke volume variation, invasive blood pressure, cardiac output, and cardiac index. It is a continuous monitoring. It is minimally invasive, and it guides fluid therapy and vasoactive drug therapy. Next is PICO monitor. With PICO is pulse index continuous cardiac output monitoring. It measures cardiac output and other parameters using transpulmonary thermodilution and pulse contour analysis. It requires the insertion of a central venous cannula and an arterial line with thermodilution sensor. It measures cardiac output, preload, contractility, afterload, and extravascular lung water. It also guides fluid therapy and vasoactive drug therapy. Next monitor of continuous cardiac output monitoring is LIDCO, that is lithium dilution cardiac output. It is an indicator dilution technique where a very small dose of lithium chloride is used. It requires an arterial line and a central or peripheral venous access. Lithium chloride is injected through the venous line and measured by a sensor in the arterial line. And by this method, cardiac output, pulse pressure variation, stroke volume, etc. can be measured. Now coming to hypervolemia. High extravascular lung water and pulmonary edema can be caused by hypervolemia. So it is better to prevent hypervolemia. How we can prevent hypervolemia? If patient can be kept at the beginning of the plateau phase of the Starling curve, then patient can be euvolemic and not hypervolemic. If patient is kept on the distal portion of the Frank-Starling curve, then patient is hypervolemic. And in dynamic measures like PPV, stroke volume variations, systolic pressure variation, etc., they should not be kept very low. For example, in pulse pressure variation, if patient is more than, pulse pressure variation is more than 12%, that means patient is hypovolemic. So we should keep pulse pressure variation around 7 to 10. We should not try to keep the pulse pressure variation to 2 and 3. So if we will keep these parameters very low, that shows that patient is hypervolemic. Flow track, PICO, LIDCO monitoring are also useful in measuring extravascular lung water, and they can directly assess that patient is hypervolemic. Now coming at the end, we can discuss about predictive ability of test for fluid responsiveness. all static measures like central venous pressure, pulmonary artery occlusion pressure, left ventricular end diastolic area, systolic arterial pressure, these all are poor predictors, while pulse pressure variation, stroke volume variation, pleth variability index, IVC diameter by ultrasonography, and transthoracic echocardiography, these are all good predictors of fluid responsiveness. So at the end, take-home message is that fluid balance is one of the major goals of management in aneurysmal SH patient admitted in neurocritical care. Dynamic monitoring for volume responsiveness predicts volume status accurately. Intensivists should be well versed with fluid assessment techniques, and cost of additional monitoring is high, but it is counterbalanced by a sustained reduction in neurocritical care stay, hospital stay, and morbidity of the patient. Thank you. I bring greetings from my institute, PGI Chandigarh and City Beautiful Chandigarh. Thank you.
I think we can move on to the next talk and have a discussion in the end. Thank you, ma'am, for the beautiful lecture. I think every part has been explained very well. We can move on to the next talk.
I request Dr. Jayati Ghosh ma'am to introduce our next speaker, please.
Okay. Yeah, it's my pleasure to introduce Dr. Kaustubh Datta. He's assistant professor, Nilgrims, Ceylon. He was former consultant in Apollo Hospital, Bangalore. He's a very dynamic fellow, and he stood first in his MD examination, and he was always a rank holder in his first, second, and final MBBS. He got the second prize in academic quiz in ISNACC Mumbai, and also the second prize for the paper presentation. He is also faculty in RISE project run by Johns Hopkins, USA. And his area of interest is neurocritical care, infection control, neuromonitoring, and pain management. Now I will request Dr. Kaustubh Datta to start his lecture. And I will
New greetings to one and all. At the outset, I'd like to
I will request all others to put their question, if any, in the chat box, so we can discuss this after the session. Thank you.
Good evening, everyone. New Year greetings to one and all. At the outset, I'd like to thank the organizers of ISNACC 2022 for giving me the opportunity to speak on a topic that is very close to my heart. The topic of today's discussion is antibiotic stewardship in neuro-IC. Today, I'll be speaking on what is antibiotic stewardship, why do we need it, the various aims of antibiotic stewardship, and how to implement antibiotic stewardship in neuro-IC, and problems specific to neuro-IC, and role of biomarkers, specifically procalcitonin, and key messages at the end. So let's begin. So what is the literal meaning of the word stewardship? Stewardship is defined as the careful and responsible management of something entrusted to one's care. In 1996, John McGowan and Dale Gerding first used the term antimicrobial stewardship. Today, stewardship is applied in the context of governance of the health sector, taking responsibility for the health and well-being of the population. The three main pillars of an integrated approach to health system strengthening are antibiotic stewardship, infection prevention and control, and medicine and patient safety. So as we see, antibiotic stewardship is one of the most important pillars to strengthen our health system. So what is antibiotic stewardship? Antibiotic stewardship or antimicrobial stewardship is a coordinated program that promotes appropriate use of antibiotics that can improve patient outcomes, reduce the microbial resistance, and decrease infections caused by multi-drug resistant organisms. So the three basic important components of antibiotic stewardship are the optimal drug selection, the right dosing, and the correct duration. Because for best clinical outcomes with minimal side effects to the patients and minimal impact on subsequent resistance, if these three are followed well, then our purpose is solved. Now, a lot of us may be asking, why do we need antibiotic stewardship? Let us look at the history. There is a very disturbing trend. Since the discovery of penicillin in 1928, there has been discovery of many new antibiotics, as you see. But over the years, with the discovery of new antibiotics, there's also emergence of new resistant strains. Strains like PCN-resistant Staph aureus, MRSA, MDR pseudomonas, Acinetobacter, Metallobetalactomasis, carbapenems, and the list is endless. But if you look at the right-hand corner at the top, you see the pipeline is straining. There are very new agents that are being discovered and very new antibiotics that are in the pipeline. So this is indeed a very disturbing trend. So if you see worldwide, there has been invasive isolates which are non-susceptible to a lot of the common antibiotics that have been used over the decades, which is very disturbing. If you look at the rate of antibiotic utilization, India is very high on antibiotic usage. If you see, there has been a jump of over 62% over a decade from 2001 to 2010 in India. The consumption is 12.9 billion, which is much higher to our very other populous countries like China or US. This is in fact a very disturbing trend. Optimal antibiotic use is crucial in the critical care setting. Studies have shown that 30% to up to 60% of the antibiotics sometimes prescribed in the ICUs are unnecessary, inappropriate, or suboptimal. So as I said, why are we worried? Because there are very few antibiotics which are in the pipeline. According to the World Health Organization, the antibiotic pipeline data report 2021, only 11 new antibiotics have been approved since 2017. Only 2 of them represent a new class and have a new target of action. Basically, all others are modifications of the existing antibiotics. And the new antibiotics include Barbobactam, Meropenem, and Lefamulin. So, antibiotic stewardship is of utmost importance to optimize the use of existing antimicrobials. There has been a slow development of antimicrobials. There is an accelerated emergence of superbugs and spread of resistant organisms. The only way to limit this is applying antibiotic stewardship. So what are the aims or goals of antibiotic stewardship? As I said in the very beginning, the optimal antimicrobial therapy depends on the right diagnosis, the right drug, right doses, and the right duration of therapy. And the fifth, and probably the most important and often forgotten component is the de-escalation. That is rapidly decreasing the dose and switching to monotherapy from polytherapy and decreasing the duration of the therapy. So the second aim of the antibiotic stewardship is prevent antimicrobial overuse, misuse, and abuse. So, for example, here we have a febrile patient with pancreatitis, another patient who has a small skin abscess that can probably be resolved with incision and drainage, and there is a patient who has been in the ICU for months, probably a patient of stroke, who has a positive urine culture. So which antibiotic do we prefer in these cases? Well, the answer is no antibiotics, because all conditions do not require antibiotics. Now, the third most important aim of antimicrobial stewardship is minimize the development of resistance, because antibiotic use, indiscriminate use, has resulted in change in the susceptibility patterns, and it has been seen that the patients exposed to antibiotics are at higher risk of becoming infected by resistant organisms. So it is a vicious cycle where you introduce an antibiotic and there is a resistant infection, and then you have antibiotics. So this goes on and on. So then these resistant organisms become transmitted in the hospital or in the community, and ultimately leads to significant economic burden. Now let's looking at the team, the stewardship team. So this is probably a difficult component of implementing the antibiotic stewardship team, because all hospitals or institutes may not have the requisite team. So it has been said that create a team which is within the budget and the personnel and the official constraints. So ideally, the team should include the neurointensivist in the neuro ICU, infectious disease physician, if available, pharmacist, microbiologist. In our hospital, we used to have the microbiology consultant take rounds with us. And it immensely helped us in learning a lot of things that we were unaware of as clinicians. And of course, you need to have the help of the administration and the epidemiologist if available. Now let us see this problem specific to neuro ICU and how can we implement antibiotic stewardship in a neuro ICU. So special challenges. So we have seen that hospital-acquired infections are common in intensive care units, including those dedicated to the care of neurological patients, because patients in neuro ICU have distinct characteristics that predispose them to infections when compared to a general ICU patient. There are high utilization of external ventricular drains. There are high rates of dysphagia, which can lead to aspiration and then subsequent infection. There is urinary retention. There are high risk of catheter-associated urinary tract infection due to the need for catheter placement and presence of stroke predisposing them to deep venous thrombosis and other infections, and finally brain injury-induced immunosuppression. So all of these makes the neuro ICU population a unique population. So what do we do? So first aim is rapid identification of neuro patients with systemic bacterial infections, because it has been seen that the time to appropriate antibiotic administration is a major outcome determinant for neuro ICU patients with severe bacterial infections. And signs and symptoms of infections due to non-infectious causes has to be ruled out. Obtain specimens for appropriate cultures before antibiotic administration, confirm the diagnosis, identify the pathogens, and once that is done, start de-escalation. So are there role of biological markers specific in neuro ICU? We have seen even during the COVID pandemic, there have been a resurgence of the utilization of all of these markers, including C-reactive protein, interleukin-6, and procalcitonin. Let us discuss procalcitonin in a little bit detail. So here is a delicate balance that needs to be maintained in any ICU. First is importance of starting an appropriate empiric therapy when the organism is not known. At the same time, keep in mind the effect of the broad spectrum therapy on resistance. Start the immediate treatment of patients with true bacterial infections and avoid overusing antibiotics and selection of resistant strains, because mortality increases when initial therapy is inappropriate. At the same time, the resistance increases when broad spectrum agents are needed. So to balance this treatment strategy, what is the most important component? It has been seen that perhaps procalcitonin here is an important player. So as we said in the very beginning, what is antibiotic stewardship and where does procalcitonin sit in here? So as you see, so limiting inappropriate uses of antibiotics, selecting the right duration of therapy, probably procalcitonin has come very handy. So we have seen the role of procalcitonin specifically in conditions like sepsis. In here, if you compare procalcitonin with lactate, C-reactive protein, and interleukin-C, here you can see procalcitonin is the first to rise, and it has a very high specificity. Specificity is 95%. The positive predictive value is 94% compared to the other commonly used biomarkers. So herein, so the role of procalcitonin stands out compared to the other biomarkers. Now, fever in neuro ICU, is it always an infection? So fever is a common occurrence in the neurocritical care unit. The incidence can range anywhere between 23 to 30%, perhaps even more. And more than 50% fevers are associated often with a non-infection cause. So what are the most common culprits of these non-infectious source of fever? So most of this is central cause of fever that includes aneurysmal subarachnoid hemorrhage, traumatic brain injury, and intracerebral hemorrhage, especially brainstem and pontine hemorrhages. So here, as I said, procalcitonin is an important biomarker for detecting infection. But is there a role of procalcitonin in neuro ICU? So it has been said that exercise caution while predicting or guiding your antibiotic therapy based on procalcitonin alone, because a lot of studies they have seen the clinical utility of serum procalcitonin in the neurosurgical intensive care unit. They've seen that the utility of procalcitonin is limited only for sepsis and bacterial pneumonia, whereas the selective use of procalcitonin in neuro ICU patients is recommended. Again, the same thing, procalcitonin is a poor predictor of non-infectious fever in the neurocritical care setting. So coming to the selection of initial antibiotic therapy. So initial antibiotic therapy could be guided by the local antibiogram, the prevalence of multi-resistant organisms, including gram-negative organisms and gram-positive organisms. And it has been said that empirical broad-spectrum antibiotics are justified for ICU patients with clinically suspected hospital-acquired infections. However, the regimen should be based on local antimicrobial susceptibility patterns. Second important component is pharmacokinetic and pharmacodynamic optimized antimicrobial therapy. So a lot of these antibiotics that we commonly use could be divided into concentrated dependent antibiotics like aminoglycosides, which we commonly use, amikacin, then fluoroquinones. And then we have the time-dependent antibiotics, which are beta-lactams and carbapenems. So the most important pharmacokinetic and pharmacodynamic parameter for aminoglycosides and fluoroquinone is perhaps the peak concentration and the minimum inhibitory concentration. If the local lab is able to provide us with the MIC values, then we can calculate and target an MIC of more than 8 to 10 to achieve optimal antibiotic concentration in the serum. Always remember, if the MIC is not available or you're not able to calculate the AUC, then always develop a priori dosing algorithm based on the MIC, creatinine clearance, and weight of the patient. Now, coming to the next important component, that is the de-escalation of therapy. So, as I said, serial clinical examinations, microbiological evaluations, and then reassess therapy after every 48 to 72 hours. And each ICU, specifically each neuro ICU, should design its own diagnostic strategy. First, identify the patients who have low probability of infections, in patients whose therapy can be discontinued, and the non-infectious fever, as we've already discussed. And always switch to monotherapy if after 3 to 5 days, provided that the clinical course has evolved favorably and the microbiological data did not indicate difficult to treat microorganisms. So de-escalation of antibiotics should be started once we have the culture reports of the blood or the respiratory tract or any other culture report that is available. If there are no resistant organisms like Pseudomonas, Acinetobacter or MRSA, then switch to narrow spectrum antibiotic. If MRSA is not found, then vancomycin and linezolid should be stopped unless there is an infection with gram-positive bacteria which is susceptible only to them. And very broad spectrum agents like carbapenems, piperacillin tazobactam, and cefepime should be restricted to patients whose infectious pathogens are susceptible only to them and should not be continued empirically. Next important component of antibiotic stewardship is shortening the treatment duration. So shortening the duration of antibiotic is very important to reduce the emergence of resistant organisms. How do we do it? We use either clinical features or markers of rectal infections like procalcitonin. As I already said, procalcitonin is a useful marker in neuro-IC provided it is for systemic infections like sepsis or respiratory tract infections, ventilator-associated pneumonia, or ECOTI or other bloodstream infections. So it has been said that if there is a decrease of procalcitonin value by 80%, then the antibiotics can be stopped. So when we look at antibiotic stewardship or when we practice antibiotic stewardship every day, at the end of the day, we should question ourselves whether the dosing is optimal, whether the combination is useful, whether the toxicity has been assessed, or whether we need to add a new antibiotic, or is de-escalation feasible and safe, and let us start de-escalating. Now, problems specific with neuro-ICUs are the use of invasive devices. One most common invasive device that we use is external ventricular drains or EVDs. It has been said that if the EVD placement and maintenance is based on a protocol designed by the neurosurgeon and followed by neurointensivist, then the rates of infection can come down. So it includes the presence of a checklist, strictly maintaining the sterility during the procedure, hair removal, tunneling, use of occlusive dressings, post-procedure prophylactic antibiotics, and reduction in the frequency of CSF. Unless required, do not frequently sample the CSF from the EVD. And finally, aseptic technique for sampling on manipulation of grade. So I've highlighted this point, that is post-procedure prophylactic antibiotics. So how long is the recommended duration of antibiotics after inserting an EVD? So some studies have said that just a single dose prophylaxis regimen is sufficient, or if you need to continue, you can continue antibiotics for a maximum of 24 to 48 hours after the EVD placement. Because if you continue antibiotic placement, continue antibiotics beyond 48 hours, there is an increased chance of infections, especially with resistant organisms or Clostridium difficile infections. So implementation of a comprehensive EVD bundle that emphasizes aseptic technique throughout the entire lifetime of the EVD has the ability to significantly decrease rates of ventriculostomy related procedures. Silver or antibiotic impregnated catheters are included in many EVD bundles in neuro ICUs where the VRI rate approaches 0. And use of silver or antibiotic impregnated catheters may reduce the need for prolonged systemic antibiotics, and this decreases the unnecessary prescription of antibiotics in neuro ICUs. Now, coming to infection prevention for patients with intracranial pressure monitors. The effect of prolonged prophylactic antibiotics in patients with parenchymal ICP monitors. There has been a study, several studies, one of which included 279 patients with TBI, and they changed the protocol from the use of a broad-spectrum antibiotic, that is ceftriaxone, to a narrow-spectrum antibiotic, cefazoline. And they saw that there was a higher proportion of systemic infections arising from resistant gram-negative species in the broad-spectrum group. So this clearly signifies that we need not use broad-spectrum antibiotics even with a patient with an invasive device like an ICP monitor. Then infection prevention for patients with subdural or subgaleal drains. So here also several studies have been done, and they have eliminated the use of prolonged prophylactic antibiotics like cefazoline or vancomycin in post-operative neurosurgical patients with subdural or subgaleal drains. And they have seen there's no resistant organisms grown in the no antibiotic group, and that has cost a lot of money to the patient and to the hospital. Now, prophylactic antibiotics. Is there a role of prophylactic antibiotics to prevent hospital-acquired infection in neuro ICU? So studies that examine whether prophylactic antibiotics are effective in lowering rates of ventilator-associated pneumonia in patients presenting with coma, and they found that patients in coma due to TBI, stroke, or post-neurosurgery patients with a low GCS and mechanical ventilation of more than 72 hours, that despite the reduction in incidence of pneumonia, there was no difference in the functional outcome or mortality between groups. Instead, there is emergence of resistant organisms. As I said, Clostridium difficile infection is again a concern for indiscriminate or prolonged use of antibiotics, and it has been seen for neuro ICUs the prevalence is 0.4 to 0.5% with an infection rate of 8.3 per 10,000 patients. And most common antibiotic that has been associated with C. diff is cephalosporin, 71% cases. So risk factors for acquiring C. diff infection include prolonged hospital stay and antibiotic use, especially for concurrent infection for prolonged period and immunosuppression. So, like access to clean water and air, we have taken antibiotics for granted for too long. Since the discovery of penicillin in 1928, antibiotics have significantly improved global health. But decades of overuse and misuse of antibiotics have accelerated the emergence of resistant bacteria, and not enough new antibiotics are being developed to fight against bacteria. So they should be prescribed only when indicated because they may cause serious side effects, and existing antibiotics must be used more responsibly to extend their lifespan. So we see that implementing an antibiotic stewardship program is met with many challenges, some of which include absence of a champion, absence of a leader who would do it. Then there is lack of time, then lack of interest, or lack of interdepartment coordination, or sometimes minimum supporting facilities like labs or epidemiologists or available pharmacists, okay? And of course, utility of the antibiogram, which is often not realized by many clinicians. So for a successful implementation of an antibiotic stewardship program, there should be a structured program. There requires an interdisciplinary team, educational interventions, training, innovations, and of course, feedback to healthcare workers. Because if it has been a successful program, if you give a positive feedback, it's of course always a welcome step. So at the end, I would like to give the key messages. Hospital-acquired infections are a distinct challenge in the neuro-ICU population. Specific characteristics of the neuro-ICU population render them more susceptible, as we've already discussed. The rapid in ICU emergence and dissemination of multi-drug resistant microorganisms is directly linked to inappropriate antimicrobial use. So how do we solve it? Of course, antibiotic stewardship is probably the only way we can do it. So rapidly identify patients with infection, start an empirical regimen, optimize the antibiotic dose, and stop therapy in the neuro patients for non-infectious fever, narrow down the treatment once the responsible pathogen is known, switch to monotherapy after day 3 if possible, and shorten the antibiotic administration as appropriate. Thank you. Antibiotics are to infections as fire extinguishers to fires, quote unquote. Antibiotics are among the most potent of all anxiolytics, of course, for prescribers, quote unquote. Thank you once again for giving me this opportunity. Thank you.
It's really very informative and much needed lecture about the proper and timely use of antibiotics. We'll take up any question, if any, at the end of the session. Thank you.
I request Sakat sir to introduce our next speaker, please.
Hello.
Hello.
Good evening, everybody. Our next speaker, Dr. Ian Shamang. She is Associate Professor in the Department of Anesthesia and Critical Care, AIIMS, Fatinda. And she has 8 years experience in neuroanesthesia with excellent academic character, has numerous papers in national and international journal, and she is also author of various chapters in reputed neuroanesthesia book. Welcome, Dr. Ian Shamang, for your talk.
Today I'll be discussing about the management of traumatic brain injury in resource-limited settings. Traumatic brain injury is a global public health problem. The greatest volume of TBI annually was observed in the Southeast Asian region with 18.3 million cases per year. It is a leading cause of death in persons between 15 and 29 years of age. Low middle income countries, of which our country is a part of, they account for 82% of the world's population. 54% of the world's registered vehicles are in low middle income countries. 69 million people sustain a TBI each year, of which HICs, that is high income countries, have nearly 18 million, while LMICs have around 50 million cases, which is nearly 3-fold increase in both cases and mortality. This high mortality and disability associated with TBI is associated with lack of implementation of preventive strategies like road safety rules, poor health infrastructure, low capacity for acute care and rehabilitation, lack of paying capacity on the part of patients. Various guidelines have been coming from time to time, as in the Brain Trauma Foundation guidelines, which came in 2020. But these guidelines mostly are developed according to the Western world or the high income countries. Their implementation in the low middle income and low income countries is difficult because of the requirement of advanced monitoring according to these guidelines. So various new guidelines or recommendations have been developed in 2020, including the protocol and the Travis protocol, which we'll be discussing. So first, the treatment phases of TBI and level of resources. So it can be divided into pre-hospital phase, emergency phase, neurological surgery, and intensive care. As for the level of resources, pre-hospital can be divided in the availability of basic trauma, basic transport services and advanced trauma services. Emergency care can be divided into low, medium, or high level units. Neurological surgery units can be divided as the one with only neurological services and the one with neurological as well as the ICU facilities. ICUs can be divided into advanced ICUs and basic ICUs. So here we can see the three-dimensional stratified scheme according to the level of resources and complexity. In low resources, they have basic emergency transport, they have low complexity emergency department, and most of the patients are referred to intermediate or high resources. From there, high resources on the other hand have advanced emergency transport, medium high complexity emergency department, CT scan, intensive care, and neurological surgery services. Now, first we'll discuss the management of an adult patient with mild, moderate, or severe TBI in a basic transport. So basic transport is like BL availability of ambulance, BLS ambulance in our country. So determine the requirement of pre-hospital transport using follow parameters. First, we'll see the mechanism and type of injury. We can assess the clinical status in GCS, age of the patient, and presence of comorbidities. So based on these, the patient can be divided into mild, moderate, and severe, and management of adult patients who present with mild TBI can be performed in a basic emergency transport or a BLS ambulance. If the planned transfer is more than 30 minutes, AET or the advanced emergency transport should be requested. No patient with moderate or severe TBI should be transported in a BET, but if the situation occurs, algorithm should be followed. So according to this algorithm, first, we need to assess if the patient has an external source of bleeding, perform AVPU or Glasgow Coma Scale assessment, check for respiratory rate, check for the radial pulse, perform glucose measurement and give glucose if possible. If the radial pulse is feeble, then give IV fluids if they're available. If the seizure medication is available, administer it. If there is a check for a nearest facility with CT ICU capacity. If it is there, then transfer as soon as possible. Reevaluate all these things every 5 minutes and document it. Now, management of an adult patient with moderate or severe TBI in an advanced emergency transport. It is recommended not to remain at a scene for more than 30 minutes, regardless of the patient's clinical status. The GCS to classify the severity of the injury in the patient should be performed after the initial resuscitation. Now, medication sequence for endotracheal intubation. It has been recommended to use any of the three options. Option 1 is use of ketamine as induction agent in a dose of 1.5 to 2 mg per kg body weight. Scoline can be used as 1 to 2 mg per kg body weight, and fentanyl can be used as an analgesic in a dose of 2 to 4 microgram per kg. Second option is the use of midazolam, rocuronium, and ketamine. And third option is the use of etomidate and vecuronium. A hemodynamically neutral induction agent like ketamine or etomidate is preferred in order to prevent transient drops in cerebral perfusion pressure. No difference in mortality or other patient-centered outcomes have been found when comparing etomidate and ketamine for traumatic brain injury patients in a study done by Upchurch et al. And published in 2017. Management of an adult patient with mild TBI in a low complexity emergency department without CT. So in that case, treat for any life-threatening event according to the ATLS primary evaluation, including those with penetrating injuries of the head. Patients with penetrating injury to the head or any other abnormal finding in the primary clinical evaluation should be referred to a higher center with neuroimaging and neurosurgical services. So what is the criteria for transfer of patients with TBI to a high-level facility? So it is recommended that patients with moderate to severe TBI, that is a GCS of 3 to 12, should be transferred immediately to high level of care hospitals. It is also recommended that patients with mild TBI and who are in active treatment with anticoagulants, have active coagulopathies, or are pregnant should be transferred to higher centers. It is recommended that patients with TBI, that is GCS 13 to 15, who present with these criteria should be referred to higher center for evaluation. GCS under 15 for up to 2 hours after injury, severe headache, previous craniotomy, skull fracture including depressed fractures or clinical signs of fracture, age more than 60, presence of blurred vision or diplopia, presence of focal neurological deficits, suspected intoxication, fall of more than 1.5 meters, retrograde amnesia more than 30 minutes or anterograde amnesia, more than 2 episodes of vomiting, the presence of post-traumatic seizure. If a patient does not have abnormal findings in the primary clinical evaluation or does not have a penetrating brain injury or does not meet the referral criteria, the patient should be observed in the emergency department. 4 to 6 hours of observation, the patient does not develop referral criteria, consider discharge of the patient with recommendations and warning signs. Now, management of an adult patient with mild TBI in a medium or high complexity ED. Here, comprehensive assessment of adult patients with mild TBI must be done as per the ATLS recommendations, define neuroimaging requirements, and then perform a CT scan. If the CT scan is normal, then observe for 4 to 6 hours. However, if it is abnormal, we have to go for neurosurgical assessment. Management of an adult patient with moderate to severe TBI in a low complexity ED, that is without presence of a CT scan machine. Adult patients who enter the low complexity ED must undergo comprehensive evaluation, prepare for immediate referral under the best conditions to a nearest center with neurosurgery and neuroimaging services for a more comprehensive management. Management of an adult patient with moderate to severe TBI in a medium or high complexity ED. It is recommended to manage an adult patient with moderate to severe TBI in an emergency department of medium or high complexity when available. So what are the surgical indications for immediate transfer to a higher level facility with neurosurgery capacities? There are clinical criteria and imaging criteria. Among the clinical criteria, if there is pupillary asymmetry of 1 millimeter of difference or a GCS motor response of 4 or less, and in the imaging criteria, midline shift of more than 5 millimeters, total cistern compressions, that is grade 3 diffuse injury, epidural hematoma more than 30 ml in volume, intracerebral hematoma more than 50 ml in volume, subdural hematoma more than 10 millimeter in width, or the presence of posterior fossa hematoma with hydrocephalus. If there is one clinical criteria and one imaging criteria, then there is surgical indication. If there is one isolated clinical criteria, then medical management must be done. Same as with the presence of one isolated imaging criteria. Neurological examination, however, must be performed after adequate resuscitation to determine the clinical criteria. Patient who presents clinical criteria without imaging criteria or imaging criteria without clinical criteria must have a neurological follow-up. Surgery may be indicated the patient with neurological impairment defined as a decrease in GCS of more than 2 points. Patients having bilateral mydriasis, score of 3 on the GCS, that is, if the patient is probably brain dead, so neurosurgery assessment must be done to determine whether to perform a surgical procedure or not in such patients. Now, criteria for admission to the ICU. So patients who have a GCS of less than 12 with or without spinal cord injury, ICU support for any other system, have a planned trauma surgery urgently required within 24 hours, or have comorbidities like anticoagulated patients, liver failure, chronic kidney disease on dialysis, heart failure, epilepsy, or who are being treated with ASA and clopidogrel must be shifted to ICU. So what are the treatment goals in ICU? So first is to halt the progress of primary lesion, and second is the prevention of secondary injuries. Management objectives in an ICU are to maintain saturation of more than 90%, maintain PCO2 in normal parameters, keep lactate levels less than 2 millimoles per liter, maintain systolic blood pressure more than 100 in patients between 50 to 60 years of age, or 110 or more for patients aged 15 to 49 or older than 70, keep heart rate at normal levels, that is between 60 to 90, maintain cerebral perfusion pressure between 60 and 70, evaluate the neurological condition of the patient if there is GCS change of more than 2 points, perform an image evaluation, maintain glucose levels between 110 and 170 to avoid hypoglycemia. So patient monitoring in the ICU must include stethoscope, pulse oximeter, capnography, invasive blood pressure, central venous catheter, jugular bulb catheter, urinary catheter, sedation scale assessment according to RAS scale, neurological status assessment using GCS and the 4 scale, pupillary reactivity and motor deficit. Vital signs must be checked every hour, temperature monitoring, glucose monitoring every 4 hours, monitoring daily sodium, monitoring of potassium, magnesium, calcium, monitoring of coagulation profile, monitoring of HP levels every day. Advanced monitoring, if available, must also be done. Monitoring of ICP should be done in patients with GCS less than 8 and abnormal CT. TCD monitoring is recommended for all patients where there is resource is available and to measure the pulsodality index in vascular reactivity. PbTO2 monitoring is recommended for all patients in the places where it is available, and continuous EEG if available in patients with unexplained altered consciousness, GCS of 8 or less with cortical injury, penetrating injury, and depressed fractures. Now we'll be discussing the Kravis protocol, which is based on imaging and clinical examination for use when intracranial pressure monitoring is not employed or available, especially in low middle income and low income settings. In this, the monitoring comprises of continuous saturation monitoring, monitor the clinical neurological status each hour, pupil size and reactivity, GCS, urine output measurement, arterial pressure measurement, CVP, and monitor ETCO2 if available, or frequently monitor plasma PaCO2. NCCT scan should be done as soon as possible after TBI. If initial CT is obtained at less than 4 hours after injury, obtain a follow-up CT within subsequent 12 years. Next CT should be done at 24 hours, then at 72 hours, and then as needed based on patient's clinical condition, which includes neuroworsening to assist in decision-making and other clinical situations. CT scans should each be individually classified according to the Marshall scale. So Marshall CT classification, in this, it is divided into diffuse injury 1 with no visible pathology, diffuse injury 2, diffuse injury 3 with cisterns, compression, and swelling, diffuse injury 4 with a midline shift, evacuated mass lesion, and non-evacuated mass lesion. Now, general management measures which should be done in such settings should include place patient on mechanical ventilation, saturation to be maintained more than 95, use adequate sedation and analgesia, maintain head of the bed at 30 degrees, maintain head and neck aligned in the neutral position, actively monitor body temperature and treat hyperthermia, early enteral nutritional support, initiate within 48 hours of injury, and give 30 kilocalories per kg patient weight per day. Pharmacological prophylaxis should be done for early post-traumatic seizures, gastric bleeding prophylaxis, start DVT prophylaxis early, frequent tracheal suctioning, avoid anemia using transfusion if needed. Higher transfusion thresholds may be chosen at the discretion of a treating physician. So treatment goals for adequate cerebral perfusion and oxygenation include avoidance of hypotension, which is defined as systolic blood pressure less than 90 and mean arterial pressure less than 70, arterial blood oxygenation more than 95 or PaO2 more than 75, avoid anemia, that is HbF less than 7. The initial therapeutic interventions include, firstly, normal saline solution to avoid hypovolemia. Initial minimal acceptable mean arterial pressure should be set at 90. Maintain MAP and volume expansion. Use vasopressors to supplement mean arterial pressure when volume status manipulation is not sufficient. Maintain PaCO2. And if a space occupying lesion exists, surgical evacuation is indicated. Now the specific therapeutic interventions. After optimized sedation and analgesia, unless clinically contraindicated, treatment for suspected ICH should be started in the presence of one of the following major or two of the following minor criteria. The major criteria include CT classification of Marshall 3 or worse, compressed cisterns, that is Marshall DI3, midline shift of more than 5 millimeters, Marshall diffuse injury 4, or a non-evacuated mass lesion more than 25 ml. Minor criteria is GCS motor score less than 4, pupillary asymmetry, abnormal pupillary reactivity, and Marshall diffuse injury 2. Such treatment may also be considered in patients at a discretion of the treating physician. Levels of treatment. There are 3 levels. First is tier 1, that is the safest. This should be followed by tier 2, which are intermediate, and then the tier 3, that is the most riskier or the one with the higher risk to benefit ratio. So first start with scheduled hypertonic saline, that is 4th-hourly, scheduled mannitol, for example, every 4 hours, maintain normotherapy. This should be followed by tier 2, that is hyperventilation, that is PCO2 of between 30 to 35, hypertonic saline 3% in continuous infusion and increase in sedation. This must be, next will be tier 3, which includes decompressive craniotomy, high dose barbiturates, and hypothermia. It is not necessary to use all the modalities in a given tier prior to moving to the next tier. There is no rank ordering within a tier. When considering advantageous, tiers can be skipped when advanced treatment is required early. What is not used is corticosteroids, anticonvulsants for prophylaxis of late epilepsy, that is beyond 7 days, hyperventilation to a PCO2 less than 30, diuretics, mannitol by continuous infusion, and a lumbar drainage of CSF. There is controversial use of neuromuscular blockade in these patients. Now coming to the surgical aspect, that is decompressive craniotomy, it is a level 3 therapy indicated at the time of admission or during the early phases of care as an alternative to other lower level treatments. For example, when the admission CT meets Marshall diffuse injury 4 criteria, in some diffuse injury 3 patients or in the face of early neurodeterioration, should be as large as technically possible and involve a similarly large durotomy and neuroplasty. Obtain CTs shortly following decompressive craniotomy, and it is recommended that the management of patients be based on early post-op CT in terms of treatment levels and decisions to escalate or taper treatment. What is neuroworsening? Neuroworsening is defined as a decrease in the motor GCS of 1 or more points, new loss of pupillary reactivity, interval development of pupillary symmetry of more than 2 millimeters or bilateral mydriasis, new focal motor deficit, and presence of herniation syndrome or Cushing's triad. A brain CT is strongly recommended following neuroworsening. Neuroworsening requires a documented rapid response towards improving control of suspected intracranial hypertension. It is defined as an increase in the TIL within 1 hour of the event. Escalation of therapy. Escalation of therapy or adding another treatment should be considered if there is neuroworsening, herniation syndrome, no improvement in initial CT, or to the latest CT without acceptable response to the initial therapy. Now coming to the tapering therapy. So when do we need tapering therapy? Consider tapering therapy in stable to improving patients as determined by their most recent Marshall classification, GCS score, and pupillary status. What is the method of tapering therapy? In general, first decrease the treatment started most recently, removing hypertonic saline. If we need to remove hypertonic saline, stop it immediately. While removing mannitol, the regime should be maintained the same for the first 24 hours and then decreased to 50% dose for 24 hours and then stop. Tapering blood pressure support. The initial minimal acceptable mean arterial pressure should be set at 90 millimeters of mercury. Weaning off of blood pressure support should target a minimum mean arterial pressure of 80 millimeters of mercury. Weaning should only be considered when there has been improvement on CT sign, imaging or signs suggestive of ICH, the clinical status is stable or improved, and systemic signs of hypoperfusion are absent. So in the end, I would like to conclude that the burden of TBI is highest in RLRs, that is resource limited settings, where it remains a significant cause of death, severe disability, and productivity loss. The care of these patients begin with rapid and appropriate triage, prompt recognition of TBI, and immediate stabilization of severely brain injured or otherwise critically ill trauma patients. Innovation on portable and non-invasive technology for diagnosis and monitoring promises to offer new possibility to reduce the enormous personal and societal losses from TBI in these countries. Thank you.
Thank you, Dr. Shaman, for your precious presentation. Actually, traumatic brain injury is now a very much common problem. It is day by day increasing, not only in urban area, but also in rural area where that neuro setup is not totally equipped for development. So the most important things are the pre-hospital care, care in the emergency, and then the categorization of the patient, which patient we refer to higher center, which patient we go for CT scan, which patient we medically treated, and then the ICU setup, and also the care of the patient during the transport of the patient. All the things are nicely described by you. So only one question I have to ask you. Do you use ketamine for intubation of traumatic brain injury patient, which is preferable than pentothal or propofol? Hello? Hello?
Dr. Namne, you have to unmute yourself. You have to unmute yourself.
Hello?
Can organizer unmute her?
I request the organizer or the
Unmute
backend team to
yourself.
just unmute her.
I
She's
think
not
ma'am
able to
has
do that.
muted his system. Ma'am, you are not audible. You have to unmute yourself.
You can unmute from your laptop.
Yeah, I'll try, sir. Just give me a minute. I'll try, sir. We are sending a link, ma'am. You just have to see and unmute. Have you got something, some prompt? You have to see it. And then you have to unmute.
Okay. Then this topic is open for discussion to all the audience and other faculties that are present.
Sorry for the interruption.
Till that time, I just wanted to ask Dr. Datta, if you have, how are you practicing antibiotic stewardship in your hospital? And are you using specific strategies like antibiotic cycling or something like that in your institution, so that the MDR should come down?
Thank you, sir, for the question. Sir, we do practice antibiotic stewardship in our ICU. So to begin with, even for empiric therapy, we do not go for the very broad spectrum antibiotics. We start with cephalosporins or even levofloxacins in mild to moderate infections. And as I said in my presentation also, we use a lot of procalcitonin in our ICU. So we use it on the day of admission if there is a suspicion of infection, and every 48 or 72 hours, we repeat it. So our antibiotic therapy is guided mostly on procalcitonin values. Ours is not an exclusive neuro ICU, it's an open ICU, but majority of patients are neuro ICUs. So as I said, in neuro specific patients, again, we look for non-infectious cause of fever and then guide our antimicrobial therapy. So
you said something about levofloxacin. Sorry, I am not able to hear that.
Yeah, so as I said, empiric therapy. So we do not start immediately with carbapenems or even other broad spectrum antibiotics. Sometimes if there is a suspicion of a ventilator-associated pneumonia, even for a pseudomonas infection, we start with moxifloxacin or levofloxacin, and considering we preserve the very broad spectrum antibiotics till the end, or there is an evidence of infection, or the cultures are susceptible only to them. So it's a practice.
I beg to differ on that, Dr. Datta, about levofloxacin per se. See, levofloxacin should be a restrictive antibiotic in India. It's a second line drug in tubercular disorders in India. And with MDR tuberculosis, levofloxacin should be a restrictive antibiotic and should not be the go-to drug in any case, unless and until you require it specifically. We have to preserve levofloxacin because it's a second line ATT drug in India, and India is a tuberculosis capital of the world. So I will say that it's not the go-to drug.
Of course, I agree. I agree completely with you.
In India, at least.
We do not use it for all infections. As I said, we sometimes do begin with, and as we get the antibiogram or the susceptibility pattern, we change it. And of course, I totally understand, because we have to preserve it for as it's a part of ATTs.
Levofloxacin should be the last resort and not the first resort or the first go-to drug in any case in India. It should not be.
Thank you, sir, for the input, sir. Thank you.
Any other question from the panelist or the chairperson for any of the speakers? Dr. Navne, if you are able to unmute yourself, you can answer the question which was put to you.
Another thing regarding TBI, ventilation. Regarding the ventilation, first 24 hours, we keep the PaCO2 in some higher level, around 35 to 40. And after 24 hours, then we can decrease around 30 to 35.
Dr. Nidhi ma'am, what you use in your institute to manage the fluid? So because euvolemia is easier said than done. So it is not as simple as it looks. It's not a word. It's a complete syndrome in itself, I say, in my ICU. So it is not an easier thing to maintain in an ICU. So how do you go for euvolemia in your ICU? We generally say, okay, you maintain euvolemia. Euvolemia is not such an easy thing to maintain. How do you do it in that ICU?
That's what. Are you able to hear?
Yeah, very clearly.
Actually, surgeons, they used to give fixed volume. 3 liters per post-operative patient, give 3 liters per day, like that. But now we have started that ultrasound guided IVC diameter, and not a single
IVC
reading
diameter.
is single IVC diameter, and single reading is not good. We should check the trend, or after fluid challenge we should check the trend. So now we are encouraging to do IVC diameter measurement.
Actually, the topic was where there is a resource limited, where there is the USD machine is not available.
No, not in
Madam's
my
topic was not resource limited. The resource limitation was the topic for Dr. Namne.
Yeah.
If I may be allowed to add, sir. So we do use cumulative fluid balance, sir, because the sisters, they calculate the cumulative is easier that way. So if you know where there has been an excess hydration for a particular day, then we can bring down the fluids and use a diuretic and maintain.
Actually, other cases it is fine, but for neuro patients, especially aneurysmal SH patients, the thing is that cerebral salt wasting syndrome is very common, and all those things. In those things, this output, urine output, are not urine output and input, then positive balance are not reliable. For that reason, in aneurysmal SAH especially, we should go for dynamic monitoring. If nowadays it is very easy to get pulse pressure variation, plethysmographic variation, all those things. And if it is not there in all the monitors, we can go for ultrasound guided IVC diameter. That is a very easy thing.
I think there are no more questions in the chat box. I'm not able to see any question and answers in the chat box as well. So we can close the session.
Okay, sir. Thank you, sir. Thank you, ma'am. It was a very wonderful and learning experience for all of us. And if you allow, we can end this session. Can we end this session, sir? Ma'am?
Yeah, thank you. Thanks
Yes,
for the
yes.
organization.
Thank you.
Okay, okay. Thank you.
Thank you, sir. Thank you giving your valuable time, sir.
Okay, thank you.
Thank you, sir. We will move ahead to our next session. That is a problem-based learning and discussion session, session 7. So for this session, I'd like to welcome our chairperson. First of all, I'd like to say good evening to all the chairpersons. I welcome Dr. Mihe Pandian, sir, Dr. Viren Jain, sir, Dr. Mukesh Gupta, sir, and Dr. Pragati Ganju, ma'am. So I would like to say a few words on our respective chairpersons. Dr. Mihe Pandian, sir, is from AIIMS. He is a professor neuroanesthesia. And our next chairperson is Dr. Viren Jain, sir, director and head Fortis Memorial Research Institute, Gurgaon. His areas of interest are subarachnoid hemorrhage and traumatic brain injuries. He has many publications, and he got the Resident Travel Award in ISNACC 2007 at San Francisco, USA, and he got the Best Paper Award ISNACC 2007. I welcome Dr. Mukesh Mohan Gupta, sir, senior consultant and head at Paras Hospital, Gurgaon. Sir is working as a head and DNB guide in Department of Neuroanesthesia and Neurocritical Care at Paras Hospital, Gurgaon. Thank you, sir. Our next chairperson is Dr. Pragati Ganju, ma'am. Ma'am is director, professor, and head at Department of Anesthesiology and Intensive Care, head of Neuroanesthesia Unit, program coordinator, DNB Neuroanesthesia and Critical Care at GB Pant Institute, New Delhi. Welcome, ma'am. So I would like to ask the chairpersons to please go ahead with this session by introducing our respective speakers, please. I request Dr. Mihir, sir, to please introduce our speaker.
Good evening, ladies and gentlemen. I welcome everyone to this session. Our next speaker is Dr. Ranadhir Mitra. Dr. Ranadhir Mitra is presently the head. He did his DM in neuroanesthesia and critical care from AIIMS New Delhi. And he has multiple papers in various national and international journals in neuroanesthesia and neurocritical care. Now he is in Utkal Hospital, Bhubaneswar, but before that, he headed the Department of Neuroanesthesia and Critical Care in KR Hospital, Bhubaneswar, and he has his areas of interest are neuroprotection and neuro rehabilitation. And he will be talking about the care of a patient, COVID positive patient for emergency craniotomy. Over to you, Dr. Mitra.
To Kolkata. I am Dr. Ranadhir Mitra, consultant neuroanesthesia and neurocritical care at Utkal Hospital, Bhubaneswar. Today's topic is how to administer anesthesia in a COVID positive patient who have been posted for emergency craniotomy. So coming to a case scenario, a 25-year-old male who has presented to a ER with a road traffic accident having an arrival GCS of E2, V2, M5, and CT scan done at the ER showed a EDH of 40 ml volume with a large midline shift of 7.5 mm. His lab investigation were within normal limits. Rapid antigen was negative, but the HRCT screening showed a core of 4. So this would be his EDH, large midline shift, but there are bilateral ground glass opacities scattered. So we have a core of 4 on our hand. So when we encounter such a patient who is either COVID positive, frankly, or who is a suspect of COVID, then and you are asked to administer anesthesia as an emergency case. So what would be your issues that you would likely face with this kind of patients? So one is the issue of how to do a PSC in this kind of patient. If they're in an active COVID phase, how to prepare a OT, how to secure the airway, what would be your ventilator strategy, what would be the intraoperative anesthesia goals, and how to go for a tight brain, and what would be your postoperative monitoring. Like Youngblood said once, good luck is a residue of preparation. So it all boils down to your preparation, how you handle this kind of patient. So you would have a fair idea beforehand, before taking up the patient. So how to do a PSC? In today's era, it is advised to go for a tele-PSC, where you can always take the history, assess the comorbidities, even examine the airway via camera. And this would reduce your risk of exposure directly to COVID. So also, when you have a suspect or diagnosed COVID, other than for a routine surgical profile, what test other than that you can ask for is an ABG, the HRCT thorax if it has not been done, coagulation profile, D-dimer. If the patient is on ex-COVID, so additionally, if the time permits, you can always have a bedside 2-dimensional echo. So, how will you prepare a OT? So generally it is asked that you have to have a negative pressure OT to reduce the risk of exposure to aerosols. And before meeting the patient, you should have a level 3 protection gear. That is, you should be wearing a scrub suit, preferably more than 92 GSM. Then you would be wearing boot scrubs, boot cover, goggles, face mask with an N95, and a face barrier to reduce splashes or any aerosol reduce exposure to aerosol generating procedures. Then during the process of intubation, there should be a maximum of 3 people. And the ideal way to go out for intubation is if you have a video laryngoscope and a bougie. One of the earliest articles which came from Wuhan during the pandemic was an anesthetic management of patients with COVID-19 infection during emergency procedures. They percent not neurosurgery, but if you have an emergency procedure, anesthesia has to be administered, how you will go about it. This is a very interesting article because it came from the Central Hospital of Wuhan, along with collaboration with Wuhan's Children's Hospital, Union Hospital, and Fourth Hospital. These hospitals were started around human seafood market, which was the wet market from where the popular theory of origin of virus is circulated. Now they have formed a flow chart based on which if you have to take care of the patient, then you need to have a negative pressure OT, along with all the other things that I have already said. While reviewing the available evidences, the Anesthesia Patient Safety Foundation in February 2021, they have come up with what type of OT we should be having when we are dealing with a SARS-CoV-2 infection. They suggested of an anteroom, that is prior to the OT, you can have an anteroom which will be made into a negative pressure chamber to the use of proper air handler. And they have created this kind of anterooms, as you can see on the photos. But they have not suggested to make the OT process negative pressure because that would increase your risk of infection from the sucked in gram-positive bacilli like staph or strep. So at present, they're saying negative pressure should not be instituted in OT, but all the aerosol generating procedures can be carried out in an airborne infection isolation room that is separate from the OT. So what are the precautions that you can take while trying to intubate the patient of COVID-19? So as I said, that you should have a level 3 gear and maximum 3 people should be there while intubating. The points are, the airway should be secured by the most experienced anesthesiologist who has got adequate experience in difficult airways. Then 2 persons may be used while mask ventilating if it is required, and there should be a vice grip. While one person from the head end will be appearing a C with both the hands, another person from the foot end will be appearing the E on both the hands, and allow for a 3 to 5 minutes of pre-oxygenation. Prior to intubation, give antiemetic, anticyanogogue, reduce secretions, and reduce risk of vomiting. Always a rapid sequence intubation is used. Adequate muscle relaxation should be there before attempting intubation. The sequence normally is a sedation, narcotic, and relaxation. Here, there will be a big change in the sequence, where you will first give sedation, then you will relax, then you will give narcotic to reduce the risk of coughing from the narcotic. Then the ideal gadget that you should be using is a video laryngoscopy with the bougie. After the tube is in, it should be confirmed by a capnograph. So these are some of the modifications that were done to the circuit. In the breathing circuit and mechanically pleated. This is mechanical pleated HME filters which are attached to both the inspiratory expiratory port, but generally expiratory port is enough. And you can use a 0.2 micron epidural filter while attaching to the gas sampling line. And this would be an HME filter at the patient end. Now, what would be the best ventilation strategy? The mechanical ventilation in COVID-19 physiological perspective is a very good article which was published by Cronin and Campota in Experimental Physiology. And they've reviewed all the aspects of COVID-19 pathology, especially when we were affected by the Delta virus and the changes that were happening within the lungs. If you meet such a patient where the lung is already involved, then you should try to optimize your tidal volume by targeting a driving pressure. This is P flat minus P or less than 14 centimeter of water. And the tidal volume generator should be 8 or less. And you should not always put a 50 kg patient, 6 ml per kg predicted body weight, and we have a 300 ml tidal volume. No. You have to see what would be the driving pressure in the particular patient and adjust accordingly. The optimal PEEP is determined by whether you have met an L-type lung or H-type lung. So if the lungs is recruitable, then you can give adequate PEEP to maintain oxygenation. To know whether the lung is a recruitable one or not, you can have a single bedside recruitment maneuver where a recruitment is to inflation ratio. If it is more than 0.5, then the lung is recruitable. So you give more PEEP. That is around 12 to 15. And if the lungs are not recruitable, if the RIB ratio is less than 0.5, then you can give less PEEP. And the less PEEP would be around the tune of 8 to 12 centimeter of water. So based on the kind of patient you are seeing, based on the HSCT screening, the patient can have a low tidal volume, low PEEP, a high tidal volume, or liberal tidal volume, low PEEP, or a low tidal volume, high PEEP. So what are the interpretive strategy for anesthesia? As far as anesthesia is concerned, I went through a lot of recommendations, articles, and statements, both from ISNACC and ISNACC, and from individual entities also. So generally, it is in all those articles and all those guidelines and statements, they all stress on how to maintain safety while administering anesthesia for both the anesthesia care provider and the surgical team. So first of all, you have to identify what are the high-risk procedures for anesthesia in terms of aerosolization. So for anesthesia like intubation, extubation, mass ventilation, open suctioning of oral secretions, high frequency nasal oxygenation, awake intubation, and CPR. This would be the high-risk anesthesia procedures. At the same time, high-risk neurosurgical procedures would be if you are going for an endoscopy, TNTS, transnasal transpyramidal surgery, skull-based surgery while using a bone drill, while trying to do craniotomy, or while using CUSA for a tumor removal. Then awake craniotomy is easy to understand. Tracheostomy. So these are the high aerosol generating procedures. As far as awake craniotomy is concerned, even in the case of SNAC guidelines, they have also said awake craniotomy can be offered in select patients. But as far as I understand, right now we are going through Omicron pandemic. Even awake craniotomy is maybe not free from risk, given the high reproductive number of Omicron virus. So some of the innovations that have been alternatively suggested while taking in a COVID patient are using double layer drape or microscopy. This has been published on IPGMR Kolkata, how to use a 2-drape closed pocket technique. So all the aerosols that we generated to lie within the drape. Then also while drilling or using while using bone drills, you can always use it through a glass receptacle to contain the aerosols. So what would be the neurosurgical patients for COVID, neurosurgical principles for COVID patients? So you can always use low speed drills. With the high speed drills, the higher the speed of the drill, the higher is the aerosolization. While you're irrigating, you should not be drilling. So it should be like drill, irrigate. Then judicious use of bipolar cautery. Use it where it is required, not use it unnecessarily and cause aerosolization. Whenever possible, go for chipping, then over drilling. Then if you have to remove a pituitary tumor, you can rather prefer for open over transspinoidal surgery. And for some certain specific areas where like vestibular schwannoma, you can go for an RMSOC over translabyrinthine approach, where bone drilling is more required. Once a specimen is out, it should be sent in sealed jars in plastic bags to prevent contamination. In between 2 OTs, and time period of 1 hour should be given so that the OT can be cleaned properly, proper surface decontamination with hypochlorite solution or 2 to 3% hydrogen peroxide or 75% alcohol. Finally, once the surface cleaning has been done, you can always use an hydrogen peroxide vaporizer for final decontamination. As far as anesthesia is concerned, for raised ICP, obviously TY is preferred. In this case, like in EDH, because there is a large midline shift, then it is better to have a TIVA. For brain bulge intraoperatively, you can always use the same maneuvers that you used to use in the pre-COVID era: hyperventilation, hypertonic saline or mannitol, steroids, head up, etc. Extubation should be planned after full reversion only, which should be calculated from the top machine, or top guard should be used ideally. And prior to extubation, the cuffing is prevented by using 2% lignocard or dexmedetomidine. So you should always use a prophylactic antiemetic prior to extubation. Then the post-extubation period, use an oxygen via nasal prong and an N95 mask. If not extubated, the patient should be transferred to COVID ICU using a single-use ambu bag with filter at the patient end. And lastly, once the OT is over, you should always allow a time period of 1 hour between 2 cases. So the take-home point should be that true emergency in a pandemic is not to treat an emergency. It should always be elective in nature. And all the procedures of securing airway and administering anesthesia, it should be properly thought before the OT. It should not be carried out at the time when the patient is already within the OT operation theater. Always prevent aerosol exposure risk during this particular time while in TSC, transport, during induction, intubation, extubation, and post-operative period. Tight band checklist remains the same with or without COVID. A dedicated COVID ICU is required where centers are engaged in doing COVID cases, because sometimes and in fact a lot of times this patient may not be extubated at the end of surgery. So in that case, the patient should be transferred into a dedicated COVID ICU. With that, I conclude. Thank you.
I request Viren Jain sir to please introduce our next speaker.
Good evening, everyone. Next speaker is Dr. M. Ramamani, she's a professor of neuroanesthesia at CMC Value. Her special interest is anesthesia for cerebrovascular and skull-based surgery and pain management and spine surgeries. She has multiple publications. And over to you, Dr. Ramamani.
Like to disclose that there is no conflict of interest regarding this talk. I'll be talking about management of a massive blood loss in neurosurgery in next 20 minutes. Massive blood loss and massive transfusions are quite common in neurosurgery because of the various factors. Brain is a very highly vascular organ. It receives about 750 ml of blood per minute, and cerebral cortex has a very high content of tissue thromboplastin. Because of this, any injury, a tissue or neuronal injury, which releases tissue thromboplastin, which can trigger the extrinsic clotting pathway, which can lead to disseminated intravascular coagulation. Ultimately, it causes conception coagulopathy. Some tumors, especially the meningioma, are shown to produce tissue plasminogen activator, which converts the plasminogen to plasmin, which leads to significant hyperfibrinolysis. Not only this plasmin leads to hyperfibrinolysis, it actually induces a thrombin generation, and it can cause cleavage of fibrinogen to fibrin. Also, it causes cleavage of receptors and platelets. Ultimately, all of these factors which leads to DIC and conception coagulopathy. Some of the brain pathologies are highly vascular. That also can lead to massive blood loss. And when we see that, achieving hemostasis during brain surgery is a very challenging task, as packing or application of ligatures or suturing is not possible in neurosurgical setup. It can lead to prolonged hemostasis. That also will lead to massive blood loss. Till now, we have seen the factors which are causes more blood loss in neurosurgery. Apart from that, there are various other reasons which are common to all other major surgeries, which can also lead to massive blood loss, especially when there is an unexpected blood loss, which will get treated with excessive crystalloid and colloid during the initial resuscitation phase. That can lead to hemodilution and dilutional coagulopathy. Also, rapid administration of cold blood and IV fluid can lead to hypothermia, which can lead to acute platelet dysfunction. Not only it causes that, it also decreases the coagulation factor synthesis from the liver, and also it decreases the activity of clotting factors, whatever is available in the blood. Then, hence, it leads to coagulopathy. Massive blood loss causes a tissue hypoperfusion and acidosis. Acidosis will worsen the coagulopathy by inactivating all the clotting factors. Surgery itself can produce fibrinolytic, fibrinogen and inflammatory pathway activation, which also leads to worsening of coagulopathy. Some patients, when they come for emergency surgery, they will be on antiplatelets and anticoagulant medication. This will lead to massive blood loss. So this is a flow chart. Whatever I have discussed till now, it is just a diagrammatic representation of the pathogenesis of hemostatic abnormality that happens in neurosurgery. Whenever the blood loss happens in the confined intracranial space and into the spinal cord, which can lead to many devastating complications. Hence, meticulous hemostasis and appropriate management of excessive blood loss is very crucial for the successful functional outcome. Whenever we manage patients with a massive hemorrhage, there are certain principles to be followed. Thorough preoperative evaluation, preoperative prediction and preparation, early administration of antifibrinolytic, maintenance of tissue perfusion and oxygenation, maintenance of normothermia and ionic calcium, utilization of all possible blood conservation strategies, including patient blood management protocol, and early activation of MTP protocol, massive transfusion protocol in selective cases, and early identification of transfusion-induced complication and its management are essential from anesthetic point of view. And from the surgical factors like proper positioning, meticulous surgical technique, and appropriate use of chemical hemostatic agents to control the bleeding is essential while managing the massive hemorrhage. Apart from this general principle, the specific principles of reduction in ICP, maintenance of CPP, and adequate brain relaxation is the key factor for successful outcome. When we talk about massive blood loss, everyone needs to know about massive transfusion. There are, whenever we transfuse blood in a large volume over a short period of time, it is called massive transfusion. There are different definitions for adult and children. When it comes to adult, when we transfuse more than 10 packed red blood cells within 24 hours, or transfusion of more than 4 packed red cells within an hour, when there is an ongoing bleeding is happening, or whenever we replace more than 50% of the total blood volume within 3 hours, it is considered as massive transfusion in adults. When we calculate the total blood volume estimation in adults, we follow Gilcher's rule of 5. So when we consider for a normal patients, we take a 65 ml per kilo as a total blood volume for female and 70 ml per kilo for adult male. When it comes to obese individual, we take 55 ml per kilo for female and 60 ml per kilo for male. And there are different definitions of massive transfusion in children. When we transfuse more than 100% of the total blood volume within 24 hours, or when we transfuse more than 10% of the total blood volume per minute in children who are having an ongoing hemorrhage, or replacement of more than 50% of the total blood volume with blood and blood products within 3 hours. Now, when we calculate the total blood volume estimation in pediatrics, it depends upon the neonate patient's age and the body weight. When we talk about neonate and infant less than 10 kilo, we take it as 85 ml per kilo. For younger children less than 25 kilo, it's 75 ml per kilo. We more than 25 kilos for older children, more than 25 kilo, we take it as 70 ml per kilo. American Society of Anesthesiologists have released an updated report on practice guidelines for perioperative blood management, which has been released in Anesthesiology 2015, and in which they have actually quoted there are 5 steps in managing the patients with the who are expecting to have a high massive bleeding. It starts with patient evaluation, pre-admission preparation, and pre-procedure preparation, and intraoperative management, and post-operative intervention. Now we will go through each of these in detail. When we talk about preoperative patient evaluation, we do conduct the patient interview and review the medical records and go through all the blood investigations, including hemoglobin and coagulation profile. In some patients, we may need to do factor assay where the coagulation profiles, PTA, PTT are borderline, and typing and cross-matching is a must. And in patients who definitely is going to have a massive bleeding, sometimes we need to order maximum surgical blood ordering technique needs to be followed. We have preoperatively evaluated. Now we need to predict them, which patients are more prone for transfusion. Now there are some general predictors that depends upon the type of surgery, what is the baseline hemoglobin, what are the comorbidities the patient has, what is the allowable blood loss for him, what is the transfusion trigger, are you going to use liberal transfusion strategy or restrictive strategies, and what is the type of the tumor, where is it located, what is the vascularity of the tumor. All those things will predict your transfusion. Now we will move on to some evidence-based evidence for these, and this is a paper which is published from the AIIMS group, and they have looked at the various risk factors for massive transfusion in patients undergoing an elective brain tumor surgery. They have looked at only in adult patients, and they have predicted that the female patients who are hypertensive, tumor size of more than 5 centimeter, and with the mass effect and midline shift, and high-grade gliomas and meningiomas, they have a high vascular and preoperative imaging, they are actually more prone for massive bleeding. And patients, some of the intraoperative factors are extended craniotomy, colloid use of more than 1000 ml, and intraoperative brain bulge, and duration of surgery more than 300 minutes is considered as a risk factor for massive blood loss. This is a paper published from Japan, and they have looked at the risk factors for massive bleeding in skull-based surgery, and they have predicted that the extent of tumor invasion and duration of surgery predicted the most. And this is another paper published in Journal of Neurosurgical Anesthesiology, where they have looked at the spine surgery and the risk factor for massive transfusion. And they have predicted that there are 4 factors. One is duration of surgery, number of posterior level instrumented, and surgical complexity scoring, and preoperative hemoglobin are the main predictors of transfusion. Here we have performed a retrospective study from 2012 to 2015, where we have looked at the various factors, and we have have predicted the tumor size of more than 5 centimeters, prolonged duration, and meningioma and spine surgeries are the common risk factors for the massive transfusion. This is the recent review published by Dr. Gleb and Dr. Flaxman, and they have actually subgrouped each of neurosurgical procedures and the various risk factors for transfusion. For example, traumatic brain injury patients comes with a traumatic coagulopathy and the transfusion risk is very high. For example, if the patient comes for pediatric craniosynostosis surgery, if they are syndromic, or if there is a pansynostosis involvement, or if their age is less than 18 months, or with their body weight is less than 10 kilo and surgical duration of more than 5 hours are the risk factors for massive transfusion. And now we have actually predicted which patient in elective surgery, spine surgery, tumor surgery, and pediatric patients, everything we have seen. Now we are moving on to trauma. There are in trauma, because of this associated comorbidities and pre-injury medications and the shock they present with and trauma-associated factors, resuscitation-associated factors, all those things can lead to traumatic coagulopathy. Hence, there are certain predictive scores that tells you that these patients need a massive transfusion. And there are various scores. I highlight only certain important scores. And one is trauma-associated severe hemorrhage, TASH score. This is the German group has published this. They utilizes various clinical and laboratory variables, and they have actually come up with a TASH score of more than 16 points. That means that probability of massive transfusion is 50, and TASH score of more than 27 points, the risk of massive transfusion is 100%. There is another score called blood consumption score. It's called ABC score of blood transfusion, which has a 4 component. If the 2 score component is there, then there is a trigger for initiating the massive transfusion protocol. There is another course called MTP score, massive transfusion protocol score. There is another score for dynamic massive blood transfusion that is also utilizes various clinical factors and lab values, which tells us that massive transfusion risk is high, or the mortalities also can be predicted using this score. Now we have preoperatively evaluated and predicted. Now we have to utilize what all the preoperative blood conservation strategies can be used to reduce the blood loss and blood transfusion. Now we will move on to each of this. What are the preoperative strategies, intraoperative and postoperative strategies can be used in neurosurgical patients? Correction of coagulopathy, correction of iron deficiency anemia, and administration of erythropoietin, and preoperative autologous donation and preoperative embolization are some of the preoperative strategies can be utilized to decrease the blood loss and massive transfusion. Some of the intraoperative factors are correction of coagulopathy, utilization of acute normovolemic hemodilution or acute hypervolemic hemodilution, or continuous hemoglobin monitoring, intraoperative cell salvage, use of antifibrinolytic agent as early as possible, avoiding NSAIDs and starch solutions, and the utilization of controlled hypotension, proper positioning, use of chemical hemostatic agents at the local site. All these things are intraoperative blood conservation strategies we can use to reduce the blood loss and blood transfusion. And what are the postoperative strategies we can follow? Correction of coagulopathy, avoidance of NSAID and starch, and postoperative blood recovery. Now we will move on to the evidence. Where is the evidence? Now this is a paper published in Canadian Journal of Neurological Sciences, where the surgeons have looked at the erythropoietin and preoperative autologous donation on allogenic transfusion. They have predicted that preoperative autologous donation is associated with increased incidence of preoperative anemia and does not increase the incidence of allogenic transfusion. And preoperative autologous donation is increased the transfusion requirement. So because of this reason, this technique is not utilized very effectively in neurosurgical setup. And this is the paper published by Dr. Anna Flaxman and Dr. Gleb in 2018 in BJA. They have actually looked at various and intraoperative, perioperative blood conservation strategies, and which is utilized for intracranial neurosurgeries. These are the following 8 techniques has been utilized in neurosurgery, and we will see what is the evidence. The reversal of coagulopathy is practiced more in ICH patients, and it is shown that 50% risk reduction in hematoma expansion, and with the reversal, the INR came down to 1.3, less than 1.3. And use of antifibrinolytic therapy, which is being used in skull skull-base tumor, craniosynostosis, and TBI and subarachnoid hemorrhage. It's shown to reduce the blood loss and blood transfusion significantly. But in SAH patient, it's also reduced the re-rupture. But there is an incidence of cerebral ischemia has increased with the use of antifibrinolytic agents. And what about administration of erythropoietin? Actually, it definitely increased the hemoglobin, but there is conflicting evidence in TBI because there is a increased incidence of risk of thromboembolism. And avoidance of NSAIDs and START solutions, which decrease the perioperative hematoma size. And utilization of ANH definitely decreases the allogenic transfusion. Whenever the hemoglobin is more than 12 grams per deciliter, this procedure is recommended, and dropping the hematocrit to 20 to 25 is done usually during this procedure. And we have already seen this preoperative autologous donation. And what about cell salvage? It is recommended only in certain benign vascular tumor and ruptured cerebral aneurysm. But when we use a chemical hemostatic agent, it is very important to not use this technique. And what about continuous serial hemoglobin monitoring, which reduced the amount of unit transfuse and also it helped in early transfusion. What about preoperative embolization? This technique is being utilized more for children, not for adults, because in many literature says that it's a conflicting event. Some there is a blood loss and blood transfusion is minimal. Some are actually very difficult to achieve hemostasis in those patients. And also they have shown that the complete resection was not possible with this technique. And because we also have to keep it in mind, because they are actually giving contrast-induced diuresis happening. So they are hypovolemic to start with. So very important, we have to resuscitate them before the bleeding happens. Otherwise, they are more prone for embolization. Air embolism. And another thing is peritumoral edema following an embolization can cause tight brain. So we may need to give extra dose of mannitol that makes the patient so hypovolemic. And also these tight brain can cause release of tissue thromboplastin. Hence, we have to be careful that can actually aggravate the bleeding. And what about role of permissive hypotension in neurosurgery? It is actually this the role of permissive hypotension is weaning from neurosurgical setup. And this is a recent survey conducted in USA and Canada. Many SNACC members were involved. They have actually, most of them, they have actually given us, they are practicing only in some aneurysm clipping and AVM surgeries. And even then, more than 45% of the individual, they have said that the mean BP was maintained between 60 to 40 during this permissive hypotension, and the systolic BP was maintained between 90 to 100 millimeter of mercury. And another one of the strategies is stopping the antiplatelet and anticoagulation drugs in an appropriate time. So there are certain recommendations. Aspirin has to be stopped 7 days, clopidogrel 7 to 10 days, warfarin 5 days, direct acting oral anticoagulant 24 hours for low risk procedures and 48 hours for high risk procedure. If they have an abnormal renal function, it has to be stopped 72 to 96 hours before surgery. And what about reversal of coagulopathy? And there are certain, many patients will be on different drugs, so certain guidelines needs to be followed. I'm not going to go through this whole slide. For example, if they are on warfarin, it has to be corrected with the 3 or 4 factor PCC, or if they have to be given, if it is not available, FFP has to be transfused at 10 to 15 ml per kilo. If they are on direct acting inhibitors, there is, except dabigatran, there is no other direct thrombin inhibitor don't have a reversal agent. So we have to administer activated protein prothrombin complex that is about in 50 units per kilo. So when we once we have preoperatively evaluated and then we have predicted the risk factors, then we'll move on to the what all the preoperative strategies we can utilize to reduce the blood loss. Now we have to prepare just before the procedure what all the things we need to keep it ready. Inform patient consent and the need for ICU, need for ventilation has to be informed to the patient, and adequate intravenous is the must, and wide bore cannulas we need, and multi-lumen catheter, central vein catheter, and warming devices, rapid infusion pump and pressure pressure bags, inotropes and vasopressor drugs to be loaded and collected close to the patient, adequate manpower, and repeat communication with blood bank doctors, and arrange the post-op ICU care. All those things are needed. So what are the monitorings do we do during massive transfusion? Apart from the routine ASA monitoring, depth of anesthesia monitoring is mandatory because most of these patients actually will receive TIVA, and cerebral perfusion monitoring in selected cases using cerebral oximetry or jugular venous oxygenation, and non-invasive cardiac output monitoring or pulse pressure variation and stroke volume variation has to be used for fluid management, and renal monitoring by measuring the urine output. And apart from that, we need to do a repeat ABG and metabolic parameters because these patients are more prone for hypocalcemia, hyper and hypokalemia, and hypomagnesemia. And also we need to have a frequent interval. We need to monitor the coagulation parameters, prothrombin time, activated partial thromboplastin time, and fibrinogen platelet counts have to be monitored. And now we are actually, there is a lot of role on viscoelastic hemostatic assays using TEG and ROTEM. And then platelet function monitoring in neurosurgery, it is not many, studies have shown that this is not utilized very often. Now, what are the goals of lab parameters during massive transfusion? Hemoglobin has to be maintained between 7 to 10 grams. INR has to be less than 1.5. PTT should be less than 42 seconds. Fibrinogen should be more than 200 milligrams per deciliter. Platelet should be more than 1 lakh per microliter. The pH has to be maintained within normal limits. Core temperature should be more than 35 degrees. Base deficit should be maintained less than 3. Lactate, if possible, it has to be maintained less than 2 millimole per liter. And it's during the massive blood loss and blood transfusion, assessment of blood loss is extremely important, and it is also difficult. And we have to see the gases, mop used, and suction bottle has to be repeatedly emptied, and it has to be measured. And we have to look at the QSA where the jar volume has to be marked, and if they have used an irrigation, then we have to subtract the irrigation volume. And also sometimes surgical drapes are coming with collection bag. That collection bag actually can accommodate more volume. If we are not looking at that volume, we may miss massive blood loss. And keep a watch on, especially in pediatrics, keep a watch on irrigation fluid also. And we have to activate the massive transfusion protocol as early as possible, because it has been shown that early activation of MTP reduces the morbidity mortality, and also it reduces the wastage of blood and blood products and improves the patient outcome, and decreases the mortality and morbidity. And whenever we transfuse, we have to go through these 4 factors in mind. Why we are transfusing? Is there a benefit is more than the risk, or are we treating the patient's symptoms or the lab values? Are we giving prophylactically or therapeutically? And what to transfuse? Are we giving whole blood or component therapy? How much to transfuse? How much to calculate? What is the type of surgery we are using, and how to transfuse using a filter, and the rate of transfusion should not exceed more than 150 ml per minute, and warming should be done while transfusing. This is a general guide. Usually when the patient is having an hypovolemia of about 25 to 30%, we usually give crystalloid and colloid. When there is an inadequate oxygen delivery, we transfuse packed RBCs. And with the patient having a PT-PTT, a rearrangement of more than 1.5 times normal, which corresponds to the coagulation factors of less than 30%. So we need to transfuse with them with the FFP and cryoprecipitate. Usually we give FFP of 15 to 20 ml per kilo, cryo 1 bag for 10 kilo. For children, if you take, it's about 5 ml per kilo. When the platelet counts are less than 1 lakh, we give platelets. So usually we give PRCs platelets 1 unit per 10 kilo. In a children, it's about 5 to 10 ml per kilo. And what to give and how much to give? There are 2 main important studies which were published in JAMA and JAMA Surgery, Prompt and Proper Trial. What they are actually predicted is higher volume of plasma and platelet ratio help during an early resuscitation, decrease the mortality during the first hour. And Proper Trial also showed that more patients achieved hemostasis better and fewer experienced death due to exsanguination by 24 hours. But there was no difference in mortality at 24 hours or 30 days due to any cause. Mortality was not different. And it's a very, very important institutional protocol to be followed prior to transfusion. You have to ensure that you are transfusing the correct blood into the correct patient, and you have to check the compatibility labels, and also you have to look at the bag, look for integrity, and when was it collected, when was that expiry date, and what is that, is there a radiation is used, and two people have to check and sign it before transfusion, and it has to be documented. And I'm not going to each institution has a massive transfusion protocol. This is the transfusion protocol we follow in our blood bank. And what is the role of, so when we transfuse first round, usually if an unexpected bleeding happens, usually we transfuse O negative and AB FFP give. Second round, 4 units of PRBCs, 4 units of FFP, and 1 platelet pack will be given. If the fibrinogen is less, cryoprecipitate. When the third round is going, then we replace another volume. Apart from that, if it is possible, where there is a role for factor 7A, we should give that. And what is the evidence saying role of factor 7A in neurosurgery? It is being used only in some reported cases of TBI, especially in a penetrating injuries, or in patients with ICH and pediatric brain tumors, and patients with hemangiopericytoma. But these cases where they have just only off-label use, FDA recommendation is not, FDA is not recommending for factor 7A. And only thing is, before using a factor 7A, you have to remember that it does not work in patients who are having acidosis. So pH correction and also the coagulation factors, minimum 30% of the coagulation factors have to be there. So before giving factor 7A, FFP, platelets, cryo has to be transfused. The dose of factor 7A is about 40 to 90 microgram per kilogram. Now, what is the evidence for viscoelastic testing, hemostatic testing in neurosurgery? The TEG and the ROTEM, the Dextem and FIPTEM, are the thing it's coming up in neurosurgical practice. It determines the how fast is the clotting is initiated, and how is the clot is growing, and is it normal strength or abnormal strength, is it holding together or is it dissolving. It is assessing all those factors. What is the advantage of TEG is turnaround time is very shorter, so we can actually because it takes less time, along with the clinical assessment, we can do this, and so that the decision making is faster. And also it detects the hyperfibrinolysis and platelet dysfunction, which cannot be measured using a conventional coagulation test. All phases of coagulation, primary, secondary, cross-linking of fibrin clot and its stability, all are assessed, and it is performed in a patient's true temperature, so that we can, hypothermia-induced coagulopathy can be picked up very early. And also it has studies have shown that it reduces the transfusion requirement and need for blood transfusion. So this is a paper published in Journal of Neurosurgery Spine. It is definitely saying that the ROTEM and ROTEM guided transfusion decreased and picked up the hypofibrinogenemia better, and it reduced the blood loss, transfusion requirement, and decreased the transfusion related cost. And what about the other traumatic brain injury and other elective neurosurgical procedures? And this study has compared the ROTEM and TEG with PT-PTT and shown that there is a strong correlation between these two. And now this is a few slides on chemical hemostatic agent use. What is the anesthesiologist's role? Why we should know about it? We all know that this use of adrenaline and bone wax is used to control the scalp bleeding and the bone bleeding. And hydrogen peroxide is no more used, though it acts by vasoconstriction. Because of the air bubble formation, it is no longer used. And the other various factors like gel form, Surgicel, Oxycel, they are oxidized glucose, which is used for achieving hemostasis, and microfibrillar, that is called Avitin, and FlowSeal, Surgiflow, fibrin sealant, and fibrin glue are used in neurosurgical practice. When you see a gel form, it absorbs the blood and it works by mechanical pressure. When we use Surgicel and Oxycel, it is an oxidized regenerated cellulose. So the acidity of the material reacts with the blood and it forms an artificial clot. So whenever we put thrombin substitute over this, it does not work. So we need to know that when we use a Surgicel and Oxycel, we cannot use any thrombin products. And when we use microfibrillar collagen, it is derived from the bovine dermal collagen. It actually causes it attracts the platelets, it increases the platelet adherence and causes release reaction. So it works by increasing the primary hemostasis. So if you use this in a patient who is thrombocytopenic, obviously it won't work. So when we are using this, ensure that the platelet counts are better. And when we use FlowSeal and Surgiflow, both are gelatin and thrombin derived products, so which actually causes by mechanical pressure and also by causing secondary hemostatic effect. And when we use Tizil, it is a component of both fibrin and thrombin. Component 1 contains human fibrinogen factor 13 concentrate, and also it has an anti-fibrinolytic solution, aproteinin. And component 2 has a bovine thrombin. Both are actually mixed and it is given along with calcium chloride. Fibrin glue, which has a cryoprecipitate, and factor 8 and calcium chloride and aproteinin and bovine thrombin. This is also used in a for chemical chemostasis. I'm not, because of the time factor, I'm just not going through the massive transfusion-induced complication, but every anesthesiologist should know the transfusion-induced complication. Whenever there is increased number of RBC unit transfused or storage time is increased, or the donor leukocyte is more the number it is present in the transfused blood, the more the problem. So you have to, there are various infectious immunological metabolic complication has been described, and there are various strategies are described in literature. Because of the time factor, I'm not going through that. We need to keep that in mind and we have to manage them appropriately. Take home message: thorough preoperative evaluation and prediction of patients who are at risk for massive blood loss and transfusion, and preparations are the essential key factor for preventing the morbidity. 3 Ps. And also we have to utilize all the blood conservation strategies and early institution of massive transfusion protocol and thorough knowledge about the blood and blood products and the complications help us to manage appropriately. Thereby, it helps in improving the patient's outcome. Thank you.
In the interest of the time, we can go on to the next speaker and we can take all the answers at the end of the session.
Sure, sir. Sure, sir. I request Mukesh Gupta, sir, to please introduce our next speaker. Mukesh Gupta, sir, can you hear us? I think sir is not able to connect. So our next speaker will be Dr. Abhijit Raha, sir. He's going to present on nosocomial CNS infection in neuro ITU. So a few words on Dr. Abhijit Raha, sir. Sir is a senior consultant neurocritical care, and in senior consultant neurocritical care in Bhubaneswar, Odisha, and he has done MD anesthesia and PDF neuroanesthesia. He has a 14 years of experience in neuroanaesthesiology and critical care. I welcome you, Dr. Abhijit, sir, to present further talk.
And delegates, we're into the 7th session of the first day's conference, and I would request you to excuse me for the bad sore throat and cough that I'm suffering from, and we'll be talking about hospital-acquired CNS infections in this topic. About hospital-acquired infection, the WHO estimates a 5.7 to 19.1% in low and middle-income countries, and the rate of incidence of hospital-acquired infection, which is much higher in ICUs. And the infection frequency is 42.7%, 42.7 episodes per 1,000 patient days. So what is the impact or ramification of the hospital-acquired infection, which is the longer hospital stays, increased cost, lost wages and employment, and morbidity, disability, and death. So the impact of the hospital-acquired infections is much higher than the primary disease that the patient suffers from. Well, so much so that the hospital-acquired CNS infection has a greater impact on the patient in terms of morbidity and mortality. And it can be defined as a new onset CNS infection, which was not present at the time of admission, usually associated with certain neurosurgical intervention or an external or internal CSF flow diversion. It can be defined as an infection of the leptomeninges acquired during hospitalization, particularly manifesting 48 hours after neurosurgical intervention or in presence of CSF flow diversion device. It is characterized by CSF pleocytosis, increase in the cell count, biochemical abnormalities like decrease in glucose and increase in protein, fever, change in mental or neurological status, and abnormal blood counts. Although the incidence of hospital-acquired CNS infection is different in different regions of the world, an overall estimate of incidence has been found to be 4 to 17%. Let's talk about certain devices or certain interventions that are associated with the increased CNS infections, one of which is CSF shunts. CSF shunts can be infected by colonization of device during surgery, or there can be retrograde infection from bowel perforation. There can be transcutaneous spread while aspirating CSF from the reservoir, and there can be hematogenous seeding. The other culprit that contributes a lot to hospital-acquired CNS infections is the EVD, incidence of which is calculated from as 0 to 22%. In a meta-analysis, Mangesh et al. Saw that the pooled incidence rate was 11.4 per 1,000 catheter days. The mean duration of EVD of less than 7 days had a pooled CSF infection rate of 19.6 per 1,000 catheter days, and those with mean duration of 7 to 10 days had a rate of 12.8, whereas the duration greater than 10 days had a rate of 8. That means the incidence of CNS infection came down as the number of days of the EVD increased, which is contrary to what we generally believe. So this indicates that there is an issue with the insertion. There's an issue with the insertion technique. So this is an insertion-related issue. Excuse me. Other factors that are associated with increased risk of infection associated with EVD is intraventricular or subarachnoid hemorrhage, cranial fractures with CSF leak, catheter irrigation, the frequency of catheter irrigation, craniotomy, duration of catheterization. This study showed that the extended catheter duration, usually exceeding more than 5 days, to be an important risk factor in subsequent infection, which is what we usually see. About antimicrobial impregnated catheters, with clindamycin, rifampicin, or minocycline rifampicin impregnated catheters show a lower rate of bacterial colonization and positive CSF culture compared to a standard catheter. There has been no difference in the antibiotic impregnated and silver impregnated catheters. And the cons is that there can be false negative cultures that may result that may be seen when a CSF sample is drawn through an antibiotic impregnated catheter. So how do we prevent EVD associated meningitis or ventriculitis or CNS infections? And that is by adherence of infection control practices. Strict adherence of infection control practices, formation of insertion bundles, formation of maintenance bundles. If there exists infection control bundles for CLABSI, for UTI, for surgical site infection, then why should there not be infection control bundles for EVD, which should be strictly adhered to and which should be followed. We should not be flouted at any step. We should avoid irrigation, frequent irrigation, unless intraventricular drug administration is required. Maintenance of closed system and avoidance of open system is very, very important. Nurses should be trained to handle EVD. So each and every nurse who is handling EVD should know the importance that a patient who acquires a central nervous system infection from this EVD can actually be fatal. And we should also try to remove the EVD as soon as it is possible clinically, as soon as the patient or the indication is taken care of. Well, British Journal of Neurosurgery in 2020 had a retrospective prospective study, and they had pre and post bundle infection rates, calculated infections rate, CNS infection rates in EVDs, pre and post implementation of pre and post bundle of care for control of infection. The pre-bundle care infection rate was 27%, and the predominant factor associated with infection being the number of cerebrospinal fluid sampling episodes. Following introduction of the EVD bundle of care, the infection rate declined to 10%, which is statistically significant. Here is an example of an EVD placement bundle that can be used. You can design it yourself in your ICU. It should be aseptic, and it can be similar to a central venous system, central venous catheter insertion bundle, and that is all that is required. And more than after designing it, implementation and adherence, strict adherence to following it is quintessential. It's essential to prevent infections of the EVD. This is another example of how to maintain the EVDs, and so similarly, this can be designed in your own ICU. It can be based on your regular infection control practices, and your infection control team can help you out in designing such a bundle. Well, another example of how to sample the CSF in a sterile aseptic way and further prevention of infection. Sampling should be as minimum as possible, but when it is required, it has to be done in a very sterile and an aseptic manner. There are certain other infection control processes that need to be addressed. Just implementation of bundles is not enough. You have prepared your bundles, but you need to educate and re-educate your ICU nurses, ICU doctors, physiotherapists, how to handle the EVD, how to take CSF samples. CSF sampling should be done by doctors. They should be trained, and they should be trained and retrained about hand hygiene, which should be the focus on repeated hand hygiene practices, and they should also be trained about how to handle the EVD aseptically, and minimum handling of the EVD as much as possible. Avoid handling the EVD. Other neurosurgical interventions that can lead to a CNS infection, meningitis or encephalitis, could be an intrathecal infusion pump like baclofen, or maybe a subarachnoid lumbar CSF drainage system, which can give rise to a meningitis. The incidence of infection is higher with subcutaneous placement of infusion pumps compared to subfacial placement. And majority of the organisms seen is Staphylococcus aureus. GNB is rare. Deep brain stimulation hardware column can also get infected, and most of it is a gram-positive infection. Coming to head trauma, the risks of CNS infection increases if there are surgical interventions done. There's a CSF drain. The perioperative steroids have been given. There is a CSF leak. There's a basilar skull fracture, and this is in order of the frequency. It's difficult in a traumatic brain injury. It's difficult to establish what is the cause of the infection. Both surgery and trauma can introduce infection into the central nervous system. Identification of the organism and sensitivity pattern would be more suggestive of the hospital-acquired infection. So whatever organism is isolated and its relative resistance can lead you to identify whether it is hospital acquired or an infection which has been acquired during the time of trauma. It should be treatment should be done as hospital acquired infections unless proven otherwise, or the evidence or the infection is less than 48 hours. Infection is seen less than 48 hours of hospital admission. It's a typical picture of the cribriform plate fracture, this basilar skull fracture, which leads to CSF anuria and can cause meningitis and CNS infections. Excuse me. So what is ventriculitis? Ventriculitis is the inflammation of ependymal lining of cerebral ventricles, usually secondary to infection, usually device-related or a complication of trauma. How can you diagnose? We can diagnose with a decrease in fall in CSF sugar, increase in protein, pleocytosis with 50% or more of polymorphonuclear neutrophils in a positive culture or a gram stain. A CSF lactate of more than 3.5 millimole per liter is highly suggestive. Procalcitonin more than 0.5 nanogram per ml is also suggestive. Lysosomal enzyme. These are helpful in making an early diagnosis. As soon as you can, you have taken a sample of CSF, you can check it in the ABG machine and see the lactate. And if it is more than 3.5 millimole per liter, then obviously the chances of infections are very high. Again, a CSF IgG index of 0.75 or greater predicts unfavorable outcome. So what is this IgG index? It is basically CSF IgG by serum IgG and CSF albumin by serum albumin. The other diagnostic modalities are in units, ultrasound, which shows increased thickness, irregularities, and echogenicity of ependyma with echogenic debris in the ventricle. NCCT head can show that the dependent hyperdense ventricular debris is there, hydrocephalus, periventricular low density, as well as features of meningitis will be there. With contrast, the ependymal lining of the ventricle enhances homogeneously. And an MRI T1, T2 would show a ventricular debris hyperintense to CSF, most common finding, and flare images are sensitive to subtle, periventricular hyperintense signals. So these are pictures, CT and MRI pictures showing ventricular debris and periventricular, leakage of CSF, which are signs or indicates. Which indicates these are the ventricular debris you can see, and there is leakage of CSF in the periventricular area, which indicates active infection. The CDC and NHSN surveillance definition of healthcare associated ventriculitis or meningitis includes at least one of the following criteria. This was published in January 2015. Organism culture from CSF, at least 2 of the following symptoms with no other recognized cause in patients aged more than 1 year: fever more than 38 degrees centigrade, or headache, meningeal signs, cranial nerve signs, or at least 2 of the following symptoms with no other recognized cause in patients aged less than 1 year: fever more than 38 degrees, or hypothermia less than 36 degrees, apnea, bradycardia, irritability, and at least 1 of the following: increased white cells, elevated protein, decreased glucose CSF, organism seen in the gram stain in the CSF, organism cultured from blood, positive non-cultured diagnostic laboratory test from CSF, blood or urine, and diagnostic single antibody titer, immunoglobulin M, or 4 increase in paired sera immunoglobulin G for organisms. Coming to the microbiological aspect of hospital-acquired CNS infections, a retrospective study published in the Journal of Hospital Infections in 2006 showed the data of nosocomial meningitis in a university hospital between 1993 and 2002. And it can be seen here clearly that initially there are more of Coagulous negative staphylococcus that was more common in hospital-acquired CNS infections, and later on the scene has been changed in 2002 to more of gram-negative bacilli. Now more and more gram-negative organisms, more MDR and XDR gram-negative organisms are seen to be the causative agents for hospital-acquired CNS infections. This is a table which shows organisms which are based on post, the pathogenesis, whether it's a neurosurgical or ventricular lumbar catheter, penetrating trauma, and as well as skull fractures. In the following slides that are to come, we will discuss about the IDSA's recommendation, which was published in 2017. And first is the CSF findings that suggest hospital-acquired infection. Abnormalities in the cell count, glucose, and protein may not be a reliable indicator for if there is a high degree of suspicion or clinical suspicion of central nervous system infection or hospital-acquired central nervous system infection. The CSF may not be very suggestive of it. Excuse me. Normal CSF cell counts, glucose, proteins may not reliably exclude infection in patients with healthcare-associated ventriculitis and meningitis, and a negative CSF gram stain does not exclude the presence of infection, especially in patients who have received previous antimicrobial therapy. About CSF culture, if the culture is positive, it's a gold standard. If initially negative and clinical evidence of CNS infection persists, repeat culture after 10 days. If a CSF shunt or drain is removed in patients suspected of having infection, cultures of the shunt and the drain components are recommended. These are recommendations of IDSA. Blood culture should be done in case of a VA shunt where there is a suspicion of infection. Obtained culture should be obtained before administration of antibiotics. So how would you differentiate a contamination or colonization and a CNS infection? The contamination is an isolated positive CSF culture gram stain with normal CSF cell count and glucose protein concentrations and with lack of clinical symptoms suspicious of ventriculitis and meningitis. Colonization, on the other hand, is multiple positive CSF cultures or gram stain with normal CSF cell count and glucose protein concentrations and with lack of clinical symptoms suspicious of ventriculitis or meningitis. Again, coming to the IDSA recommendations of some special tests, CSF special tests, lactate procalcitonin, as we have talked about, nucleic acid amplification tests of PCRs can be done, and detection of beta-D-glucan and galactomannan in CSF may be useful in diagnosis of fungal ventriculitis and meningitis. Imaging recommendations, CE-MRI brain is highly recommended to see if there is a leptomeningeal enhancement in patients with infected ventriculoperitoneal shunts, abdominal symptoms, Example, pain and tenderness. Ultrasound computed tomography of the abdomen is recommended to detect CSF loculations at the shunt terminus. Recommendations of empiric antibiotics in case of suspicion of hospital-acquired CNS infection. First is vancomycin plus an anti-pseudomonal beta-lactam such as cefprime, ceftazidime, or meropenem is recommended as empiric therapy for healthcare-associated ventriculitis and meningitis. The choice of empiric beta-lactam agents should be based on local in vitro susceptibility patterns. So your antibiogram is important. You need to have a communication with the microbiologist and the infection control team to form an antibiogram which will lead you to choose your antibiotic. If there is a reaction to beta-lactam antimicrobial agent, or in patients whom meropenem is contraindicated, for example, if the patient is having seizures, then astronam or ciprofloxacin is recommended for gram-negative coverage. Vancomycin is a time-sensitive drug. It has to be a minimum, MIC has to be maintained. A trough concentration should be maintained at 15 to 20 microgram per ml. So the duration of dosage and the frequency should be adjusted accordingly. What about specific antibiotics? If it is a methicillin sensitive Staphylococcus aureus, methicillin or oxacillin is recommended. Whereas a methicillin resistant Staphylococcus aureus, vancomycin is the drug of choice. Alternative to vancomycin are linezolid, daptomycin, or cotrimoxazole. Devices associated with Staphylococcus which are sensitive to rifampin can be added along with vancomycin. In case of gram-negative bacilli susceptible to third generation cephalosporin, ceftriaxone, ceftazidime is recommended. And MDR, Pseudomonas, meropenem, or alternatives to meropenem or astronam and quinolones. If it is an Acinetobacter, meropenem is the drug of choice. And if we isolate a Pseudomonas or an Acinetobacter, which is an XDR, then intravenous plus intraventricular colistin or polymyxin should be used. Both meropenem and vancomycin are time-dependent drugs, so the duration of administration is important. A single dose of meropenem should be given at least over 3 hours, if not a continuous infusion. We calculate the total dose in a day. Suppose 6 grams, you are giving 2 grams 8 hours. 6 grams, it can be given by continuous infusion over 24 hours. 6 grams of meropenem can be given over 24 hours in continuous infusion, which would be more beneficial. For the treatment of infection caused by fungus formed by Candida species based on in vitro susceptibility testing, liposomal amphoby is often combined with 5-fluorocytosine is recommended. And for treatment infection caused by Aspergillus, voriconazole is the drug of choice. Intraventricular antimicrobials, which are what are the key points of intraventricular antimicrobials? Is to consider, we have to consider giving intraventricular antimicrobials in poor responders to systemic therapy alone. When antimicrobial therapy is administered via ventricular drain, the drain should be clamped for 15 to 60 minutes to allow the agent to equilibrate with the throughout the CSF. The doses in interval of intraventricular antimicrobial therapy should be adjusted based on CSF antimicrobial concentration to 10 to 20 times the MIC, the causative microorganism, ventricular size, and the daily output of ventricular drain. So these are the recommended table shows recommended doses of antimicrobial agents administered by intraventricular route. Usually colistin 10 milligram, that's almost equal to 1.5 to 1.7 MIU. 1 MIU is equal to 80 milligrams. Sorry, 1 MIU is equal to 1 milligram is equal to 12,500 MIU. So 10 milligrams would be around 1.5 MIUs per day. The cholesterol is required. What are the preventive approaches that is recommended by IDSA? The peri-procedural prophylactic use of antimicrobial agents is strongly recommended. Prolonged antimicrobial prophylaxis is not recommended. Antimicrobial impregnated CSF shunts and CSF drain is recommended. Fixed interval exchange of AVDs is not recommended. And insertion and maintenance of care bundles for infection control is highly recommended. In traumatic brain injuries with CSF leak for neurosurgical patients, perioperative antimicrobial agents are recommended. Basilar skull fracture and CSF leak, prophylactic antimicrobial agents are not recommended. In patients with basilar skull fractures and prolonged CSF leak more than 7 days, an attempt to repair the CSF leak is recommended. In patients with basilar skull fractures and CSF leak, pneumococcal vaccination is recommended. Coming to the key points, infection control bundles are to be prepared for insertion and maintenance of CSF drains, and they should be implemented. There should be strict adherence to these infection control processes, regular audits, education, and re-education about handling of CSF drains. The nurses should be trained, the IC doctors should be trained, they should be aware of the consequences of a central nervous system infection, particularly hospital-acquired central nervous system infection. Removal of CSF drain should be done as soon as possible, and peri-procedure or perioperative antibiotics should be used. There should be vigilance, early detection and CSF analysis on slightest doubt of a central nervous system infection. A CSF lactate and a procalcitonin value may be used for faster diagnosis and initiation of treatment. Thank you very much for bearing with me.
Thank you, sir. I request Dr. Pragati ma'am to introduce our next speaker, please.
Yeah, thank you so much. Sorry, apologies for joining the session very late. I was caught up in Hall B.
Yes.
Now we have the last session, but very interesting from the neuroanesthetist point of view, because we offer a topic which is lesser known to us compared to the cardiac anesthetist, and that is the ECMO. So I'll introduce Dr. Sindhu Priya. She is she did her MD from KIMS Hubli and her DM from NIMHANS Bengaluru, and she's now a consultant at MGM Healthcare Chennai. And she'll be talking about this topic, which you can see there. It is intracerebral bleed in a patient on ECMO. So welcome, Dr. Sindhu Priya, and you can start.
Good evening all. Today I'm going to talk about intracerebral hemorrhage in a patient on ECMO. So I'm going to discuss a few case scenarios. In the first case, we had a 29-year-old male. He was a post-COVID sequelae on veno-venous ECMO day 40 on heparin infusion 500 units per hour. His relevant lab investigations are platelet count 1,28,000, an APTT of 30.9, an INR of 1.1, and a fibrinogen of 169. We received a call when his GCS had dropped from E4-VT-M6 to E1-VT-M3. His pupils were on the right 5 millimeters and on the left 6 millimeters, not reacting. And the TCT showed an oscillatory pattern which is suggestive of a very high raised ICP. And this is a monitor showing his hemodynamics, and we can see that there is a low amplitude of the ETCO2 waveform, and this is mainly because the ECMO has taken over the oxygenation and ventilation function, and the lung per se contributes very less. So what next? We did an emergency CT scan, and it showed that there was a left frontoparietal ICH with a midline shift, and a sample was sent for thromboelastogram. Now we have to decide about whether we do an urgent reversal of anticoagulation as a patient will be in a prothrombotic state versus take the patient for the surgery without any anticoagulation reversal and face an intraoperative bleeding and the risk of hematoma expansion. We decided to stop the heparin infusion, and anticoagulation reversal was done with protamine. We arranged blood products and the patient was taken up for emergency left FTP decompressive craniotomy. The intraoperative blood loss was 800 ml approximately, and the surgical site oozing was present in the intraoperative period. Post-procedure, the patient was E1 VT M1 as he was sedated. The pupils on the right were 3 millimeters and on the left it was 5 millimeters, not reacting. Post-procedure TCD shows very good flows in the MCA, and immediate post-operative tech showed a fibrinolytic pattern, and hence tranexamic acid was given, and it showed a fairly better tech after the correction. In the postoperative day 2, the patient's GCS was E1 VT M4. The pupils were 2 millimeter on the right and on the left it was 4 millimeters. The patient was on noradrenaline and adrenaline infusion for maintaining the hemodynamics. The heparin remained discontinued. This is the monitor showing the hemodynamics of the patient. And we did an interval TCD which showed very high resistance pattern. Hence, we did a repeat CT scan. And the repeat CT scan showed that there was a subgaleal collection in the left craniectomy site, as well as there was a midline shift. In the postoperative day 3, the INR was 1.3, the APTT was 28.1, the fibrinogen was 213, and there was a drop in the platelet count, that is, it had become 77,000. And the patient was started on tranexamic acid infusion previously. The patient's GCS was E1 VT M5. The pupils were 2 millimeters on the right, and on the left it was 3 millimeters, and it was not reacting. And this is a TEG which was done, which is fairly normal. On postoperative day 4, the patient's GCS was E2 VT M4, and the patient had severe surgical site oozing, as can be seen in this picture. And the platelet count had dropped further to 20,000 per cubic millimeters, and correction was on. This is a TCD which was done, which shows a normal resistance flow pattern. On post-op day 4 by evening, the patient's GCS had dropped to E1 VT M3, and the pupils had become right 3 millimeters and left 4, and there was surgical site bleeding. And we did a repeat CT brain, which showed that the subgaleal collection had increased, and there was also infarction on the opposite side, and there was a midline shift. The TCD showed a very high resistance pattern. On postoperative day 5, the GCS of the patient was E1 VT M1. The flap was very tense, and vasopressor support for the patient kept on increasing, and the patient had an unfavorable outcome. Case 2 was a 45-year-old male. He was also a post-COVID sequelae on veno-venous ECMO day 52. He had a decreased GCS, E1 VT M2. His pupils were right 3 millimeters and left 3 millimeters, not reacting to light, and he was off supports. Fearing an ICH and because of high suspicion, the ECMO team had already stopped the heparin. The platelet count was 169,000. The PT was 18.3. The INR was 1.54. The APTT was 56.9, and the fibrinogen was 194. So an emergency CT scan was done, and it showed a right parieto-occipital ICH with a midline shift. The ECMO team this time had concerns about heparin reversal, and hence they did not reverse the heparin. The risk was explained to the patient and patient party, and the patient was taken up for an emergency suboccipital decompressive craniectomy, and the blood loss was approximately 1 liter. Blood products were transfused. In the immediate postoperative period, we can see that the MCA flow velocities were good, and this is the monitor showing the hemodynamics of the patient. The TEG which was taken intraoperatively showed an increased R value corresponding to a raised APTT. In postoperative day 2, that is ECMO day 53, the patient's GCS had dropped from E1 VT M3 to E1 VT M2. The pupils on the right were 3 millimeters, and on the left it was 4 millimeters, not reacting. There was continuous surgical site oozing, as we can see in this picture, and we did a TCD which showed a very high resistance ICP, and hence we did an emergency CT scan which showed a left acute SDH. The patient was taken for left acute SDH evacuation, and the intra-op TEG showed that there was coagulopathy, and we had the surgeon had a great difficulty in achieving hemostasis, and even in the post-operative period there was a lot of surgical site soakage. We did a repeat CT brain after the evacuation of SDH, and it showed that there was a left frontal new hemorrhage. On post-op day 3, the GCs of the patient became E1, VT, M1. The pupils were 5 millimeters, bilateral not reacting, and the cough reflex was absent. The patient also had an unfavorable outcome. Case 3, we had a 5-year-old child who was awaiting a heart transplant and was put on a biventricular assist device. This child was on warfarin, the INR was 3.4, and the child weighed 12.6 kgs. We received a call when the GCS of the patient dropped from E4 V5 M6 to E2 V2 M4. The pupils were 3 millimeters on the right and 4 millimeters on the left, sluggishly reacting. So we did an emergency CT scan, which showed that there was a left temporoparietal ICH with 136 cc volume with a 1.8 centimeter midline shift. This patient was also on dual antiplatelets because he had a right MCA stroke in the earlier time. So here also we should decide about the whether we want to go ahead with urgent reversal of anticoagulation as the patient will be in a prothrombotic state versus whether to take the patient for surgery without the reversal with the risk of intraoperative bleeding and hematoma expansion. So we did an urgent reversal of anticoagulation. We aimed for 40% of the functional prothrombin complex concentrate. So octaplex 400 units and 10 milligrams of vitamin K IV was given, which is the standard protocol for urgent reversal of warfarin in an acute emergency situation. The surgery was completed with 200 ml blood loss. This is a TEG which shows a normal pattern after octaplex administration. This is the immediate postoperative TCD which shows a very good MCA flow velocities. So just quoting few relevant articles. In this study done in 2017, they have concluded that ICH in adult ECMO patients is associated with a very high mortality. Treating a patient with ICH during ECMO represents an intricate balance between pro and anticoagulatory demands. In another study, they have also concluded that ECMO remains associated with a high incidence of ICH, and there are still wide gaps in understanding the disease and the ECMO. In another study, they have made a tabular column for the overall incidence and mortality of the ECMO-associated intracranial bleedings. Here, as we can see, even when there is no hemorrhage, the mortality is 46%. When there is a singular small hemorrhage, it is 48.5% mortality. For a large hemorrhage, 79.2% mortality. For an acute SDH and EDH, there is 100% mortality. And all hemorrhages combined, there is 65% mortality. So they concluded that swift and non-hesitant normalization of coagulation status will improve mortality, and the benefits of coagulation reversal outweighs the prothrombotic complications. In our experience, we came across 21 cases of ECMO patients who presented to us with intracerebral hemorrhage, out of which 7 patients were taken for decompressive craniectomy, and all 7 patients had an unfavorable outcome. Initially, we had hesitancy in urgent reversal of anticoagulation, fearing the prothrombotic risks like the ECMO machine malfunction, but later we were aggressive in anticoagulation reversal. And we also faced that despite a normal coagulation parameters, there was clinical coagulopathy, and the overall outcome of these patients is poor. The take-home message: in a patient on ECMO, whenever there is a decrease in the GCS, it warrants a high suspicion of intracerebral hemorrhage. So an emergency CT should be done. There are a lot of practical difficulties in shifting a patient to CT scan room because of the bulky nature of the ECMO machine and also the risk of disconnection of the ECMO circuits. We also have to make a decision whether to take the patient for the surgery versus the futility of the surgery. For example, if the patient is already on continuous renal replacement therapy, or if the patient is also having a GI bleed, which is also a very common manifestation, then the risk in taking the patient for surgery is more when compared to the benefit. We have to give urgent reversal of anticoagulation. We did not face any incidents of ECMO filter malfunction. Despite correcting the coagulopathy, we saw that the surgical field was oozing. Even in the postoperative period, there was persistent clinical coagulopathy despite correcting it. There was postoperative surgical site bleeding and soakage. We also found there was a lot of platelet drops and platelet dysfunctions. So a liberal platelet transfusion strategy is to be followed. Generally, these patients have a very poor outcome, and COVID patients on ECMO with ICH is a very poorly understood disease. So we have to formulate more treatment strategies to improve the patient outcome. Thank you.
Thank you so much, Dr. Sindhu. That was a really good PBLD, a true PBLD, because this is a practical dilemma. We've all been through this, and still, I think there won't be many people who would have the courage to reverse the anticoagulation, like you're saying, aggressively. So we'll throw the session, the whole entire session open for questions, and you can go ahead and ask if time permits. One thing, just one question, Sindhu. You said the outcomes are very poor. Is it because of the bleed, or is it because of COVID, or is it because obviously the patient has reached a stage when he or she requires an ECMO? So the outcome is poor because of what? Or is a combination of factors?
It's a combination, ma'am. It's a combination. Even generally, if the patient is not a COVID patient, like in one of the articles in 2017, they still, those studies were done on a non-COVID patients only, ma'am. But even then, they also found that they had an unfavorable outcome on a patient with ECMO if they had an ICH. So now with an ECMO and when there is an ICH in a patient with ECMO, it's a bad prognosis.
Okay.
One another question, Dr. Sindhu. Your second patient was for suboccipital decompressive craniotomy.
Yes, sir.
So while making prone, how does ECMO circuits, whether they were transiently disconnected or what? Just for our knowledge.
It was a big circus, sir. Actually, the patient is anyway on a tracheostomy, so the tracheostomy will be sutured, sir. And then the ECMO circuits, a lot of manpower is required to turn the patient into the.
I've been through that. That's why I'm asking. Yes, making a patient prone on ECMO is like hell. I can imagine that. But then, my question is whether somebody disconnected it for a transit period or whether it was.
No, sir.
That's okay. And then it's okay.
In
so we need at least 3 more people, I think.
In the COVID ICU itself, they were doing awake proning, sir, for certain patients who are like doing well. They were doing awake proning, even though the patient was on ECMO. So here also they did the same.
Okay, nice. Thank you.
I have a question for Dr. Mitra. Dr. Mitra, if all these patients are somehow COVID positive patients, maybe on some these drugs like remdesivir or ivermectin, hydrochloroquine, what are the implication of anesthetic implication of these drugs? If patients are on these drugs, how we have to modify our technique, or how do they influence the interact with other anesthetic agents and influence the outcome? Of course, you know about steroid. If patient is on steroid, we have to supplement some steroid.
Regarding the other drugs that are being provided during COVID time, I think our protocol has already changed. We are no more using any drugs. And as far as any comorbidity and the patient is taking some drugs because of those comorbidity, then our usual anesthetic interactions are already there in place. Regarding specific drugs like hydroxychloroquine or remdesivir and all and those drugs, I think nowadays we are not getting it, so I'm not very sure. Interactions are pretty theoretical in nature. Until unless QT prolongation is there, the patient is on hydroxychloroquine, and as definite QT prolongation, then that could be an issue. But apart from that, yes.
Just to add to Dr. Pandya's sir question, remdesivir has some electrolyte associated electrolyte abnormalities. So if you are on 3rd or 4th day of remdesivir, then we can have some issues with electrolytes. So you have to continuously monitor the electrolytes. Regarding the other therapies like the newer therapies which were initiated, like the tocilizumab and all those immunomodulator drugs, so they all have some effects on, if the patient is on a chronic therapy, maybe like 3-4 days the therapy is going on, then they all have some effect on LFTs. So your muscle relaxation and all those things, they have to be modified. And if we are using halogenated fluorocarbons, again, they will have some impact on the liver functions. So all those things we have to take care during this thing. For especially the liver function test, and maybe sometimes because they are on unfractionated heparin also, so we have to take care of the anticoagulant this thing also, because of the high risk of Well, again, it has to be a balance. We are doing a surgery also, and the patient, they are at risk for thromboembolism, all these patients. So that starting of the low molecular weight heparin in the post-operative period, again, that has to be taken care of. Regarding one question to Randir again, how, if you have a patient of COVID, so whether you will go for a pressure control or a volume control straight away? Yeah. Whether it has recovered, whether it has, because now everybody has operated, I think COVID recovered everybody. In my personal experience, it might be different. What's your take on it?
Yeah, but it all depends on what the screening HRCT is showing it to you.
No, a recovered patient has come to you for anesthesia.
Pressure control.
You can't order HRCT
yeah, no. If even if he is recovered COVID, does not mean that necessarily his lung has been involved.
That's why
if his lung is involved, and then I will prepare for a pressure control ventilation. That is what I have practiced.
Yeah, I think I also agree with you. We all have been operating many patients on the pressure control ventilation works very fine in these patients. There were some questions for Dr. Ramamani from the chat box. I think Dr. Ramamani has answered some of the questions to the presenter. So just one question was that role of embolization, that was by Dr. Venkat, and the other was role of tranexamic acid. She has already answered, but just for the benefit of the viewers, that if she can answer all those questions.
Yeah, actually, regarding preoperative embolization, it is definitely shown beneficial in the literature. Whatever literature I was going through, it was actually beneficial. For pediatric, it has been utilized routinely. For adults, some of them showing that there is a reduction in blood loss and transfusion, but some of the studies, they have shown that there are actually increase in blood loss, and also they are not able to take out the whole tumor. That may be because of the brain bulge, and those may be the reason for it. But definitely there are, in our institution also, we are also doing for hemangioblastoma or very highly vascularized tumors, still we are doing. So from our personal experience, yes, it helps in reducing the blood loss and massive transfusion. Anil sir had asked role of
ecosprin.
Yeah, ecosprin, usually we do have to do a platelet function assay, PFA. It cannot actually, the TEG may be normal, but you have to do a platelet function assay. But when I went through the literature, it is not used routinely for assessing the platelet function, maybe because of the time and you may need specialists to report. Hence, we are actually, especially when the posterior hematoma happens, we are actually reversing with platelets. As sir asked about whether you will give single donor or random donor. We do give random donor only in certain cases, like hematology cases where you expect problems, then we are actually aiming to give single donor platelets. Yeah. And to Sindhu, I just wanted to ask, so when you started ECMO, this is just, I don't have any experience, I'm just asking one. So you have reversed heparin, one shot, and then, yes, so after that, did you give protamine as an infusion? You said tranexamic acid was given as an infusion, but did you come across any complications of, blood clot and cardiac complications, those things?
No, ma'am, we did not. We just gave a bolus of, we didn't give an infusion of protamine. We just gave a bolus of protamine and means in a short while over 30 minutes, and we just reversed the patient. It was actually ongoing when we shifted the patient to the OT. It was as fast as that. From the time, and we also did a TEG, ma'am. So seeing the TEG, whatever we had to reverse, we reversed. In fact, in the first patient, there was a thrombolytic pattern for which tranexamic acid was given.
Fibrinolytic. Okay, thrombolytic. Okay.
So we tailored our treatment according to the TEG as well.
Oh.
But in so many patients, even if the TEG was normal, still we had a surgical site which is very oozy, a lot of blood loss, ma'am. And even the post-operative period, we faced a lot of surgical site soakage. It wasn't a very pleasant picture to look at all, ma'am.
So do you recommend, this is just, do you recommend in case if they have a massive bleed, because after seeing this outcome,
So what do you say, especially because it causes so much of financial burden to the family, correct? So I don't know what, maybe how to counsel them not to have surgery, correct? Because anyway, outcome is bad, and after so much of financial burden, then if we say negative outcome, maybe we should consider not doing, I think. I don't know.
Yes, ma'am. There are lots of gaps. I mean, it's actually a very poorly understood thing, but as per our experience, after we did like 7 cases, and when all the cases had an unfavorable outcome, then we used to see the age of the patient. If the patient is a very young patient, then definitely we would give the chance to the patient. We are no one to say don't go ahead with surgery, but we did explain the risk and the benefit of stopping the reversal of anticoagulation, and everything was explained. Even the poor prognosis, the results of the previous 7 patients, everything was explained. And then only we used to, we left the decision to the patient party, sir. Party, ma'am.
Randir has raised a hand.
Thank you.
Sir, actually, just going back to Pandya sir's question, actually, I forgot to add. Last year, a lot of people came up with taking Ramdev concotations, and they all had increased INR. No, that is what one thing. They all were in coagulopathy. So that is one thing. And secondly, regarding COVID, a lot of patients end up with viral transaminitis. So from the very beginning, when you do LFT, you will see the LFT, SGOT, SGPT are raised. So,
yeah, that way you have to be very careful, because anesthesia also has an effect on the liver function. So all those things that has to be taken care of, especially when you are going for an emergency surgery, and we have the investigations you send, but the reports you don't wait, you take for the emergency surgery. All those things, that has to be taken care of.
I think Virender, Mihir, should we close?
Yeah, please.
Quite late today and tomorrow. Now we still have 2 more days to go, so
okay,
save our energies for that. Okay, thank you all. Thank you.
Thank you.
Thank you.
Thank you. Thanks a lot.
Thank you
Thank
all,
you,
dear
speakers.
persons and speakers,
Good
for
night to
giving your
everyone.
valuable time.
Thank
It was
you.
a wonderful session and a great learning experience for all of us. Thank you, ma'am. Thank you, sir. And tomorrow we'll join from 8 a.m. for further sessions. Thank you all.
Thank you.
Can we end the session? Thank you.
Good night all.
Thank you, ma'am. Thank you, sir.